Hello students, welcome to this rapid revision of anesthesia. So your exams are approaching and you want to revise. I have made things simple for you in anesthesia and have shrunk my entire lecture in just few hours of revision. In this few hours of revision, you will revise most important points of anesthesia, which will cover your 90-95% of the questions. Once you are done with the main app, the revision would be very easy for you. And even if you have not done the main app, or you didn't have time to do the main app, then also this revision would be very helpful for exam. Now, the sequence of all the chapters in this rapid revision has been maintained as the chapters are in sequence in my main app to maintain a synchrony, so that when you are done with main app and you revise the rapid revision, you have a better synchrony. And all the chapters has been revised in a tabular form for a better retention. So I think once you cover this rapid revision, you will cover most important points of anesthesia very quickly. And one more very important thing is that all the images which I have covered in my main app has also been covered in the respective chapters in rapid revision also, so that you don't miss any image-based question and you revise all the image along with rapid revision as well. So let us start with rapid revision. The first thing which I will tell you would be what are the topics which we need to cover in this. So let us start with rapid revision of anesthesia. So what are the topics that we have to cover? Well, we all know that anesthesia is basically divided into two broad divisions, that is general anesthesia and regional anesthesia. General anesthesia and regional. Okay. So I will also divide my topics in these two. But before going into independent specific topics of these two broad divisions, there are a few common things which we do in any patient coming for any type of anesthesia, whether general or regional. Okay? They all need to have a pre-anesthetic evaluation done. Pre-anesthetic evaluation. So, first topic which I will discuss with you in rapid revision would be a revision of pre-anesthetic evaluation. Second, whether I take a patient for general anesthesia or regional anesthesia or even for a monitored anesthetic care or simple sedation, I need to attach certain monitors. So monitoring, what are the important monitors which we need? So monitoring in anesthesia would be our second topic. So important monitors I will rapidly revise for you. Third would be, before I take any patient for any kind of anesthesia in operating room, we always have to keep our anesthesia machine ready. We have to keep our airway circuits ready. In general anesthesia, these equipments are required to give anesthesia. And in regional, we keep it as a backup that if any complication happens or any mishap happens, I can take my patient on, let's say, on anesthesia machine, and let's say I can manage any complication of my patient. So the third topic would be anesthesia machine. So I will rapidly revise anesthesia machine as your third topic. Fourth topic would be anesthesia circuit or breathing circuit, whatever you want to say. Fifth topic would be airway. Okay. After completing these 5 topics, I would discuss with you the specific drugs which we use for general anesthesia. So what are the drugs which we use for general anesthesia? Guys, when I say I'm giving general anesthesia to my patient, then what are the components of GA? What exactly I give to my patient? So what are the important components of general anesthesia? Components of GA. Well, the first thing when I say I'm giving general anesthesia to my patient is I make my patient unconscious. I put my patient in sleep so that he doesn't have any awareness of the procedure being done on him. So loss of consciousness. So first component of GA is loss of consciousness. Second is loss of reflex response. Loss of reflex response. Third component would be amnesia. We provide a perioperative amnesia. Fourth, analgesia. Fifth, muscle relaxation. So when I say GA, these are the 5 important components I provide to my patient. And I'm not using one drug to provide all these 5 components. I'm using multiple drugs. So what we provide today is balanced anesthesia, something called balanced anesthesia. Now balanced anesthesia, an important term given by Dr. John Lundy and Dr. Ralph Waters. So Lundy and Waters gave the term balanced anesthesia, which means use of multiple drugs for the different component of general anesthesia. Okay, so to provide all these components, we are using multiple drugs. Okay, so those are the drugs which we will cover in the topics of general anesthesia. Now, how do I give general anesthesia? Before I tell you those drugs, how do I give general anesthesia? What are the steps of general anesthesia? So the first step is loss of consciousness or induction, we call it induction. And how do we induce? Either by intravenous anesthetic agent or by inhalational anesthetic agent. Inhalational anesthetic agent. After induction, well, induction means only from consciousness to unconsciousness. But I have to maintain this unconsciousness as long as the surgery has to go on. So the second step of general anesthesia is maintenance of that unconsciousness. So maintenance of unconsciousness. Maintenance of unconsciousness. And how do we maintain? Same way, by continuous intravenous anesthetic agents infusion or by continuous inhalational anesthetic agent through anesthesia machine given to the patient. So same way, intravenous or inhalational. So guys, you can notice that there are 2 ways of induction and there are 2 ways of maintenance. So induction and maintenance can be done by 2 ways, either IV or inhalational. And for both, if I am using intravenous for induction also and for maintenance also, then we call it TIVA. What is this TIVA? TIVA is total intravenous anesthesia. Total intravenous anesthesia. Right? And when I am saying TIVA, the most common drug which we are using is propofol. Okay. After completion of the surgery, I need to make my patient conscious again. And the third step of general anesthesia is our reversal of general anesthesia. Okay. How do I reverse? Simply by stopping my anesthetic agent and helping my patient in consciousness in return of his muscle power by giving some reversal agents. So we will discuss all these things. So very important that before induction, depending upon the requirement of the patient, there is one more thing which we can do. We may or we may not do is pre-oxygenation. Pre-oxygenation. Guys, it is not necessary that you always pre-oxygenate every patient taken for elective general anesthesia. So what do I mean by pre-oxygenation? I mean giving 100% of oxygen to the spontaneously breathing patient for 3 to 5 minutes. So that all the nitrogen of the alveoli replaced by oxygen, and if patient stops breathing, then the oxygen content of the alveoli would last for, let's say, 8 to 10 minutes and there would not be any hypoxia. If I am breathing room air and if I stop breathing, then the oxygen content would not last for more than 3-4 minutes. But after pre-oxygenation, it will last for 8 to 10 minutes. So I am increasing the time for which I can maintain, let's say, no breathing in the patient. So we call it pre-oxygenation. Okay. So it is not a mandatory thing. We may do or we may not do depending upon the type of the patient and our requirement. So these are the steps. So for all these components and the step for general anesthesia, we use certain drugs. So let us say what would be our 6th topic. Our 6th topic would be the first drug for general anesthesia which I am using, that is inhalational anesthetic agent. Inhalational anesthetic agent. The seventh topic would be intravenous anesthetic agent. And the eighth topic would be neuromuscular blocker. Right? Now see guys, inhalational and intravenous anesthetic agents are used for induction and for maintenance of anesthesia. Right? So they are used to produce loss of consciousness, and along with loss of consciousness they also produce loss of reflex response and amnesia. So these three components are produced uniformly by all the drug which is we will discuss in inhalational and intravenous anesthetic agent. Now analgesia, some of inhalational intravenous can provide, some may not provide. Okay, for analgesia we may use some other drugs like we can use opioids, etc. And for muscle relaxation we specifically use our neuromuscular blocker. Neuromuscular blocker. Neuromuscular blocker, the third group of drugs which I will discuss with you, they do not produce unconsciousness. They are only used to produce a muscle paralysis. As a result of paralysis, we get a muscle relaxation. So this would be our eighth topic. Now the ninth topic would be the drugs which we are using for regional anesthesia. So before coming on the ninth topic, regional anesthesia. Now guys, in general anesthesia, I made my patient unconscious. But in regional, I am not making my patient unconscious. Only the part which has to be operated is anesthetized. Let's say if I have to get a surgery done on right upper limb, I give a block which would anesthetize my right upper limb. Let's say I block right brachial plexus, which supply the sensory, motor and autonomic supply of the right upper limb. So if I block the right brachial plexus, what will happen? This limb will get anesthetized and a surgery on this limb can be done, but the patient is not unconscious and rest of the part of the body has all the sensation and all the power, etc. Okay, so this is regional anesthesia. So to produce regional anesthesia, we need to locally deposit the drug near the nerve fiber we want to block. And the drug which we use would be our ninth topic, that is our local anesthetic. The drug we use for regional anesthesia, local anesthetics. Okay. The 10th topic would be central neuraxial blockade, a special type of regional anesthesia in which we block spinal nerve roots. That is central neuraxial blockade. In central neuraxial blockade, we will discuss spinal anesthesia, that is subarachnoid block, and epidural anesthesia. Epidural anesthesia. Okay, so these two topics we will discuss in central neuraxial blockade. Now, after anesthesia, any kind, general or regional, we shift the patient. We shift the patient to post-op room, and if the patient requires, right, any oxygen, then we give oxygen through different oxygen delivering devices. So I would discuss as my 11th topic as oxygen therapy. Oxygen therapy, in which I will tell you about different oxygen delivering devices. Different oxygen delivering devices. Okay. Now all the patients under anesthesia and also on post-op needs to be given certain fluids, certain amount of fluids. So a little bit I will tell you about peri-operative fluids as my 12th topic. And then last I will talk about CPCR, that is cardiopulmonary cerebral resuscitation. That is, if any cardiac arrest happens, how do we manage that cardiac arrest? So I'll talk about cardiopulmonary cerebral resuscitation. Or popularly called CPCR. So these are the 13 topics which I will discuss in rapid revision. Okay, so let us start our rapid revision. First topic, and that is pre-anesthetic evaluation. Pre-anesthetic evaluation. So whenever I get a patient for any kind of anesthesia, how do I do a pre-anesthetic evaluation? The first thing I do, I take a focused history. In this focused history, apart from routine history which we ask, two important things which we focus on is that of previous anesthesia exposure. Patient had any previous anesthesia exposure, and we also focus on anything important about comorbidity of the patient. Comorbidity, any relevant comorbidity present in the patient, which will affect our plan of anesthesia. And this history is very important because it will help us in planning a couchered anesthesia plan for the patient. Okay, so how do I take history? Like any routine history, we take the medical history, we take surgical history, right? After this, we do a general examination, okay? We do systemic examination. One very important thing which we do apart from routine examination in anesthesia history is in anesthesia pre-anesthetic evaluation is airway evaluation. So very important thing is airway evaluation, which I will talk in little detail. And after this, certain routine investigation we need to see in patients. So certain routine investigation depending upon the comorbidity of the patient, depending upon the type of surgery. So routine investigation. After doing all these things, the first thing which we do is give a ASA grading to the patient. We do a American Society of Anesthesiologists grading, or popularly known as ASA grading. Okay. So very important, guys. This grading system was developed for elective surgery firstly. So we have ASA grade 1 to 6, which I will discuss with you, which was for elective surgery. Now this grading system was also used for emergency surgery later on. So it became ASA grade 1E to 6E. E stands for emergency surgery. Let us discuss ASA grade 1 to 6. What is ASA grade 1? ASA grade 1. ASA grade 1 means patient does not have any comorbidity. He is a healthy patient and has come for some surgery. So, no comorbidity. Okay. Then ASA grade 2. ASA grade 2 means patient has a comorbidity, but it is a thoroughly controlled comorbidity. Patient is maybe on some medication and has a very good compliance for that medication, and due to that comorbidity, patient has no limitation on his any activity. So, controlled comorbidity. ASA grade 3. Patient has a comorbidity and he is on some medication for that comorbidity, and he can carry out his normal activities, his day-to-day activities. He can also carry out strenuous activity, but while doing that strenuous activity, he becomes symptomatic. For example, if I ask my patient that, can you do normal activities like bathing, walking, sleeping, etc., normal activities? Yes, doctor, I can do it, he will reply. And if I ask, can you play football? I can, doctor, but I become dyspneic. I can run, doctor, but I become dyspneic. I can walk for 5 miles, doctor, but I become dyspneic. So patient has a comorbidity which is posing a moderate limitation on his activities, right? On strenuous activity. So, comorbidity with moderate limitation. Comorbidity with moderate limitation. ASA grade 4. Now, patient's comorbid condition is in such a deteriorated state that patient is symptomatic even at rest. Now, surgery and anesthesia requires more than normal cardiac output. And because of the comorbid condition of the patient cannot even maintain a normal cardiac output to do the normal activities. He is symptomatic even at rest. So, this is ASA grade 4. That is, comorbidity is a constant threat on his life. So, comorbidity is a constant threat on his life. Now, remember, ASA grade 4 patient is never taken for elective surgery. Patient is optimized. And once the optimization is at fullest, then a risk-benefit ratio is done. And if the benefit of surgery is more, then only patient is taken for surgery. ASA grade 5. Surgery is the only option for survival. Surgery is the only option for survival. Patient will die if not operated. So in desperation, I have put the patient for surgery. Even with surgery, chances of survival is less, but whatever chance he has if the surgery is done. So we have put the patient for surgery. This is ASA grade 5. And what is ASA grade 6? ASA grade 6 is comatose patient for organ transplantation. Comatose patient for organ transplantation. Organ transplantation. So this is our ASA grade 1 to 6. It is important from exam point of view. Now, apart from this ASA grading system is done for all the patient, routine normal patient presenting for any surgery. Now, apart from this ASA grading, there are few other grading systems, which is special grading system done in a special population of the patient. Like if the patient has some cardiac disease, patient with cardiovascular comorbidity presenting for a non-cardiovascular surgery, for let's say non-cardiovascular surgery. So in these patients, some special grading system is done to assess the risk associated with surgery. You just need to remember the name of the grading system, and that one important grading system is Goldman grading system. In this Goldman grading system, a risk assessment is done for the patient with cardiac disease presenting for a non-cardiac surgery. Now, after grading, this is a special thing. This is a special thing done for only patient presenting for surgery with a cardiovascular comorbidity. Okay. Now, apart from this grading system, once we have graded the patient, a very important thing which we need to do in any patient presenting for anesthesia is airway evaluation. So, we have to do something called airway evaluation. How do we do airway evaluation? Right from beginning from the history only, we start evaluating the airway. So, in history, when we take the history of the patient, we always ask about previous anesthesia exposure, and during that exposure, any airway mishap or not happened to the patient or not, or any other mishap related to anesthesia like malignant hypothermia, etc. So, history of previous anesthesia exposure, and during that any airway mishap. Then after that, evaluation, physical evaluation of the airway, physical evaluation. In physical evaluation of the airway, lot of things are done, like patient's Mouth opening is assessed. Mouth opening is assessed. After assessing mouth opening, the different joint movements which is required for securing the airway is also assessed, like atlanto-occipital joint and neck joint. So, atlanto-occipital joint movement and neck joint movement is also assessed. Then a very important thing is assessed, that is the distance between mentum and hyoid bone or mentum and thyroid bone, that is mentohyoid or mentothyroid distance. So, mentohyoid on mentothyroid distance. This gives us an idea whether the patient can be made in the position for airway securement or not. So, by measuring the mentohyoid and mentothyroid distance, we get an idea whether the patient proper positioning for the airway securement can be possible or not. After this, the neck circumference. The neck is inspected for whether the patient has short neck or etc. So, neck circumference is evaluated, and very important evaluation which is asked in exam, I'll discuss with you. We do something called Mallampati grading. Mallampati grading. What is this Mallampati grading? What I am doing at present, I am doing a pre-anesthetic evaluation. So, Mallampati grading is pre-anesthetic evaluation of airway to assess difficulty in intubation. Difficulty in intubation. So, how do we assess difficulty in intubation by this Mallampati grading? We ask the patient to open his mouth and take his tongue out. I make the patient in sitting position in front of me, ask him to open his mouth and take his tongue out. And then I peep inside his oral cavity and try to see the structures of oral cavity. If I am able to see all the structures, then we write Mallampati grade 1. If I miss one or two structures, then grade 2. And if I see only one, let's say hard palate, soft palate, then grade 3 and only hard palate grade 4. So what I am doing in this, why I am trying to see the structures? I am trying to just evaluate the size of tongue with respect to oral cavity. Why I am trying to see the structures? Because I am trying to evaluate the size of tongue. If the tongue is of bigger size, the structures won't be visible. And if the tongue is bigger, then it would be difficult to take the tongue out of my way during laryngoscopy for intubation, right? So just see in this image, this is Mallampati grade 1 to 4. You can see this is Mallampati grade 1. In Mallampati grade 1, all the structures of the oral cavity is visible, that is hard palate, soft palate, tonsillar pilus, uvula and fauces. Tongue is of normal size. Now tongue has gradually increased in size and one or two structures are now obscured. Let's say tonsillar pillars are not clear in this. Hard palate and soft palate and uvula is visible, but tonsillar pillar is not clear. Now tongue has further increased in size and now only hard and soft palate is seen, and let's say base of uvula is also not seen. The tongue further increases in size, the only hard palate is seen. As the tongue increases in size, then difficulty in intubation increases. So, Mallampati grade 3 and 4, large tongue and large tongue, so difficult intubation. Okay. Mallampati grade 1 and 2, normal tongue, no difficulty. Now guys, remember as we wrote that this is a pre-anesthetic evaluation. For evaluating airway for difficulty in intubation. Now there is another way in which we evaluate for difficulty in intubation, a popular method, but it is not a pre-anesthetic evaluation. Just see this image. This is something called Cormack-Lehane system for grading laryngoscopic view at intubation. When we do laryngoscopy, how much the glottic opening is visible is graded by something called Cormack-Lehane system in 4 grades: grade 1, grade 2, grade 3, grade 4. You can see if when I do laryngoscopy an entire glottic opening is visible, we write grade 1. If let's say only posterior part of the glottic opening is visible, we write grade 2. Let's say if only your glottic opening is not visible, only the epiglottis is visible, then we write grade 3, and when even epiglottis is not visible, we write grade 4. This is not a pre-anesthetic evaluation. This is evaluating difficulty in intubation, but not a pre-anesthetic evaluation, but a laryngoscopic view. So grade 3 and grade 4, difficult intubation, because glottic opening is not visible, right? Grade 1 and 2, intubation is possible. So this is also a grading system for assessing difficult intubation, right? Difficult intubation, but not a pre-anesthetic evaluation, right? Laryngoscopic view. So we discussed Mallampati grading for airway evaluation. So after airway evaluation, the next important thing is we give pre-anesthetic order. Pre-anesthetic order. In pre-anesthetic order, 3-4 things are very important. First, we have to always take a written informed consent regarding surgery and anesthesia. We have to see the consent has been taken. Second, we have to give order regarding nil per oral, NPO orders. For NPO orders, for adult, you need to remember 2 hours and 6 hours. 2 hours NPO for clear fluid. So I asked the adult patient, they can take water till 2 hours prior to surgery. But after, let's say if surgery is at 8 o'clock, till 6 o'clock he can take clear fluid like water or apple juice without particulate. 6 hours NPO for semi-solid like khichdi, etc. So these 2 you have to remember for adult, and for pediatric you have to remember a few more. We have to remember 2 hours, 4 hours and 6 hours. 2 hours NPO for clear fluid, 4 hours NPO for breast milk, mother's milk. So if child is on exclusively breastfed, I ask the mother to, if the surgery is at 8 o'clock, to feed at, last feed to be given at 4 o'clock. 6 hours NPO for semi-solid and outside milk or formula milk like cow's milk, the outside milk, or formula feed like lactogen, etc. So 6 hours NPO. And for both adult and pediatric, we need to keep 8 hours NPO for full fatty meals. So still 8 hours NPO for full fatty meals. Okay, so this you have to remember for the NPO order. Now, third important thing we need to give in pre-anesthetic order is order regarding previous medication. Patient may be on many medications, so which medication he has to continue, which medication he has to stop. There should be a clear-cut order regarding that. So orders regarding previous medication. First order, some oral antihypertensive medication. Now all antihypertensive medication has to be continued. None has to be stopped. Continue till the day of surgery. So I'll ask my patient to take his antihypertensive with a sip of water even on the morning of the surgery. Continue till the day of surgery. Then oral hypoglycemic. Oral hypoglycemic agent. Oral hypoglycemic agents. If patient is posted for minor or moderate surgery, then we simply ask the patient to omit the last dose. Omit the last dose. The last dose which the patient has to take prior to surgery, patient has to stop it, not to take it, and nothing else. But if it's major surgery, then whenever we stop the hypoglycemic agent, the blood sugar level will get increased or blood sugar level will get deviated, right? And for major surgery, we need to have a tight glycemic control. So we ask the patient to omit the last dose because we have to keep NPO also. And if we will not omit oral hypoglycemic, patient can go into hypoglycemia. So we ask to omit the last dose and put patient on insulin. Put patient on insulin. What we do? That we check the blood sugar level and accordingly we give the insulin and try to maintain the blood sugar level. Okay. So this is for oral hypoglycemic. Third, antipsychotic, antidepressant, anti-epileptic. So these three has to be continued till the day of surgery. Only remember, tricyclic antidepressant, stop 3 weeks prior to surgery. 3 weeks prior to surgery. And lithium, which we use for bipolar mood disorders, stop 24 to 48 hours prior to surgery. Okay, so lithium we stop. Patient on thyroid medication. Continue till the day of surgery. Continue. Fifth, anticoagulant. Remember guys, if patient is on anticoagulant like aspirin, clopidogrel, ticlopidin, low molecular weight heparin, continuation of anticoagulant can cause a lot of let's say problem during surgery like bleeding, etc. But discontinuing can also cause problem because they are started for some reason. So there are some special recommendations which we need to follow. Let's say for aspirin, continue till the day of surgery. Continue till the day of surgery. Okay. We don't stop aspirin nowadays. Now rest we stop. And what the recommendation? Clopidogrel. Stop 5 to 7 days prior to surgery. 5 to 7 days prior to surgery. Well, I am rating 5 to 7 days. Remember, nowadays for general anesthesia, prior to general anesthesia, they are stopped only for 5 days. But for regional, still we follow 7 days stoppage of the clopidogrel. If it is not mentioned the type of anesthesia and clopidogrel stoppage has been asked in exam, go for 5 days as answer. Okay. Then ticlopidin. Stop 14 days prior to surgery. Then warfarin. Stop 3 to 4 days prior to surgery. Then low molecular weight heparin. Stop 12 to 24 hours prior to surgery. 12 to 24 hours prior to surgery. Then unfractionated heparin. Stop 6 hours prior to surgery. Okay, so this is for the anticoagulants. Now, very important. Now, patient may be on multiple anticoagulants after coronary stenting. And if you stop the anticoagulants, then stent thrombosis can happen. Now, regarding coronary stenting, coronary stenting has been done. Two type of stent would be placed: bare metal stent. Bare metal stent. We need a gap of 1 month before elective surgery. So, a bare metal stent has been placed. You cannot stop anticoagulants prior to 1 month. So, you need a gap of 1 month before elective surgery. And for medicated stent, you need a gap of 1 year before elective surgery. Okay, so you need a gap of 1 year before elective surgery. Next group of drug which you need to know is steroids. So if a patient is on steroids, then what do we do? Well, if a patient is on a regular steroid therapy, or let's say steroid for even more than 3 to 5 days, then it's a possibility that his hypothalamic pituitary axis would be inhibited and cortisol synthesis would be affected. And during stress, we need a more dose of cortisol. So if hypothalamic pituitary axis is inhibited and cortisol synthesis is inhibited, then there would be problem for the patient. So during, let's say, patient on regular steroid, we go for continuation of steroid with a perioperative supplementation. So continue with perioperative supplementation. Okay. Number 1, this continuation has 3 contraindications. We cannot continue steroid in 3 conditions. So this recommendation has 3 contraindications. Number 1, diabetes. For diabetic patient, we need to stop. Then active infection and immunodeficiency. In these 3 conditions, we need to stop steroid. Okay. 7th, herbal medication. We don't know what are present in those medications, so stop 6 to 8 weeks prior. 8th, hormone replacement therapy. OCP need not to be stopped, oral contraceptive pill. But a patient on high dose estrogen, hormone replacement therapy, stop 6 to 8 weeks prior. So this is the recommendation for our previous medication. Apart from this, there is no strict medication for any other drug. Most of the other drugs can be continued till the day of surgery. Okay. Now, after giving the order regarding previous medication, the next important thing which is important is we have to prescribe medication, pre-operative medication for few reasons. Number 1, to allay anxiety in the patient. Number 2, to decrease pain, that is for analgesia if the patient is having some pain. To decrease reflex response in some patients. It may not be given in all the patients. 4th, to decrease secretions. And the 5th is for anti-aspiration prophylaxis. Now, it's not necessary that every patient is given anti-aspiration prophylaxis or medication to decrease secretion. It depends upon the type of surgery and the requirement of the patient. Okay. Now, the one drug which is prescribed to maximum of the patient is an anxiolytic to allay anxiety. So, for anxiolysis, the most important drug which is used is benzodiazepine. Benzodiazepine. And three important drugs you have to remember in this: midazolam, diazepam, and lorazepam. We also use anticholinergic drug for pre-medication, in which three important drugs we need to remember: atropine, glycopyrrolate, and scopolamine. Now, anticholinergic drugs are used for pre-medication for three main roles. Number one, to decrease secretion as antisialol. Number two, for sedation. And number three, to decrease the reflex response. To decrease reflexes, that is as a vagolytic, right? For vagolytic, the best drug is to be used is atropine. For sedation, the best drug to be used is scopolamine, and to decrease secretion, the best drug to be used is glycopyrrolate among anticholinergic. This is specifically asked in exam. The role of anticholinergic in pre-anesthetic medication, you have to remember these are the three important roles for anticholinergic. Now, we also go for antibiotic prophylaxis. We go for pre-op antibiotic prophylaxis. And here the question is asked, what is the best time for antibiotic prophylaxis? So remember, for antibiotic prophylaxis, best time to give antibiotic prophylaxis is 1 hour prior to induction, 1 hour prior to the surgical incision. So, pre-operative antibiotic best time, the recommendation is to give 1 hour prior to surgical incision. Okay. Actually, in books, two things are mentioned: at the time of induction and 1 hour prior to surgical incision. At the time of induction, we try to avoid it because both antibiotic and anesthetic agents can cause anaphylaxis reaction. So, if we are giving multiple drugs at same time, which drug would cause anaphylaxis, it is difficult to ascertain. So, that is why at the time of induction, we try to avoid giving any antibiotic to the patient. Okay. So, this is about our antibiotic prophylaxis, and this is all about our pre-anesthetic evaluation. So, after, let's say, we have evaluated the patient, and now patient has followed all the recommendation of pre-anesthetic evaluation, has followed all the pre-anesthetic orders, and he has now come for surgery. So, now we have to attach certain monitors. So, what are the monitoring in anesthesia? Monitoring in anesthesia. What are the important monitors which we need to attach? Monitoring in anesthesia. Guys, according to the ASA guideline, American Society of Anesthesiology guideline, any patient presenting for any type of surgery, the level 1, the standard 1 says that a registered anesthesiologist should be present in the operating room. So, presence of registered anesthesiologist is mandatory. This is the standard 1. This cannot be replaced. And the standard 2 says that we need to have a continuous monitoring of oxygenation, ventilation, metabolism, temperature of the patient, for which we need to attach certain monitors. So according to the standard 2, there are 5 mandatory monitors. 5 mandatory monitors. What are the 5 mandatory monitors? Number 1, ECG. Number 2, non-invasive blood pressure monitoring, that is NIBP. Number 3, pulse oximetry, Number 4, capnography, and number 5, temperature monitor. Continuous temperature monitoring. Okay, for ECG, remember guys, lead 2 and lead V5. Lead 2 and V5 are the most important lead. Lead 2 to diagnose any arrhythmia, most sensitive, and V5 for any MI, for myocardial infarction. So these are the 2 things which we need to monitor through ECG. Non-invasive blood pressure monitoring is must. We have to attach to every patient. Now, apart from non-invasive blood pressure monitoring, we have invasive blood pressure monitoring, which is only attached in certain surgeries in which massive blood loss is expected, like any neurotumor surgery, neurosurgical surgery, or massive, let's say, tumor, or let's say a lot of fluid shift is expected out of the surgery, right? Then only we attach invasive blood pressure monitoring. But non-invasive is mandatory. We have to attach it in every surgery for any kind of anesthesia. Pulse oximetry, that is SpO2 probe, we attach to every patient. Capnography, and what does pulse oximetry measure? It measures oxygen saturation of arterial blood. And what about capnography? Capnography is graph of expired carbon dioxide against time. Expired carbon dioxide against time. And temperature monitoring is also must. We have to monitor core temperature. And for core temperature monitoring, we have certain sites which I will just tell you in few minutes. Okay, first monitor, apart from these 5 monitors, there are few more monitors, and you need to remember name of 2 more important monitor, which I am writing as 6th and 7th monitor. They don't come under mandatory monitor, but they come under something called a desirable monitor, which you need to attach to any patient during general anesthesia. 6th is your BIS monitoring, bispectral index, that monitors the depth of anesthesia, that is BIS. And 7th is neuromuscular monitoring, which monitors the adequacy of neuromuscular blockade. So remember that BIS monitoring monitors depth of anesthesia, and neuromuscular blockade monitors adequacy of neuromuscular blockade. So these are both desirable monitor, and any patient under GA, if we have the provision, we should attach the desirable monitor also. Now apart from this, we have other monitors also, which as and when required we put. So other monitors are attached when required. Other monitors are attached when required, like your CVP monitor, central venous pressure monitoring, or your pulmonary artery pressure monitoring, right? Your, let's say, transesophageal echocardiogram. It depends upon the type of surgery. For cardiovascular surgery, we normally attach it. That's called T monitor. So other monitors as and when depending upon the type of surgery we attach. Got my point? Okay. So there are a few monitors which I need to tell you in little detail, and the first monitor which I will talk about is capnography. Capnography. So let us talk about capnography. Now what is capnography? Capnography is graphical representation of expired carbon dioxide against time. So when we expire, the expiratory gas would have carbon dioxide, and this is being monitored in a graphical form. How do we get this carbon dioxide? And so exactly what does capnography monitors? Let's say the carbon dioxide, how we get it. This is, let's say, your anesthesia machine. From machine, the circuit is attached. Okay. And circuit is in turn attached to the airway of the patient, and this is the patient lying on the OT table, and this patient is being operated. Now this patient who is being operated, we are giving gases continuously from anesthesia machine. What are the gases which we are giving to the patient? We are giving to the patient nitrous oxide, oxygen, and let's say an inhalational agent for maintaining the anesthesia. This nitrous oxide and inhalational agents are being used for anesthesia. Oxygen which we are giving to the patient, it is being used for carrying out the metabolism of the patient. So inside the body, and for metabolism we need a continuous supply of oxygen. And by this metabolism, carbon dioxide is excreted as the byproduct by tissues and cell. And this carbon dioxide which is produced by metabolism, this carbon dioxide production is by metabolism. If in body metabolism is happening, then only the carbon dioxide will be produced. Circulation, the blood carries this carbon dioxide. This carbon dioxide is carried by circulation, blood, right? And this carbon dioxide reaches the pulmonary capillaries and exchanged through alveolar ventilation. And along with other gases, this carbon dioxide comes out in the airway and enter the circuit, the expiratory limb of the circuit. So in between the airway of the patient and the circuit, there is a monitor attached, the CO2 capnograph. This is the monitor capnograph. So when this CO2 passes through this capno, a graphical representation of CO2 comes on the monitor. So what did I say? By metabolism, this carbon dioxide is being produced. By circulation, it is being carried, and CO2 is being exchanged, and it comes out in the external artificial airway from the natural airway through ventilation. So through ventilation, the CO2 is being exchanged, and as a result, the monitor senses the CO2 and gives the graph on the screen. This is CO2 graph against time. If I see this graph, I am very happy, because if this graph is coming, metabolism is normal, circulation is normal, and ventilation is normal. If any problem would happen in these three, the graph would not be there. So let's say the surgery was going on, the graph became flat. If this graph becomes flat, what would be the differential diagnosis? So differential diagnosis of flat capno. Flat capnogram. First thing which we need to see, that whether the ventilation is being done or not, is happening or not. Let's say this tube in the patient, this got detached, this came out, accidental extubation. Surgeon manipulated the head and tube came out. If tube would not be there, the endotracheal tube, the artificial airway of the patient, then the patient ventilation is not possible. So accidental extubation. But let's say if tube is there and then also I am getting a flat capno, then there is a possibility the circuit got disconnected. If the circuit will get disconnected, again no CO2. If circuit was also there and then also I am getting a flat capno, then it's a possibility that ventilation is not happening. Let's say the ventilator of the machine is not working. Ventilator has stopped. Or let's say the airway of the patient is totally obstructed, then also ventilation is not possible. So all these 4 DDs which I just now told you, accidental extubation, right? Circuit disconnection, then third is your stoppage of ventilator, that is stoppage of mechanical ventilation, of mechanical ventilation. Fourth, absolute or complete bronchospasm, that is complete obstruction of the airway, absolute bronchospasm. All this will stop the ventilation to happen. This will stop the ventilation and I'll get flat capno. Ventilation will stop, then only I will get flat capno. If ventilation is happening and then also I am getting flat capno, it means metabolism has stopped. Let's say, or circulation has stopped. Let's say patient is in cardiac arrest. So cardiac arrest patient will also have flat capno. And sixth, if the tube accidentally goes into esophagus, it comes out of the trachea and migrates into esophagus. Or when I am putting the tube goes into esophagus, then also I'll get flat capno. Well, the short confirmation of correct placement of ET tube is capnography. So, esophageal intubation. Esophageal intubation. So, 6 DD is esophageal intubation. Okay. So, these are the 6 DDs of flat capno. So, now let us discuss a normal capno and few abnormal capnograph. Okay. Now, see this graph. This is a normal capnograph. How do I get this normal capnograph? Now, this is your ET tube. This is your ET tube and this is your circuit. Okay. During inspiration, the inspiratory gas will go from circuit and it will enter the ET tube. And during expiration, the expiratory gas will come out of the ET tube and enter the circuit. In between the two is a monitor called capno, as I told you. So, let's say respiratory cycle comprises of inspiratory phase and expiratory phase. During inspiration, there is no carbon dioxide. So, during inspiration, the graph would be on the baseline. The graph would be on the baseline. This is the inspiratory phase. The graph would be on the baseline. I'll come on the graph. During expiration, first gas which we expire is dead space gas. Dead space gas. Dead space gas, which does not have carbon dioxide. So, expiration has started, but CO2 is still 0. Now, in dead space gas, alveolar gas will mix. Alveolar gas. So, alveolar gas will have CO2. So, what will happen? The graph will start ascending. Now, the third phase, only alveolar. No dead space gas. All dead space gas has been removed. So, fixed amount of CO2. So, till here, there is expiration. Expiration is happening. Okay. Phase 1, dead space ventilation. Phase 2, dead space plus alveolar ventilation. Phase 3, only alveolar ventilation. And now phase 4. Phase 4, inspiration has started and it will touch the baseline because inspiratory gas will have no CO2. So, this is phase 4 is inspiration. Phase 4 is inspiration. Okay. So, this graph has 4 phases, 1, 2, 3, 4. You can see in this graph also, phase 1, that is dead space ventilation. Phase 2, this is phase 1. Phase 2, ascending, that is alveolar gas begins to mix with dead space. So, ascending. Phase 3, only the alveolar gas. And phase 4, inspiration, inspiratory phase, right? Inspiratory phase. Expiratory phase and inspiratory phase. Again, after inspiration, again a expiratory phase will come. Again, inspiratory phase will come. So, I will get this graph. Okay. So, remember this graph has 4 phases. And what is the normal value of EtCO2 graph? The normal value of EtCO2 graph is, the normal numerical value is 35 to 45 mm of Hg. So, if there is a normal metabolism, or normal circulation and normal ventilation, I will get this 35 to 45 mm of Hg. In case of any abnormality in ventilation, metabolism or circulation, the numerical value will also vary. So, if we just see that normal value of EtCO2, which I told you is 35 to 45 mm of Hg, it will increase, this value of EtCO2 will increase if CO2 production in the body will increase, as in case of hypermetabolism, as in case of hypermetabolism. or if we start ventilating at a lesser rate and CO2 is getting retained in the body in case of hypoventilation. And EtCO2 value will decrease in case of hypometabolism and in case of hyperventilation and in case of hypoperfusion, if perfusion is not good, hypoperfusion. If the perfusion is not good, CO2 will not be carried to the pulmonary capillaries for any exchange. Now, hypermetabolism like fever, malignant hypothermia, right, which can double the triple the value of CO2, or shivering, all this will cause increase in CO2 value, especially this malignant hypothermia, which you have to remember. Hypoventilation, if the respiratory rate of the patient is not adequate, less respiratory rate, CO2 will be retained. Now, in hypometabolism, what are the conditions of hypometabolism? Hypothermia, anesthesia, it will also decrease the metabolism of the body. Hyperventilation, if patient is ventilating at a higher rate, or we are ventilating the patient at a higher rate, CO2 will get cleared very fast. And hypoperfusion, like your embolism. In case of embolism, CO2 value will decrease because perfusion will be affected, decrease. Or high shock, hypovolemic shock. In case of shock also, the CO2 value will decrease. Okay. So now I have told you a normal graph, the phases of the normal graph, a normal value, and when I will get abnormal value, increased or decreased. Now let us discuss few abnormal graphs. Now see this. This is a normal graph, and what is happening? The graph is of normal shape, but the CO2 value is gradually decreasing. This can happen in hyperventilation if I am ventilating the patient at a very high rate, right? So a gradual decrease in CO2 value can happen in hyperventilation. Like instead of keeping the respiratory rate 14-15, I am keeping it at 20-30. So CO2 is getting cleared very fast and value is decreasing. This can also happen if this is happening suddenly. See, if this is a normal graph which is at 40 and there is a sudden drop. This sudden drop to 20, sudden drop. What did I tell you? That graph, the EtCO2 value will decrease in case of hyperventilation, in case of hypometabolism, and in case of hypoperfusion. Sudden decrease, sudden drop, hypoperfusion, sudden hypoperfusion, embolism has to be suspected. Air embolism during anesthesia or surgery. Air embolism has to be suspected. So sudden drop, right, means sudden decrease in the perfusion, and sudden decrease in the perfusion, air embolism, a very notorious cause during anesthesia and surgery. Okay, so remember, sudden drop of CO2 value, you have to diagnose air embolism. So see this next graph, gradually it is increasing, okay. So this can happen in hypoventilation. So instead of 14-15 breath per minute, I am giving 3-4 breath per minute. CO2 is gradually increasing in the blood and increasing in the expiratory gas also. Or if you see that CO2 value from 40 has suddenly increased to 80, sudden increase or a gradual sudden increase, whatever, this doubling, tripling of CO2, definitely the production of CO2 in the body has increased, and your blind answer has to be malignant hyperthermia. Malignant hyperthermia. Remember, this is important. So doubling or tripling of CO2 during surgery anesthesia, go for answer as malignant hypothermia. Okay. Next, so two things I have shown you. Hypoventilation. What is happening in hypoventilation? The CO2 value is gradually increasing, and I am comparing it with something called rebreathing. What is happening in this below graph? In this below graph, this baseline is getting elevated. This is a normal graph, and when the baseline gets elevated, that is, it is not touching the baseline of the graph. That is, EtCO2 is not zero even in dead space, during dead space ventilation, or when inspiration is also happening. That means patient is rebreathing carbon dioxide in the inspiratory gas. So that means the expiratory and inspiratory gases getting mixed. So this is a graph in which the baseline gets elevated, baseline elevation. This means a graph of rebreathing. This is a graph of rebreathing. And when this will happen? If CO2 absorber has exhausted, the circuit CO2 absorber has exhausted. Okay, or mixing of inspiratory and expiratory gases due to incompetence of the valve of the circuit. So mixing of inspiratory and expiratory gases happening. Okay, so I am getting carbon dioxide rebreathing. Next graph, I told you if there is a sudden doubling, tripling of CO2, we have to suspect malignant hyperthermia. So graph, the shape would remain normal, but the graph value, the EtCO2 value will double or triple. Now this is a very important graph. This is called shark fin pattern. Shark fin pattern. What do I mean by this? When a group of sharks swim in the ocean together, above the water, this pattern comes above the water. This is called shark fin pattern, and this pattern comes in partial obstruction. This is a graph of partial obstruction of the airway. So partial obstruction, complete obstruction of the airway will happen, then I will get a flat capnum. But if there is a partial obstruction, I'll get a shark fin pattern, and this we will get in bronchospasm. This we can get in your ET tube obstruction, partial obstruction, ET tube obstruction. This we can get in COPD. This we can get in bronchial asthma. Any reason, if the caliber of the airway has decreased, I'll get a shark fin pattern. So remember, shark fin pattern in partial obstruction. Next important graph. In a normal graph, I start getting this cleft. This is called curare cleft, and this is important. This means the patient's spontaneous breathing has returned. Well, patient is paralyzed and ventilator is giving the breath. I am getting a normal graph. And when patient starts breathing along with ventilator, this cleft appears. So this means return of spontaneous ventilation. Return of spontaneous breathing in the patient. Spontaneous breathing. If this is happening during the surgery and I have to maintain the paralysis of the patient, I will have to repeat a dose of neuromuscular blocker. Got it? So this cleft will disappear. So this curare cleft means return of spontaneous breathing. So these are the few graphs. Now very important, I want to discuss what is the use of capnograph during CPCR, cardiopulmonary cerebral resuscitation. Now, three important use. Number one, whenever we put the airway device during cardiopulmonary cerebral resuscitation, that is when we intubate or put any other airway device, confirmation is by capno. Confirmation of airway device, right placement. Because if I will put it in trachea, then only I will get a graph. So confirmation is nowadays mandatory. You have to do through capnograph. Second, adequacy of chest compression. If I am doing chest compression and if the compression which I am doing during CPR is adequate, then the EtCO2 value will come above 20 mm of Hg. If the compression is not adequate, the EtCO2 value will be less than 10 mm of Hg. So we have to try to maintain the compression to keep the EtCO2 value above 20 mm of Hg. So if I attach capno, whether the chest compression is adequate or not, I will get an idea through capnograph. Third important, as you can see in this graph, the chest compression was undergoing and I was getting a, let's say, graph of 20 mm of Hg, and suddenly the graph size increased. It became 45, 50, whatever. This means return of spontaneous circulation. Return of spontaneous circulation. Guys, if I do a very good chest compression, then also I will maintain only 30% of the cardiac output. So EtCO2 value during normal compression, chest compression also would be hardly 20 to 25 mm of Hg, not beyond that. So if there is a sudden increase in the EtCO2 value, this means patient's own circulation has returned and CPR is successful. So third use of CPR in capnography in CPR is indication of ROSC, return of spontaneous circulation. ROSC, return of spontaneous circulation. Got it? So if they ask a question that during CPR the graph suddenly increase, what does this mean? Return of spontaneous circulation. Okay. The first use I told you, if the tube I put it in esophagus instead of trachea, then I'll get a flat. So sure shot confirmation of right placement of ET tube is by capnography. So if I put the tube in trachea, I will get a graph like this. Then I am 100% confirmed tube is in trachea. It's a sure shot confirmation. But if I put it in esophagus, I'll get a flat cap. Got it? Okay. Now, I told you, if the chest compression during CPR, if it is good chest compression, right, then I will get a graph till above 10. That is, it will be between 10 and 20. If it is below 10, right, we have to improve the chest compression. And if the graph increases, becomes normal or above normal, then ROSC, that is return of spontaneous circulation. So these are the 3 important uses during CPCR. Okay, understood? Now next monitor which I want to discuss with you is pulse oximetry. Pulse oximetry. You can see this. This is a pulse oximeter probe. Pulse oximeter probe. You attach it on the terminal phalanges and it gives us the oxygen saturation of arterial blood. Arterial blood. Right? It works on 2 principles. Right? It works on 2 principles. Number 1, law of plethysmography. And number 2, law of oximetry. Law of oximetry. Now understand, plethysmography, what does it mean? I told you we attach on terminal phalanges. Here we don't have artery, we have capillaries, which can be both venous and arterial. So how does pulse oximeter measure oxygen saturation of arterial blood? By law of plethysmography. When we attach this probe, it has light emitting diode which emits the light which falls on the capillary, and first thing which it does, senses the flow of blood in the capillary. If it is pulsatile, then it is arterial capillary, it will pass through it. And the photodiode on the other side of the probe will, what will it do? It will absorb the light, it will take the light which has passed through the capillary. So first, by law of plethysmography, it recognizes the flow of blood in the capillary, pulsatile or non-pulsatile. And through law of oximetry, it measures how much light has passed through the arterial capillary and tell us the oxygen saturation of arterial blood. Okay, so this is our pulse oximetry. Okay, the next monitor is, this is a temperature probe. Temperature probe. Remember, this is a temperature probe. We need to attach temperature probe during general or regional anesthesia for core temperature monitoring. Core temperature monitoring. And now guys, there are sites for core temperature monitoring. Number 1, the best site for the core temperature, the most let's say sensitive site for the core temperature monitoring is pulmonary artery catheter core temperature monitoring. Now just understand, see this image, this is a pulmonary artery catheter. This catheter, when we place, it has one of the tubing which has a thermistor attached to it, and this thermistor attached to the pulmonary artery catheter is used to measure core temperature. But this pulmonary artery catheter is not placed in every patient. It is placed mostly in cardiovascular surgeries, CABG, etc. This is a very invasive monitor and has a lot of complications. So it is not put in every patient. So this is a very sensitive site for core temperature monitoring, but not a common site. So this is the most sensitive site, but not a common site. So it is most sensitive, but not common. Second best site for core temperature monitoring is lower 1/3 of esophagus. Lower 1/3 of esophagus. Lower 1/3 of esophagus. And this is the most common site which we use, most common site which we use for core temperature monitoring. Third is tympanic membrane. Tympanic membrane. This is the third best site. Fourth is nasopharynx. Nasopharynx. So these are the sites for core temperature monitoring. A question is asked, best site, if pulmonary artery catheter is mentioned, you go for that as an answer. If it is not in the option, lower 1/3 of the esophagus. If it is not in the option, tympanic membrane and then nasopharynx. This is the sequence for the best to worst site for core temperature monitoring. Got it? Okay. Next monitor which I will discuss with you is a desirable monitor. This is something called bispectral index or BIS monitor. This monitor monitors depth of anesthesia. Depth of anesthesia. What happens? We attach a BIS probe or band on the forehead of the patient. It has 3 EEG electrode which measures the electrical activity of 3 lobes, that is frontal, parietal and temporal lobe. And graphically and numerically it is represented on the monitor. The value of the BIS varies from 0 to 100. If value is coming 0, it means there is no electrical activity over the brain, patient is in coma. And if it is 100, patient is fully aware. We need to keep the value of BIS introp between 40 to 60. So this is the desirable introp BIS value. So what are the questions asked? Questions asked, what is the use of BIS monitor? It monitors depth of anesthesia. Or which monitor monitors depth of anesthesia? Answer is BIS. Okay, what is the normal introp BIS value? It is 40 to 60. So these are the few questions which can be asked on BIS monitor, which monitors depth of anesthesia. Next important monitor is a desirable monitor, neuromuscular monitoring. Neuromuscular monitoring. What did I tell you? What does this monitor monitors? This monitors adequacy of muscle paralysis. Adequacy of muscle paralysis, right? It measures adequacy of muscle paralysis. See, in any nerve, on any nerve, electrodes are attached and the nerve is stimulated by electrical signals and the muscle innervated by that nerve, the effect is seen. The most common nerve which is used, any superficial nerve can be used, most common nerve which is used is ulnar nerve, and this is the commonest question asked, that the commonest nerve monitored for monitoring the adequacy of anesthesia or adequacy of neuromuscular blockade. Answer is ulnar nerve. So the most common nerve used for neuromuscular monitoring is ulnar nerve. The most common electrical stimulus given, most common electrical stimulus used is train of force stimulus. Train of force stimulus. Train of force stimulus. So you have to remember these two questions in this neuromuscular monitoring. Okay? Okay. Just for the image based question, this is a CVP monitor. CVP catheter rather I would say. CVP catheter. This we use for central venous pressure monitoring. Okay. We use it for central venous pressure monitoring and it has other uses also like fluid to be given to the patient, etc. But here I am discussing monitoring, so I am telling you it is used for central venous pressure monitoring. Okay. So the tip of this catheter is left at the junction of superior vena cava and right atrium and it monitors the right atrial pressure of the heart. This is a pulmonary artery catheter or we popularly call it as Swan-Ganz catheter. Okay. And this is for this catheter, the tip has a balloon which is wedged in the pulmonary capillaries. So it passes through all chambers of the heart and it is wedged in the pulmonary capillary, and it measures the left atrial pressure of the heart. So right atrial pressure is measured by CVP, and pulmonary artery catheter measures the left atrial pressure of the heart. Okay, got it? So these are the monitors which I needed to discuss. So the next topic is anesthesia machine. Anesthesia machine. What does anesthesia machine do? It receives gas from the compressed source, mixes the gas in known concentration and known flow, and deliver it to the patient at a pressure which patient can tolerate. So first thing, it receives gas from compressed source, mixes the gas in known concentration and flow, delivers to the patient through the breathing circuit, of course, at a pressure which patient can tolerate. Okay, so this is the function, basic function of anesthesia machine. Now for doing this function, machine has been, the modern anesthesia machine which is I am talking about, a machine has been divided into two parts. So two parts, machine has two parts. First one is electrical component. Electrical component. And the second one is mechanical component or pneumatic component, or popularly known as pneumatic component. Okay. In electrical component, we have following things. Master switch. Master switch is a switch which will turn on the machine's all electrical and pneumatic parts. Then we have power backup. Well, every machine has a battery. Machine runs on electrical supply, but it has a battery which goes on continuous charging, and if the supply of the electricity is affected, power backup starts. Then we have power failure indicator. If power failure happens, it will indicate power failure indicator. It's very important. Whenever there is a scope of power failure, the indicator turns on. Fourth is sockets, electrical sockets. Well, machine has some sockets present on them which is used for giving electrical supply to the equipments attached to the machine like monitors, etc. And fifth is circuit breaker. If let's say there is a problem in an electrical circuit, or there is a very high voltage generated by the equipment attached to the electrical socket of the machine, and there is a chances of damage to the machine, there is a power breaker which breaks the power and saves the machine from any damage. So these are the electrical components of the machine. We just have to know the name and nothing else. Now coming on the more important part, that is the pneumatic part. The pneumatic part of machine is which little thing, more things we need to know. It is divided into three parts. Number one, high pressure system, intermediate pressure system, and low pressure system. So the pneumatic component is divided into three parts: high pressure, intermediate pressure, and low pressure. This depends upon the difference in the pressure in the machine. Like high pressure system would have the parts which are at high pressure. Then once the pressure is reduced, it will enter the intermediate pressure, and once the pressure is further reduced, then it will become low pressure system. So machine has some pressure regulators which will reduce the pressure of gas flowing through it, and as pressure is reduced, the parts comes from high pressure system to intermediate pressure system to low pressure system. Okay, and in little detail we have to study about these parts. So let us talk about I'll show you the picture also, which we need to know. So let us talk about first what are the parts which comes under these three divisions. So high pressure system. High pressure system, number one, the first part is hanger yoke assembly. We need to remember the name, hanger yoke assembly. I'll show you the picture of this hanger yoke assembly, and you should know that cylinders, one of the compressed gas source to the machine. Machine receives compressed gas from two sources, cylinder and pipeline supply. Cylinder is attached on hanger yoke assembly. So hanger yoke assembly is that part of the machine which comes under high pressure system, and it hangs the cylinder and receive gas from the cylinder, right? Second part is of high pressure system, cylinder pressure indicator. Cylinder pressure indicator. Third part is first pressure regulator. First pressure regulator. Okay guys. Hanger yoke assembly, little bit more I will tell you. Just remember, cylinder pressure indicator is that part of the high pressure system which will indicate the pressure of gases in cylinder, and it is popularly known as Bourdon's pressure gauge. And first pressure regulator is that part which will decrease the pressure of gas, the gas which passes through the first pressure regulator, and when the gas passes through the first pressure regulator, the gas will enter the intermediate pressure system. The intermediate pressure system. So if you just see this image, So these are the cylinders attached to the machine. Okay. Now from cylinders, let us see the oxygen. From cylinder, the gas flow. This is the pressure indicator which will indicate the pressure of the gases in the cylinder, and now it will pass through the pressure regulator. This is the pressure regulator, and once it passes through the pressure regulator, the pressure of the gas reduces, and now it has entered the intermediate pressure system. So from this portion of the machine, all the things which will come, it will come under intermediate pressure system. So what comes under intermediate pressure system? What are the other parts of intermediate pressure system? So I told you about high pressure system. I told you about high pressure system, hanger yoke assembly, cylinder pressure indicator, and first pressure regulator. This is the hanger yoke assembly where the cylinders hang to the machine. This is the pressure indicator, and this is the first pressure regulator. And once the gas passes through first pressure regulator, it will enter intermediate pressure system. Now coming on the parts of intermediate pressure system. Intermediate pressure system. The first part is pipeline inlet connection. You know, pipeline attaches to the machine at intermediate pressure system. Cylinder attaches at high pressure and pipeline attaches at intermediate pressure system. So pipeline connection inlet, in which I will discuss a very important thing with you, that is DIS, diameter index safety system. Second, pipeline pressure indicator. Third, second pressure regulator. Second pressure regulator. Okay. Second pressure regulator is that part will reduce the pressure of the gas, right? And then the gas will enter the low pressure system. Okay. Then we have piping, which will bring the gases. Then we have some auxiliary things attached in the intermediate pressure system, where the intermediate pressure system has to do some more works. So some auxiliary things attached, very important, that is emergency oxygen flush. I'll talk about it in little detail. Sixth, very important, let's say when the gas pressure decreases, the supply of the gas either through pipeline or through cylinder, the pressure decreases, then there are alarms in the intermediate pressure system which will start ringing. So gas pressure failure alarm. And very important, last thing in intermediate pressure system is a flow control valve. The valve which will control a flow of oxygen and nitrous oxide and air from the machine. So, flow control valve. This second pressure regulator is just attached to the flow control valve, right? So that when the gas passes through this flow control valve, then the pressure of the gas reduces and it will enter intermediate pressure system. So if you just see this image, this was high pressure system, this is intermediate pressure system. What else? What comes? Pipeline pressure gauge, pipeline supply, right? Then oxygen supply failure alarm, that is oxygen pressure failure alarm. Then second pressure regulator, oxygen flush valve, and it will reach the flow control valve. This is the flow control valve, and once the gas flow through the flow control valve, now it comes under low pressure system. Okay. Third part is low pressure system. So what comes under low pressure system? Everything outward from flow control valve, that is flow meters. That is, second thing is vaporizer. Third is back bar of the machine on which this vaporizer and the flow meter are attached. Vaporizer and flow meter attached. Then very important, hypoxia guard. The intermediate pressure system has alarms which will start ringing if the oxygen pressure falls below a certain mandatory value. And in low pressure system, there are alarms which will start ringing if oxygen concentration falls below certain limit, right? So hypoxia guard, which will guard against giving hypoxic picture to the patient. And fifth, very important, that is common gas outlet, the outlet of the machine. The common gas outlet, whatever machine gases you will start in machine, it will come out of the common gas outlet. Okay, so just see this image. Now coming on the parts of the low pressure system, this is the flow meters, right? From flow control valve, flow meters. Okay, then we have vaporizers, as I told you, vaporizers. Then the gases flow, and we have hypoxia guard in between, and then we have common gas outlet of the machine. Okay, common gas outlet of the machine. And this flow meter and vaporizer are attached to the part that is called back bar of the machine. So these comes under low pressure system. Okay, so very important, few important points about the individual parts. Okay, so let us talk about high pressure system. The first thing, high pressure system. One part I will tell you, that is hanger yoke assembly. Hanger yoke assembly. On hanger yoke assembly, what is attached? Gas cylinders. So let me tell you a little bit about gas cylinders first. So gas cylinders are mounted on hanger yoke assembly of anesthesia machine. So you can see this is an image of gas cylinder. Now gas cylinder has three parts. It has a body, this is called the body. Then the tapering end is called the shoulder. And the upper part of the tapering end of the shoulder is fitted with something called valve, right? A valve is fitted on it, so, and it's called neck, actually, neck, right? Now this body and shoulder of the cylinder are color coded for different gas cylinder. So body and shoulder are color coded for identifying the content of the cylinder. Now remember, the content of the cylinder can be identified by various things. We have something called label. There is a label attached on the cylinder which will tell about content of the cylinder, pressure of the content and everything about it, which is the most important thing. So we always check the label before using a cylinder. Then we have something called color coding of the cylinder, color coding. Then we have something called pin index, which I will discuss. This pin index system is for special cylinders attached to the anesthesia machine. Remember, the cylinder size is from A to HH in increasing order, A, B, C, D, E, F, G, H, and type E or size E is most common cylinder size attached to machine. Most common cylinder size attached to anesthesia machine. Attached to anesthesia machine. Remember, right? And color coding is one way of identifying the content. Pin index is something which is specifically present in those cylinders which are attached to the machine. And label is most important, right? And every time a cylinder is refilled, the label is freshened. So let us talk about first about the color coding. Color coding. If you see this image, you can see that the various cylinders are of various color. First cylinder is oxygen cylinder. This is oxygen cylinder. Oxygen cylinder, which has black body. You can see this is the body and white shoulder. So it has black body, white shoulder. The second cylinder, this one, this is air. It has gray body and black and white shoulder. Gray body, black and white shoulder, right? This is air cylinder. You can see this part is black, this part is white. Carbon dioxide, it's not in the image, but I am writing carbon dioxide. It has, the whole cylinder is of gray color. Nitrous oxide, this one is nitrous oxide. Nitrous oxide is of blue color, the whole cylinder is of blue color, right? Entonox, this is Entonox cylinder. It has blue body and white shoulder. White shoulder, because Entonox has both nitrous oxide and oxygen. Okay. And remember, helium cylinder. Helium cylinder, one more color, cylinder color you have to remember, is of brown color. So I'm just writing helium is of brown color, right? So color coding you have to remember. They can give you a picture of cylinder and can ask you to identify it. This cylinder I have left it, it is not required. You can see this body and shoulder I told you is important for the color coding. Now see the valve, cylinder valve. Now cylinder valve, right? Let me talk about the front part. It has a central opening which is called port, right? So this is the cylinder port, right? Port for the exit of the gases. And below the port, we have another opening that is called holes for the pins. This is the holes present below the port, which will go in the coded pin index system. Now remember, let port be the center of the circle, and a circle of 9 by 16 circumference is drawn around that port, and on this circumference, pin positions are ascertained, like 1, 2, 3, 4, 5, 6, and center one is 7, right? Different pin positions are ascertained. So let's say 1, 2, 3, 4, 5, 6. Nitrous oxide has pin index of 3 and 5, right? So where in a nitrous oxide cylinder, only third and fifth hole position would be there to fit in the machine from pin coming out from third and fifth position only. Nitrous oxide has pin index 3 and 5. So at third and the fifth position, the hole would be there, which will go inside the pins coming out from the anesthesia machine where nitrous oxide has to be attached. So if you see, this is the cylinder and this is the machine. This is the center port which will attach to the machine for the flow of gases, and these are the two pins coming out from the machine which will go in the corresponding holes present on the cylinder, which would be unique for a particular cylinder. So coming on the pin indexes of the cylinder which we need to remember, a few pin indexes. So let us start with air. Air has pin index of 1 and 5. Oxygen has pin index of 2 and 5. Then nitrous oxide has pin index of 3 and 5. Carbon dioxide has 2 pin index, 1, 6 and 2, 6, depending upon carbon dioxide concentration. Higher concentration has 1, 6 and lower concentration has 2, 6. Then we have cyclopropane, which is not used nowadays. It has pin index of 3, 6. Okay. Remember, nitrogen, not much used nowadays, has pin index of 1, 4. And helium Helium and oxygen concentration. Helium. Important nowadays. Helium has pin index of 2 and 4 or 4 and 6 depending upon the helium concentration. If less than 80% helium, then it is 2,4, and more than 80%, then it is 4,6. So this is the pin index which you need to remember. So this cylinder would fit on the machine in something called hanger yoke assembly. So this is the hanger yoke assembly. You can see this image. This is the cylinder loaded on the machine, right? This is the cylinder loaded on the machine, and this part of the machine, this is called hanger yoke assembly. Okay. So from hanger yoke assembly, let's say a nipple protrude which will fit into the port of the cylinder. Okay, and below it 2 pins also protrude depending upon which gas cylinder has to be attached at a particular place in the machine. So this is all we need to know about hanger yoke assembly. It has a center port coming out, center protrusion coming out, which is called nipple, which has a washer around it for a tight seal, to prevent any leakage of gas, and 2 pins below, unique for every particular gas. So what is pin index system? It is a system which prevents incorrect attachment of cylinder to machine. Where a particular cylinder has to be attached, it will only be attached because of pin index system. Okay, so this is all about high pressure system. Now coming on intermediate pressure system. Intermediate pressure system. So for intermediate pressure system, I told you we have to know about pipeline supply. In pipeline supply, what are important? Piping. Then what is important? Pipeline inlet, which I told you is very important because of something called DIS, unique system like pin index DIS, and pipeline pressure indicator, which will tell us the pressure of the pipeline supply. Now see this. This is the piping. These are the different piping, which is again, pipings are color coded. You can see that white one is oxygen. White piping is for oxygen. Blue for nitrous oxide. Black for air, and yellow is for vacuum. Okay. So remember guys, that the terminal end of this pipeline, you can see this is the terminal end of this pipeline. It will go into inlet present on the machine, right? You can see this image. It will go into inlet present on the machine, right? From the wall mount, the piping will come and it will go into the inlet present on the machine. So let us talk about pipeline inlet connection. This pipeline inlet connection also has a unique system in it which will prevent incorrect attachment of piping to the machine. That is called DIS, diameter index safety system. Diameter index safety system. Okay, diameter index safety system. You can see every pipeline terminal end has a different diameter which will go into a particular slot present on the machine only to prevent any incorrect attachment. So this is DIS. It is analogy to pin index system of the cylinder. Okay, and every cylinder has a pipeline pressure indicator, which will every piping will have a pressure indicator to show the pressure of the gas flowing through that pipeline. And remember, all gases are coming at a pressure of 55 to 60 psi. Cylinders have different pressure, like oxygen cylinder has 2000 psi pressure, nitrous oxide has 760 psi pressure, but pipeline supply, all the gases are supplied at a uniform pressure of 55 to 60 psi. One more important thing which you should remember in the cylinder, that 2-cylinder pressure. Oxygen cylinder has 2000 psi pressure, and let's say nitrous oxide cylinder has 760 psi pressure, right? And oxygen cylinder should always have mandatorily 1000 psi pressure before starting a case, right? If it is showing less than 1000 psi, we always change the oxygen cylinder and then start a case. But all the gas supplied through pipeline, whether it is oxygen, nitrous oxide or air, they all are supplied at 55 to 60 psi pressure. Got my point? Okay. So this was the first part of intermediate pressure system. The next part, important part of which I want to tell you is emergency oxygen flush. Just this is your common gas outlet. Just beside the common gas outlet, there is a button. There is a white surrounded with a black halo in between. White surrounding with a black halo. This is the black hollow. If we press it, right, per press releases this from this oxygen flush, per press releases oxygen at 35 to 75 liters per minute. Minimum 35 liters per minute of oxygen will come out from the common gas outlet. Okay, per press. Now, routinely, the oxygen or any other gas flow from low pressure system when we turn on the flow control valve. But this is an emergency oxygen flush provided to be used in emergency condition. Three important points you have to remember. That what is the minimum oxygen flow out of the emergency oxygen flush? Remember, 35 liters is minimum. It can go up to 75 liters. Then what is the pressure at which oxygen comes out? 55. It is an intermediate pressure system, 55 to 60 psi. And very important, the third important thing, it comes under intermediate pressure system. It is near the common gas outlet, but it comes under intermediate pressure system. Okay? Okay. So next important point of intermediate pressure system which I am talking about is oxygen pressure failure indicator. If oxygen pressure falls below, let's say 30 psi, there is alarm in the machine which will start ringing. So alarm is activated. Alarm is activated. Okay. Then the very important part, the next part of the intermediate pressure system is flow control valve. Flow control valve. These are the valves which will control the flow of gases coming out from the machine. If you see this image, these are the flow control valve. Okay. If you turn this valve, then the flow of the gases will start from machine, and again this is color coded. So flow control valve, color coded. White for oxygen, blue for nitrous oxide, and you can see black and white for air, or simple black for air. Let's say black for air. So remember guys, if you see, the fluting of the oxygen flow control valve is wider as compared to nitrous oxide and air, so that you can, by just feel, you can say this is oxygen flow control valve, right? So oxygen flow control valve has wider fluting. So till here we are in intermediate pressure system. Now here we have second pressure regulator, and now the gases will go into low pressure system. So third part of the machine is low pressure system. So what is the first part which we need to know about in low pressure system is flow meters. Flow meters. Okay. What is flow meter? If you see this, this is the flow control valve I talked about. This comes under intermediate pressure system. Now when I turn it on, the gases comes out of the flow meter, and this flow meter comes under, this is flow meter. This comes under low pressure system. Low pressure system. So flow meters, they are tubes, right, arranged on the machine, which will indicate the flow of gases. It is calibrated to tell us about the exact flow of gases, and it has a bobbin which will ascend, right, which rotates in middle, and gases will go through its edges, and together all the gases will mix and come out of the common gas outlet of the machine. Remember, now oxygen, nitrous oxide, air, all three will have their flow meters. Sometimes machine has only two flow meters, oxygen and nitrous oxide, or oxygen and air, right? A lot of machines have all three flow meters. Now remember, this tube, glass tube, mechanical flow meter, this is called Thorpe's tube. Thorpe's tube. It's a special tube. It's called Thorpe's tube. and this is the bobbin which indicates the flow. That's called rotameter because it rotates, rotameter, and the whole system is called flow meter. Okay, so arrangement of flow meter of oxygen, nitrous oxide and air has to be in a particular direction. It has to be downstream. What do I mean by downstream? Oxygen flow meter, this is oxygen flow meter, should always be towards the common gas outlet. This is the common gas outlet of the machine. And oxygen flow meter should be towards the common gas outlet. We call it downstream arrangement. Downstream arrangement, right? The direction from cylinder towards the common gas outlet is called downstream, and from common gas outlet towards the cylinder is called upstream. So it is towards the common gas outlet, so it's called downstream arrangement. And oxygen should always be in the downstream arrangement, so that any leak anywhere in the other cylinders or in the oxygen cylinders can make the patient by mistake be given a hypoxic mixture, that is less oxygen content. It can be prevented. So any, let's say, delivery of a hypoxic mixture to the patient can be prevented. So why is oxygen flow meter in a downstream arrangement? So that hypoxic mixture to the patient should be prevented. Oxygen in cylinder flow meter, oxygen flow meter leak or any other flow meter leak, this will not make us give a hypoxic mixture if it is in downstream arrangement, right? So downstream arrangement is must. Okay. Next important thing is vaporizer. Vaporizer attached to the machine. Vaporizer is an equipment which is used for delivery of our potent inhalational agent, in which we have halothane, isoflurane, sevoflurane, desflurane. Okay, and they all are color coded. Halothane has red color vaporizer, iso purple, sevo yellow, and desflurane blue. Okay, so this is the next part of the low pressure system. The next part of the low pressure system is this, the last part is this common gas outlet. Okay, common gas outlet. Here the circuit is attached and all the gas come out of the machine. Now remember, circuit is attached here. Circuit, anesthesia breathing circuit is attached here. And from common gas outlet, when the gases comes out, they are at 5 to 8 psi pressure, which the human lungs can very well tolerate. In between, we have something called hypoxia guards, which prevent us giving any hypoxic mixture to the patient. There are 3 hypoxia guards. Number 1, every anesthesia machine, when you turn on the master switch, there is a basal oxygen flow. So basal oxygen flow, or we call it minimum mandatory oxygen flow in every machine, mandatory oxygen flow, which you cannot deny to any patient. Second, something called link 25 system. Nitrous oxide, when you turn on the nitrous oxide flow control valve, it will never open alone. It will always open in, let's say, in a fixed concentration with oxygen. Oxygen, if you want to open alone to give it to the patient, oxygen gas flow, it will start. But nitrous oxide can never open without oxygen. So nitrous oxide flow control valve is linked with oxygen through this link 25 system. Nitrous oxide always open with oxygen. And the third is alarms, oxygen failure alarms present in the machine. So these are the 3 hypoxia guards. If the oxygen concentration falls below certain limit, there is an oxygen analyzer which analyzes the gases, and if oxygen concentration is below certain limit, this alarm gets activated. And we will be forced to think that we are giving less oxygen concentration gas to the patient. Okay, so this is all about our anesthesia machine. The questions can be asked, parts of different pressure system and little bit about the individual parts. Okay, now from your, I told you about the common gas outlet. From the common gas outlet, what is attached? The breathing circuit. Anesthesia breathing circuit. So anesthesia breathing circuit is a system which connects anesthesia machine to the patient. So it is a system which connects anesthesia machine to the patient's airway. It will bring the inspiratory gas towards the patient and it will remove the expiratory gases, right? So this is the work of breathing circuit. It will take the inspiratory gas and it will remove the expiratory gas. And we need to know about two type of breathing circuits, which is asked in exam. Number one, semi-closed, and number two, closed. In semi-closed system, we will read about Mapleson system. And in closed, we need to know about circle system. Okay. So let us talk about the first one, that is Mapleson system. Okay. Mapleson system, we have total six circuits. A to F. We can see A, B, C, D, E, F. Okay. So with this picture, I will compare and contrast all the six Mapleson circuits for you. Okay. A, B, C, D. These four, they are adult circuits. Okay. E and F, they are pediatric. Okay, pediatric circuit. Now, in let's say adult circuit, only two important circuits you have to remember, A and D. So I'll talk about only A and D in adult circuits. Why E and F is pediatric? What is different from A to D from E and F? Remember, in A we have this A to D, we have this APL valve and we have this closed bag, right? Both are something which is generating high pressure and high resistance in the circuit, which is difficult for the pediatric lung to tolerate. So in pediatric circuit E and F, both APL valve, adjustable pressure limiting valve, and the closed bag has been removed. So these two become low resistance, low pressure generating circuit, and it became pediatric circuit, right? Let us talk about first Mapleson A. Mapleson A circuit, this is also called Magel circuit. Okay. Mapleson A or Magel circuit, if you just see on the screen, this image, this is the patient's end and this is the fresh gas flow end which will be attached to the machine. From machine, the fresh gas will enter the patient and it will reach the patient, and when the patient will expire, the expiratory gas will come out of the patient into the circuit and will flow out of the APL valve. This APL valve in Mapleson A circuit is very near to the patient's airway, patient end. So the expiratory limb is small. So this Magel circuit is best for spontaneous ventilation. Patient on spontaneous ventilation, ventilating on his own, breathing on his own. And when we put a patient on Magel circuit, on Mapleson A circuit, it's say Magel circuit is the name of Mapleson A. On spontaneous ventilation, we need to keep the fresh gas flow, that is the gas flow from machine into the circuit, equal to the minute ventilation of the patient, and carbon dioxide or expiratory gases will come out of the APL valve. Okay. So this was most economical circuit for spontaneously ventilating adult. So this became circuit of choice for spontaneous ventilation. Okay. Now guys, B and C was little modification of A, not a useful circuit. Then came D. Mapleson D doesn't have another name, but it has a very popular modified version, coaxial version, popularly called Baines circuit, which I will show the image also, Baines circuit. This Mapleson D or Baines circuit, you can see this. In this, APL valve has been taken away from the patient end and the fresh gas inlet, that is that site which will be attached to the machine, it has been brought near the patient. So this inspiratory limb became shorter and expiratory little longer. So this became best circuit for controlled ventilation. So repulsion D is best circuit in adult for controlled ventilation. Controlled ventilation. And if I am keeping a patient on repulsion D on controlled ventilation, I need to keep the fresh gas flow from anesthesia machine equal to 1.8 times minute ventilation of the patient, and carbon dioxide will be removed. Remember, if I am using A for controlled ventilation, then I will have to keep fresh gas flow very high. So A is not at all a good circuit for controlled ventilation. If I am using D for spontaneous ventilation, then I'll have to keep fresh gas flow 3 to 4 times the minute ventilation of the patient, which is much higher than what is required in repulsion A circuit in a spontaneously ventilating adult. So D is not as good as A for spontaneous ventilation. If a question is asked, best circuit for spontaneous ventilation, answer is repulsion A. Best circuit for controlled ventilation, answer is repulsion D. And worst circuit for controlled ventilation, answer is repulsion A. As I told you, if I keep patient on repulsion A circuit on a controlled ventilation patient, I'll have to keep fresh gas flow very high. So A is not good for controlled ventilation. D can be used for spontaneous, right? Little more flow is we have to keep 3 to 4 times the minute ventilation, but D can be used. A should not be used for controlled ventilation at all. Now comes E and F, the pediatric circuit. Just see. I'll show you the image. This is the repulsion E circuit. You can see this. This is repulsion E circuit. Okay. It doesn't have a bag. A bag was removed and it doesn't have a valve. This was inverted T-shaped circuit, right? This end was machine end. This was open to atmosphere and this end was attached to the airway of the patient. This was called IR's TPs, popularly called IR's TPs. Right, it was popularly called IR's TPs. This was bagless, no bag, as you can see, no bag, and no valve, bagless, valveless. It was not very useful until and unless what was attached to it? A bag, an open bag was attached to it. Not a closed bag like A to D, an open bag was attached to it. Now this became repulsion F circuit, repulsion F, right? This is Jackson-Reeves. Jackson-Reeves modified, attached this bag. So repulsion F is also popularly called Jackson-Reeves circuit. Jackson-Reeves modified this E and made it F. And for any question on pediatric, for spontaneous or for controlled ventilation, anything asked, they ask the best circuit, answer would always be F. E was the first pediatric one, inverted T-shape, no bag, no valve, was not very useful. It was made useful in the form of F by some person called Jackson-Reeves. Repulsion F or Jackson-Reeves circuits is the best circuit for pediatric for any type of ventilation, spontaneous or controlled. So in adult, you have to remember 2 circuits for spontaneous A and for controlled D. In pediatric, you have to remember only 1 circuit, that is repulsion F, both for spontaneous and controlled. Okay, so this is all about semi-closed circuit. The circuit was further improved and very important, circle system was made. I'll talk about circle system. But before talking about circle system, I just want to show you a few images. This is repulsion D, right? I told you. This is the patient's end. This is the machine end. Okay. And this was modified in the form of Bain's coaxial form. Coaxial. That is, in D you can see that same limb is being used for inspiration and same limb is being used for even expiration. What was done? The limbs, inspiratory limb and expiratory limb was separated. And now the inner limb, this is for inspiratory, this is inspiratory limb. This will be attached to the machine. The gas will reach the patient and when the patient will expire, the gas will come out of this outer ring and will be expired out. So inspiratory and expiratory limb was separated. And it was put one inside another, so it became coaxial. And this was modified by Bain, so it's called Bain's circuit. How does Bain's circuit look commercially? This is a Bain's circuit. Bain's circuit. Okay, you can see this outer is a transparent tubing, which is the expiratory limb, and the inner one, this goes inside the expiratory limb throughout, and this is the inspiratory limb. Got my point? So this is the Baines circuit. So they can ask you to recognize and ask which this circuit is best for what type of ventilation. You always remember controlled. So this is best for controlled ventilation and second best for spontaneous. And after A, second best for spontaneous ventilation. Remember, best for controlled, second best for spontaneous ventilation. This is Mapleson A's modification. Mapleson A also had a coaxial modification in the name of lax circuit, right? In the name of lax circuit. Again, inspiratory and expiratory limb was separated, and inspiratory limb was the outer one, the expiratory limb was the inner one. Okay, just it was separated for a better separation of expiratory and inspiratory gases, and this was lax system. This is modification of Mapleson A. Modified coaxial Mapleson A. Okay, this is best circuit for what type of ventilation? Spontaneous, and worst for controlled. Okay, so these are the semi-closed circuit, and above semi-closed circuit, now we are using something called closed circuit or circle system. And remember, closed circuit is the best circuit. Semi-closed circuit we are using, but if I have a closed circuit, I'll always use closed circuit. Closed circuit is best, is much better over the semi-closed circuit because it separates inspiratory and expiratory gases and has a very important, some few important attachment to it. So closed circuit is best. We are talking about the best closed circuit, circle system. Why we call it circle system? Because the gases flow in a circle. You see this is a closed circuit. Now this is the patient and airway of the patient will be attached. Okay. Now this is the inspiratory limb and this is the expiratory limb. Now from this is the fresh gas inlet, here anesthesia machine will be attached. From machine, the gas will enter the inspiratory limb. The gas will enter the inspiratory limb. It will reach through unidirectional valve. There is unidirectional valve. Unidirectional valve. It will reach the patient. The gas from machine will never enter. It will never enter the expiratory limb because of the unidirectional valve. So it will enter the patient. Now patient is expiring. The expiratory gases will only go into expiratory limb because of the unidirectional valve, and it will pass through a very important something called CO2 absorber. CO2 absorber to absorb carbon dioxide. So what will happen? CO2 will be absorbed here, and again the expiratory gases will recycle into inspiratory limb. So what will happen? This will become very economical. Very economical. Semi-closed was not that economical because all the expiratory gases had to go in atmosphere. There was no separation of carbon dioxide from rest of the expiratory gas. So circle system is very economical, right? Second important thing about circle system was that minimal atmospheric pollution because CO2 was removed by a chemical reaction and rest of the gases were recycled. So minimal atmospheric pollution, right? So this was the two benefit, and this made this circuit best circuit over semi-closed circuit. One very important thing which we need to talk about the circle system is its CO2 absorber. So this is a CO2 absorber, carbon dioxide absorber. You can see it has small pink granules in it. What is present in the CO2 absorber? The most popular one which I will talk about is soda lime. This is the most popular one, and this is what is asked in exam. So these granules, they have sodium hydroxide in it, potassium hydroxide, calcium hydroxide, water and silica and dye. This is of pink color. If it becomes white, this CO2 absorber has exhausted. So there is a dye which indicates exhaustion of carbon dioxide of, let's say, exhaustion of CO2 absorber. So when the pH changes, then the dye changes the color and tell us about the exhaustion. Why is the silica added? Silica gives hardening to CO2 absorber so that it doesn't break and flow along, the dust flow along with the expiratory gases, because it will cause chemical pneumonitis because it's a circle system. Everything is flowing in a circle. So silica gives hardness to granules and prevent its breaking. Okay, and rest 4 are for CO2 absorption. Now sodium hydroxide is present in 4%, potassium in 1%, 11 to 18% is water and rest is calcium hydroxide. If any question is asked, which component is present in the highest amount in CO2 absorber, soda lime, highest major constituent, always remember that calcium hydroxide is present in the highest amount. But calcium hydroxide is not the main component. It is present in highest amount because it is the least toxic hydroxide, least caustic hydroxide. Sodium hydroxide is the main one which is responsible for all the CO2 absorption. When the carbon dioxide passes through this CO2 absorber, it reacts with water and form H2CO3. Then sodium hydroxide very fast react with H2CO3 and forms sodium carbonate, right? And what happens that sodium carbonate is formed and water is reconstituted. This sodium carbonate later on react with calcium hydroxide and again a fresh sodium hydroxide is reformed for fresh absorption. So all the work of the absorption is being done by sodium hydroxide. Calcium is only there to make always every time fresh sodium hydroxide. So the causticity of CO2 absorber remains less. Sodium hydroxide is very caustic. So main component is sodium hydroxide. Major constituent is calcium hydroxide. Okay. So this is all about our CO2 absorber, all about our circle system and all about circle. So from machine, the circuit is attached and circuit comes and attached to the airway of the patient. So next topic which I will discuss with you is airway. What is airway? Okay. Now airway, natural airway is that part of the respiratory tract which takes the atmospheric air and take it to the alveoli for gaseous exchange, take it to the alveoli. Now if I put any equipment in this natural airway, we call it artificial airway. So this is the glottic opening, this is the trachea, this is right and left bronchus, okay. This will lead to alveoli. If you put any equipment in this for giving the gas or maintaining its, to keep it open, we call it airway, okay. So we have to maintain the patency of this pathway or maybe we have to create an artificial pathway for the gas to go, okay. So if the equipment passes through the glottic opening, we call it infraglottic. Though it is not a very popular term, but if the equipment remains above the glottic opening, we call it supraglottic, okay. This is a very popular term and here you need to know about a very important device, laryngeal mask airway, okay, or popularly known as LMA. In infraglottic, you need to know about endotracheal tube, the most important airway device, most primitive and still the calmest in use, endotracheal tube, okay. So these two devices you have to discuss in detail, little detail. But before I go on these two devices, some maneuvers which maintains the patency of the airway. These are the devices which will maintain patency and also be used for positive pressure ventilation. There are some devices, there are some maneuvers and there are some devices, adjuncts which we can put in the airway and maintain the patency. So let us talk about the first maneuver. So I am talking about airway maneuver to open an obstructed airway. So anytime a patient comes in emergency and you have to open, airway is obstructed, the gas will not go to the alveoli. So you have to maintain the patency of the airway, you have to remove the obstruction. There are two maneuvers which we do to remove the obstruction. The first one is head tilt and chin lift. You can see in this head tilt and chin lift. Head is tilted backward and chin is lifted forward. This pulls the tongue away from the airway and remove the obstruction, right? So this head tilt and chin lift, head tilt and chin lift pulls the tongue away from obstructing the airway, But in this maneuver, the movement of the neck joint is happening. So in trauma victim, where cervical injury is suspected, we try to avoid this maneuver and we go for another maneuver that is called jaw thrust. So jaw thrust, simply cup both sides of the face of the patient in our both hand and with the thumb we protrude the jaw forward. We cup it and protrude the jaw forward. So when the mandible is protruded forward, again the same thing happens, tongue is removed from obstructing the airway. So jaw thrust movement of neck not happening. So this is best for trauma victim. For trauma victim, this is what we do. But if the airway is not opening by jaw thrust, then we go for head tilt chin lift, because obstructed airway is an emergency and we have to open it. So if these two maneuver cannot open the airway, then we have some airway adjuncts. Airway adjuncts. Devices which will help in opening the airway. The number one is, this is the oropharyngeal airway, OPA. Oropharyngeal airway. The most popular one is Goodell's airway. Now what we do? We simply put this Goodell's airway. It has a curvature in its body which will lift the tongue away from obstructing the airway. So this is the flange. This is the tip which will go in the oral cavity, and this is the body which is channeled, which will lift the tongue away from it. You can see it has assorted sizes to be used in different adults. So first thing which we do, we choose the size which is from angle of mouth to angle of mandible. So first we do choose right size, right? What did I tell you? Angle of mandible to the angle of lip. So angle of lip to angle of mandible. The distance, this distance should be covered. Okay, right? Then we put it in upside down position most popularly. But the problem is that in a conscious patient with an obstructed airway, since it is made up of rigid plastic, it can generate spasm, laryngospasm, etc. So in conscious patient, to remove the obstruction of airway, we have another device. The second airway adjunct, nasopharyngeal airway. Nasopharyngeal airway. This is nasopharyngeal airway. This is made up of soft silicone material. Silicone, right? Very soft. It is inserted through nose, right? It creates a pathway for the air to pass into the glottic opening, right? It doesn't remove the tongue away from the oral cavity. It itself creates a pathway for the air to go into the glottic opening, right? Now it also has assorted sizes. So the first thing we have to do, choose the right size from tip of the nose to the ear lobule. So first we do choose the right size. So how do I choose? Tip of nose to ear lobule. Tip of nose to ear lobule. Then we lubricate it and put it through the nasal cavity. It creates a pathway for the air to pass. So this is nasopharyngeal airway. These are two simple devices used in emergency to open the obstructed airway. Okay, so we discussed two maneuver and two devices. Both are important. And this nasopharyngeal airway is very soft. It can be tolerated even by a conscious patient. Now coming on advanced airway devices, and the first we will discuss infraglottic one. Infraglottic. This is ET tube, endotracheal tube. Okay, the first thing, this ET tube can be inserted through oral cavity, through nasal cavity. To insert it through nasal cavity, we don't need laryngoscope, right? But to insert it through oral cavity, we need laryngoscope. So the laryngoscope which we are most popularly using is Macintosh, that is curved blade. Macintosh in adult. Macintosh, that is curved blade laryngoscope. Curved blade laryngoscope, right? Now, how do I insert it through oral cavity? That is the best way to insert it, right? Through oral cavity. How do I insert it? We insert it with the help of laryngoscope, a device which gives us the visibility of the oral cavity, and in full vision we insert the endotracheal tube through glottic opening into the trachea. But before insertion, talking about laryngoscopy, I will first talk about the parts of this ET tube. Just see the important parts. This end goes in the glottic opening, glottic end, and this is B-weld. Okay, B-weld to give us a better visualization of tube crossing the glottic opening. Then we have another opening on the wall, that's called Murphy's eye. This is alternate opening for ventilation if the terminal opening gets blocked or touches a wall and gets obstructed, etc. Then we have cuff. This cuff creates a seal in trachea for positive pressure ventilation, and this cuff prevents any upper secretion of the upper airway to go into the lower airway. So it prevents from any, let's say, aspiration. So cuff creates a seal in trachea, right, to prevent any aspiration and also to create a seal for positive pressure ventilation. Then we have this black mark, and this black mark is left at the glottic opening. So this left at glottic opening to give us a right, to help us in positioning the tube rightly above 3 to 4 centimeter above carina. So this is the carina, and we have to keep the tube 3 to 4 centimeter above carina. And what helps us in doing that? This black mark, which is left just at the glottic opening. Got my point? Then the size of the tube, the internal diameter of the tube in millimeter is written. Then it can be used both for oral and nasal, and then the markings on the tube to tell us the distance from the glottic end. And then we have something called universal connector, which will connect to the circuit. This end will go into the circuit, which I talked about just now, the anesthesia breathing circuit. Okay, so these are the parts of the tube. Now, how do I do laryngoscopy? How do I insert this tube in glottic opening? Laryngoscopy. I told you the most popular laryngoscope we are using is curved blade laryngoscope. So what do? The first thing for laryngoscopy is to make a position. So steps, laryngoscopy steps. The first thing is to make a position. The position has a specific name, that's called morning sniffing position. Morning sniffing position. This morning sniffing position, that is when you inhale fresh morning air, how do you take it? This is the morning sniffing position. It has movement at two joints, atlanto-occipital joint and neck joint. Atlanto-occipital joint is extended. That is, it is extended, extension. And neck joint is flexion. Okay. Now remember guys, atlanto-occipital joint means head and neck joint is flex. So head is extended, neck is flexed. So we make a morning sniffing position. After that, I hold the laryngoscope in my left hand. So next point is hold laryngoscope in left hand. Okay, we always hold it in left hand. From right angle of mouth, I introduce it. Introduce from right angle of mouth. Move the tongue aside and visualize epiglottis. And after visualizing epiglottis, you take the tip of the laryngoscope and array epiglottic fold, or in vallecula, glossoepiglottic fold. So introduce from right angle of mouth, visualize epiglottis, and then vallecula. Hinge the tip of laryngoscope in vallecula and lift it. What will happen? Epiglottis will get lifted up and the glottic opening will be visualized. So hinge the tip of laryngoscope in vallecula, right, and lift it. So this will happen. I will see the glottic opening, and under full vision in my dominant hand, I will hold the endotracheal tube and introduce it, leaving the black mark on the glottic opening. Okay, so I will do this. So just see this image. So I introduce the tube under full vision, leaving the black mark on the glottic opening. After introducing the tube, the next step, what I do? The next step is I inflate the cuff. There is cuff in the tube which I showed. I fill the air through the pellet balloon system and inflate it. After inflating the cuff, the next step is inflation of the cuff. So next step is, what was my previous number? 5. So inflate the cuff. Inflate the cuff after introducing. Inflate the cuff after introducing the tube. Okay, so I inflate the cuff. After inflating the cuff, guys, after inflating the cuff, I check for the right position. So check for the right position. I always check for the right position. How? Either through auscultation or through a very important device called capnography. So you have studied previously in this rapid revision about capnography. We attach this capnography on the outer end of the tube, and the gas which expiratory gas which will go out of the capnography, I will have a graphical representation like this. I will see this and I will know the tube is at right position. So capnography is the sure shot confirmation. So capno is a sure shot. So after checking the tube for the right position, the next step is I fix the tube, then fix the tube. So never fix the tube before checking. We always check and then fix the tube. Okay, so this is how we do laryngoscopy and intubation. Okay, let us talk about some special tubes. The first one in the image you can see is flexometallic. Flexometallic, or we call it reinforced, or we call it a armored tube. Why we call it armored or reinforced or flexometallic? Because its inner diameter is reinforced by a metallic wire. Why? To make it kink resistant, so that when we bend it, then the bent portion does not loses its caliber. So this is a kink resistant. Kink resistant. Since it is kink resistant, any condition in which the tubes can kink, as in neurosurgery or head and neck surgery, this is the tube of choice. So this is the tube of choice in head and neck surgery, neurosurgery, prone position surgery, etc. Got my point? Okay. Next tube which I will discuss with you is double lumen tube. You can see this, it has two lumen. Double lumen tube. It has two lumen, a tracheal lumen and a bronchial lumen. Okay, so when we want to separate one lung from another, we use this tube. So this tube is used for lung separation, and this is a tube which we use for thoracic surgery. So this is tube of choice for thoracic surgery. Thoracic surgery. Got it? For thoracic surgery. Okay. Next tube is our uncuffed tube. You can see there is no cuff in this tube. So uncuffed tube. Uncuffed tube or pediatric tube. It is used in pediatric patient for minimizing the subglottic edema. So less than 7 to 9 years, this is the tube which we use to minimize the subglottic edema. Two important things you have to remember for pediatric intubation. So for pediatric intubation, two things. A special tube is used, that is uncuffed tube, which I talked about. And second thing, a special laryngoscope is used, that is Miller's laryngoscope or straight blade laryngoscope. In adult, we use Macintosh. Here we use Miller laryngoscope or straight blade laryngoscope in pediatric intubation. So two important things you have to remember. And the last tube is, you can see this is a curved tube, or we call it RAE tube. RAE tube. On the name of the three people who designed it, RAE tube. This is RAE tube, or we call it North Pole, South Pole, depending upon the direction it is bent, above or below. And this is special tube for cleft lip palate surgery. Cleft lip palate surgery. Lip palate surgery. This was a tube which was pre-bended so that you can fix it on the middle of lip when you have to do for cleft lip palate surgery. Nowadays, since we have flexometallic available, the significance of this tube is lost. So these are the four tubes I wanted to talk about. So this is, let's say, what are the indications of intubation? Why do we put these tubes? Indications of intubation. Indications of endotracheal intubation. Number one, for general anesthesia. These are tubes we are putting for different surgeries for keeping the airway open and for ventilation. So during general anesthesia, to keep the airway open and for ventilation. The second indication, let's say patient has an airway compromised state, we put the tube for positive pressure ventilation. Any reason, due to any problem in the lungs of the patient or in problem let's say in the respiratory center of the patient, and patient is unable to take his adequate tidal volume, we put this tube for positive pressure ventilation. So for positive pressure ventilation. Third indication is to protect the lung from aspiration. Patient is in coma. GCS is less than 9. We put the tube, patient can breathe through the tube, but upper airway secretion will not go in the lower respiratory tract. So, to protect the airway from aspiration, to protect the airway from aspiration. And fourth is pulmonary toileting. That is, patient is unable to cough and take out his secretion. So we put the tube so that patient, and we do the suctioning so that pneumonia can be prevented in the patient. So for pulmonary toileting, these are the 4 indications of intubation. Okay. Now let us say that I received the patient in emergency and patient was not taking his adequate tidal volume. Saturation was dropping, and I tried to intubate the patient, but I failed. I couldn't visualize anything because of the trauma and everything, or it was a difficult airway. Then the saturation of the patient was further reducing. So what can I do in the situation? I can use an alternative airway. And the alternative airway which is most popular is supraglottic, which is easy to put, supraglottic airway device. And in this, we'll talk about laryngeal mask airway. You can see the image. This is laryngeal mask airway. It has a cuff made up of soft silicone, and it has a tube attached to it with a universal connector as an endotracheal tube to connect it to the breathing circuit. Well, how do I put it? I hold the laryngeal mask airway in my dominant hand, open the oral cavity of the patient, and push the laryngeal mask airway through my index finger in the oral cavity, and when I face any resistance, I stop it there. This tip goes, and this goes into hypopharynx. This goes into hypopharynx. Okay, and it rests in hypopharynx. Now, see this. This is the tip, and this is the image of dorsal side. Look, see the ventral side. It has an opening. This ventral side opening, the tip will go in hypopharynx, and the opening on the ventral side will fall on the glottic opening, right? Through this opening, which is the proximal end for the proximal opening, and the distal opening is on the tube, we can ventilate the patient. So what do we need to know about it? That laryngeal mask airway is a supraglottic airway device, the first point. We don't need laryngoscope etc. to insert it. We don't have to visualize anything to insert it. So it is easy and fast to insert as compared to ET tube. Third important point, less complication causing device. We don't need laryngoscope. We are not doing much instrumentation. It's a very soft device, easily tolerated by the patient. So less invasive. Now what is the problem of this device? Now guys, when we put this, it rests on the glottic opening. We inflate the cuff, it forms a seal over the glottic opening. The seal is not strong enough to prevent aspiration. When we put ET tube and inflate the cuff of ET tube, it creates a very good seal and prevent aspiration. So remember, aspiration cannot be prevented. Which can be very well prevented in ET tube. ET tube today also, endotracheal tube today also is the best device to prevent aspiration. We inflate the cuff and we prevent aspiration. Best device to prevent aspiration, and we need to keep the cuff pressure to prevent aspiration. Here only I am writing. That is 20 to 25 centimeter of water or 18 to 24 mm of Hg. Okay. So remember, sometimes they ask, what is the cuff pressure to prevent aspiration? Okay. So problem of this device was aspiration cannot be prevented. So of supraglottic airway device. So not a definitive device. Not a device which we can put for a longer duration. Definitive device. ET tube we can put for a longer duration. It ventilates and prevents aspiration. Supraglottic airway device ventilate but does not prevent aspiration. So this device is not preventing aspiration. Remember, tips rests in hypopharynx. The ventral part goes on the glottic opening for ventilation. So remember guys that the device was improved. This is first generation supraglottic airway device. This is classical LMA. This is classical LMA. This classical LMA cannot prevent aspiration. This was designed by Dr. Archie Brain. Dr. Archie Brain. So Dr. Brain noticed that this device was not preventing aspiration. So he made second generation. This was first generation. So Dr. Brain made second generation, an improvised device, second generation. Now first generation and second generation. First generation had only one work for positive pressure ventilation. This was used for positive pressure ventilation only and cannot prevent aspiration. Cannot prevent aspiration. Okay. Second generation was used for positive pressure ventilation and had additional use also. So used for positive pressure ventilation and also additional use like gastric deflation, etc. Additional use also. And this was very important point, second generation, comparable to endotracheal tube in preventing aspiration. This was the beauty of second generation, comparable to ET tube in preventing aspiration. So I'll show you the image. This is first generation, it has only one tube. This is first generation, it has only one tube. Okay, this is the cuff and this is the ventilating port and this is the distal ventilating port. It can only be used for ventilation, and this is a classical LM. This was improvised in form of this one. This is ProSeal LMA. ProSeal LMA. You can see this. It has a gastric tube and it has an airway tube. The gastric tube ends at the tip, which ends in hypopharynx. I told you tip rests in hypopharynx. So through this we can put a Ryle's tube into esophagus and prevent and deflate the stomach. And this forms a seal, very good seal, which can prevent aspiration also. Right? So this was ProSeal LMA, which was comparable to ET tube in preventing aspiration. Now sizes of classical and ProSeal LMA, they come in all sizes, and the sizes are decided according to body weight. So how do we decide the size? Weight in kg, size of both classical LMA and PLMA, that is ProSeal LMA. Less than 5 kg, 1, 5 to 10 kg, 1.5, 10 to 20 kg, 2, 20 to 30 kg, 2.5, 30 to 50 kg, 3, 50 to 70 kg, 4, more than 70 kg, 5, and more than 100 kg, 6. So total 8 sizes were available, 8 sizes according to body weight. Got my point? Now apart from ProSeal LMA, there are a few other second generation supraglottic airway device very commonly used nowadays. Here I have given you the picture of 3 second generation supraglottic airway device. The first one is ProSeal, which we have already discussed. It has a gastric tube, it has an airway tube, and it has a very good cuff, which is comparable to ET tube in preventing aspiration. The second one is iGel airway. You can see the difference that ProSeal has an inflatable cuff. We have to inflate it. iGel does not have an inflatable cuff, non-inflatable cuff. You can see it doesn't have a cuff balloon system to inflate it. It's non-inflatable. It is made up of a special material. This iGel is made up of special polymer. This swells in oral cavity by secretions and the warmth of the oral cavity and seals over the glottic opening. This is also a very good device. It has an airway tube and it also has a gastric tube through which we can put a Ryle's tube. So this is iGel, non-inflatable cuff. And the third one is LMA Supreme. It is like LMA, cuff, inflatable cuff, but only it is curved. The tube is curved so that it facilitates its entry in the oral cavity. Right? So this is LMA Supreme. So if straight is given, it's LMA ProSeal. If curved one is given, it is LMA Supreme. Both have inflatable cuff. Okay? And iGel has non-inflatable cuff. So these are the 3 second generation supraglottic airway device, which I want you to keep in mind, very commonly in use nowadays, and questions can be asked. The last point which I want to tell you is two special circumstances in which we need to have some precaution in airway securement. Number one, cervical spine injury. Cervical spine injury, you don't want any movement of the neck joint. So if a patient with suspected cervical spine injury, how do you open the airway? We go for jaw thrust. As I told you, this movement would not cause much of the neck movement. And if I have to put the airway device, patient is desaturating, I have to put an airway device. For cervical spine injury, in emergency, we go for manual inline stabilization. See, in emergency, whenever you have to secure the airway, the only thing you have to do is orotracheal intubation. So you go for that is the only way to get a fast airway securement. So we don't want to have a head and neck movement, so we go for manual inline stabilization of head and neck by a person. We call it MILS, and orotracheal intubation. But this cervical spine injury patient, if elective, matlab planned, we are taking it for the planned surgery, then we don't want to go for orotracheal intubation at all. We go for fiber optic nasal intubation. Fiber optic nasal intubation, right? So this is for cervical spine injury. This is for cervical spine injury. Now let us talk about for maxillofacial injury. Next is maxillofacial injury. For maxillofacial injury, guys, if it is emergency, always remember, in emergency, always orotracheal intubation. Orotracheal intubation. And if it is elective, tracheostomy, because you don't want a maxillofacial injury patient to do a nasal intubation, because it will take the infection to the brain because of the fracture of the base of the skull, and you don't want to do orotracheal intubation because it will dislodge the fracture. So tracheostomy is the only way we do it, for elective planned one, but for emergency, orotracheal intubation. So this is about the airway device. So we have finished the airway device. So next topic is the drugs of general anesthesia, and first group of drug which I will tell you is inhalational. So we'll discuss then this in a tabular form, inhalational anesthetics. So what are the commonly used inhalational anesthetics? So commonly used inhalational agents are inorganic gas, nitrous oxide, which is very less potent and used as carrier gas, and volatile anesthetic agents, volatile liquids, volatile inhalational anesthetic agents, which are liquid at room temperature and they form a gaseous vapor when we have to give it to patients through a special device called vaporizer. So volatile liquids, they are more potent and they come under potent inhalational agents, and they are our main inhalational anesthetic agents. Apart from in volatile anesthetic agents, what we need to know is about halothane, isoflurane, sevoflurane, and desflurane. So apart from this, we have one inert gas. Xenon, which has anesthetic properties, but it is not as potent as potent agent, so it can also be used as a carrier gas like nitrous oxide, but due to high cost, it is not in clinical use. High cost, it is not in clinical use, not in use. And among volatile liquids, there are two agents which are not in clinical use because of the toxicity. First one is methoxyflurane. Methoxyflurane is a volatile inhalational potent agent which is not in clinical use because it is most nephrotoxic. Actually, this was most potent agent, but it came out to be most nephrotoxic also, so it was abandoned from the clinical use. So most nephrotoxic. And enflurane, it precipitated epilepsy, so it is also not in clinical use. So let us discuss the remaining agents in a tabular form. So let us make a chart which will compare the pharmacokinetic and pharmacodynamic property. Pharmacodynamic properties of volatile inhalational, that is potent inhalational, of potent inhalational agents. Okay. Halothane would be our first agent which we will compare. Then isoflurane, sevoflurane and desflurane. Now, developed countries are not using even halothane because of its instability. But in India, we are still using it, so I am comparing it in the tabular form. So, first point, what is their chemical property? Halothane is a halogenated ethane. And rest are halogenated ether. So rest are ether derivative and halothane is a ethane derivative. And remember guys, isoflurane and desflurane are structural analog. They are structural analog. And I talked about enflurane, which is not in clinical use. It is isomer of isoflurane. So enflurane is isomer of isoflurane. Actually, enflurane came first. It was abandoned because of epilepsy. Its isomer came, so its name was isoflurane. Next point I will discuss with you, next property is their boiling point. I told you there are volatile inhalational anesthetic agents, so they need to be made in a gaseous vapor form to deliver it to the patient through a device called vaporizer. So we need to know their boiling point. And boiling point of halothane, isoflurane and sevoflurane is more or less same, 50 plus minus 2 degrees Celsius. But boiling point of desflurane is unique. It boils at room temperature. 22 degrees Celsius. So desflurane needs a special vaporizer. The rest have same boiling point, so they don't need a special device to deliver them, but desflurane needs a special vaporizer. So next point which I will tell you is about the color coding of their vaporizer. All inhalational agents are color coded and their vaporizers maintain this color coding. So if you see this image, you can see there are 4 vaporizers. This is vaporizer, and they all are color coded. Sevoflurane, yellow, isoflurane, purple, halothane, red, and desflurane, blue. And you can see that vaporizer of desflurane is different from rest 3. Rest 3 have a similar kind of vaporizer. Only isoflurane has a different vaporizer because it needs a special, because it boils at room temperature. Okay, and one of the first vaporizer used for desflurane was known as Tech 6 vaporizer. Okay, next, so I told you about color code: halothane red, isoflurane purple, sevo yellow, and blue is for desflurane. Next point we need to know is about their potency. Something called MAC, we know their potency. What does MAC tell us about? MAC stands for minimum alveolar concentration. MAC tell us about the potency of inhalational agent. More MAC, higher the MAC, more MAC, less potent. Agent is less potent. That is, more inhalational agent required, so it is less potent inhalational agent. Less MAC, more is the potency. So less MAC, high potency. So remember this. More MAC, less potent, less MAC, high potency. Halothane has a MAC of 0.75, isoflurane 1.12, sevo 2 and des 6. So as new agent came, halothane was the oldest among these 4, then iso, then sevo, then des. Their MAC increased and potency decreased. potency decreased. Okay, so they ask about MAC and potency, so we need to know about it. Next point which I need to discuss with you is something called blood gas solubility. That is, what is this blood gas solubility? Blood gas solubility is solubility of agent in the blood or any other tissue. And blood gas solubility tell us about two things: speed of induction and speed of recovery of any agent. Speed of recovery of any agent. And remember, high blood gas solubility, less speed of induction and less speed of recovery. They are slower agent. High blood gas solubility, slow induction and recovery, and vice versa. Now, halothane has blood gas solubility 2.25, ISO 1.3, CO 0.63 and desflurane 0.42. So, as new agent came, their blood gas solubility decreased, speed faster of both recovery and induction. Now, CO and DES both are fast agent. Sevoflurane and desflurane both are fast agent, right? They are giving us fast induction and fast recovery. But desflurane, there's a problem with desflurane, that desflurane has a very bad smell. So, because of the bad smell, if I use it for induction in a conscious patient, it can cause laryngospasm. So, it is not used for induction. So, not used for induction. So, which is the second fastest? Sevo. And Sevo has a very sweet smell. So, it is inhalational induction agent of choice. Agent of choice. And remember guys, this is a very commonly asked question, that which is the inhalational anesthetic agent of choice for induction. Always answer in any age group of patients should be sevoflurane. Okay. So, this was blood gas solubility. Next is metabolism and stability. Metabolism and stability. Agent which will be more stable, which would be least metabolized. If they are stable, they will do their work, that is produce anesthesia, and will come out of the body when we stop giving them. So, and if they are unstable, then they will react and have effect on different other organs of the body. Remember, halothane is most unstable, can react with anything, and among these four, most metabolized. So, halothane is most metabolized, most unstable, that's why developed countries not using it. Most metabolized, and by metabolism it can cause autoimmune hepatitis. Autoimmune hepatitis, right? This is the major demerit of halothane, H4 halothane, H4 hepatitis. Rest of the agent, isoflurane, stable, less metabolism, sevoflurane, stable, less metabolism, and desflurane, most stable, no metabolism. It is not metabolized in the body at all, and because it is not metabolized, we can use it for hours without much repercussion on the body. Plus, it gives fast recovery, so it's a very good agent for maintenance of anesthesia. So, good agent for maintenance. Best for induction, sevoflurane. Best for maintenance, desflurane. Right? In obese patient, a number of other patients where we need a fast recovery, desflurane is a wonderful anesthetic agent. Okay, so this was little bit I wanted to tell you about the let's say pharmacokinetics. Now coming in the same table about pharmacodynamics, same table, halothane, isoflurane, sevoflurane, desflurane. First organ system, CNS. So what does inhalational anesthetic agent do? It put the patient in a sleep mode. So what does it do? It decreases the cerebral activity. So all of them decrease cerebral activity. So whenever the cerebral activity, same in all three, all four of them, decrease cerebral activity. Whenever cerebral activity will decrease, then it will decrease cerebral metabolic oxygen requirement. When activity is less, then the metabolic oxygen requirement also will be less. Then it will decrease. Whenever cerebral metabolic oxygen requirement decreases, the cerebral blood flow should decrease, right? Because we all know that cerebral blood flow is directly proportional to cerebral metabolic oxygen requirement. So if this is decreasing, cerebral blood flow should decrease. But inhalational anesthetic agent, by its intrinsic property of cerebral vasodilatation, instead of decreasing cerebral blood flow, is increasing cerebral blood flow. So instead of decreasing cerebral blood flow, they are increasing cerebral blood flow because of intrinsic vasodilatation of cerebral blood vessel. So all of them are increasing cerebral blood flow. All of them are increasing cerebral blood flow. And guys, what I am doing, I am making 3 arrows in halothane because it is increasing the cerebral blood flow most. And whenever cerebral blood flow would increase, intracranial pressure would also increase. So all of them would little bit increase the ICP. Halothane would be most notorious because it is causing maximum increase in cerebral blood flow. So halothane is increasing ICP the most. Okay, remember this. So this is the effect on central nervous system. Halothane is worst for central nervous system. It is increasing the ICP most. So for cerebral surgeries, for neurosurgeries, halothane is not used. So halothane not used for neurosurgery. These 3 can be used for neurosurgery. Desflurane is least affecting the cerebral blood flow, so it's the best agent. So des is best agent for maintenance in neurosurgery. Just remember this. Okay, next organ system is cardiovascular system. Remember guys, halothane is a direct myocardial depressant. Direct myocardial depressant. So it decreases the heart rate of the patient. And because of decrease in heart rate, cardiac output decreases, and because of decrease in cardiac output, the blood pressure decreases, right? So it is myocardial depressant. The rest of the agent are not direct myocardial depressant, right? At normal MAC, they don't cause myocardial depression, but they decrease the systemic vascular resistance. That is, they dilate the blood vessels, vascular resistance. So what will happen if systemic vascular resistance will decrease? It will decrease the blood pressure, and this will increase the heart rate. This will increase the heart rate. Now remember that halothane is arrhythmogenic also. Arrhythmogenic. Most arrhythmogenic is halothane. And one special phenomena exhibited by isoflurane, which you need to remember for cardiovascular system, is coronary steal phenomena. Something called coronary steal phenomena. Isoflurane causes coronary steal phenomena, a unique property exhibited only by isoflurane. For a direct question, you need to remember this. This is the effect on cardiovascular system. The next organ system is respiratory system. Respiratory system. Now, before going on respiratory system, remember, halothane should be avoided for cardiovascular surgery since it is most arrhythmogenic, most myocardial depressant. These 3 can be used for cardiovascular surgery. Again, desflurane is best agent. Now for respiratory system, all of them do the same thing. They all are respiratory depressant. They all are respiratory depressant. They all inhibit respiratory drive, that is O2-CO2 drive. Respiratory drive. So they also inhibit the respiratory drive. They all are bronchodilator, which is a good property of inhalational bronchodilator. And halothane is a bad agent. Halothane is best bronchodilator. So for bronchial asthma, it is still preferred at number of centers. Sevoflurane is the second best bronchodilator. So I am writing Sevo is also a very good bronchodilator. Very good bronchodilator. Halothane is best, Sevo is second best bronchodilator. So this is the effect on respiratory system. Next organ system is liver, hepatic. Now remember for hepatic, halothane is causing autoimmune hepatitis. I told you H for halothane, H for hepatitis, autoimmune hepatitis. And halothane also disrupts the dual blood flow of liver. So halothane is bad for liver. So halothane disrupts dual blood flow of liver. So halothane is bad for liver. Okay. The rest of the agent, not much effect on liver. So they are not affecting those. They can be used for hepatic surgery. Rest of the agent, desflurane is best for hepatic surgery. Now next organ system is kidney, renal. Halothane, no effect on kidney. Isoflurane, no effect on kidney. Sevoflurane, by a byproduct of metabolism, produces a byproduct which causes nephrotoxicity. And that byproduct is called compound A. Just remember this. Desflurane, no nephrotoxicity. Just remember this. So this is the effect on renal. Next is their effect on neuromuscular junction. All of them are skeletal muscle relaxant. All of them. Skeletal muscle relaxant. And desflurane is the best, then sevo, then iso, and then halothane. Remember this. Now guys, all inhalational anesthetic agent except the carrier gases, they all causes a bad side effect. They all can precipitate malignant hypothermia. So all of them can precipitate malignant hypothermia. So in malignant hypothermic patient, halothane is most unsafe, and rest are also unsafe. They all can precipitate malignant hypothermia. So inhalational agents are unsafe in malignant hypothermia. We have to remember. Malignant hypothermia, a pharmacogenetic disease which can be life-threatening and can be precipitated by very important two group of drugs. First one is precipitation of malignant hypothermia by first group of drug is succinylcholine. Succinylcholine is the most potent trigger of malignant hypothermia, and second is potent inhalational. And in malignant hypothermia, the metabolism becomes hyper. So it's a hypermetabolic state which can cause hypercarbia, hypertension, tachycardia, and hyperthermia. And it can be life-threatening because it all will lead to arrhythmias and muscle degradation, etc. So this is a life-threatening condition which can be precipitated by potent inhalational. So this is all about our potent inhalational anesthetic agent. Now coming on the carrier gas. Carrier gas, I told you, the one which is in clinical use is nitrous oxide, and one which we want to use it, but the problem is very costly, so we are not using it, is xenon, inert gas. So this has anesthetic property, but because cost-effective way of producing xenon is yet to be made, so it is still not in clinical use. So what's the difference between these two carrier gas? Number one, nitrous oxide has highest MAC. This is least potent. Xenon is also carrier gas, so it's less potent but more potent than nitrous oxide. So its MAC is 70. So it is more potent than nitrous oxide. Okay. Then blood gas solubility. Blood gas solubility of nitrous oxide is 0.45. It's a fast agent. Xenon is the fastest. It has blood gas solubility 0.11 to 0.19. So it is fastest. That's the best thing about xenon. Fastest agent, fastest induction, fastest recovery. Third, nitrous oxide is cardiovascular unstable. Why? Because it causes sympathetic stimulation. Xenon is cardiovascular stable, completely stable. Fourth, nitrous oxide is not metabolically inert. So it affects number of system of the body, metabolically inert. It can cause peripheral neuropathy. It can cause megaloblastic anemia. It can cause bone marrow depression. Xenon, no such thing. It's a metabolically inert agent. Okay. Then nitrous oxide is environmental pollutant. So environmental pollutant. Xenon is environmental friendly. Environmental friendly. So remember, xenon is a very good agent. The only problem is it is very costly. Very costly. So not in clinical use. Not in clinical use. So this is about our potent inhalational anesthetic agent and about our inert gases, which we use along with oxygen to carry the potent inhalational agent to the patient from anesthesia machine through the circuit to the airway of the patient, so that they reach the alveoli, patient inhale it, from alveoli they are uptaken in the blood and then they reach the target organ, central nervous system. Okay, remember, most of the inhalational anesthetic agents, they reach central nervous system and they act on the GABA receptor. So all inhalational and even the intravenous anesthetic agent, all inhalational and intravenous anesthetic agent acts on GABA receptor in brain, right? On GABA receptor in brain. Only nitrous oxide, xenon and the IV anesthetic agent ketamine, they act on NMDA receptor. NMDA receptor. Got it? So this is about our inhalational anesthetic agent. So the next group of drug which I will tell you is next induction and maintenance agent for general anesthesia, intravenous anesthetic agent. Intravenous anesthetic agent. Intravenous anesthetic agent. Guys, from inhalational, intravenous anesthetic agents has some clear-cut advantages. And when I use intravenous anesthetic agent alone, we call it TIVA, total intravenous anesthesia. Now, intravenous anesthetic agent is divided into two broad groups, opioids and non-opioids. Non-opioids, which is a diverse group. Well, opioids mostly for anesthesia, during general anesthesia, for routine general anesthesia, we are using it for analgesic dose. Analgesia, we are using it in analgesia dose. But we can also use them in a higher dose as a sole anesthetic agent. So, can be used as sole anesthetic only for major cardiovascular compromised patient. Why? Because opioid is completely cardiovascular stable. Non-opioids, most of them are cardiovascular unstable. So for major cardiovascular compromised patient, we are using opioid as sole anesthetic agent. Otherwise, we are using opioid only for analgesia purpose. And there are 4-5 opioids which is used as a sole anesthetic agents. Number one, which can be used as a sole anesthetic agent. Number one, morphine, fentanyl, sufentanil, alfentanil and remifentanil. Remember, in all these opioids, the best one is remifentanil. Why? Because it is not dependent upon liver and kidney for its metabolism. So, metabolism unique. Its metabolism is unique, independent of liver and kidney by non-specific esterase. It can undergo self-metabolism, non-organ elimination, and that's why it is safe even to be used in fetus, right? So, remifentanil is the best one. It is ultra short acting and given as infusion. Ultra short acting. Its half-life is 3 to 5 minutes. So, we use it as infusion. So, these are the opiates which can be used for sole anesthetic agent in severely compromised, cardiovascular compromised patient. Otherwise, for rest of all our patients, we are using non-opioids, right? We are using non-opioids. And in non-opioids, what are the drugs which will come? Thiopentone, propofol, etomidate, ketamine. These four I will discuss in a tabular form. So there is one more group of drug, that is benzodiazepine, which can also be used for induction and maintenance of general anesthesia. But as compared to other four drugs, it has slow onset and slow offset. So it is not a very popular drug to be used as induction for general anesthesia induction and maintenance. The major use of benzodiazepine, the three important benzodiazepine, that is midazolam, diazepam, and lorazepam, is for being prescribed as pre-anesthetic medication to allay anxiety, for pre-op medication, as a pre-op medication, as anxiolytic, okay, to allay anxiety. Rest of the four drugs, that is thiopentone, propofol, etomidate and ketamine, is being used as commonly used as IV anesthetic agents. So let us compare and contrast these four agents in a tabular form. So I will discuss with you thiopentone, propofol, etomidate and ketamine. These four drugs. Okay. The first point of comparison, I will discuss their commercial preparation. How do they look commercially? Commercial preparation of thiopentone, it's a yellowish powder. It comes in a yellowish powder form. Yellowish powder. Okay. Propofol is milky white in color. It's a milky white emulsion. Milky white emulsion. Etomidate comes in both milky white and transparent. Milky white and transparent both. So milky white and transparent. Transparent. And ketamine only as transparent liquid. Transparent liquid. Okay. So commercially they are available like this. Sometimes questions are given to recognize the drug. Okay. Next, I will discuss their chemical property. What are they chemically? It's a diverse group. They all belong to different groups. Thiopentone is a barbiturate. Barbiturate. Propofol is di-isopropyl phenol. Etomidate is imidazolone derivative. And ketamine is phencyclidine. Phencyclidine derivative. Okay. Next point I will discuss as what is their onset of action for induction. So what is their onset time? Well, thiopentone is has fastest onset within 11 to 14 seconds. Rest within 60 to 90 seconds. So which is fastest? Thiopentone. Now what is the duration of their action? Single dose duration. If I give a single dose, if I use it for maintenance, I have to give up infusion. But if I use it just like single dose I am giving to the patient, what is the duration of action? Well, all of them act for 6 to 8 minutes. All of them 6 to 8 minutes. That is, all of them are ultra short acting. All are ultra short acting. Why are these drugs ultra short acting? Because of rapid redistribution. This question is very popularly asked, that single dose of thiopentone or propofol causes rapid awakening. What's the reason? Answer is rapid redistribution. So all of them, not only thiopentone, all of them rapidly redistribute. This is an important thing which we need to remember. Okay. Next point which we will discuss is effect of these drugs on different organ system. Let us start with central nervous system. Well, all IV anesthetic agent decreases cerebral metabolic oxygen requirement, that is, they decrease cerebral activity. They all decrease cerebral activity, so oxygen requirement of brain is reduced. Except this unique drug, because of its unique property, ketamine. It does not decrease cerebral activity, rather it increases cerebral activity, so it increases cerebral metabolic oxygen requirement. Why? Why this drug increases cerebral metabolic oxygen requirement? Because This drug is sympathomimetic. Sympathomimetic, we have to remember it. It is sympathomimetic. So the effect of ketamine on different organ system would be affected by the fact that it is sympathomimetic. Okay. Now let us discuss. If CMRO2 is reduced, the cerebral blood flow should decrease. Yes. Cerebral blood flow, as I have already told you, that cerebral blood flow is directly proportional to oxygen requirement of brain. And here, if cerebral metabolic oxygen requirement is increasing, definitely the cerebral blood flow will also increase. So which IV anesthetic agent increases cerebral blood flow? Answer is ketamine. Which IV anesthetic agent increases the oxygen requirement of brain? Answer is ketamine. And when cerebral blood flow decreases, the ICP reduces, which happens in the first three agent, but ketamine increases intracranial pressure also. So ketamine is increasing ICP. Ketamine is increasing the activity of brain. It is doing so because it is sympathomimetic. Rest of the three drugs, similar effect. The next organ we will discuss is effect on cardiovascular system. Guys, the major demerit of non-opioid IV anesthetic agent is they are cardiovascular unstable. Thiopentone, myocardial depressant. So it is cardiodepressant. Propofol, myocardial depressant. So it is also cardiodepressant. The only non-opioid IV anesthetic agent which is not cardiodepressant is etomidate. So this is cardio stable, and I am writing it with red. It's very important point. Ketamine. Now people get confused by ketamine, that what is the effect of ketamine in cardiovascular system. Remember, ketamine in presence of catecholamine, it is sympathomimetic. It is sympathomimetic, we have already discussed. Why it is sympathomimetic? Because it inhibits catecholamine, that is adrenaline catabolism. That catecholamine, it inhibits catecholamine metabolism. That's why it is sympathomimetic. Okay. So when catecholamine is present in body, which normally should be there. So in presence of catecholamine, which should be a normal thing, it increases blood pressure and heart rate. Why? Because it is sympathomimetic. But in absence of catecholamine, right? In absence of catecholamine, as in critically ill patient, in absence of catecholamine, what will ketamine do? It will also be myocardial depression. So ketamine is also myocardial depressant. It is myocardial depressant. Only when the catecholamine is there, it will increase blood pressure and heart rate. And then also why it's increasing blood pressure and heart rate? It is cardiovascular unstable. So only cardiostable drug in this group is etomidate, an important exam point. Next effect is on respiratory system. The common thing which we all should know for any anesthetic agent, they all are respiratory depressant. They all are respiratory depressant. They all inhibit respiratory drive. So they all blunt respiratory drive. Similar thing actually. And most of them are bronchodilator except thiopentone. Thiopentone is bronchospastic. Bronchospastic, a major issue of thiopentone. Propofol, very good bronchodilator. Very good bronchodilator. So propofol is also a bronchodilator, a good one. Even etomidate is a bronchodilator, and ketamine is the best bronchodilator. Best bronchodilator. So ketamine is best bronchodilator. So in bronchial asthma, best is ketamine. Ketamine is best in bronchial asthma. So in bronchial asthma, ketamine would be best. And the second best would be propofol. Places where ketamine is not much in clinical use, propofol is agent of choice in bronchial asthma. But if ketamine is given in the option, we still have to go for ketamine is an answer because it is a better bronchodilator than propofol. Propofol is the second bronchodilator. Then hepatic and renal. For hepatic and renal, no one has any untoward effect. No untoward effect. Now remember, all of them are metabolized by liver and kidney. Only propofol has a extrahepatic and extrarenal route of metabolism. Only propofol has extrahepatic and extrarenal route of metabolism, which is a unique property of propofol, right? So that is why in case of liver or kidney dysfunction, propofol could be used and other agents should be avoided. Now let us discuss where were their agent of choice. Remember, thiopentone nowadays for anesthesia has become obsolete. If at all it is used, only it is used for induction, and then also it is not agent of choice. But it is agent of choice for two non-anesthetic use. It is agent of choice in narcoanalysis, sometimes asked as a truth serum, and third, for agent of choice for neuroprotection, cerebral protection. It is the best drug for cerebral protection because it decreases cerebral metabolic oxygen requirement maximum. Now, propofol is a wonderful anesthetic agent and it is the anesthetic agent of choice for many conditions. So, propofol is used for induction and maintenance of anesthesia as agent of choice in number of conditions like daycare surgery. It is best for daycare surgery because it has some unique benefit which other drug doesn't have. It is antiemetic. It gives pleasant recovery, and it has no residual effect after anesthesia, no residual effect post-op. Okay, so all these makes it best agent for daycare surgery. For daycare surgery, the only agent which we should choose is propofol. Second, it is agent of choice for neurosurgery. It is agent of choice for thoracic surgery. It is agent of choice for hepatic and renal surgery, since it has extrahepatic, extrarenal route for metabolism. It is agent of choice in malignant hyperthermia, patient with malignant hyperthermic gene, malignant hyperthermia. It is agent of choice in porphyria, where other agents are not used. So it is agent of choice in number of clinical conditions. So very good IV anesthetic agent. Only problem is it is cardiovascular unstable. Etomitate for induction and maintenance of anesthesia is only used in a patient with cardiovascular dysfunction because it is cardiovascular stable. So only used in cardiovascular compromise. Why it is used in cardiovascular compromise? Because it is cardiovascular stable. And why it is not used in other condition? Because it has a very bad side effect which I will discuss in few seconds. Okay, ketamine, it is agent of choice in bronchial asthma because it is best bronchodilator. Shock, very important because it is sympathomimetic. It will increase blood pressure and heart rate and also give anesthesia. So, agent of choice in shock. And it is agent of choice in cyanotic heart disease. Because it increases the blood pressure being sympathomimetic. And in cyanotic heart disease, we don't want the systemic pressure to fall because it will cause reversal of shunt. So, it is agent of choice in all these conditions. Now, where they are contraindicated? Contraindication of these drugs. So, where they are contraindicated? Thiopentone has three important contraindications: shock, bronchial asthma, since it is bronchospastic, and porphyria. It can precipitate porphyria. And propofol has only one contraindication: shock. Etomitate is not used apart from cardiovascular unstable patient because etomitate has a very bad side effect, adrenal suppression. So, not used except in cardiovascular compromise. In cardiovascular compromise, we want to use it because it is cardiovascular stable. And ketamine is contraindicated in number of conditions because it is sympathomimetic. So, it is contraindicated in ischemic heart disease or coronary artery disease. It will increase blood pressure, heart rate. It can precipitate it. In hypertensive patient, we should avoid it. In patient with increased ICP, that is neurosurgery patient, we should avoid it. Glaucoma, we should avoid it. Right? All these conditions we should avoid using ketamine. We should also avoid using ketamine in critically ill patient, because critically ill patient, it will cause severe myocardial depression because they are catecholamine depleted. So in all these conditions, ketamine is contraindicated. Now let us discuss unique side effect of these drugs. Side effect. Thiopentone is anti-analgesic. So requirement of analgesia increases. It decreases the pain threshold, patient feels more pain. Propofol, pain on IV injection. Pain on IV injection. Local pain on IV injection. Where you inject propofol, the vein out that area starts having patient having a lot of discomfort in that area. So local pain on IV injection is the most common side effect of propofol. And one more side effect, propofol infusion syndrome. Propofol infusion syndrome, which can cause death. So that is why propofol is avoided for clinical use for more than 48 hours infusion. So not used for more than 48 hours infusion as sedative. So we use it for short duration, less than 48 hours, not for more than 48 hours. Okay. And as an anesthetic, we don't need it to use for more than 48 hours. Etomidate, the most important side effect, which I'm writing with red, is it adrenal gland suppression, causes adrenal suppression. That is, inhibits cortisol synthesis. Cortisol synthesis. That's the major demerit of your etomidate, adrenal suppression. And next is myoclonus. Myoclonus. It causes post-op myoclonic activity. And it is most emetogenic, highly emetogenic, most emetogenic. Right? These are the major issues of etomidate. Ketamine, again a very unique side effect which you need to remember, so many times asked in exam. It causes emergence delirium. Emergence delirium. Post ketamine anesthesia, patient starts hallucinating and become delirious. So this is the unique side effect of ketamine. And what is the treatment of this emergence delirium? We give midazolam, that is benzodiazepine. So these are the points which we need to know in IV anesthetic agent. And as I told you, if I am using IV anesthetic agent for induction and maintenance, then we call it TIVA. That is total intravenous anesthesia. Got it? So we call it TIVA. Okay. So these inhalation and IV were our induction and maintenance agent of anesthesia. Now in general anesthesia, we also need a muscle relaxation, and for that we need the third group of drug which I am going to discuss with you, and that is neuromuscular blocker. Neuromuscular blocker. Now neuromuscular blocker are the drugs which are used, which act on neuromuscular junction. They act on neuromuscular junction and they cause something called muscle paralysis. Muscle paralysis. As a result of muscle paralysis, we get a very good muscle relaxation. They never act on CNS and they never produce loss of consciousness. So neuromuscular blocker are divided into two groups. It is divided into two groups. Okay. They are divided into depolarizing and non-depolarizing. Non-depolarizing. Okay. Depolarizing and non-depolarizing. In depolarizing neuromuscular blocker, the only example which we need to know is succinylcholine. This is the only clinically used neuromuscular blocker, that is succinylcholine in depolarizing group. It is classified into three groups. The first one is aminosteroid. The second is benzyl isoquinoline. And the third group is new group, that's oxime. Oxime chlorofumarate group, oxime group. Okay. In aminosteroid, we have pancuronium, pipecuronium, vecuronium, and rocuronium, and rapacuronium, right? Rapacuronium. In benzyl group, we have D-tubocurare, right? We have D-tubocurare, right? Doxacurium, atracurium, cisatracurium, and mevacurium. And in oxime group, we have a new drug. I'm writing with red, that's gantacurium. Okay, so these are the drugs which belong to the group non-depolarizing neuromuscular blocker. Okay, now let us talk about the difference between depolarizing and non-depolarizing. Okay, then I will come on the drugs in the chart itself. So what is the basic difference between depolarizing and non-depolarizing? Depolarizing, what is the mode of action? Mode of action. The depolarizing neuromuscular blocker, the mode of action is by prolonged or persistent depolarization of nicotinicholinergic receptor. So succinylcholine causes prolonged or persistent depolarization of nicotinicholinergic receptor. So what is the mode of action of succinylcholine? Prolonged depolarization of nicotinic cholinergic receptor. Nicotinic cholinergic receptor. What is the mode of action of non-depolarizing? They do not cause depolarization of the nicotinic cholinergic receptor. Their mode of action, all of them, what is their mode of action? The mode of action is by competitive inhibition. Competitive inhibition or competitive antagonism. Okay. Succinylcholine causes depolarization. So, succinylcholine, the paralysis is preceded by a fasciculation. So, here fasciculation, because it causes depolarization. So, a temporary contraction is seen in, a small contraction is seen in, a fasciculation is seen in all the muscle of the body. Fasciculation is seen. Here, they do not depolarize. So, no action on neuromuscular junction will happen. So, what will happen? No fasciculation. No fasciculation. Now, because of this fasciculation, there is post-operative myalgia complaint in succinylcholine. Here, no fasciculation, so no post-op myalgia. Succinylcholine, what is the mode of action? Persistent depolarization. So, until and unless receptor gets repolarized, a normal action at neuromuscular junction is not possible. But competitive antagonism, what is their mode of action? The non-depolarizing, more in quantity, goes and sit on the receptors, nicotinicholinergic receptor, do nothing, right? And does not let acetylcholine come in contact with the receptor. So, there is a paralysis. If I increase the quantity of acetylcholine again, I can reverse the paralysis produced by non-depolarizing. And what can increase the quantity of acetylcholine? Answer is an anti-acetylcholinesterase, which will prevent the action of cholinesterase, which causes metabolism of acetylcholine. An example of anti-acetylcholinesterase, neostigmine. So, reversal by neostigmine is seen in non-depolarizing, not in succinylcholine. So, succinylcholine not reversed. Non-depolarizing, reversed by neostigmine. So, remember, okay. Fifth important point, there is response to the stimulus, train of force stimulus. If I give force stimulus of equal strength after giving succinylcholine to any neuromuscular junction, then it will not have a fade, because succinylcholine reaches the neuromuscular junction and most of the nicotinic receptor goes into depolarized state. So, only action would take place on the remaining receptor. So, there would be no fade seen. So, here no train of force response. No train of force response. So, if I give, I would get 4 contraction of similar amplitude, just less than what normal contraction I would have got. And in case of non-depolarizing, fade on train of force stimulus, and that is what is called train of 4 response. So something like this will be seen. 4 equal strength stimulus would produce a lesser and lesser response. So this is called train of 4 response, and this is seen in non-depolarizing. Okay, and the last difference is that succinylcholine, no post-tetanic facilitation, no post-tetanic facilitation seen. Non-depolarizing, post-tetanic facilitation seen, right? So these are the basic difference between depolarizing and non-depolarizing, and all the non-depolarizing would show these difference with succinylcholine. Okay, now guys, remember, succinylcholine is fastest and shortest neuromuscular blocker, fastest and shortest neuromuscular blocker. It is metabolized by something called pseudocholinesterase present in plasma, by pseudocholinesterase present in plasma, or we call it plasma cholinesterase or butyryl cholinesterase. So it is metabolized by pseudocholinesterase. In case of absence of this pseudocholinesterase, a side effect called succinylmethonium apnea can be seen with succinylcholine. So succinylmethonium apnea in case of pseudocholinesterase deficiency or atypical pseudocholinesterase or not normal pseudocholinesterase. What will happen? Succinylcholine will not get metabolized and more drug will reach neuromuscular junction, and action of succinylcholine will be prolonged. It is shortest. It should only act for 6 to 8 minutes. But in case of absence of pseudocholinesterase, the action would get prolonged, and we call it succinylmethonium apnea. Okay. And succinylcholine, we routinely use single or maximum 2 doses of succinylcholine or 3 doses maximum, not more than that. Because when we give repeated dose of succinylcholine, the receptor can get desensitized by the effect of succinylcholine, and again succinylcholine can start showing prolonged duration of action, and we call it desensitization block or phase 2 block. So another side effect of succinylcholine is phase 2 block on repeated administration. When I give it repeatedly, it can go into phase 2 block, and phase 2 block is desensitization block, and when it enters phase 2 block, it starts behaving like a competitive antagonist. So in phase 2 block, succinylcholine starts behaving like a competitive antagonist and will start showing all the property of non-depolarizing. It's succinylcholine. In phase 2 block, it will start showing the property of non-depolarizing. Got it? So remember, now succinylcholine has a lot of side effects. As just now I told you, it can have pseudocholinesterase, it can cause succinylmethonium apnea in the absence of pseudocholinesterase, it can on repeated dosing goes into phase 2 block, and since it causes fasciculation, succinylcholine, prior to paralysis it produces fasciculation. The side effect because of fasciculation would be post-op myalgia, right? And it can increase intraocular pressure, intracranial pressure, that is intragastric pressure, all the closed cavity pressures. And it can also cause, because of fasciculation, hyperkalemia, right? It can cause hyperkalemia. And since it is a depolarizing neuromuscular blocker, if it goes near cardiac muscarinic receptor, it can show a side effect, bradycardia also. Bradycardia, right? It can cause bradycardia because acetylcholine causes bradycardia. Succinylcholine will act similar to acetylcholine on muscarinic receptor and can cause bradycardia also. And it can trigger malignant hypothermia. We have already discussed malignant hypothermia. So all this makes succinylcholine a bad neuromuscular blocker. We should not use succinylcholine because it can cause bradycardia, it can trigger malignant hypothermia, it can cause hyperkalemia, it can increase the pressures of the body, it can cause fasciculation, post-op myalgia, succinylmethonium apnea may happen, and even phase 2 block on repeated administration. So all this makes it a bad neuromuscular blocker. But since it is fastest and shortest, we need to use it at certain indicated condition. So what is the use of succinylcholine? Succinylcholine use We use it in two major conditions. We use it for rapid sequence induction when we want the onset of neuromuscular blocker to be fast, as in rapid sequence induction intubation. So we use it for rapid sequence induction intubation. Okay, we use it for rapid sequence induction intubation because why do we use it here? Fastest onset. Fastest onset. Okay. And the second use of succinylcholine is for very short general anesthesia, right? For very short general anesthesia, as in electroconvulsive therapy, etc. And we also use it because it has shortest duration for difficult airway condition. Difficult airway intubation. Difficult airway intubation attempt. So these are the uses of succinylcholine. Otherwise, routinely, which neuromuscular blocker we use? We use non-depolarizing neuromuscular blocker, our competitive inhibitors. And what are the drugs which comes in it? Aminosteroid, benzyl and oxime. Now, in this group, first two drugs of aminosteroid and benzyl group, they are long-acting. Second two drugs, they are intermediate acting. And last one drug of both the group are short-acting. Now, guys, remember, Gantacurium. Gantacurium, a new drug of belonging to non-depolarizing neuromuscular blocker, and oxime. This drug, it has been made to replace succinylcholine. It also has very short duration and very fast onset, similar to succinylcholine. But since it is non-depolarizing, it will not have the side effects of succinylcholine. So once it comes in the clinical use, it will replace succinylcholine. Gantacurium, a new drug. Now, rest aminosteroid and benzyl isoquinoline. Guys, few important things we need to know of these two groups. Remember, benzyl group. Benzyl group is histamine releaser group. Histamine releaser. Since it is histamine releaser, it can cause hypotension and tachycardia. So this group is cardiovascular unstable. And aminosteroid group is non-histamine releasing group. Non-histamine releasing group. So non-histamine releaser, so cardiovascular stable. So definitely in our operating room, we would like to use aminosteroid, which is cardiovascular stable. And today we like to use intermediate acting one. So most common neuromuscular blocker for the routine use nowadays is vecuronium and rocuronium. Remember, vecuronium and rocuronium. But both are metabolized by liver and kidneys. Most of the aminosteroid metabolism is by liver and kidney metabolism. In case of any liver and kidney dysfunction, atracurium or cis-atracurium becomes neuromuscular blocker of choice because of their unique metabolism. Atra and cis-atra has a unique metabolism in the name of Hoffman degradation. Hoffman degradation. Got my point? So atracurium and cis-atracurium undergo non-organ elimination or Hoffman degradation and non-specific ester hydrolysis. Two pathway. Both are organ independent. Non-specific ester hydrolysis present in RBC and let's say some esterase present in RBC, WBC can also break atracurium and cis-atracurium. So non-specific ester hydrolysis and Hoffman degradation. So they have a organ independent metabolism. So in liver and kidney dysfunction, they become neuromuscular blocker of choice. Otherwise, the commonest one is vecuronium and rocuronium. Now, one last point I want to add in this chart, that if Gantacurium is mentioned among non-depolarizing, it is the fastest and the shortest. But if it is not mentioned, since it is still not very much in clinical use, then the fastest non-depolarizing is rapacurium. This is the fastest, but it is not in clinical use. Then rocuronium is second fastest. The rest have same onset of action. Rocuronium, the onset of action is 90 seconds. Rapacuronium has fastest 75 seconds and rest all have 3 to 5 minutes of onset. They produce paralysis within 3 to 5 minutes, rest all. And shortest duration, mivacurium. Miva has shortest duration among non-depolarizing. If Ganta is not in the option. If Gantacurium is in the option, it is shortest and fastest. but it is a new drug, still not very much in clinical use. Okay, just remember. Okay, overall fastest and shortest is our succinylcholine. Fastest and shortest is succinylcholine. Okay, Ganta is nearly, its onset and duration is near about to succinylcholine, but overall still the fastest and shortest is succinylcholine. But if Ganta comes in the market, then Ganta cream will replace all the uses of succinylcholine. Okay, so this is the difference between depolarizing and non-depolarizing. Now guys, when we reverse general anesthesia, the reversal of neuromuscular blocker, we have a privilege of using some reversal agent. So neuromuscular blocker, for neuromuscular blocker, we have some reversal agents. Okay. The first drug is the commonest one which we are using, I am telling you, neostigmin, as I talked about, neostigmin and anti-acetylcholinesterase, stigmin plus glycoparolate or atropine combination. Atropine combination, right? Neostigmin is an indirect reversal agent. Indirect reversal agent. How would it reverse? Indirect reversal agent, how would it reverse? Simply by increasing the quantity of acetylcholine. There is a direct reversal agent in the name of Sugama-dex. Sugama-dex. Sugama-dex, a direct reversal agent. Okay, direct reversal agent for which group? Aminosteroid. It will bind to the aminosteroid and it will reverse it, especially rocuronium and vecuronium, right? Rocuronium or vecuronium. And there is a new drug in the market, a new reversal agent still in inception phase, calabedion. This is a direct reversal agent, calabedion. This is a direct reversal agent for all non-depolarizing, right? Even benzyl isoquinoline. Sugama-dex is only against aminosteroid, but calabedion has shown a promising reversal effect even on our benzyl isoquinoline. Okay, still in inception phase, still not in the market. So these are the drugs I wanted to discuss in drugs which we use for general anesthesia. We discussed inhalational, intravenous, we use for induction and maintenance, and neuromuscular blocker which we use for producing muscle paralysis. Now let us discuss the drugs which we use for regional anesthesia. Coming on regional anesthesia. And what is the drug which we use for regional anesthesia? We use local anesthetic. Local anesthetic. So what is local anesthetic? Local anesthetic, when deposited locally near a nerve fiber, it will stop the transmission of that nerve fiber. So this drug, when it is locally deposited near a nerve fiber, it will stop its transmission. It will stop its transmission. So it will stop the transmission of that nerve fiber and the area supplied by that nerve fiber will get anesthetized, and this is what is called regional anesthesia. Now first point, how does it stop its transmission? By binding to the voltage gated sodium channel. So how does it stop the transmission? By binding to the sodium channel. By binding to sodium channel. Action of local anesthetic, remember, is voltage gated because it binds to the sodium channel, a voltage gated channel, voltage gated and time gated. It acts best when the channel is open, so that it binds to the sodium channel from its inner cytoplasmic side. It does not bind to the sodium channel from its outer side, rather from its cytoplasmic side. So when the channel is open, it binds to it faster. So both time gated and voltage gated. Third important point, number of time we add some additive to the local anesthetic for making its onset fast and duration prolonged. So what a common additive which we add is a vasoconstrictor. So we add vasoconstrictor vasoconstrictor. Adrenaline, the most common, adrenaline. Number of other vasoconstrictor also we add, but the most common one is adrenaline. Sometimes we also add alpha 2 agonist like clonidine, dexmedetomidine. Adrenaline, when we add, there are some additives which we add to the local anesthetic to prolong its duration and also to make its onset fast, like adrenaline, and some alpha 2 agonists like dexmedetomidine or clonidine. Okay, adrenaline is added in 1:2 lakh concentration. 1:2 lakh concentration. Always in 1:2 lakh concentration. So when adrenaline is added or any other alpha 2 agonist is added, they are vasoconstrictor. They constrict the surrounding blood vessel and keep the drug there near the nerve fiber, prevent the intravascular absorption of the drug. So what they do? They keep the drug near the nerve fiber, so onset becomes fast and duration gets prolonged. So they make onset fast and duration of the block prolonged, duration prolonged, plus less systemic toxicity because of less systemic absorption of the drug. So less systemic toxicity, less systemic toxicity. Got it? There is another vasoconstrictor we popularly add. We add sodium bicarbonate, right, to local anesthetic. That is, we alkalinize the drug. Why? To prevent ionization of the drug. Ionization of the drug. The drug remains unionized, so they remain lipid soluble. Again, the same benefit: onset fast, duration prolonged. Duration prolonged. Got it? Okay. The next point, sensitivity of local anesthetic on different nerve fibers. Now, there are different nerve fibers. We all know A, B, C, A alpha, beta, gamma, delta, different nerve fibers. So, sensitivity of local anesthetic on different nerve fiber. Now guys, this is a bit controversial question, and number of places answer is given in a very different sequence. Well, from few books, what I have come out to be, and clinically what also we see, that it is most sensitive on B fibers, then A delta equal to C, then A gamma, A beta and A alpha, right? Some books also write that A delta, A gamma, A beta, A alpha, B, C, this sequence also. So in some books it is written, one of the very important textbook of anesthesia, Miller, it writes A delta, then A gamma, then A beta, A alpha, then B and then C. So anesthesia textbooks have quoted it differently. I go more with this sequence. This is what we clinically also see, because what we clinically see is that sympathetic block is happening first. So sympathetic block first, that is, first the autonomic nervous system gets blocked. So autonomic first, followed by sensory and followed by motor. So autonomic nerve fibers are most sensitive, and we all know B is preganglionic autonomic fibers. Okay, autonomic fibers are blocked first, then sensory, and then motor block happens. In sensory also, we have temperature blocked first, then pain, then touch, and then proprioception. Proprioception. Got it? Okay. Now, local anesthetic is divided into two broad groups. It is divided into two broad groups. It has a amide, amino bond, and it has a aromatic group, which is binded to each other either through a ester link or a amide link. And depending upon the link binding the amino and aromatic group, it is divided into two groups, ester and amide. Right? In ester we have cocaine, procaine, chloroprocaine, benzocaine and tetracaine. In amide we have lignocaine, mepivacaine, prilocaine, bupivacaine, levobupivacaine, ropivacaine and dibucaine. Ropivacaine and dibucaine. Okay. Ester, first three drug, they are short acting. Duration of action is shortest. So short acting. And last two long acting. Amide, first three drug, intermediate acting, and last four long acting. Now remember guys, all ester LA except cocaine are metabolized by pseudocholinesterase. So this group, metabolism by pseudocholinesterase, except of course cocaine, and the other group metabolism is by liver. This group hepatic metabolism, and cocaine also hepatic metabolism, cocaine also hepatic metabolism, remember. Okay guys, among this whole group of drug, few important points we need to know. Well, cocaine is an exception in this group. Cocaine is metabolized by liver in spite of belonging to ester local anesthetic, and cocaine is a only vasoconstrictor among all local anesthetic. Rest are vasodilators. Okay, cocaine is a vasoconstrictor, so it would not need addition of adrenaline with it, right? So it's the only vasoconstrictor. Why it is vasoconstrictor? Because it's sympathomimetic. Cocaine was the first LA to be used. It's a natural LA. It was first LA to be used. Shortest local anesthetic, cocaine, procaine, chloroprocaine is short, and shortest is chloroprocaine. It has shortest duration. Longest we have dibucaine. Most common LA used is lignocaine. This is the most common local anesthetic to be used. The only LA which is used intravenous also, IV also. So this is the only LA which is used intravenous also, because it is considered as one of the safest local anesthetic. And most cardiotoxic is bupivacaine. Bupivacaine is most cardiotoxic. Okay, it is most cardiotoxic because it has highest risk of cardiotoxicity. Okay, so these are the few important points I have to tell you in this table. Now coming on the side effects of local anesthetic, what are the complications of using them? We always have to give them locally near a nerve fiber. If they will get systemically absorbed, they will cause LAST, that is local anesthetic systemic toxicity. And in this you need to know CNS toxicity and CVS toxicity. CNS toxicity, clinical features like tinnitus, perioral numbness, right? Seizures, etc. can happen. None are life threatening. But CVS toxicity, arrhythmia and cardiac arrest. It can also lead to cardiac arrest. And bupivacaine is most cardiotoxic. So bupivacaine is most unsafest LA. It's one of the commonest used LA because of a very good duration of action and very good differential blockade. So we have to use it carefully. Okay, just remember, last local anesthetic systemic toxicity. The management is symptomatic management. Whatever the symptom comes, we manage it. And a very important drug, an antidote in local anesthetic systemic toxicity, is something called lipid emulsion, 20% intralipid emulsion, because local anesthetic undergo lipid escape. Okay, the second complication is methemoglobinemia. They can cause methemoglobinemia. Not all of them, just two important local anesthetic which is very important to remember: prilocaine and benzocaine. They both can cause methemoglobinemia. So the next complication is neurotoxicity, that is direct toxicity to the nerve fibers. And two local anesthetic, chloroprocaine and lignocaine, is notorious in causing neurotoxicity. There has been report of them causing neurotoxicity. So what is the use of these local anesthetic? So what are the uses of this local anesthetic? Definitely it is being used to produce regional anesthesia. So local anesthetic is used to produce regional anesthesia. Now, depending upon where it is deposited, regional anesthesia can be divided into different divisions. Now, first is, for example, topical anesthesia. Topical anesthesia, when we put the drug on mucous membrane or skin surface. And one very important local anesthetic you have to remember in it is EMLA, that is eutectic mixture of local anesthetic in which lignocaine plus prilocaine is mixed in 1:1 ratio in 2.5% concentration each. It is applied on the skin surface and produces a very good topical anesthesia. Okay. Then the other is our local infiltration. This is very popular technique for dental procedures, local infiltration. Now, in local infiltration, the local anesthetic is deposited around the nerve fiber, not let's say extravascular space, around the nerve fiber in extravascular space. And for tooth extraction, etc., this is a very common technique practice. So, local infiltration, LA deposited in extravascular space around the nerve fibers, terminal nerve fibers. Third is peripheral nerve block. Peripheral nerve block. Now, for peripheral nerve block like brachial plexus block, sciatic nerve block, the local anesthetic is deposited around in the tissue around the nerve fiber. So, wherever the nerve fiber is located, around that tissue, the local anesthetic is deposited. So, this is peripheral nerve block. Fourth is IVRA, that is intravenous regional anesthesia. IVRA. This is IVRA, a popular technique in which local anesthetic is given intravenously after excluding that limb from rest of the circulation by tying a tourniquet. It is practiced only in either upper or lower extremities. Two important points you have to remember in this, that most common drug used is lignocaine, which I told you is considered one of the safest, and local anesthetic contraindicated for IVRA is bupivacaine. Local anesthetic contraindicated for IVRA is bupivacaine. And the fifth type of regional anesthesia is central neuraxial blockade. Central neuraxial blockade, very important. What do I mean by central neuraxial blockade? This is the spinal cord, and from spinal cord, spinal nerves come out. When I block the spinal nerve root, then we call it central neuraxial blockade. That is when I am targeting spinal nerve root, when I am putting the local anesthetic around spinal nerve root. And we all know that spinal cord is covered by pia mater, arachnoid matter, and by dura mater, right? So, pia mater, arachnoid matter and dura matter. And if I put the drug between pia and arachnoid matter, that is in subarachnoid space, we call it spinal anesthesia. And if I put the drug outside dura mater, we call it epidural. And they come under central neuraxial blockade, and both are targeting spinal nerve root. So, first point in this I will tell you about difference between spinal anesthesia and epidural anesthesia. Epidural anesthesia. Spinal anesthesia and epidural anesthesia. Okay. As I told you, spinal means drug in subarachnoid space, local anesthetic in subarachnoid space. Epidural means local anesthetic in extradural space. But both are targeting spinal nerve root. So what is the difference? First, In subarachnoid space, we have CSF. So when I am putting the drug in CSF, very fast drug is ascending and descending and number of spinal nerve root gets blocked. So onset is very fast in spinal. So onset, fast. Epidural onset is delayed onset. Then in spinal, since we have a vehicle called CSF, so a very small amount of drug is enough to block many spinal nerve roots. So quantity of a local anesthetic required is less. Here, to block per segment, we need a certain amount of drug, 1.5 to 2 ml drug per spinal dermatome which we have to block. So, per spinal dermatome requires 1.5 to 2 ml drug. More drug, more risk of local anesthetic systemic toxicity. Okay. Then spinal anesthesia, we get a dense block, immediate dense block. Epidural can sometimes be patchy. Now if you see this, for spinal, I am taking the spinal needle. So if you see this diagram of this image of spinal needle, this is a spinal needle. This is spinal needle. So if you see, this is a uniform needle with no markings on it and it has a stellate inside it. Okay. So when I take the spinal needle, first thing which I pierce is skin. Then I pierce subcutaneous fossa. Then I pierce supra and then I pierce interspinous ligament. And then I pierce ligamentum flava and then dura mater and then arachnoid mater and then I reach subarachnoid space, right? Then I am reaching subarachnoid space. Then I take the stellate of the needle out. There is a return of CSF. See the CSF and then I give the drug and take the needle out. So the end point has a visible identification in the form of return of CSF. So I can identify the subarachnoid space by return of CSF, free flow of CSF. But for epidural, how I am giving, if you see this is a epidural needle. It is thicker than spinal and it has markings on it, right? It also has stellate. So I'll come on needle a little later. Okay. So for epidural, again I take the epidural needle. I pierce skin, then I pierce subcutaneous fossa, then supraspinous ligament, then interspinous ligament, and then ligamentum flavum. And then I reach the epidural space. If you have seen the whole kit, I showed you the whole kit of epidural. This is something called loss of resistance syringe. We attach on the back of the needle and with the constant pressure on the plunger, we go inside. And when I feel a sudden loss of resistance, I know I am in epidural space. So I feel the epidural space. I do not have a visible elicit, right, of something when I reach the epidural space. In spinal, we have a visual elicit of return of CSF, but same thing we don't have in epidural. So guys, epidural, chances of failure is more. Spinal is easy and less incidence of failure. Epidural needs more expertise and then also chances of more failure. So till now we have discussed all the benefits of spinal. What are the benefits of epidural? Definitely it must have a benefit. Definitely we have benefits of epidural also. Spinal is a single shot technique, right? Single shot technique. So duration is fixed. So duration of anesthesia produced by spinal is fixed. Duration is fixed. But if you have noticed the whole epidural set, you can see this is a catheter. When I reach epidural space, I do not give the drug. I put this catheter in the epidural space. The terminal end of the catheter is in epidural space and the other end is on outside the skin. So through this end, I can go on giving the drug and I can prolong the duration of anesthesia as long as I want. So the duration can be prolonged. Epidural is mostly continuous technique. Duration can be prolonged. Now the spinal has fixed duration, 2.5 to 3 hours, max 3.5 hours. So it is only used for intra-op anesthesia, only for intra-op anesthesia. Epidural is used for intra-op anesthesia plus post-op analgesia. Post-op analgesia. Got my point? Spinal is producing dense immediate block. So number of spinal dermatome, spinal nerve root is immediately getting blocked. So more hemodynamic imbalance. So more hemodynamic imbalance due to blockage of sympathetic nerve fibers traveling with spinal nerve, right? Epidural is gradual, so less hemodynamic imbalance. Less hemodynamic imbalance. Now, spinal cannot produce a segmental block. Epidural, depending upon which area I have to block, I can produce a segmental block. Spinal segmental block not possible because of CSF, the drug mixes and uniform block we get. Segmental block not possible. Epidural segmental block possible. Okay. Ninth point. Spinal and epidural both can be combined, and today we are practicing combined spinal epidural. So both have their benefit and both can be combined, and we are practicing something called combined spinal epidural. For spinal, what are the needle which we use? For spinal needle, we are using two type of needle, dura cutting and dura splitting. Dura cutting needle, most popular one is Quincke. Dura splitting, we have two important needles, Proti and Whitaker. So if you see the image, first one, this is dura cutting needle. It has a sharp edge, and on the edge only there is a opening for the CSF to come out and for the drug to go, right? So it has a very sharp edge. It cuts the dura mater fiber, and chances of CSF, continuous CSF leak is more with this. Other two needle you can see, they are pencil tip. They are not so sharp on the terminal end, they are pencil tip, and they have opening on in their body, in their terminal body, not on the terminal end. So these are dura splitting, pencil tip, dura splitting, and this is dura cutting. So I gave you the example of both the needle. For epidural, the most popular needle which we use is Tooheys needle, and I told you we have markings, 1 centimeter markings on it. This is how you distinguish between spinal and epidural needle. Now let us discuss the complication of both spinal and epidural. The most important questions asked are on complications. So as I told you that when we block spinal nerve root, along with it we are blocking also sympathetic fibers, right? And because of the block of the sympathetic fibers, we are getting a lot of complications, right? This is the spinal cord, and from spinal cord, the spinal nerve which is coming, it is carrying with it sensory fibers, motor fibers, and also autonomic fibers. And with spinal nerve, total sympathetic nervous system travels, because sympathetic nervous system, the origin of preganglionic sympathetic fibers are from thoracolumbar segments. So when I am blocking thoracolumbar spinal nerve, along with it also I am blocking the sympathetic fibers, and I am producing a most common complication, hypotension. So most common complication is hypotension. This is most common complication of spinal and epidural anesthesia. More of spinal, less of epidural. Second, bradycardia. Because of sympathetic block, the parasympathetic overdrive, bradycardia. And together, if the patient has high spinal, together hypotension and bradycardia can come. So in high spinal, we will get both hypotension and bradycardia. Then respiratory depression. It may be due to hypotension because of hypoperfusion of the respiratory center, and also may be due to blockage of C fibers. Fourth, retention of urine, because bladder, sympathetic and parasympathetic both will get blocked with spinal and epidural. Retention of urine. This is most common post-op complication. Post-op complication. Then fifth, very important, total spinal anesthesia or high spinal. Total spinal anesthesia or high spinal. In this, what can happen? All the 31 pair of spinal nerve root can block. 31 pair of spinal nerve root can get blocked. So, hypotension, bradycardia, respiratory depression, all can come. Sixth, in epidural mostly, last, local anesthetic systemic toxicity, since we are using a higher volume. So, local anesthetic systemic toxicity can happen. Then infection, if we don't paint and drape properly, and post-dural puncture headache due to CSF leak. Post-dural puncture headache, which is less seen nowadays because we are using mostly dura splitting needle. So these are the complications. Now what are the contraindication of central neuraxial blockade? Contraindication of central neuraxial blockade. When we cannot give spinal and epidural. There are few contraindications. Number one, local infection of the site from where we will inject, we'll use the needle, the site is infected, local infection of site. Second, high intracranial pressure, high intracranial pressure. Third, patient's refusal, patient is refusing the regional, he doesn't want to remain conscious in operating room. So it's an absolute contraindication, patient's refusal. Fourth, severe hypovolemia, severe hypovolemic shock, hypovolemia. If patient is in hypovolemia, then they need a high sympathetic tone to maintain the blood pressure, and with spinal and epidural we will remove that sympathetic tone, so it will get exaggerated. So in severe hypovolemia we don't go for it. Then fifth, severe heart disease, severe heart disease. Well, for severe heart disease, general anesthesia is preferred. For severe heart disease, we are using general anesthesia. Sixth, coagulation disorder. Coagulation disorder. Okay. So, fifth is coagulation disorder, because these are blind procedures and coagulation disorder. In case of coagulation disorder, spinal or epidural hematoma can form. Got it? So, these are the 6 contraindication of central neuraxial blockade. These two nowadays have become relative contraindication, right? That we have to, depending upon the person who is giving the spinal epidural, can decide depending upon the condition of the patient. But still you remember these are the contraindication of central neuraxial blockade. So this is all about central neuraxial blockade. Now before finishing off this rapid revision of this topic, just a small table. How do we answer any question on post-op analgesia? For post-operative analgesia, post-operative analgesia, we see the type of surgery, major surgery or minor surgery, and then we see the patient, that is adult or pediatric. If it is adult and the surgery is major, then we go for neuraxial, that is epidural opioid. We give morphine in the epidural space and it produces an excellent analgesia. If it's minor surgery, then IV, IM, oral, NSAID. Pediatric neuraxial route for opioid is not preferred because respiratory depression is a complication with neuraxial opioid. So we can go for IV opioid, IV fentanyl infusion. And for minor, IV, IM, rectal, NSAID. So any question asked in pediatric and major surgery, the post-op analgesia of choice, answer should be IV opioid infusion. For adult, neuraxial opioid. So this is about post-op analgesia. For labor analgesia, the technique of choice, or gold standard technique is epidural. Epidural local anesthetic plus opioid. This is the technique of choice for labor analgesia. If female has any contraindication for putting the epidural catheter, then in them we go for IV opioid. If any contraindication for epidural, that is coagulation disorder or patient has severe heart disease, anything of that sort. Got it? So this is about central neuraxial blockade and few more points which I told you about. The last thing which I want to discuss in rapid revision, I want to tell you about oxygen delivering devices. Now see this image. Whenever we take the patient in post-op room, post-operative room, and we need to give our patient oxygen therapy, then we have two options: low flow device and high flow device. High flow device. Now low flow device has definitely low flow and variable FiO2. They do not give fixed oxygen concentration. And high flow device has high flow and fixed FiO2. Fixed FiO2, right? So these are the difference between low flow and high flow. Now what are the examples of low flow and high flow devices? For low flow, we have simple nasal cannula, simple face mask, and face mask with reservoir bag. Okay, face mask with reservoir bag. High flow device, Venturi mask, then nebulizers, high flow nasal cannula, high flow nasal cannula, and we have self-inflatable bag valve mask, bag valve mask, BVM, popularly the Ambu bag which you call, right? So these are high flow devices. Now let us see their images, and with images we will just write few points about these devices. Now this is nasal cannula, as you can see, nasal cannula. What is the oxygen flow which we need to keep in it? 2 to 6 liters we should give per minute. And what is the FiO2 achieved in it? 0.24 to 0.45, that is from 24 to 45%. Maximum FiO2 0.45. This is a low flow device. Only 2 to 6 liters of oxygen flow can be given. Then this is a simple face mask. Simple face mask. What is the oxygen flow which we need to give? 6 to 10 liters per minute. And what is the FiO2 achieved? 0.35 to 0.6, that is 35 to 60% of oxygen, right? You can see there is a source of oxygen, pipeline supply, and there is a reservoir space, right? Patient exhale in this space and expiration happens from expiratory ports. So this has 6 to 10 liter per minute. So this is again a low flow device. Then this is a face mask with reservoir bag. Reservoir bag. This is the reservoir bag attached to the face mask. It is of two types depending upon the valve between reservoir bag and the mask. Number 1, face mask with non-rebreathing reservoir bag. Non-rebreathing reservoir bag. And second, face mask with rebreathing reservoir bag. So if the valve between the face mask and reservoir bag, the gas can move in both directions, then it is rebreathing. And if the gas can go from reservoir bag to the face mask, but not expiratory gas from face mask will go into reservoir bag, then it is a non-rebreathing reservoir bag. Remember, they can achieve a very high FiO2. So we have to keep the flow rate of 6 let's say 10 to 15 liters per minute in non-rebreathing, 10 to 15 liters, and they can achieve FiO2 from 0.6 to 0.85, that is 60 to 85%. And rebreathing bag, it's more or less same as simple face mask, flow rate 6 to 10 liters per minute, and FiO2 it can achieve is right 0.6 to 0.7, that is 60 to 70%. Okay, so this is all about our low flow oxygen delivering device. Now this is Venturi mask. Now don't confuse it with simple face mask. It has a Venturi barrel attached to it, right? So this gives high flow. It can give a very high flow, and it has a fixed FiO2. So always see there is a Venturi barrel, then it's a Venturi mask. Then this is a bag valve mask device. This is a self-inflating bag. This is the source of the gas, and this is little unidirectional valve which will take the gas to the patient. So this is bag valve mask device. This is a very good device and can also be used for mechanical ventilation and can give FiO2 from 0.2, that is it can give from room air to 1, that is 100% oxygen. When we have a source of oxygen, we can even give 100% oxygen through this bag valve mask device. The first company which produced it was Ambu, so very popularly it is also known as Ambu bag. Okay. Then this is a high flow nasal cannula. Now you can see it is different from simple nasal cannula. It has a nasal interface, a special tubing, a high pressure tubing, inspiratory limb. Then it has a humidifier, it has a blender, it has a source of oxygen. This can give flow up to 60 liters per minute. It can achieve FiO2 from 0.21 to 1, that is from room air. It can give room air to 100% oxygen. It can offer a PEEP of 4 to 5 mm of Hg, and it can decrease dead space ventilation, because of its high flow. And the other benefit is it offers heated and humidified gas to the patient. So these are the benefits of high flow nasal cannula. Okay. So this was the devices. Now next topic which I want to revise with you is our perioperative fluid. Perioperative fluid. Now the fluid which we use are of two types, crystalloid or colloid. So crystalloid is aqueous solution of low molecular weight electrolytes like normal saline, right? Ringer's lactate, the popular one, or simple, the distilled water, right? Or dextrose. These are all crystalloid. That is aqueous solution of low molecular weight electrolyte. And colloid is aqueous solution of high molecular weight substance like dextrin or starch. So we have different type of starch like heta starch, gelatin, blood products, they come under colloids. Now remember, crystalloids, they have a very short half-life. They have a half-life of 15 to 20 minutes. And colloid has a very prolonged half-life, minimum starting from 3 to 4 hours. And when I am using crystalloid as a blood replacement fluid for blood loss, then I replace it in 3:1 ratio. Replacement ratio for crystalloid is 3:1. This is important. This is the replacement ratio. Because it is aqueous solution of low molecular weight electrolyte, the fluid can pass throughout the extracellular space and attain an equilibrium. So only one, let's say, of extracellular fluid, only 1/3 is inside the vascular space, right? Rest is in the interstitial space. So we have to replace in 3:1. But colloid, the replacement ratio is 1:1. Let's say the devices which we are using to give fluids, we are using IV cannula. You can see this, we are using intravenous cannula. So you have to remember the color coding of the cannula. from 24 gauge to, let's say, 14 gauge. The thinnest is the yellow one to 24 gauge, which we use in pediatric. Then the blue one, 22 gauge. The most common which we are using in adult is 20 and 18 gauge. 21 is pink and 18 gauges is your green one. Then we have 17, which is less used, white one. 16 gauge more common, gray, and then orange is 14 gauge. So these are the color coding. You have to remember the color coding, sometimes asked in exam, the color coding, and you have to remember the flow rate of at least two most common cannulas which we are using in adult. The pink one and the green one. The green and pink. Green, as I told you, is of 18 gauge, right? And the flow rate of green, that is 18 gauge cannula, is 100 to 120 ml per minute. In 1 minute, it can give the fluid at the rate of 100 to 120 ml. This has been asked in exam. The pink one, which is 20 gauge, its flow rate is, the pink cannula, the flow rate is 55 to 80 ml per minute. Okay, and you won't believe the orange one can give 300 ml per minute. That is, if 500 ml saline bottle I am giving, I can give it in 1.5 minute patient, right? So these are mostly used in trauma victim or cardiac surgery, trauma or cardiac surgery. The orange and the gray cannula. The green and the pink one are the most common which we are using in adult patients, and the blue and the green and the yellow one is used in pediatric. Okay, so you have to remember the color coding of the cannulas. So this is a central venous catheter, the whole set. This is the catheter which we put it in at the junction of superior vena cava and right atrium. And this can also be used, the ports can also be used for giving fluids and for other purposes also. So this is a central venous catheter, okay, the whole set. The last topic which I want to revise with you is cardiopulmonary cerebral resuscitation. So whenever I come across an unresponsive adult, first I will talk about basic life support. Basic life support. So whenever I come across an unresponsive adult, the first thing which we do is scene safety. I make the scene safe and then I call for help. Call for help. After calling for help, I check for pulse of the patient and breathing by the chest movement. Pulse we always check, only one pulse, that is carotid in adult. Carotid. Okay. If no pulse and no breathing, patient is in cardiac arrest. And whenever patient is in cardiac arrest, we start with chest compression. Chest compression. Chest compression at the rate of 30 compression followed by 2 ventilation. 30 compression followed by 2 ventilation. This is the ratio of compression and ventilation. And the rate of chest compression should be, the speed should be 100 to 120 compression per minute, and depth in adult should be between 5 to 6 centimeter, right? 5 to 6 centimeter. So we do 5 cycles of 30:2 compression and ventilation, and then after completion of 5 cycles, which should take around about 2 minutes, we again check for pulse, carotid pulse within 10 seconds, not more than 10 seconds, within 10 seconds. If no pulse, I again repeat the same thing. If there is pulse, then ROS has been achieved, return of spontaneous circulation, but no pulse, again the same thing. We go on doing this till the automated external defibrillator comes. Automated external defibrillator. Defibrillator comes, that is AED arrives. Whenever this AED arrives, we attach it. So AED is attached immediately, and once the AED is attached, AED starts giving the commands. So AED will analyze the rhythm, and AED will analyze the rhythm and give the command. Depending upon that, we have to follow. If it is shockable rhythm, if AED says shockable, then we charge the AED and give shock and immediately start compression ventilation. Immediately compression ventilation, okay, is started. If AED says non-shockable, then what do? We continue with compression ventilation 30:2 for 5 cycles. Again, once 5 cycles finishes, 2 minutes finishes, the AED again goes into analyze the rhythm, and depending upon whether the rhythm is shockable or not, right, we further move. So we go on doing this till we achieve ROS, that is return of spontaneous circulation, right, till we achieve ROS. If I don't achieve ROS, an advanced cardiac life support team takes over, then I can stop it. Team takes over. So when the advanced cardiac life support teams take over, what do they? This first thing they do, they attach monitors. So once the monitor is attached, compression ventilation is going on, monitor attached. Now once the monitor is attached, we have to recognize the rhythm. There are two types of rhythm, shockable and non-shockable. Depending upon that, we have to move further. So monitor attached, and we have to recognize the rhythm. So rhythm are of 4 types, broadly divided into 2 types, shockable, non-shockable, but out of 4 types. So first is ventricular fibrillation, or pulseless ventricular tachycardia. These are shockable rhythm. And the second group is asystole or pulseless electrical activity. These are non-shockable. So guys, remember that VF and PVT, these are shockable and these are non-shockable. So let us talk about very fast, how do I manage the shockable rhythm? So once the rhythm is shockable, what we do? We have to give the shock as fast as possible. So we charge the defibrillator, the manual defibrillator, not automated external defibrillator, to 200 joules asynchronized bipolar, right, and give shock, right. Resume compression ventilation 5 cycle. Again we analyze the rhythm, shockable, we again give 200 joules asynchronized shock. After giving 2 shock, we can start giving drug through the IV line of the patient. Compression, ventilation, continued after shock, and now drugs are given. The first drug which we give, IV, we give IV 1:10,000 10 ml adrenaline, right? We give it, we take 1 in 1000, dilute it to 10 ml and we give 1 in 10,000 adrenaline, right? After this, I can repeat it every 3 to 4 minutes. We can repeat it every 3 to 4 minutes, okay? The second drug which we can give in VF and pulseless ventricular tachycardia is IV amiodarone 300 milligram bolus first dose, and I can give one more dose 150 milligram bolus second dose, right? And only two dose. Adrenaline is repeated every 3 to 4 minutes or 3 to 5 minutes, but amiodarone only 2 dose. A shock, there is no upper limit. You can go on giving till the rhythm is shockable, right? We can secure the airway by definitive device, like ET tube, right? And ventilate at the rate of 8 to 10 breath per minute. Continue compression at the rate of same 100 to 120 compression per minute, and try to find the cause, treat the cause, and reverse the cardiac arrest. This is the management of shockable rhythm. For non-shockable rhythm, we continue with compression and ventilation. 5 cycles, and start giving the emergency drug, IV adrenaline. 1 in 10,000, 10 ml, and we can repeat after every 3 to 4 to 5 minutes, right? No other drug, no shock, no other drug, right? We go on doing this in asystole and pulseless ventricular tachycardia and try to find the cause. What is causing the asystole or pulseless ventricular tachycardia, right? We have to remember that 5H, 5Ts. Try to find the cause. We have to remember the cause. Try to find the cause. That is 5H and 5Ts. H, that is hypoxia, hypovolemia, hydrogen ion, hypokalemia, and hypothermia. Anything among these has led to the cardiac arrest, right? And 5 T's: tension, pneumothorax, tamponade, cardiac tamponade, thrombosis, that is cardiac or pulmonary, and toxin, any toxin ingestion. So we will try to find the cause, treat the cause, then only we can reverse the cardiac arrest caused by asystole and pulseless ventricular tachycardia. VF and pulseless ventricular tachycardia, the most definitive management is to give the shock. And for asystole and pulseless electrical activity, the most definitive management is to find the cause, treat the cause, then only it is possible to reverse the cardiac arrest. Remember this, okay? So this is how we manage victim in cardiac arrest. And this is all about the rapid revision of anesthesia. Hope you have enjoyed it, and this will cover a good bulk of question, plus all the images also I have revised with you. Thank you.
Hi friends, so let's start with our rapid revision. All the best to you in all the exams that you appear, and I hope your name is in the list. This is the first page which welcomes you, all of you, to this lecture, also called as Ortho Dhoom Dhalaka. This is my daughter, and this was the first slide I made when I started teaching, thanking good God above for enabling me to interact with my students to increase my knowledge. The father of orthopedics, remember the name Nicholas Andre. If this name is not there, you will mark Thomas. And then remember a nephew of Thomas called as Robert Jones, who is the father of modern orthopedics. If you divide a bone and take an X-ray of it, the bone has got upper end or lower end called as ends of a bone, which has got epiphysis, then physis, then metaphysis, and then the middle of a bone also called as a diaphysis. Remember a lesion called as Ewing sarcoma, which is in the diaphysis? It's a question that's asked. And in the metaphysis, remember, it is the most common location for infections and tumor. So M for metaphysis, M for most common. And what you should remember, if you remember this word bone, the word bone in itself has a 1. So this is type 1 collagen. And similarly, if you write down cartilage rather than writing cartilage, it has type 2 collagen. Remember that. And one important thing here, if you see the image of the bone, you will have a labeling of the cartilage. But on the X-ray, that label does not exist because cartilage is radiolucent. It's not seen on X-rays. That's why physis, which is also a growth plate or cartilage, is not seen on X-rays. And now the epiphysis, then the physis, then the metaphysis. If your physis disappears and the epiphysis fuses with the metaphysis, that's called as skeletal maturity. You need to remember the age of skeletal maturity of 6 joints in human body. If you look at this position, which is also called the milking position, the 3 joints that point up, they look up, so they grow more till the age of 18. And the 3 joints that look down, they look down, so they are over early at the age of 16. So this is the age of skeletal maturity. The shoulder, the wrist and the knee, 18 years. The elbow, the hip and the ankle, 16 years. And when you look at the end of a bone called as epiphysis, the terminal end of a bone, there are 4 types of epiphysis. The number 1 is the weight bearing, like the head of femur, pressure epiphysis. Number 2, which is very commonly asked to you, because of a muscle pull, the traction epiphysis, like the trochanter's of femur or tuberosities of humerus. Number 3 are aberrant epiphysis, not of much significance, but what is very commonly asked to you are the atavistic epiphysis, like the coracoid process having a fusion with the scapula. This is something that is very commonly asked to the students. And then comes the physis or the growth plate, which is bridged between the epiphysis and the metaphysis. And when I look at that, from the epiphyseal area, you start the resting zone, the storage disorders, the proliferative zone affecting in dwarfs and giants like Laron syndrome, which is growth hormone deficiency, which is very commonly asked in Jipmer, and scurvy. The maturation zone, which is affected in traumatic disorders, and the zone of calcification, which is just next to the metaphysis, affecting the mineralization disorders like rickets. And then comes the next point. If there is a damage to the maturation zone, there will be a slip or a split of epiphysis. This is called as Salter-Harris classification. So in Salter-Harris classification, the type 1, when there is a slip of the epiphysis, so you can write a 1. Type 2, there is a slip along with the metaphyseal part. This is called as type 2, which is the commonest type, and also called as a Thurston-Holland sign. Type 3 is a split of the epiphysis. So there is an epiphysis split. And if you can see here, you can write a 3 here. So type 3, you can write a 3. And type 4, there is a split of epiphysis with a metaphyseal chunk. So you can very well write a 4 here. So it's just like a 4 here. So 1, 2, 3, 4. And type 5, there is a crushing of the 5. Crushing of the 5. 5 for 5. 5 means physis. The growth plate or cartilage, which is radiolucent, which cannot be seen on an X-ray. And that is why you should remember this very, very important key point here, that type 5 looks normal on the X-ray. Commonest is type 2. And then we come to the interaction of the hormones on the bone, and I want you to remember one key point. Parathyroid hormone has its receptors on osteoblast, which stimulates the osteoblast, releases the rank ligand, which in itself activates the rank receptors on the osteoclast, which causes the remodeling of the bone. The estrogen and the denosumab, they inhibit the rank ligand, so they inhibit the bone resorption. The bisphosphonates and the calcitonin, they also act on the osteoclast, directly inhibiting the bone resorption. The parathyroid hormone in low dose can directly stimulate the osteoblastic, increasing the osteoblastic proliferation. So, which is the drug of choice if you have bone weakening disorder or osteoporosis? Bisphosphonates, because they are the most potent. Name a drug that acts on the osteoblastic cycle purely. PTH, low dose parathyroid hormone. Remember this. Where are the receptors? PTH. Which cell releases the rank ligand? Remember that, osteoblast. And estrogen and denosumab acts on inhibiting the rank ligand. This is an important cycle that you should remember. Some important movements at the hip. If you have a normal hip, you will have normal internal rotation and abduction. And when you are taking the hip in, your leg goes out, and this is how the internal rotation is shown. External rotation is not clinically significant, so this photograph is rarely shown to you. Remember, you're born like this. The first movement that we do in our life is yes. So atlanto-occipital joint, the first joint in human body, will say yes. The second movement is atlantoaxial joint, which is saying no. So this is a rotational movement. Remember that. When I look at an X-ray, I see a bone made out of cortex, whose break is called the fracture. So fracture is break in the cortex, but I can also see the soft tissue planes outside. And I cannot see the cartilage, as already told you. And when you look at the bone and the joint space is reduced, which is made out of cartilage, that means you're dealing with arthritis. So if I compare here, you have a beautiful joint space here, which is gone here. This is a case of cartilage damage, also called as arthritis. And if there is a medial cartilage damage, then in between the two legs, you will form an O. So this is genu varum. Varum means towards the midline. So this is genu varum seen in OA. And if there is a valgus, it will look like a R seen in RA. Remember this image forever. O, osteoarthritis, R, rheumatoid arthritis, varum and valgus. And then important key points that you should remember about each joint. Around the shoulder, remember the coracoid is just beneath the clavicle. Remember, it's like a golf ball on a small tee. The ratio between the two is 4:1 between the head of humerus and the glenoid surface. And then around the elbow, remember, it is the capitulum which articulates with the radial head, and it is the capitulum which is the first ossification center to appear around the elbow. Remember the mnemonic crito. This is the capitulum at the age 2 years, radial head 4 years, internal epicondyle or the medial epicondyle at 6 years, trochlea at 8 years, olecranon at 10 years, external epicondyle or the lateral epicondyle at the 12 years. So this is the mnemonic crito, which is the first one to ossify capitulum. Remember that the wrist joint is the radiocarpal joint. Ulna is not a significant portion, and on the radius, the boat-like bone is the scaphoid, and just next to it is the lunate. Lunate means the moon, which looks like a moon on the lateral view. And when I look at the lateral view, remember, it is the thumb which is anterior. The first metacarpal is anterior, and on the lateral view that can help you guide whether the dislocation or displacement along with the fractures is occurring anterior or posterior, that is volar or dorsal. And then if I look at the pelvis, I must always remember as a clinician to look at the sacroiliac area, more so in a young man with low backache who might have sacroiliitis, and I might be thinking about a condition called as ankylosing spondylitis, which is HLA-B27 positive. A very, very, very important point you should keep in mind. And similarly in the pelvis, remember to draw the arches between the upper end of femur and the pubic rami, and this arch will be broken in cases of fractures involving the acetabulum or the head of femur, the neck of femur, or a dislocation like you can see here. Remember, CT scan is a specialized investigation to look better at a calcification, or the cortex, it looks white because calcium is white. MRI can help you see the soft tissues, the bone marrow, and can also see you the cartilage, which cannot be seen on X-ray or CT scan. And an MRI will have two images, T1 and T2. The T1 image will show you the anatomy. 1 means anatomy, the first prof subject. T2, 2 means second prof subject, the pathology. And how do you pick it up? The water is white on T2. So CSF is water, traumatic edema, inflammatory edema. They are all water, so they can look white on T2 image. It's very common to see a sagittal view of the knee joint where they show you the femur, the tibia, and they mark over the ligaments that bridges between the two, the femur and tibia, called as the ACL, which is going anteriorly on the tibia, and the PCL, which goes on the posterior border of the tibia, anterior cruciate ligament and the posterior cruciate ligament. ACL restricts the hyperextension, the interrotation of the knee joint. PCL restricts the external rotation, and the movement they restrict, they are damaged by the same. And this is what you should always remember. And if you look at a repetitive force, it's called as a stress fracture, and in stress fracture, remember, you can pick up the marrow edema. The cortical breach is later, so a stress fracture will always be picked up on an MRI. So overall the investigation is MRI. Unilateral stress fracture is again an MRI, but if they talk about bilateral, do an investigation which can scan the whole body, picking up the osteoblastic activity, call it a bone scan. But if you want to pick up a malignancy in a radiological appearance, it is going to be a PET scan. It can scan the whole body, and the fluorodeoxyglucose, the deoxyglucose will be taken up by the tumor cells which have anaerobic metabolism also, and you label it with radioactive fluorine, you can pick it up. So if you have single lesion of a metastasis, MRI, multiple PET scan, but if you have osteoblastic lesion, PET scan is quite about it, and you will be picking up in a bone scan, like the lesion of a prostate cancer, the carcinoids, or the medulloblastoma. All three of them are labeled as osteoblastic metastasis, which is very important, can be picked up on bone scan. And if I am going to find out about the investigations that become positive in cases of infection of the bone, number one sensitive and specific is MRI, followed by bone scan, and X-rays, which usually become positive after 24 hours, showing you a periosteal reaction in day 10, but after 24 hours there will always be a loss of soft tissue plane. Mind you, the first change on an X-ray of osteomyelitis is loss of soft tissue plane, whereas periosteal reaction occurs in the second week of life. And then comes the bone tumors, which are usually picked up on MRI, except one, that's osteoid osteoma, because it's a cortical lesion, so that is what is picked up on CT scan. And then remember, you can do anything for a tumor, but if you have to be diagnostic, it is going to be tissue, which is diagnostic. So infection on tumor, take out a tissue, divide it into two parts, send one for culture. If it's infection, it will grow the organism. The other one goes for histopath. If it's a tumor, you can pick it up. That's how it goes. One condition in which you have a shallow acetabulum. So if this is your cup holding on to the head, this is the cup called as the acetabulum, and this is the head. And if this is shallow, your head is bound to dislocate, called as DDH, developmental dysplasia of hip, which has got a screening tool of ultrasonography, but the investigation of choice is going to be an MRI. And remember, on ultrasound in DDH, it is the alpha angle that decreases. So remember this mnemonic, AD. So alpha angle decreases in DDH and ultrasonography. And I just told you that tissue is diagnostic. You will always do a clinical radiological evaluation before doing a tissue diagnosis. The incision is along the long axis of the bone or the limb. Avoid the neurovascular status. You go through the muscle, plan to take a round or an oval hole, never make a square, otherwise there will be stress fractures. Take it from the periphery, because in the center you have necrosis. Take it from the multiple sides. And then if you're looking at a joint, remember the mnemonic X-mass. Number one investigation to look at the joint is X-rays, followed by MRI, followed by aspiration or arthroscopy. And remember, the aspiration is always done by ultrasonography. And then if you have anything that irritates a bone, it will show a periosteal reaction, which is a new bone formation. If it's a benign lesion, it will be a single layer called a solid periosteal reaction, seen in day 7 to day 10 of osteomyelitis. But if the disease is aggressive or more chronic, you can have rays coming out called as sun ray appearance. You can have multiple layers over it called as onion peel appearance, or you can have a triangular piece underneath the periosteum called as Codman's triangle. So this is a Codman's triangle, which can be seen in any malignant lesion, any chronic process, but usually osteosarcoma. Similarly, sun ray appearance, any malignant lesion, any chronic process, but usually osteosarcoma. And then onion peel appearance will look like a hazy cortex, any malignant lesion, any chronic lesion, but usually Ewing sarcoma. And this is what you should remember. And this is what is the classical feature: sun ray and Codman's triangle, osteosarcoma, but any malignant lesion, onion peel appearance, Ewing sarcoma, but can be seen malignant lesion or chronic osteomyelitis, soap bubble appearance, giant cell tumor or adamantinoma, patchy calcification. At some places it's calcified in cartilaginous tumors like chondrosarcoma and chondroblastoma, and homogeneous uniform calcification seen in bone forming tumors like osteosarcoma. And if they don't mention patchy or homogeneous, remember to choose chondrosarcoma, then chondroblastoma, then osteosarcoma in this order. And this is what you should remember: soap bubble appearance, going right till the end of a bone. There is no tumor which can involve the joint except the giant, called as a giant cell tumor, which can go and invade the cartilage. Because tumors, they respect the joint, they respect the cartilage, whereas the infections, they eat both. The only tumor which can involve it is GCT, and that's the only tumor which can go in the subchondral area or involve the joint surface. This is giant cell tumor. And remember the dictum: tumor of lower end radius till proved otherwise is GCT. Remember that. Coming to some question regarding investigation of malignant tumors, you will do a biopsy by transverse incision, wrong. You will go in a vertical direction. Sample should be taken from two sides, correct. You should do sampling before radiological appearance, wrong. Sample should be taken from periphery and not from center, correct. So B and D are correct. Coming to the next, a young marathon runner is participating in a marathon competition. After running for 100 meters, he develops pain in the anteromedial tibia, which was mild to start with, but increased on further running. So this is a classical case of a stress fracture, also called as shin splints, which is due to repetitive force, which is seen in military recruits or marathon runners. A 14-year-old male obese child from endo department is referred to emergency for a limp. And if there's a limp, you will get an X-mass done. So you'll do an X-ray, you do an MRI, and do an aspiration, which is done by ultrasonography. So CT scan is not carried out. The earliest neurological sign of TB spine is loss of curvature of the spine. But if loss of curvature is not given as in this question, you will choose narrowing of the disc space. So remember, the loss of the curvature of the spine is the earliest sign of the TB spine. And what is the earliest bony change of osteomyelitis on X-rays? Mind you, in this question, they're not asking you to change. The change is loss of soft tissue plane. The bony change is a periosteal reaction, and that is why this is a key point that one should remember. Coming to infections, remember in orthopedics, the number one organism is Staphylococcus aureus, and the area affected is metaphysis. As I had already told you, infections and tumors in metaphysis. Some exceptions that you should remember: sickle cell anemia. Salmonella is the organism, but it affects the diaphysis. If they ask you metaphysis in sickle cell, think about Staph aureus. Drug abusers, Pseudomonas. Foot, Pseudomonas. Open injuries is also Staphylococcus aureus. Human bites is Eikenella. Animal bites is Pasteurella. Also remember that in sickle cell anemia, the Salmonella can cause multifocal osteomyelitis, can involve different areas of the body. The most common area affected in osteomyelitis is lower end of femur. In adults is the vertebral body. And if they talk about the joints, the knee is the commonest affected joint. Coming to the position that a joint can attain is in the lower limbs of Faber, which is flexion, abduction, acceleration of the lower limb, and that's the position in which the hip has more capacity. And the opposite of it is flexion, adduction, internal rotation. Now the causes of Faber, number one is synovial proliferation. It can be idiopathic, transient, tubercular. Number two is infection, septic, that is pus in the joint, pyogenic. It's not actually arthritis, it is pus in the joint causing Faber. Iliotibial band contracture seen in polio, and dislocation of the head out called as anterior dislocation. That's a rare variety. The commoner variety of dislocation, which is majority, more than 90% cases, is posterior dislocation called as Fadir. And if there's a cartilage damage, the actual arthritis, it's Fadir. So remember the last line, posterior dislocation is more common than anterior dislocation. Similarly, if the joint is totally destroyed, it's called as Tom Smith arthritis. So whenever there's an infection of the limb, that is osteomyelitis, or the joint, the movement is absent. But Tom Smith arthritis is an exception. Initially the movement is absent, but then the head or the capital epiphysis of the femur gets destroyed. There is hypermobility and instability of the joint. Very commonly asked question in NEET and AIMS. Coming to subacute variety of infection called as Brody's abscess. If subacute is not mentioned, you can take chronic. It's seen at upper end of femur and has sclerotic margin. Sclerotic margin means good immunity. So it's not seen in HIV positive. Whereas when there's a chronic infection, there will be a dead bone called as sequestrum, which is pathognomic, surrounded by a reactive bone called as involucrum. Then the draining sinus is right from the center through the involucrum called as cloacae. Chronic osteomyelitis should be handled immediately. If not, can lead to amyloidosis and malignancies. When we look at the image, in the center, the dark, dense, white colored, dense bone is sequestrum, followed by a reactive bone called as involucrum. Sequestrum means in the cavity. And then you have the draining sinuses called as the cloacae, which are coming till the surface. And this is very pathognomic picture. You can see the upper end of humerus here. You have a cavity, the sequestered bone, and the surrounding involucrum. Many a time they just show an image, or they can just ask you by labeling is sequestrum or involucrum. And then this surrounding live bone or involucrum creates a rim around the bone called as a rim sign. And when you want to remove the dead bone, there will be a point where the bleeding starts, and that's called as paprika sign. And the instruments which are shown here, you can see the bone nibbler and a bone cutter, and bone nibbler has been asked multiple times in the exams. And when you want to cover up any area of infection or trauma with a good soft tissue, there's a technique called as negative pressure wound therapy. This was asked as an image in AIMS November 2019 this year, where they wanted to understand that are the students aware of these type of technology which are coming. And this negative pressure wound therapy, you create a pressure of -75 to -125 millimeters of mercury. It gives a good granulation tissue, but contraindicated if the infection is not controlled, if there's a necrotic tissue or is a malignancy, because this increases the proliferation. When I spoke about salmonella, I told you there can be multifocal osteomyelitis. But then if they ask you out of salmonella and one more condition, which is multifocal osteomyelitis, the answer is SAPHO syndrome. Although it's not an osteomyelitis, it's an osteitis. It's an autoimmune disorder which also has, along with ankylosing spondylitis, the HLA-B27 positivity, and it has an acronym of synovitis, acne, pustulosis, hyperosteoitis, and just like any autoimmune disorder, treated by NSAIDs, steroids, and disease-modifying drugs. They can show you a finger and they can ask you to pick up some diseases like infection of the nail bed called as paronychia, which is the commonest infection of hand, or they can involve the pulse space of finger called as phelon or whitlow, and or they can show you infection of the flexor tendon sheath, where you can have the Cannibal sign, which are 4 features, which is pain on stretch, uniform swelling, flexion of the finger, and percussion along the sheath, which is the most specific Cannibal sign. And remember, it is the communication between the fingers which can spread the infection. So there can be a spread of infection between the thumb and the little finger, but since the middle 3 fingers, they are separated out, they are not connected to these 2 bursas, so the infection from the little finger can involve the thumb but not the index finger. That's a rule that you should remember. And look at this image, you should not forget this image. If you have multiple draining sinus around the foot, think about mycetoma, which is the mycetoma, the fungal mycetoma, and if you have it around the jaw, that is actinomycosis. So above the waist is bacterial cause, below the waist is fungal cause, and mycetoma is on MRI creating a dot-like circle. This is what dot in the circle sign, remember that. And 2 conditions which are painless in orthopedics, Charcot's and mycetoma. So this is what you should remember, the neuropathic joints and the mycetoma. And coming to questions, true or false in view of septic arthritis, widening of joint spaces, they are no, because it is reduced. Staph aureus is the organism, true. IND and are after the culture and aspirate an antibiotic for 24 hours, and you might have to do it more aggressively. You don't have to wait in such cases, but yes, if the presentation is more than 24 hours, you usually have an operative intervention in cases of infection but of the bone, but in the joint infection you have to be very aggressive. So false. Kocher's criteria can be used to differentiate, is true. It is basically a composition of 4 criteria, and as they become positive, the chances of septic arthritis being very high. If the patient is not able to bear the weight, if the ESR is more than 40, if the fever is more than 38.5 degrees, and if the WBC count is more than 12,000, these are 4 criteria. From 3% in 1 positive to more than 90% in 4 positive is the sensitivity of these criteria, which can be used for differentiate. Position of the hip is FADIR. So septic arthritis has a Faber, so that is not possible. So there are 2 answers which you remember. This is what I discussed with you, that little finger can spread to thumb but not to index finger. This is true about tenosynovitis. Multifocal osteomyelitis, here you have both the options, SAPHO syndrome and sickle cell, and I told you that you will choose SAPHO syndrome. And in osteomyelitis of spine, the most common organism, remember, in cases of any bone in the body, the king of orthopedics is Staphylococcus aureus. Do not try to deviate from this path. Remember, this is a very, very important point. So anywhere, even spine, the organism is going to be Staph aureus. Tuberculosis. TB is always secondary in bone and joints. It comes from the lungs followed by lymph nodes. The spread is through the blood. All the infections come to the bone or the joints through the blood, hematogenous, but the picking up rate of organism is very low, so called as paucibacillary. The order of involvement is just like SRK, Shah Rukh Khan, SHK, spine, then hip, then knee. Spine involvement is also called as pot spine. Tuberculosis of shoulder is dry, called as Keri sicca. Tuberculosis of finger is called as spina ventosa. Tuberculosis usually does not produce the periosteal reaction. The only place where it can do is spina ventosa. TB involves 2 vertebrae. It is not a single vertebral disease. It involves the anterior elements in the spine. Tuberculosis of the spine will involve the vertebra and the cartilage both, the bone and the cartilage both, the vertebra and the disc both. It's according to the distribution of the mesodermal somites in the segmental artery carrying the bacteria. When you look at the presentation, the earliest presentation is pain, earliest sign is tenderness, earliest neurological sign is increased deep tendon reflex. TB, the treatment principle is rest plus ATT, and when indicated surgery. The indication of surgery in any disease of spine is 3. Bowel bladder control lost. Patient has a worsening neurological status. Patient is not improving in spite of the conservative management. Good signs: when it will improve, younger people improve better. Early disease in the first 2 years, better. Infection present, ATT will work. Active disease, better. Slow worsening of neurological status, better. Neural tissue normal on MRI, better. When you look at the outcomes of joint disorders, you can have ankylosis, which is a pathological fusion of a joint, which can be fibrous, which is painful because fibrous has F, painful has F in it, and it is seen in tuberculosis of the peripheral joints, and RA. Bony fusion, which is rock solid fusion seen in joint infection like septic arthritis, spine TB or ankylosing spondylitis. As for solid, as for septic, spine TB or ankylosing spondylitis S. And when there is a surgical fusion of a joint, it will always be bony, but it will be painless. And an example is cobra plate used for hip arthrodesis. But the trend today is to replace the joints. When I look at the upper end of femur, there is an area which has got less monocyte macrophage system called as the Babcock's triangle, which is very common area where the tubercular bacilli sit. But the commonest area where the TB hip will affect is acetabulum. TB hip stages: synovitis causing fibr, lengthening, only stage of lengthening, early arthritis, damage to the cartilage, less than 1 cm shortening and FADES, flexion, adduction and rotation, late arthritis, more than 1 cm shortening, damage to the joint, unstable femoral head, migrating from one corner acetabulum to other, wandering acetabulum. It should be called as wandering femoral head, but a misnomer when there is a fibrous fusion, fibrous ankylosis, because the spine is bony, peripheral joint is fibrous ankylosis. Remember, TB affects the acetabulum. There is earliest neurological sign in TB spine: loss of curvature. TB hip, periarticular osteopenia. Tuberculosis of knee is a chronic process. Gradual onset pain, limp in the child, flexion of the joint and synovial proliferation are the features. If you do not treat it early, it will end up into triple deformity, which is also very commonly seen in RA. So TB and RA, 2 causes of triple deformity, you must remember, which involves the posterior subluxation, external rotation and flexion. These are the components of triple deformity. Coming to the questions: assertion and reasoning. Decompression surgery is needed with a progressive deficit in port spine. True. Even after completion of ATT, there can be neurological abnormalities. True. It is not a guarantee it will recover. So assertion is true, reasoning is true, but it is not the correct explanation of assertion. Coming to next, a 30-year-old male, HIV positive, is on antiretroviral therapy. He has pain in the right hip with fever. So HIV is a very common setting in which you have tuberculosis. Along with fever, you will mark it to be TB hip. Similar question but very different. Same age, HIV, but is on antiretroviral therapy, protease inhibitors, has a pain in the hip, but there is a limitation of abduction and rotation. Whenever these two movements are limited, as I told you in the first part, that there is a loss of the hip. So there is a change in the shape, and this is not TB hip. So on protease inhibitors, the vascularity can be compromised, causing predisposition to avascular necrosis, which is the answer here. We'll talk about AVN later. I had shown you this image, bone and the x-rays. The cartilage is not picked up. So when they talk about the upper end where you will have epiphysis or metaphysis, the tumors of epiphysis are chondroblastoma followed by GCT in this order. Metaphysis is the most common location of tumors, and osteosarcoma you should remember. And in diaphysis, remember the 3 points: osteoid osteoma, adamantinoma, but one you should learn with your heart is Ewing sarcoma. Remember that. And this is what is given here: epiphyseal chondroblastoma more than GCT. But if they mention calcification, so I told you cartilaginous tumors, they calcify, so epiphyseal plus calcification, chondroblastoma. And if they talk about metaphyseal osteosarcoma and diaphyseal, 3 tumors. If at the upper end of humerus they talk about, remember, one lesion, unicameral bone cyst. Unicameral means single cavity cyst followed by chondroblastoma. Epithelial tumors, not epiphyseal, there are 2 of them. One is adamantinoma and the other one is the ameloblastoma. That should come to your mind. And before 1985, these 2 terms are interchangeable, but now they are used independently. The epithelial tumor that involves the tibia is the adamantinoma, and the one that involves the mandible is ameloblastoma. And here comes a very, very important point. The mandible most common tumor is squamous cell carcinoma. But ameloblastoma, the most common location is mandible. This is what you should remember. So ameloblastoma will occur in mandible, but the mandible's most common tumor is SCC. It's like a love triangle. Ameloblastoma likes mandible, but mandible loves squamous cell carcinoma. And when we talk about the age of the patient, first decade, think about Ewing's. Second decade, osteosarcoma, again a love triangle. So the love triangle says the most common tumor of the first decade is Ewing's. So first decade likes Ewing's. But Ewing's maximum number of cases are seen in the second decade. So if there are 10 tumors in the first decade, maybe 9 are Ewing's. But rest 90 of Ewing's will be seen in second decade. But this most common tumor of the second decade is osteosarcoma. It's in thousands and millions. Then coming to after skeletal maturity, which is 20 to 40 years, you have a giant cell tumor going right till the joint. And after 40 years, two tumors, which are the commonest tumors in the bone. Metastasis, number one bone tumor. Multiple myeloma, number one primary bone tumor. So if you have a conflict between the age and part, remember the part is more important than age. So remember the epiphysis, the metaphysis, diaphysis, they will be more important than the decades that the patient suffers from. Coming to radio-resistant tumors, I will love that you remember osteosarcoma. This is a name that you should not forget. Coming to a treatment of tumors, you can do a curettage. It's just like dry mopping or jharu lagana, opening up the cavity and cleaning it out. Or if it's sticking tight, embedding into the bone, you will like to do a dry curettage. Along with that, apply a chemical treatment called as a wet curettage. This is called as an extended curettage, right? This is jharu plus pocha. So there's something more. And the most common chemical which is used for extended curettage is phenol. Not phenyl like in home, phenol. In orthopedics, it's phenol. But then you have excisions. You will remove the tumor, like taking out from the center, intralesional, taking out through the margins of the tumor, that is the pseudocapsule, the marginal excision. Normal cuff of tissue all around, wide local excision, removing the entire bone called as radical excision, and which is the most common one, the wide local excision. How much margin? 3 centimeters. That is the standard margin that you take, and that's why I remember the tumors. Benign tumors always operated. Cartilaginous tumors again operated, because cartilaginous tumors are radio-resistant, chemo-resistant. Most common surgery in the tumors, wide local excision. Other surgery is curettage for like unicameral bone cyst, single cavity at the upper end humerus, unicameral bone cyst. While you have extended curettage, we are using chemicals like phenol, the commonest one, or liquid nitrogen, the most effective one. And then you have 4 lesions here which is treated by extended curettage: aneurysmal bone cyst, giant cell tumor, chondroblastoma, and enchondromas on the hand that you see. So these are 4 lesions treated by extended curettage. And then if you have a malignant lesion, treat them with chemotherapy, decrease the size, decrease the vascularity, followed by a surgery with 3 centimeter margin all around, followed by subsequent chemotherapy called as neoadjuvant chemotherapy, followed by surgery, followed by adjuvant, means after chemotherapy. And remember one thing, which is the dictum here: Ewing's is the most radiosensitive tumor known to mankind. It melts like snow. Even then, the treatment of Ewing's is neoadjuvant chemotherapy, followed by surgery, followed by adjuvant chemotherapy. This is what one should always remember. Very, very, very important. And coming to the tumor identifications, if you are looking at the upper end humerus, your mind should run in the direction of UBC, unicameral bone cyst, single cavity upper end humerus. It's a central lesion. And when you look at the second thing here, you will have a broken cortical piece at the bottom because it's a single cavity, called as a fallen leaf sign. There's one more sign called as a trapdoor sign, which is also seen in this lesion. Coming to the second lesion, aneurysmal bone cyst, multiloculated. If you get an MRI of an aneurysmal bone cyst, it will be like a fluid level. And ABC is a metaphyseal lesion seen before skeletal maturity. And if you want to see an epiphyseal lesion before maturity, it's a cartilaginous lesion, chondroblastoma, with calcification. So also called as a Codman's tumor. It's not Codman's triangle, which is a periosteal reaction associated with malignant or chronic process like osteosarcoma. Chondroblastoma is a benign lesion right at the top of the bone in the epiphysis, along with calcification. And then talks about osteochondroma. It's a bony growth with a cartilage cap. So when you will touch it, you will touch the bone and the cartilage both. When you get an X-ray, you will only see the bone because the cartilage is radiolucent. So it's large to feel small on X-rays. It's not a tumor, it's a developmental malformation. It has a malignant potential. It can change into chondrosarcoma. The risk of malignant potential is less than 1% in case of solitary lesion, more than 6% in case of multiple lesions. And then there's a tumor which has night pain relieved on taking salicylates or aspirin. This is called as osteoid osteoma in the cortex of the lesion, which has lysis and sclerosis. So both osteoblastic and osteolytic cells are seen, and remember it has a growing point called as a nidus, which is in the diaphysis. And then there are not so offending lesions which are incidentally discovered. They are like white dots on the skull called as ivory osteoma, or the compact osteoma, or a shining white also called as eburnated osteoma, and they don't require treatment. But then coming to tumors of the hand, you know, the most common tumor of the hand is squamous cell carcinoma. Most common tumor of the bones of the hand is a cartilaginous tumors called as enchondroma, which is highly in cartilage in them. And there are two syndromes associated with them: Olliers, which is only enchondromas, Olliers syndrome, and then you have Maffucci, M for Maffucci, M for many things, that is multiple enchondromas with hemangiomas with phlebolith, which means the calcified superficial veins. So these are the three components. You have the phleboliths, you have the hemangiomas, and you have the enchondromas. All three can be featured here. And then coming to the tumor, which is the ruler of MCQ world, the giant cell tumor. That's the only tumor which can go to the joint. So if I look at the upper end of tibia, I will see a tumor going right till the joint. That's a GCT. It's seen after skeletal maturity, and it's seen right in the epiphysis. Whereas before maturity in the metaphysis is an aneurysmal bone cyst. I told you the tumor that can go to the joint, and if you have lower end radius, is GCT till proved otherwise. That's a rule, that's a dictum. This is how the X-ray will be. It will finish off the bone, thin cortex, because it loves to eat. Slow grumbling. After maturity, upper and femur, within 1.5 centimeter of the joint. So it can be till the joint, but it should be within 1.5 centimeter. So this is what lower end radius, upper end tibia, upper end femur, and then remember the most common area is lower end femur. The third love triangle. Lower end radius loves GCT, but the GCT loves lower end femur, the commonest site for it. And coming to upper end femur, in the upper end femur, you can see the change of the shape like a stick of a shepherd called as shepherd crook deformity, which is seen in fibrous replacement of the bone called as fibrous dysplasia. And there's a syndrome with it called as Mac-Acune-Albright syndrome, which has polyostotic fibrous dysplasia, precocious puberty, and coffee colored spot, the coffee colored spot called as pigmentation. If you have vertical striations in a vertebra, it's called as hemangiomas, corduroy appearance or jail bar pattern or jailhouse pattern. And if you do a CT scan of this lesion, you will see unequal sized dots called as a polka dot pattern. It's a theoretical question. And if they talk about a lysis of the sacrum, think about chordoma, which arises from the notochordal remnants, and they have the cells which have vacuoles called as physalliferous cells. When they talk about the pulsatile bone tumor, it should come to your brain. They're talking about a tumor that makes ossification called osteosarcoma. It's a cancer of the youth seen in second decade of life. Radiation-induced sarcoma, radio-resistant bone tumor, bone-forming tumor associated with retinoblastomas. This tumor is very commonly metastasized in the lung, can cause pneumothorax. The poor prognostic factors are grade of a lesion, systemic metastasis, which are more poor than pulmonary. So if liver is there, lung is there, the patient with liver mets is the poor. Pulmonary metastasis, extent of a disease, which means the stage, is also important in cases of osteosarcoma. And coming to Ewing's, remember the controversial point here. The first decade most common tumor is Ewing, but Ewing's peaks in the second decade, seen in the femur diaphysis. Osteosarcoma femur, lower end. Ewing sarcoma femur, middle. Both have pain. Most common tumor with pain, osteosarcoma. Most common tumor with night pain, osteosarcoma. Most common tumor with night pain relieved on taking salicylate, osteoid osteoma. Another tumor which has pain is Ewing sarcoma. It presents like osteomyelitis. Classical presentation of Ewing's and osteo can be like osteomyelitis. And remember the poor practice of Ewing's: relapse, chemoresistance, metastasis, increased counts, ESR, fever. And isn't it just similar to presentation of osteomyelitis? Yes, fever. So if Ewing's presents like osteomyelitis, is already a poor prognosis. So remember one thing: Ewing's cannot be graded like osteosarcoma. All Ewing's are high grade. Coming to a third malignant tumor, chondrosarcoma, which is commonly seen in pelvis. It has the best prognosis among the malignant tumors. So the best among malignant, chondrosarcoma, osteosarcoma, the worst is Ewing sarcoma. And then this is a tumor which is associated with hyperglycemia. Skulls and the lytic lesions have been shown for last 5 years in every exam. Multiple lytic lesions which are punched out are seen in multiple myeloma, which is a plasma cell tumor, which is a lytic tumor, which will never have an osteoblastic activity except for a fracture. And there can be lysis anywhere in the body, in the skull, the femur, the humerus, the vertebra, the rib cage, any bone in the body. And that's why the lytic lesion of skull are asked to you in multiple places. And the mnemonic is Melthorme metastasis, eosinophilic granuloma, histiocytosis, tuberculosis, hyperparathyroidism, bone infections, radiotherapy, multiple myeloma, epidermoids. And if they show you punched out lesions, multiple myeloma. If they show you beveled lesions, think about eosinophilic granuloma. They have beveled sloping lesions. So they have histiocytosis and they have grooved nucleus, which is a very characteristic feature. They can show you histopath, they can discuss in theory, has been coming in last 2 aims. They can have large lesions called as the permeative lesions, again seen in histiocytosis. Or they can have dots like a mixed paper of salt and pepper called as salt pepper skull. So beveled lesion, permeative lesion, salt pepper skull. Salt pepper skull is a feature of hyperparathyroidism. So salt pepper skull is a feature of hyperparathyroidism. It's just not a classical lytic lesion, but it has been grouped here because unlike the classical osteoblastic lesion like cotton wool skull, which is seen in Paget's, or a large area of osteoporosis called as osteoporosis circumscripta, again seen in Paget's, or they can be hair on end appearance on the skull seen in hemolytic anemia like thalassemias. So a 9-year-old boy presents with a lytic lesion in the shaft of tibia with histopathic grooved nucleus, I'll think about histiocytosis. Which of the following is a sign of metastasis? Remember, infections affect the vertebral bodies. Metastasis, they will destroy the pedicles. If one pedicle is destroyed, it's called a winking owl sign. If both are destroyed, it's called as a blind bat. So the answer here is the first one, single pedicle destruction, the winking owl sign. And then comes the next question. Most common type of fibrous dysplasia is a monostotic fibrous dysplasia involving the femur. So polyostotic was McEwen-Albright syndrome. The single involvement is monostotic, and middle-aged patient presents with a lytic lesion with back pain. So I told you osteoblastic mets are prostate carcinoid and medulloblastoma. So the answer here will be renal cell carcinoma. And then again, this is a patient of Langerhans cell histiocytosis. They can show you an image, they can show you the theory part, but this is something which is very commonly asked. A patient with GCT, which of the following is false? This is a GCT, they have already mentioned, but you can see that this tumor is going right till the joint. And remember, in GCT, the treatment is extended curettage or excision, but you will never use a chemotherapy. So that is the answer here. And which of the metabolic condition can cause osteomalacia? So there are tumors which are from the fibrogenic origin, and they can produce phosphotonin, which causes the phosphaturia and an osteomalacia or the weakening of the bone, which is very commonly asked. And look at this tumor, it's going right till the joint. Why did I place it in the first place? Because this is a tumor going right till the joint, but it has 2 options here which you should remember: osteoclastoma and giant cell tumor, which mean the same. But if I have to choose, I'll choose GCT because the more classical name. Most common tumor of hand, I told you. Most common tumor of hand is squamous cell carcinoma. Most common tumor of bones of hand is enchondroma. So the answer is squamous cell carcinoma here. 8-year-old boy, 8-year-old, first decade of life, complains and pain of swelling upper end tibia, local temperature raised, margins are irregular, variable consistency. Irregular margins, variable consistency means it's an aggressive lesion like a malignancy. 8-year-old, you won't think of METs because it's more than 40. GCT, you won't think because usually between 20 to 40. So you have Ewing's and osteogenic sarcoma. Ewing's, 8-year-old, Ewing's is more common. But when you look at upper end, so Ewing's occurs in the middle. So part affected is the middle, the diaphysis. Age is the first decade. Age goes towards Ewing's. Part upper end means the metaphysis. Ewing's occurs in the diaphysis. Part affected, given here is upper end, metaphysis, osteogenic sarcoma. Part is more important than age, so osteogenic sarcoma is the answer here. A very important question. And the associated genetic effects with Ewing is translocation 11-22, not 22-11. So the answer here is trisomy 8. And this is what you should remember when it comes to the bone tumors. This image we all remember. In this image, the different parts being shaded by different nerves supplying the different dermatomes. But I'll just tell you a simple way to remember. Tip of index finger is by median nerve, tip of little finger is by ulnar nerve, dorsum of first web space is radial nerve. So if you remember this will be good. It is very, very important to remember this point. Median nerve, ulnar nerve, radial nerve. That's all. You don't have to remember the entire chart. Seddons classify the nerve injuries into neuropraxia, which is a physiological block which have 100% recovery but recovers in one moment. The point is one moment. Axonotmesis is recovery from proximal to distal. This is also called as motor march. The Tinel sign is considered to be positive, which marks the recovery of the nerve at 1 mm per day and progressive. Neurotmesis is complete nerve transaction. It does not recover without a surgical intervention. Tinel sign is positive, means there's a cut nerve end, but not progressive because it doesn't recover. So it's static. Axillary nerve is damaged in shoulder dislocation, fractures of upper end of humerus and injection into deltoid. This is the area at the upper end of humerus, proximal arm, where the regimental badge is there. The army people have their badges called as regimental badge area. When we look at the area supplied by ulnar nerve, it supplies the palmar interossei and dorsal interossei. Palmar interossei to do adduction of the fingers and dorsal abduct, pad and dab. So if you give a card to a patient, ask him to hold it between the fingers, he is able to hold it. It means the palmar interossei is functioning. If not, it means the palmar interossei gone, ulnar nerve palsy. Similarly, you give a book to a patient to be held between the thumb and palm. This is by adductor pollicis and adduction is by the ulnar nerve. So if it is gone, the patient will not be able to hold the book. So he will not let the book go. So he will grasp it by flexing his thumb. This is called as Froment sign. Similarly, if the little finger gets abducted, it's called as a Wartenberg sign. Again, the ulnar nerve. The movement of the middle finger to either side is called as abduction. Because the middle finger does not have the palmar interossei, it only has a dorsal interossei. So it's called as abduction, and this abduction of middle finger to either side is called as Igawa test, Igawa with I. Coming to the median nerve, if you ask a patient to make a fist and there is a median nerve palsy, the first two fingers don't flex. This is called as pointing index. It's also called as the benediction attitude. It's also called as the Ochsner clasp test. Similarly, if you keep the pen above the palm and ask the patient to touch the pen, this is called as a pen test by abductor pollicis brevis. This is again for the median nerve. The median nerve is responsible for opposition. In cases of median nerve palsy, your thumb will be in the same plane as palm. The thumb is ideally anteriorly. This is called as ape thumb deformity, median nerve palsy. The branch of median nerve called as anterior interosseous nerve flexes the index finger and flexes the thumb, creating a wow sign, sign of appreciation called as Kilo-Nevin sign, which is for anterior interosseous nerve, a very, very important sign. Remember, the anterior interosseous nerve and the posterior interosseous nerve are very commonly asked in the exams. The lumbricals, they make a L in your hand, they flex the metacarpophalangeal joint and they extend the interphalangeal joint, so they make a L. When they are paralyzed, opposite of it occurs called as a claw hand. So claw hand. When you give a splint to it, this is called as knuckle bender splint. We have 4 lumbricals. The lateral 2 are supplied by the median nerve, the medial 2 by the ulnar nerve. When all are involved, it's called as a total claw hand. And when all are intact, this is what is called as a Babaji Ka Thullu by Kapil Sharma. It's a way to remember that lumbricals can make a L in your palm or hand. Knuckle bender splint is to correct the claw hand. Coming to the radial nerve. The radial nerve is involved in fractures of humerus. It is in contact with the bone at the spiral groove, but at the lower 1/3 level where it pierces the intermuscular septum and comes anterior. That is the most common level where it's involved. It's called as a Holston-Lewis sign at the lower 1/3 level. Then the radial nerve goes ahead, divides into 2 parts, the posterior interosseous nerve, which goes around the radial head, and the superficial radial nerve. The posterior interosseous nerve is a pure motor branch. So radial nerve palsy will cause a wrist drop, with a sensory loss at the first web space on the dorsum, whereas posterior introitious nerve palsy will cause a finger drop and there is no sensory loss. This is the sensory area for the radial nerve. Radial nerve palsies can occur in Saturday night or crutch palsy or honeymoon palsy, where the nerve is compressed against the bone with sustained pressure. So when you look at the radial nerve, when the radial nerve palsy is high, there is involvement of the brachioradialis. In low, brachioradialis is spared. In high and low both, there is a wrist drop, finger drop and sensory loss. So loss of wrist extension, finger extension and sensory loss on the first web space. Whereas posterior introitious nerve palsy is a pure motor branch, only causes finger drop, whereas superficial radial nerve causes sensory loss and rarely palsy of extensor carpi radialis brevis. For radial nerve palsy wrist drop, we have something called as a Cockup's splint, which was asked in AIIMS November 2019. So remember, when you have an injury to a nerve, if it's a closed nerve injury, you apply a splint like a Cockup's splint for radial nerve or knuckle bender for claw hand. And when it's an open injury, you operate open, operate. That's a rule. Neuropraxias, 100% recovery. Radial nerve, the most commonly damaged nerve, has the best prognosis amongst all the nerves for recovery. When you look at the brachial plexus palsy, there are two types. When there is involvement of upper trunk C5 and C6, which is a common one with better prognosis, there is Erb's palsy. So flexion of elbow, abduction of shoulder, external rotation of shoulder, they are lost in Erb's palsy. So this is how he presents with, called as waiter tip deformity or policeman tip deformity. The other variety, the Klumpke's palsy, involves the C8 and T1 nerve roots, and there is involvement causing claw hand plus minus Horner syndrome. It has poor prognosis as compared to Erb's palsy. When we look at the compression of a nerve in a closed space, what tops the chart is a carpal tunnel syndrome, which has got a Fallon's test where you have Ulta Namaste or a reverse Fallon's test where you have a Sita Namaste. The most common cause of carpal tunnel syndrome is idiopathic. Then you have pronator syndrome. Again, there is involvement of median nerve. You have cubital tunnel syndrome, which has a U in the spelling, ulnar nerve. You have Guyon's canal syndrome with a U in the spelling, again ulnar nerve. You have thoracic outlet syndrome where C8 and T1 nerve roots are involved, T1 more commonly. And there are three tests for the same, the Adson's test, where you are abducting and hyperextending the shoulder. The Roos test, this came as a video in AIIMS November 2019, again the same. Or the Wright's test, again abduction and hyperextension. So these are the three tests which are done for thoracic outlet syndrome. You have one test called as Allen's test for the patency of the radial or the ulnar artery. This again came as a video in AIIMS November 2019. You first press both the arteries and make a fist. When you do that, your palm will turn out to be white. Then if you release the radial artery, the circulation will come back and it will become red. It means there is a patent radial artery. Again, press it, make a fist, it will become white. Then release the ulnar artery and it will become red. It means that both the arteries are patent and there is a possibility of doing the cannulation. So identify the splint. This is a Cockup's splint. Middle finger extension can be used to identify the posterior introitious nerve palsy, which causes finger drop. Radial tunnel syndrome, in which this maneuver is painful. Tennis elbow, in which this maneuver is painful, but not in motor neuropathies. A patient can't extend his wrist, so he has a wrist drop. But he has no sensory loss. Doesn't matter. If he has a wrist drop, the radial nerve is involved. So level at which the affected nerve is there. So head of radius will involve posterior introitious nerve. It will only have a finger drop, can't have a wrist drop. Near medial epicondyle, ulnar nerve. It can have a claw hand. Surgical neck humerus, axillary nerve. It can have a deltoid or a teres minor palsy or regimental badge sign. So the answer is spiral groove, where the radial nerve is involved. Coming to trauma, Remember, in ATLS protocol, it's ABC which is important. Whereas ACLS protocol, which is not important for trauma, it's a CAB. But remember, before airway, breathing, circulation, stabilize the cervical spine. Most common bone to fracture. What's a fracture? Break in the cortex. What is the surest sign of fracture? Abnormal mobility or failure to transmit the movements proximally. Crepitus is not the surest sign of fracture. Most common bone to fracture, clavicle. At birth, clavicle. In children, radius more than ulna. Most common joint to dislocate, shoulder anteriorly. In children, elbow posteriorly. Rarest to dislocate, ankle. And since ankle is the rarest joint to dislocate, it is the commonest area where the ligamentous injuries occur, anterior talofibular ligament. And on the medial side of the ankle, you will have deltoid ligament. When there is a fracture, the bone undergoes the stages of union. The stages of fracture healing are the hematoma, the blood around it, which is very vital, granulation tissue, the callus, the immature bone like a cotton. The consolidation means the stage of union and remodeling over years, which you will not be able to find out where the fracture took place, which is under the osteoclast. One of the important markers of bone formation are osteocalcin and alkaline phosphatase. They will be high when union occurs. And the marker of resorption is hydroxyproline. It will be high when there is a lysis of the bone. When the union occurs with a callus formation, it's called as a biological union or secondary healing. But when the union occurs when there is no mobility at the fracture site, because callus formation requires a mobility, it's called as a primary healing or direct union. It occurs in plating, P for plating, P for primary union. Where the secondary healing has a C, so callus is formed. When you expose the hematoma, it's called as an open fracture. When the hematoma is inside the skin, it's called as a closed fracture. For example, this is a fracture supracondylar humerus. This is the hematoma. It's a supracondylar humerus, extra-articular fracture. For this, you will take the patient to operation theatre, give anesthesia, and under X-ray control without opening the fracture site, put a K-wire. So you are doing a close reduction. Whereas if the fracture is through the joint, there is hematoma, but the articular cartilage is breached. You need to open it, expose it, and restore the surface. This is called as open reduction. So lateral condyle humerus, intra-articular fracture, open reduction. Supracondylar humerus, extra-articular fracture, close reduction. And close or open depends upon the hematoma. If the fracture unites within a period of 9 months, it's union. If it does not, it's non-union. Fractures undergoing non-union are femur neck, lateral condyle humerus, ulna, tibia, talus, and scaphoid. And remember, scaphoid, its most common complication is non-union. Coming to fractures undergoing malunion. So M is malunion, intertrochanteric fracture, supracondylar humerus, Colles, and clavicle. And Colles fracture causes dinner fork deformity. Supracondylar humerus fracture causes cubitus varus, the distal part, that is the forearm and hand towards the midline. Whereas lateral condyle humerus non-union causes cubitus valgus, and these are spotters that come to you in the exam. If there is an open fracture, Gustlow-Anderson classification. Grade 1, wound less than 1 centimeter. Grade 2 is a wound more than 1 centimeter, no combination, no contamination. Grade 3 is a contaminated segmental fractures or farmhouse injuries or gunshot injuries. 3A has a good coverage of the bone, no coverage procedure required. 3B requires a secondary procedure like skin graft or muscle transfer. 3C is associated with a vascular injury. Treatment, debridement plus external fixator. You get a question on 3A or 3B usually. Remember, in swimming, shoulder is the most common joint damaged. At the shoulder, you have a tendon called as subscapularis, which is internal rotator, which allows you to place your hand over the lower back and you can lift it up, called as lift-off test. And when there's a damage to it, you can't lift it up. So it's an internal rotation called as a forgotten tendon of rotator cuff. Shoulder dislocation is the commonest anteriorly. 95% of dislocation are anterior. The Dugas test is inability to touch the tip of opposite shoulder. Dur gaya opposite shoulder. So this is normal. When you can't touch it, this is Dugas test. Callaway's test is increase in the circumference of the axilla. Remember the first two alphabets. Circumference of the axilla lengthens when the head is away. And when you place a ruler over the lateral epicondyle, it should touch the tip of acromion. It should be away from the acromion. If it touches both the point, the acromion and lateral epicondyle, it means the contour of the shoulder is gone and you are able to touch it. Whenever the head goes anterior, it will be below the joint and there will be abduction. So it's down and it's out. And when you want to reduce it, you have a Kocher's maneuver. So how do you do that? When the shoulder dislocates, that's the maneuver, abduction, external, that's how it stays. So in Kocher's, you give traction, you increase the external, you adduct it, and you do a medial rotation. Remembered by the mnemonic team: traction, external, adduction, medial rotation. Whereas Stimson's is a gravity-assisted reduction of any joint, and Hippocrates maneuver should not be done because it applies force in the axilla with your feet. The most common complication of a shoulder dislocation is a recurrent dislocation again. And one of the common lesions associated is tear in the anterior part of the glenoid labrum, called as a Bankart's lesion, which is treated by a repair. The other lesion associated is a defect in the posterolateral aspect of the head, called as a Hill-Sachs lesion. Both Bankart's and Hill-Sachs are associated with anterior dislocation. The rare variety of dislocation at the shoulder is the posterior dislocation, which is associated with electric shock or epilepsy. Here the head is at the level of the joint and it's adducted, so it's up and in. And here the head will look like an electric bulb sign, or there will be an overlap of the head on the glenoid which is normally present and it will not be here, called as empty glenoid sign. And when you have a recurrent posterior dislocation, it's associated with anteromedial defect called as a reverse Hill-Sachs. So in Hill-Sachs lesion, there is a posterolateral defect seen in anterior dislocation. In reverse Hill-Sachs, you have anteromedial defects seen in posterior dislocation, remembered by the mnemonic ramp. Coming to traumatic nerve injuries. Around the shoulder, remember it's axillary nerve. Around humerus, the radial nerve. Around the medial epicondyle, it's the ulnar nerve. If there is a cubitus valgus occurring slowly, it's called as tardy ulnar nerve. Elbow dislocation behind the epicondyle, medial epicondyle, the ulnar nerve. Around the head of radius is the posterior interosseous nerve. And when there is a fracture of upper end of ulna with a dislocated radial head, then the posterior interosseous nerve gets damaged. This is called as montagia. So in montagia, there is a dislocation of the radial head. In the wrist dislocation, it's a median nerve. Around the hip is the sciatic nerve, and around the knee is the common peroneal nerve. Now this is the Halston-Lewis sign occurring in the lower one-third of humerus. The radial nerve is getting involved because it's getting entangled in this spiral fracture. This is the montagia, fracture of ulna with dislocated radial head, and around the radial head you have the posterior interosseous nerve going, which is damaged, causing the finger drop, only pure motor branch. And when a person has a fallen outstretched hand called as a fouche, the most common injury is a Colles fracture in a fouche. And Colles is also the most common fracture in the elderly, in the osteoporotic ladies. And when we talk about in a young man, the most common injury is a scaphoid fracture into fouche. And in a child is a supracondylar humerus, fall on outstretched hand, fouche. And when I look at the elbow, the 3-point relationship, the 3 points are the medial epicondyle, the lateral epicondyle, and tip of olecranon, and they form a triangle in 90-degree flexion of elbow. Mind you, any injury above the level of elbow will not affect the points, like supracondylar fracture humerus, maintained. Whereas in elbow dislocation, this is a sign for dislocation, the 3-point relationship is disrupted. So 3-point relationship is maintained in supracondylar humerus and disrupted in elbow dislocation. You measure it in 90-degree flexion. In extension, all the 3 points are in one line. The carrying angle, the angle between the arm and the forearm is carrying angle. It's more in females as compared to males because in females the trochlea, the medial end of humerus, the lower end of humerus, medial part is lower, causing more valgus. Whereas carrying angle is reduced, called as cubitus varus, and carrying angle is increased, called as cubitus valgus. So varus occurs in supracondylar humerus, malunion. Valgus occurs in lateral condylar humerus, non-union. This is what I told you. Supracondylar humerus fracture causes varus, also called as a gun stock deformity. Also remember in supracondylar fracture humerus, right, you can have two tractions which are given in older times called the Smith traction or Dunlop traction. Nowadays you do closed reduction plus K-wire fixation, what we saw. And if there is a damage to the artery in supracondylar humerus, the brachial artery, which is the commonest artery involved in upper limb, popliteal artery is the commonest artery involved overall in the body in trauma conditions. What will be the method? Close, reduce and look for reappearance of the pulse. Fracture lateral condylar humerus, which is treated by open reduction plus K-wire fixation, because it's an intra-articular fracture, can cause cubitus valgus, and the second complication is slow onset tardial ulnar palsy because it goes behind the medial epicondyle, and as the limb will go into valgus, there will be stretching of the nerve. The Monteggia fracture. There is a fracture of the ulna with a dislocated radial head, and the direction of the radial head classifies it into different types, like type 1, anterior dislocation of the radial head. This is the commonest. Type 2 is posterior dislocation. Type 3 is a lateral dislocation, and type 4 is the fracture of both the bones along with the dislocation. When we go further, Monteggia involves the fracture of ulna. So Galeazzi involves the fracture of radius, damage to the interosseous membrane, damage to the triangular fibrocartilage complex called as TFCC at the distal radial ulnar joint, and damage to the distal radial ulnar joint itself. Four things are there in Galeazzi, and Galeazzi is 3 times more common than Monteggia, and Galeazzi was a brilliant scientist who described that Galeazzi fractures have to be operated. That is why it was called as a fracture of necessity. Over time, any fracture which requires surgery was classified into it, like lateral condyle humerus, like fracture neck of femur, like Galeazzi fractures, like olecranon and patella, or any articular injury. They were all classified, but if you have to choose one fracture of necessity, that's a Galeazzi fracture. Coming to the distal radius fractures. If it's an extra-articular fracture and the distal fragment goes posteriorly, means the first metacarpal is anterior. So if the fragment displaces posteriorly, it's called as Colles. So remember the mnemonic PC, Priyanka Chopra. Posterior is Colles. And if the fracture occurs and the fragment goes anteriorly, it's called as anterior is Smith along the first metacarpal. So anterior is Smith and posterior is Colles. Remember that. These are two very, very important things. And in Colles fracture, the treatment is close reduction plus cast application. And the rule is, since the Colles fragment is in supination, lateral displacement and posterior displacement, so you apply the cast in pronation, palmar angulation, ulnar deviation, called as propaganda. And if you do not treat these components of Colles fracture, there will be a dinner fork deformity. That's how it looks like. Whereas opposite of Colles is Smith. There is a fracture with anterior displacement, and that will cause a garden spade deformity. Remember this. The most common complication of Colles is not dinner fork deformity, it is finger stiffness. The other complications of Colles are carpal tunnel syndrome, rupture of extensor pollicis longus tendon, and most importantly, we'll talk about it, the Sudeck's dystrophy. But Colles, which is the most common complication of fracture of elderly, occurs due to Fuchs. Most common complication is the finger stiffness. If there is a traction to the elbow in a child less than 4 years of age and more than 1 year, that is between 1 to 4, the radial head subluxates out of the annular ligament. The forearm comes in pronation. This is called as pulled elbow, and the treatment is very simple. Just supinate it. It will get corrected. It also gets corrected on its own. It's a self-resolving condition. One fracture of lower end radius, which is through the joint, is called as a Barton fracture. Here it's an intra-articular fracture. Colles and Smith were extra-articular with the subluxation of the wrist. So it's an intra-articular with the joint subluxation called as volar Barton if it goes anteriorly, Dorsal Barton if it goes posteriorly, and unlike Colles and Smith, which are usually treated conservatively by cast, the Barton fractures are treated by surgical intervention. Now, this is how the wrist looks like, and the blood supply of the scaphoid goes from distal to proximal, and the fractures occurs at the waist, and that is why it is the proximal pole of scaphoid which undergoes avascular necrosis. There is tenderness in the anatomical snuff box in scaphoid, trapezium, and base of first metacarpal, 3 points, but most importantly scaphoid. Scaphoid fracture, you should learn to pick up the boat-like bone fractured right at the center, the waist. The proximal pole undergoes AVN, and any AVN, avascular necrosis, the bone will look more white, dense. And then if there's a disruption between the scaphoid and lunate, you will see a gap here, which is like a gap between the tooth of this gentleman, called as Terry Thomas or David Letterman sign. And in cases of scapholunate dissociation, you have something called as a ring sign also, which is there. Fractures of the base of first metacarpal are very commonly asked. If there's a fracture with a dislocation, it's called as Bennett's. And when there's only a fracture, comminuted fracture with no dislocation, it's called as Rolando. Remember one golden rule, both are intra-articular. If you look at the lateral view, the radius, the lunate and the capitate, they are in one line. If only the lunate comes out, this is called as lunate dislocation, and the lunate stays in, all other goes out, it's called as perilunate dislocation. Also remember one important key point. In lunate dislocation, on AP view, it looks like a pi sign, a pi of a bone. And on the lateral view, it looks like as a spilled teacup sign, a teapot sign. When you look at the complications of the trauma, compartment syndrome is a tight cast. If there's a tight cast application, there's a disruption of the microcirculation. Compartment syndrome, the most specific sign and symptom, pain, not relieved or anything. Sign, stretch pain. And if you have compartment syndrome, do a fasciotomy, release till the deep fascia, decompress the muscles, otherwise they will undergo ischemic contractions. The clinical indicator is a stretch pain, and paresthesia is an absolute indicator, clinical indicator. Normal compartment pressures are low. If the pressure is more than 30 millimeters of mercury, it's an indication, but you don't measure the pressures. So compartment syndrome, tight cast, stretch pain, pain not really doing anything. Myositis, massage. Somebody had a trauma, somebody did a massage, the movement is lost, myositis, massage. Sympathetic overactivity, Sudex. Colles fracture, united, but then there is red hot shiny skin, osteopenia. Sudex, sympathetic overactivity after Colles fracture. Femur fracture, 48 hours, fat embolism. Somebody had a trauma, femur fracture, after a gap of 48 hours he became breathless, oxygen saturation dropping, petechiae all over the body, axillary subconjunctival. Think about fat embolism. Usually they give you fat embolism after 48 hours, but nowadays they're also giving it early, like that occurred in NEET this year. Also remember, out of all the 4 complications, compartment syndrome, myositis, Sudex, and fat embolism, it is the fat embolism which is the most grievous. So this is how Sudex looks like, red hot shiny skin, patchy osteopenia. So you can see here the telltale sign that the bone has united. That's how it looks like. So patient, known case of epilepsy. Where will the dislocation occur? Posterior, in the shoulder. Which of the following fracture is seen in patient who follow a flex wrist? Remember, flex wrist, Smith fractures. Colles is extension injury. Which is the most common sequelae of a dislocation of shoulder? Recurrent dislocation. So when we look at the spine, the curvature of the spine, we have the cervical spine which has got lordosis, thoracic spine, the kyphosis, and the lumbar lordosis. Is the lumbar spine lordosis? That comes as a question to you. And similar in the spine, you need to remember one angle. The lateral curvature of the spine with the rotation is called as scoliosis, and the edges of the top and the bottom of this curve is measured. The total curve is called as Cobb's angle, and that decides in the management of scoliosis. When we look at the trauma in the spine, we need to know some fractures like Jefferson's fracture, which is the fracture of atlas, or hangman's fracture, which is the fracture of C2 over C3 spondylolisthesis. But if you have to choose between the one, C2 is the answer. Spondylo means vertebra, listhesis means slip of one vertebra over the other. Then you have the Clay-Shawler's fracture. It is the damage to the lower cervical spine and upper thoracic spine, so C7 and D1. And if you have to choose C7, because C for Clay-Shawler, C for C7. Sometimes in children, because of the flexibility of the spine, there is no damage to the vertebra, but the neural tissues can be disrupted. This is called a spinal cord injury without obvious radiological abnormality. The word radiological here means the X-rays, not the MRI, because MRI will obviously show you changes. The stability of the hip is assessed by the Trendelenburg test, and your hip is, along with the acetabulum, the head of femur, the trochanters, and the intact femur neck, can maintain your body weight on one limb, will not allow the drop of the pelvis on the opposite side when you're standing on one limb. So you're standing on the left side, the right side stays straight. But if the left side, the nerve supply, the liver arm, or the muscles are paralyzed or affected, then the opposite side drops. It's called as a drop. That is, drop of the opposite side of pelvis is called as positive. And when both the sides is positive, bilateral disease called as a waddling gait, because the duck waddles, that's how it walks, called as a waddling gait. Thomas test, and it's for the hip flexion deformities. And if you look at the upper end femur, the bony trabeculae clearly shows that the form is because of function. So weight bearing axis, there is more density of the trabeculae. This is the weight bearing line, and the trabeculae between the acetabulum, the head, and the neck are aligned. And when there's a disruption at the neck, the rotation of the head occurs and these trabeculae can be disrupted. This is called as fracture neck femur disruption. And then you also can have a fracture, the intertrochanteric area, which is extracapsular. When I look at the neck femur fracture, it is classified according to trabeculae. When there is only a valgus at the between the head and the neck trabeculae, it's called as type 1, Garden stage 1, which is an incomplete fracture, but there's a valgus. So the trabeculae are not aligned. Stage 2 is a complete fracture, but there is no displacement, so all the trabeculae are aligned. Stage 3, the head and the neck, they lose their contact and there's a rotational ligament, so all the trabeculae are disrupted. So all three malaligned. It's a partial displacement. Stage 4 is completely displaced, so head aligns with the acetabulum, but the neck malaligned. 1 and 2 are clubbed together, 3 and 4 together, because that's how the prognosis is. When we look at Powell's classification of neck femur, it is the angle that the fracture makes with the horizontal, more the vertical, more the displacement, more the horizontal, more the compression. So the prognosis depends upon the verticality, 30 degree, 30 to 50, and more than 50. So vertical fractures have poor risk. And as the blood supply goes from the distal to proximal, so the more the proximal the fracture, the worse the prognosis. So subcapital fractures have poor prognosis in the transcervical, means between the neck, which is poorer than the intertrochanteric areas. So when I look at the neck femur and intertrochanteric, also called extracapsular fracture, the intracapsular fractures have less age. They usually present around 60. Extracapsular usually present around 80. They have less pain. They have less shortening and less externodation. Whereas intertrochanteric fractures have more externodation. The lateral border of the foot touches the bed and they have marked shortening. So all the clinical features are more in extracapsular. So extra, everything is extra. And when we look at the treatment of extracapsular fracture is simple. You put a nail along with a screw called as proximal femoral nail, now the preferred treatment, or you can also put a dynamic hip screw along with a plate, and as the bone unites, it slides on. Whereas the neck femur is also called an unsolved fracture in patients less than 65 years of age, and the fracture less than 3 weeks, you just put the screws. If the fracture in the same age group is more than 3 weeks, you put something more, because these fractures are known not to unite, like a bone graft or an osteotomy, to make the fracture line more horizontal. But if the age is 65 or more, you replace half the joint, called as hemiarthroplasty. But any age, if the cartilage is getting damaged along with neck femur, you do a total hip replacement. right? The most common complication of a fracture neck femur is avascular necrosis, followed by non-union. When I look at this image, this is a gallows traction used for fracture shaft femur less than 2 years of age. And this is a Thomas splint, which was initially described for TB knee by Thomas for his own wife. But now this Thomas splint is being used to immobilize the lower limbs. When I look at the fracture shaft femur, so if you look at the age group less than 5 years, you usually treat it with hip spica. So spica is any cast that goes around the spine. And if it is 5 to 10 years, you do titanium nails. And if the age is more than 10 years, you put a intramedullary rod with screws called as interlock nailing. And so less than 2 years, gallows is an option, but the preferred is spica. So when I look at the hip joint, this is an image which tells you the different injuries around the hip. So hip flexion deformity is by Thomas test, image-based question. When there is shortening and external rotation of the lower limb, that means the neck femur fracture has occurred. When there is flexion, abduction, external rotation at the hip, there is anterior dislocation. And when there is flexion, adduction, internal rotation at the hip, so adduction and internal rotation at the hip, this is posterior dislocation. And FADIR of flexion, adduction, and rotation is an image that is coming next to you, very common. So this is Faber, flexion, abduction, external of the lower limb, anterior dislocation. In anterior dislocation, whether it's the shoulder or the hip, the head will be down and the limb will be out. So the head will be below the joint and the limb will be out. So it's called as down and out. And in anterior dislocations, upper limb, lower limb, there's a lengthening. Whereas in posterior dislocation, it's opposite. So if you're going in a high-speed vehicle and there's a sudden brake, sudden halt, and your knees, they go and collide against the dashboard in the front, the force along the shaft can take your head out, called a posterior dislocation, also called dashboard injury. But if the force goes around the knee, it injures the posterior element on the upper end of tibia, posterior cruciate ligament. So if dashboard injury does not mention the posterior dislocation of hip, you can choose the PCL avulsion. Either of them is accepted as an answer. And when there's a posterior dislocation, there's a flexion, adduction, and rotation. There's a shortening. And in posterior dislocations, as a shoulder or the hip, the head is at the level of the joint and adducted. The femoral artery pulsations, they are felt against the head of femur. And when they are felt against the head of femur, that's called as vascular sign of Narat. And when the femoral artery pulsations, when the artery goes there and the head is not there, is one posterior, you will not feel it. So vascular sign of Narat is positive. Positive means posterior dislocation. It's a controversy, but you should remember positive in posterior dislocation. And when we look at the angles in orthopedics, I told you Cobb's angle for scoliosis, lateral curvature of spine. Then you have Bowler's angle and angle of Gissane around the calcaneum. Bowler's angle, it decreases with fractures of calcaneum. Bowler's lowers. An angle of Gissane, it increases in the fractures of calcaneum. Gissane gains. Q angle is measured around the knee joint. It's an angle of the pull of quadriceps, and it's more in females, but as it increases the chances of patellar subluxation or dislocation. Coming to the cast and the splints, hanging cast, H for hanging, H for humerus, it's for fracture shaft of humerus. U slab is again for humerus. Cylinder cast is for the fractures of patella. PTB is for the fractures of tibia. Glass holding cast, you align the radius and the thumb is for the scaphoid. Handshaking cast is for Colles propaganda. Dunlop traction and Smith traction are for supracondylar humerus fracture. So remember, Smith is not for Smith fracture. So Smith traction is for supracondylar humerus, and figure of 8 bandage, I think this image is going to come to you, is for the most common fracture that occurs, and that's called as clavicle. The mallet finger is an avulsion of extensor tendon from the distal phalanx. It is one of the most commonly asked MCQs. And this is a splint given to treat it for 6 to 8 weeks. Then you have Bola-Brown splint, which can be used for femur, knee, or tibia, and the direction of the pull is along the pulleys. They have Russell traction, which was initially described as skin traction, but now is a skeletal traction, which is for the hip fractures, or you can have the Agnes Hunt traction for the flexion deformities of the hip. You have Milwaukee brace, the Boston brace, which is for scoliosis, And coming to the important fractures, the eponymous fractures, the named fractures, which is always asked in every exam. If you ask me, arthritis, the nerve injuries, and the upper limb, these are three important things in orthopedics. And Jefferson's fracture is the first fracture as you go cranial to caudal. So it is the fracture of the atlas, Hangman's C2. You remember it like this, H2. Then you have the nightstick fracture, which is an isolated fracture of the ulna. It's because of a direct blow on the ulna. Then you have the Schoffer's fracture, an intra-articular fracture because of the radial styloid, a very commonly asked MCQ. Colles, I told you, is an extra-articular fracture with a posterior displacement. So posterior is Colles. Then you have the bucket handle injury. Now the bucket handle injury means if there is an anterior disruption of the pelvis on the right side, there is a posterior disruption on the left side. So that's how, like a bucket handle, it sways down. This is bucket handle injury. Now the open book, the anterior structures open up hinging on the posterior side, called as an open book. Both are the type B injuries. So they are instabilities occurring in the pelvis, which are type B injuries. And then you have, this is open book. And then you have the Melgagnez injury, where the disruption anterior and posterior on the pelvis occurs on the same side. So that's the Melgagnez injury, which came as an image in the Jipmer. Straddle fracture is a superior pubic rami bilaterally. And the pylon fracture, again, it came as a question in May 2019, is an intra-articular fracture of the lower end of tibia disrupting the joint. Aviator's fracture is a fracture involving the neck of the talus. Then you have Jones fracture, which is involving the base of the fifth metatarsal, and pseudo-Jones involving the tip of the fifth metatarsal, the insertion. So it's more proximal. That's pseudo-Jones. And then you have the proximal humerus fractures, which are classified by NEET's classification into 4 parts: the head of humerus, the greater tuberosity, the lesser tuberosity, and the shaft, and then the supracondylar fracture humerus, which usually goes posteriorly and medially, called as posteromedial displacement. And since it goes posteriorly, it's called as an extension type of injury. And then you have the Monteggia, fracture of the ulna with the dislocated radial head. Then you have the Galeazzi, fracture of the radius with the disruption of the distal radioulnar joint. Then you have the Boxer's fracture, where there is a fracture of the neck of the fifth metacarpal. Then you have the bumper fracture. Again, Schoffer's and bumpers are two fractures very commonly asked. Fracture of the lateral tibial plateau. Then you have the Cotton's fracture, involvement of the posterior malleus, the medial malleus, and the lateral malleus. So CT, trimallar fracture, 3 malleus. You have the Potts fracture, the lateral malleus, and the medial fracture. So it is the bimallar fractures. And then you have the Chopard's fracture. There is a displacement of the intertarsal area. CIT, sit. Chopard's is intertarsal, and Lisfranc's is a disruption of the tarso-metatarsal area. They are anatomical areas, Chopard's and Lisfranc's, very commonly asked. And now we remember this March fracture, a controversial king, the neck of the second or third metatarsal. It's not the shaft, it's the neck that you should remember. Runner's fracture, very commonly asked, is fracture of the lower part of the fibula. So this is the NEET's classification. Dennis has classified the columns of the spine into 3 parts. The anterior part of the vertebral body in the disc and the anterior longitudinal ligament is the anterior column. The posterior part of the vertebral body, the disc and the posterior longitudinal is the middle column. And all the other posterior structure, the pedicle, lamina, the transfer process, and the spinous process is the posterior column. So if you have involvement of 2 out of 3 columns, it's an unstable injury. When you are treating the trauma, remember the tension band principle. When you have a fracture, the muscle pull will pull it away, and you need to hold them together. So conversion of distraction into compression is tension band principle. You need to approximate that. You can put a wire or a plate on which surface? The convex surface. Why the convex surface? Because the muscle acts on the convex surface. That's called as a tension surface. So tension band principle, tension band principle. Tension principle, apply the force to compress it. This is called as TBW, done for olecranon. The patella, the image here, that commonly asked, or medial malleus. Open injuries, Gusklo classification we had done, external fixators. The plates which are done now for osteoporotic injuries, the metaphyseal area, or non-unions or weak bones, are called as a locking plates. The advantage of a locking plate, the screw heads have got threads, the holes have threads, they lock to each other. So locking plates are the plates which are being used now. You can get an image on the locking screw or a locking plate. These are different types of screw, the normal cortical screw, the canceller screws, which are that have the threads at distal space, or the locking screws which have threads on the head too. An osteotome used to cut the bone, cure it, to clean it up, mop it up, bone cutter to make good bone grafts, bone nibbler to clean the cavity or sharpen the bone edges. These are the bone holding forceps and the plate holding forceps. So this is a bone holding forceps. What will hold the bone which will have teeth? Bone holding forceps, bone holding forceps. And if you have a smooth surface on one side, it's a bone plate holding forceps. Both the bone holding forceps and the bone plate holding forceps has come in the exam, and also the nibblers have come in the exam. This is a type of an external fixator called as a rail fixator. And if you're looking for lengthening, you can use a rail fixator or an Elizarov external fixator. Rail fixator came as a spotter in 8th November 19 exam. So this is what angle? Cobb's angle to measure the scoliosis. When you have the fusion of the vertebrae congenitally, that's called as congenital scoliosis causing the lateral deviation. Back-to-back AIMS and NEET exam. All are true regarding Jefferson's fracture, except remember, upper cervical spine has a lot of space for the neural tissues. That is why C1, C2 injuries rarely have neural deficit. So they don't have neural deficit in Jefferson's fracture. It is a disruption of the arch, involve the atlas, X-rays can be normal. Which of the following are true with respect to the intertrochanteric fracture? More common in males than females. 1 year mortality rate is 20 to 30%. This is correct. More commonly associated with non-union, it's not correct. So C is not correct. So look at the options where C is not there. So you have to choose the answer C, B and D correct, because B is correct and D is correct. If you operate early, you can reduce the mortality. Coming to next, a child brought to the emergency with multiple injuries, femur fracture, he is dyspneic. Now, it is an emergency situation. In this patient, the answer was fat embolism, but it was early than 48 hours. Normally, fat embolism occurs in femur fracture after 48 hours, but rarely they give you a presentation here. Now, this is a bone plate holding forceps, which will hold the bone and the plate. And this is a bone nibbler, which is very, very important, that again came in the AIMS exam. March fracture involves the neck. This is what you should remember. When you look at a spine injury, initial injury, there is a total areflexia. No motor, no sensory symptoms, no Barber bladder control, called as spinal shock. This gets over. There is a return of bulbocavernosus, end of spinal shock. In the lower part of the spine, where the nerve roots are there and terminal spinal cord is there, if you have a symmetrical damage with Barber bladder involvement, it's called as conus medullaris. And if you have asymmetrical involvement, it's called as the cauda equina syndrome. So the difference is, in cauda equina only the right side can be affected, whereas conus medullaris will usually have equal involvement of both the right and the left lower limb. These three terms are very importantly asked. Rarely all the three will be a question in the exam. So joint disorders are very, very important, because in central exams you will always have lots of questions coming from it. Remember one thing, that if you point your finger towards somebody and the two joints that points towards him, these two joints are involved in OA, because that's how you say OA. And then the two joints in the finger which are towards you are RA, means calling towards you, RA. So MCP and PIP are involved in RA, and PIP and DIP are involved in OA. So OA does not involve the MCP, it also does not involve the wrist. Whereas OA involves the base of the first metacarpal, carpometacarpal joint. This is what you should remember. This is what I just said. OA involvement in the DIP will be Hubbard nodes, in the PIP will be Bouchard nodes, and first carpometacarpal is the characteristic joint involved. Whenever they will show you OA, they will show you the front view. RA, they will show you the side view. That's a rule. When you have osteoarthritis of the knee, remember it's the medial compartment which is more commonly involved. And if you remember, we have done it earlier, that there is an O formation. This O formation means genu varum bilaterally, O. And the most commonly involved muscle is quadriceps, and the most common component of quadriceps is vastus medialis. And if you want to go further, the fibers are obliquus, vastus medialis obliquus. When I'm treating OA knee, the initial treatment is conservative with glucosamines or physiotherapy and medicines. If it does not resolve and the patient has limitation of activities of daily living, in a young patient, correct the deformity up to 20 degrees by high table osteotomy. In a patient who's more than 60, do a knee replacement, which will correct your deformities, will allow good movement, good proprioception. Sometimes the patella rubs against the femur upper end on extension, called as patellar clunk syndrome, but it's a rare complication to even be treated arthroscopically. Now, this is what I spoke about. In RA, you have two criteria. You have 1987 and 2010 criteria. Old is gold. It has 7 points, and 1987 7 points, and 4 out of 7 is RA. So you have morning stiffness more than 1 hour. You have arthritis of 3 or more out of 14 areas, which is PIP, MCP, wrist, elbow, knee, ankle, MTP. So bilaterally, so 14 joints, 3 out of 14. You have bilateral hand involvement. You have symmetrical involvement. You have presence of rheumatoid nodules, which is the most specific pathognomic, serum rheumatoid factor positivity or X-ray changes. Out of these 7, if 4 are there, this is RA. Whereas in 2010 criteria, 10. So there's a 10. Total score is 10. More than equal to 6 is RA. Number 1 is more the joints involved, more the points. So up to 10 joints involved, 5 points. High rheumatoid factor anti-CCP more than 3 times, 3 points. ESR and CRP, C-reactive protein high, 1 point. More than 6 weeks, 1 point. 5 and 3, 8 and 1, 9 and 1, 10. More than equal to 6 is RA. In RA patients, you should be knowing how to identify the swang neck deformity, flexion of DIP, extension of hyperextension of PIP. This is swang neck. When there is only flexion of DIP, that is mallet finger, avulsion of extensor tendon. Opposite of swang neck is the boutonniere deformity. There is extension of DIP, flexion of PIP, and it's because of disruption of the extensor tendon. Whereas in swang neck, there is a disruption or weakening of the flexor tendons. You have ulnar deviation of fingers, which are very common. There is a subluxation, ulnar deviation of finger, and radial deviation of wrist. So the wrist will go radial and the fingers will go ulnar. That's very common in RA. Coming further, they can show you the X-rays of hand where they can show you a pencil and cup deformity, psoriasis. They can show you resorption of terminal tuft of phalanges, scleroderma, acroosteolysis, or they can show you totally destroyed hand seen in psoriasis or RA if you have to answer 1 mark RA. Whereas when it comes to the axial skeleton, if they show you sacroiliitis, think about a condition which is HLA-B27 positive. Yes, it's ankylosing spondylitis, low backache in a young man with reduced chest expansion, hands paired, ankles paired, is ankylosing spondylitis. This is so commonly asked. They have fusion of the entire vertebra called as squaring of the vertebra, bamboo spine. They have calcification along the interspinous and supraspinous ligaments called as a dagger sign, which is an inverted knife. When along with these calcifications, there is a calcification along the facet joints. It's called as a trolley track sign. Mind you, tuberculosis involves the anterior structures more commonly. The rarest involved in TB is facet joints. So facet joints, remember, at 2 places, trolley track sign in ankylosing spondylitis, and rarest involved in tuberculosis of spine. And then you can have the shiny corner of the Romanes sign, sclerosis at the edge of the vertebra. They're all the features of ankylosing spondylitis. And then if you have disc calcification, intervertebral disc calcification, it should come to your main, you're dealing with alkaptonuria or ochronosis. Spotter, the urine turns black on standing. This line will be there along with this question. Inflamed great toe with erosions of the soft tissues and the bones is gout. Whereas calcification of the meniscus called as chondrocalcinosis is pseudogout. In gout you have uric acid crystals, in pseudogout you have calcium pyrophosphate crystals. And when you look at the gout, the great toe, there's a hanging bony edges. This is called as a Martel sign. They punched out or rat bite erosions around the joints. This is feature of gout. Because this is the area which is under maximum stress of the body, the great toe, that's why it's involved in gout. And then if the joints are totally destroyed but there is no pain to the patient, that's Charcot's, called as neuropathic joint. There is loss of proprioceptive fibers. And when there is a widened intercondylar notch, this is a characteristic feature of hemophilia, which has periarticular osteopenia all around, tall epiphysis. The patella, it looks squared, but the important point is widened notch. It's also seen in tuberculosis and juvenile rheumatoid arthritis, the widened notch. But characteristic is hemophilia. And when you have multiple loose bodies all over, that's called a synovial chondromatosis. This is the most common cause of multiple loose bodies. But the most common cause of a loose bodies is osteoarthritis. Most common joint where you have a loose bodies is knee joint. So theme and focus type of questions are being asked in AIIMS now. They'll give you multiple options and then you have to choose along the theme. So the options were ankylosing spondylitis, RA, gout, pseudogout, psoriasis, reactive arthritis. 60-year-old man, dull back pain for 2 months, difficulty in sitting, standing up. There is fixed SI joints. You will think of AS. Irrespective of age, if sacroiliitis is talked about, think about ankylosing spondylitis. Middle-aged male with acute onset right knee fusion with pain, he says recurrent episode. Remember, gout will have recurrent episodes. So this is ankylosing spondylitis and this is gout. This is what you should remember. And now a patient present with knee pain, aspiration, WBC is high, viscosity is normal. So when you have normal viscosity, think about OA because most of the disease will cause reduced viscosity. And then more specific for diagnosis of ankylosing spondylitis, we have spoken this sacroiliitis. HLA-B27 is not specific. Although it's present in more than 90% cases, but sacroiliitis is the most specific. Now, if you look at this child and you have bleeding of the costochondral junction, you will think about, this is called as rosary. If it is sharp, tender, scurvy, scorbutic rosary. Like round, smooth, non-tender, rachitic rosary. R for rickets, rachitic round. S for scurvy, sharp. Now, if you look at this in a child, if you have O or R, it means it's a metabolic disorder, rickets. In rickets, there is widening. It's a mineralization disorder. So the zone of mineralization is affected, zone of calcification. And the bones, they have cup in the shape. They have splaying and they have flaring. So the bony edges, they flare out. They have splaying, broaden out, and they have cup shapes, cupping, splaying, and flaring. So when you look at rickets and you give calcium, vitamin D to the patient, you will see the sign of healing, the white line of Frankel. This white line of Frankel indicates is getting treated. Whereas B and C, B is active rickets, C is healing rickets. And when I look at rickets, broadening, widening. So wrist is usually rickets, but at the knee, sometimes they talk about scurvy, sometimes rickets. So scurvy, Wimberger ring sign, sclerotic margins of epiphysis. Remember the word sclerotic. So scurvy, sclerotic margin of epiphysis is called as Wimberger ring sign. A synonymous Wimberger corner sign is seen in metaphyseal defect in syphilis. Now this is scurvy, widening rickets, whitening scurvy. So in scurvy, you have, this is called as the Wimberger ring sign. And then white line of Frankel is always seen in scurvy. What is white line of Frankel? White line at the metaphysis. So rickets, widening, scurvy, whitening, all around is white. This is what you should remember. And then if there's a bone softening disorder like rickets or osteomalacia, then the bone will give up. There's a fatigue fracture, insufficiency fracture, and that is called as pseudo fracture because it's only because of pulsations of the artery, indentation of the cortex, not a breach of cortex, which is a fracture, also called as Ambausen or milkman fracture or loser zone after the man who described it, Emil Loser. Treatment is just wait. Causes osteomalacia, rickets, hyperparathyroidism or neurofibromatosis, and this is osteomalacia. You can look at that, the reduced neck shaft angle, the triangular pelvis, the triradiate pelvis, and so many pseudo fractures which have healed. So I just spoke about a bone softening disorder called as hyperparathyroidism. Our teeth have got lining called as lamina dura. And when there's a resorption of the lining, it's called as loss of lamina dura. It is seen in hyperparathyroidism, which will cause dot 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 on the skull, called as salt pepper skull, or because the PTH acts on the osteoblast also, so you can be having sclerotic and lytic phases called as rotting fence post appearance. You remember as a child, we used to draw the fence post called as rotting fence post appearance. And they also have lytic cavities filled with blood, and the blood degradation product gives it a brown color called as a brown tumor. Coming to the ossification defects, you have two types of ossification, the end-condyle ossification and the membranous ossification. So end-condyle ossification, there's a cartilage base over which you ossify, and if it's a defect in that, it's called as achondroplasia. The patient will have short height. You know, the trunk size is normal, but the limbs are short. They're very intelligent people. They're happy people, just like Down syndrome or Angelman syndrome. But they have trident or starfish hand. This is a trident hand. There's a gap between the middle and the ring finger. And you know, many people can't do it. It's also an easy way to remember the sensory supply of hand. This is C6 supplying the thumb, C7 the index and middle finger, C8 the ring and little finger. And then you have the starfish hand where all the fingers are equal. They can have broadened pelvis called a champagne glass pelvis, or they can have the bullet shaped vertebra. So these are the features of the achondroplasia. This is trident hand. So I just told you C6, C7, C8. This is the sensory supply to remember, just a way to remember. This is all fingers equal, starfish hand. And when you have intramedullary ossification defect, cleido means clavicle, cranial means skull. They are defective. And when you don't have clavicle, your shoulders can meet in the midline. This is called as cleidocranial disorder. Shoulders can meet, it can come as a spotter. Your osteoclasts are important markers for bone. They do remodeling. And when the osteoclast is defective, there can be two disorders, osteopetrosis or Paget's. Paget's has multifactorial cause, so I've kept it second. In osteopetrosis, there's no marrow. Bones will look white, called as marble bone disease. No marrow, so pancytopenia. Anemia. And then, because of anemia, pancytopenia, secondary hematopoiesis, hepatosplenomegaly. The cranial nerves are narrowed down. The second nerve, the seventh nerve, and the eighth nerve are compressed. And this is treated by bone marrow transplant, which is given intravenous. The bones don't unite normally in these cases. Whereas in Paget's, you have osteoblastic and lytic phases. It's increased turnover, more formation, more resorption. You can have sclerotic margins of the vertebra called as picture frame, or you can have the entire vertebra being white ivory vertebra, or you can have a cotton wool skull in the sclerotic phase, or which causes increasing the head size, or you can have an osteoporosis circumscripta in the lytic phase, or you can have a shatter sign where it looks like as if more sclerosis is occurring and as if the hanging cap somebody is wearing. And then you will have thickened pelvic brim called as the brim sign. There can be lysis along the cortex called as blade of grass or flame appearance. These are all the features of Paget's. When you compare the bone quality, there is a ratio between the yellow and the red area. The red area is an unmineralized matrix and the yellow is a mineralized bone. When the amount of the bone goes down, the ratio maintained is osteoporosis. Calcium phosphate ALP levels are normal, but when the red area goes broad, that's osteomalacia or rickets. There is fall in the calcium, fall in the phosphate, high ALP. That's what the metabolic disorders will cause. In osteoporosis, you can have fractures of the vertebra, hip, or the choles. And the bone mineral density of a patient, which is measured by the DEXA scan, should be done in females more than 65, in males above 70, is reduced. So bone mineral density 0 to -1 is normal, -1 to -2.5 is osteopenia, and less than -2.5 is osteoporosis. And osteoporosis, the fracture is severe osteoporosis. And when the entire vertebrae are involved, it will give you an appearance like this called as codfish vertebra, which is seen in osteoporosis, can be seen in osteomalacia as well, but characteristic of osteoporosis. If you have crumpled skeleton, the entire skeleton, you're dealing with collagen 1 defect called as osteogenesis imperfecta, the skeleton looks white. Compare it to this skeleton, which is also white, but the shape of the bone is maintained, seen in bone osteopetrosis defect, osteoclast defect, where the marrow is not there. And then We talk about the osteogenesis imperfecta. Remember the blue sclera, it can come to you as an image. When I look at the vertebrae, when you have alternate bands in the vertebra, when there is an alternate band in the vertebra of light and dark bone, that's called as rugger jersey spine. When you have ivory vertebra or picture frame vertebra, that's Paget's. When you have bamboo spine, that's ankylosing spondylitis. When you have codfish vertebra, that's osteoporosis. And when you have bullet-shaped vertebra, that's achondroplasia. So all the vertebrae together. And then you have increased density of the bone, like malorhistosis, which is candle dripping bone disease, or osteopoikilosis, which is spotted bone disease, or osteopathia striata, which is a striated bone disease, which are incidental discoveries. Which drug is the first line for postmenopausal osteoporosis? Bisphosphonates, because of their efficacy. What is the likely diagnosis here? Coxa vara, reduced neck shaft angle. Pages affects what disease? It occurs more than 50 years. So if you count on the fingers, it will affect 6 decades onwards. So the answer is 7 decades. This is very commonly wrongly given in your books. Please correct that. Coming to the next phase, Chopard's amputation is an amputation involving the intertarsal area. Chopard's dislocation, intertarsal area. Lisfranc's amputation, tarsometatarsal area. Lisfranc dislocation, tarsometatarsal area. So they are anatomical terms. When I look at the knee joint, when I take my leg in, I am testing for the lateral structures called as lateral collateral ligament. So the varus stress, lateral collateral ligament is tested. The valgus test, the medial collateral ligament is tested. So when you're doing the valgus, means taking the leg out, you are testing for the medial collateral ligament. Dial test, the posterolateral corner in the knee, which is a very, very important corner. If it is damaged, the prognosis of the knee is very poor. Now pivot shift test, anterolateral corner, where mainly ACL is there, and posterolateral corner, mainly PCL is there. And when I look at ACL and PCL, we saw this when we were doing imaging starting. ACL restricts hyperextended interrotation and it goes anteriorly on the tibia, whereas PCL goes on the posterior margin of the tibia. But both come from the posterior aspect of the femur and the sagittal view on the MRI. And PCL is the most posterior structure on upper end tibia. That is why when the dashboard injury affects the tibia, it is the PCL which is the worst. Right? So PCL restricts the external rotation, ACL restricts hyperextended interrotation. And when there is an ACL injury, sometimes there can be a chipping of the lateral tibial plateau called as a Seagan's fracture, which is a telltale sign this patient has an ACL injury. ACL injury, when you assess in 90-degree flexion, it's called as an anterior draw test. When you do it in 20 degrees, it's called as a Leishman test, which is more specific. And you can remember it like this, LAC, the first three alphabets is ACL. So ACL, Leishman test. So ACL has two parts, the anteromedial part, which provides flexion stability, and the posterolateral part, which provides the extension stability. And it's the posterolateral part providing extension stability, which is very commonly asked in your exams. And then if you look at an athlete, they can be damaged to three structures. MAM is dangerous. MCL, ACL, and medial meniscus. So there is a damage to medial collateral ligament, anterior cruciate ligament, and the medial meniscus. This is O'Donoghue triad and the prognosis is not good. Meniscus are the shock absorber, the cushions. So you have the Apley grinding test, grinding the femur and tibia together, or the McMurray's test for the same. You have the mnemonic MATE, McMurray's test, the Apley's grinding test, the Thessalay test, and the Agace test. These are the four tests which you have for the meniscus. The blood supply of the meniscus comes from out to in. So the peripheral 1/3, which is vascular, can be repaired, whereas the inner 2/3, which does not have a blood supply, needs to be excised if it is coming in between the joint, causing a locking. Locking means inability to extend the knee. This is called as the pathological locking. When you look at the spine and you look at the MRI, this is what is a vertebra, a disc, a vertebra, a disc, and the disc has come out. This is called as prolapsed disc. And a prolapsed disc will usually compress the neural structures, will present with a backache going down the limb. An MRI can pick it up. You can see here that the T2 image will show water as white. So water is white on T2, which you can pick it up here. So this is a T2 image on both the sides. And then remember these myotomes, you will be asked them. C5 is shoulder abduction and elbow flexion. C6 is wrist extension. C7 is elbow extension. C8 is finger flexion. T1 is intrinsic muscle of hand. And you remember the sensory supply? C6 is thumb. C7 is index and middle finger. C8 is ring and little finger. This is what you should remember, the trident hand. And when you look at the lower limb, L2 is hip flexion. L3 is knee extension. L4 is ankle dorsiflexion. But what you need to remember, L5 is extension of the tongue, called as extensalis longus, and S1 is flexalis longus. Why did I ask you to remember L5? Because it's the most common nerve compressed. Why? Because the most common disc prolapse described is L4, L5. And the disc will always compress the lower nerve root. So L4, L5 disc will compress the L5 nerve root as a rule. And if you look at the dermatomes, L4 supplies the medial aspect of leg and foot. L5 the lateral aspect of leg, dorsum of foot and great toe all around. And is the S1 which supplies the sole and the little toe. So these are the important dermatomes that you should remember. But L5 happens to be the most important. And when you have any compression anywhere, whether it's a compression neuropathy or a disc prolapse, which is also a compression neuropathy, the treatment is plan A. Plan A means rest plus NSAIDs. If not relieved, local steroids, not oral, local steroid, if not surgery. And what are the surgery you can do? You can make a hole in the lamina, remove the lamina or the half lamina. So these are the ways that you can remove the disc. You can just make a small hole in the lamina, or you can remove the entire lamina or the half lamina. Right. When you look at the spine lateral view, you see a dog. And the neck of the dog is made by an area called as interarticularis. Why? Because the ear of the dog is the superior articular process, the front leg of the dog is the inferior articular process, in between is the neck called as an area interarticularis, and all the force in the spine when you dance, you jump, goes to the area, the neck of the dog, and it breaks. The vertebra is called as spondylo, break is called as lysis. Combination is called as spondylolysis. So break in the neck of the dog or dog with a collar in the neck most commonly occurs at L5 vertebra. And when the neck breaks, the head falls. Slipping of one vertebra over the other called as spondylolisthesis, beheaded dog, also called as beheaded Scottish Terrier sign between the L5 and S1 vertebra. When you have a ball coming and hitting your thumb, it can do a radial deviation of thumb, and the ulnar collateral ligament of the thumb can be injured, called as a gamekeeper's thumb. This is the most common injury of the MCP that you see. And if you have inflammation of the insertion of extensor carpus longus and brevis, brevis more than longer is called as tennis elbow, which is tested by Cosin test. This is painful wrist dorsiflexion. Treatment for tennis elbow, plan A, rest plus NSAID, if not release, surgery, if not release, steroids, if not surgery. So most of the inflammatory conditions are treated by plan A. And then if there is medial epicondylitis, it's called as golfer's elbow. If there is olecranon bursitis, student's elbow. If there is prepatellar bursitis, housemate's knee. Infrapatellar bursitis, clergyman's knee. All are treated by plan A. And there is something called the decurvens tenosynovitis, which is very commonly asked nowadays. So if you put your thumb on the palm, close your palm, fingers, and you take it towards the ulnar deviation, the tendons whose stretch you feel is the tendon of abductor pollicis longus and extensor pollicis brevis. And they are inflamed in this disease called as decurvens tenosynovitis. Treatment is plan A. The test that we just did is called as a Finkelstein test. If there is an inflammation of the insertion of tendoachilles with retrocalcaneal bursitis, it's called as a Hank-Lund's deformity. And if there is a contracture of the palmar aponeurosis, it's called as Dupuytren's contracture, very common in diabetic alcoholic patients, involves the ring finger and the little finger. And if you look at the claw hand, there is hyperextension of MCP and flexion of interphalangeal joints in claw hand. Whereas in Dupuytren's contracture, there is flexion of interphalangeal joints and flexion of MCP. And that's how you should remember. You should always look at the lateral view to differentiate claw hand or Dupuytren's, because on AP view they can look the same. And if there's a deformity of more than 30 degree of MCP and more than 15 degree of PIP, then you need to operate. Otherwise, the treatment is conservative, wait and watch. And this is mallet finger, also called as the baseball finger. And this is jersey finger, opposite of mallet finger. In mallet finger, the extensor tendon goes away from the DIP, from the distal phalanx. Whereas in jersey finger, it is the FDP, flexor ditum profundus avulsion. Mallet finger is treated conservatively by a splint for 6 to 8 weeks. whereas the jersey finger is treated by surgery. And this is hallux valgus. The lateral deviation of the great toe is hallux valgus. So in hallux valgus, you have lateral deviation of the great toe. It can be bilateral. So this comes as a spotter, as an image. So great toe inflamed is gout, and lateral deviation is hallux valgus. And when I look at the shoulder, if I have initial 60 degrees, no pain, 60 to 120 there is pain, it's called as painful arc syndrome, mid-abduction pain. If your movements are obstructed throughout, it's called as impingement. And if you have a rotator cuff tear, so these three things, rotator cuff tear, the painful arc syndrome, and the impingement syndrome, have been put together in shoulder conditions because all three are treated similar, and the treatment is plan A. But the only difference is in plan A you have rest, here you have physiotherapy, if no relief, local steroids, if not surgery. And the question that is asked is, which of the following is not true about the rotator cuff syndromes? And the answer is that steroids are contraindicated. It's not true because they are in fact indicated. And when there is fragmentation of the cartilage with underlying bone, it's called as osteochondritis. Important are 5 osteochondritis. Severs involve the calcaneum. Isolene is the base of 5th metatarsal. Freiberg's is the head of 2nd metatarsal. Kohler is navicular. And Kainbach is osteochondritis of lunate. So this is, if you look at this image, the lunate is gone. This is Kainbach. If you look at this image, navicular is gone, called as Kohler. So these are 2 important osteochondritis that should come to your mind. Loss of blood supply causing death of a bone, avascular necrosis. And avascular necrosis will look more white on the x-rays. So if it involves the head of femur in the traumas around the upper end femur, proximal pole of scaphoid, we saw that the blood supply comes from distal to proximal, both these. Body of talus and the proximal pole of lunate. Now, if you look at this, this is white, dead bone. Dead bone. So dead bone is white. Compare it with the surrounding black bone. This is proximal pole of scaphoid, avascular necrosis. This is upper end of humerus, avascular necrosis, white. Snow cap, as if the clad snow is wearing on the head. And when you look at the avascular necrosis of the head of femur, there is an anterolateral aspect which is defective. There is loss of abduction and interrotation. The movement of the hip is different in different sectors, called a sectoral sign. When you look at an X-ray, you will see a crescentic lucency, called as a crescent sign. When you get an MRI, you will see 2 bright lines, called as double line sign. Your aim is to make this area decompress, to make multiple holes, called as core decompression. Or take a blood supply with a muscle, put it there, muscle pedicle graft. Or what you do routinely today, replace it. So if you look at this question, the telltale sign of ACL, C-gone fracture. AVN can occur at all except it occurs at the femur head. It does not occur at the femur neck. So when we look at the shape of the femoral head, if it is altered, there is a limitation of abduction and interrotation. Normal axis, when you flex your hip, the knee goes to clavicle. If there is a damage, the knee will go to axilla, axis deviation. The investigation of choice in any hip pathology, in fact in orthopedics, is MRI. Treatment of choice, maintain the hip reduced. This is what you should remember. How do you maintain the hip reduced? Abduction. So if you want to reduce the hip abduction, remember the mnemonic RUB, reduction on abduction, that's the rule. DDH, normal acetabulum, shallow acetabulum. Normal epiphysis, small epiphysis. Normal Shenton's arch, broken Shenton's arch. Blood supply going on the head, femoral artery, blood, the vessel going there, called as vascular sign of Narath, positive. Unstable joint. Investigation of choice, MRI, screening tool, ultrasound. If you abduct it, you will feel a clink of reduction, called as ortolani. Hip ko andar lana. It's a test of reduction. O rub. Ortolani, reduction on abduction. Abduction, O rub. Get our selection done. O rub. Hamara selection kara dena. Ortolani, reduction on abduction. Whereas when you adduct, the head goes out. DAD, dislocation on adduction. Barlow's maneuver, bad. So dad is bad. Dislocation on adduction, bad. So ortolani, hip ko andar lana, bar low, dislocated. If you ask the patient to lie down and flex the knees, the side which is dislocated will be lower because it's dislocated, so it will be lower. Ali's or Galeazzi test. DDH is associated with firstborn child, female, family history, breech presentation, but some conditions are associated with it. Deviation of the foot medially, metatarsus adductus. When the sternocleidomastoid is short, your ear will touch the shoulder, chin opposite, called as torticollis, congenital muscular torticollis, associated with DDH. When your heels are prominent, called as calcaneovalgus, opposite of CTEV with DDH. So, if you look at the Indian scenario, the DDH is very less because abduction at the hip prevents it. Whereas if you put it adducted, as in Western countries, it's more common. That's why DDH is not seen in India. And that's why the principle of treatment of DDH is maintain abduction, Pavlik harness, or a bachelor's cast or a von Rosen splint. Whatever you wish to do, the treatment is abducted. First 6 months, close reduction. 6 months to 18 months, open reduction, because the structures are inside, you need to open and release. 18 months to 3 years, femoral correction. Cut the femur, rotate the head and get it in. Beyond that, acetabular correction. So you need to identify where the acetabulum is, where the femur has to be bought. And that's how you do it. When you look at the DDH, it's seen in birth, at birth. Perthes is between 4 to 8 years of life. This is the normal epiphysis. This is avascular necrosis of the femoral epiphysis. It's usually a painless condition, self-resolving. The head can become large and can go out of the socket. There is sclerotic head along with lytic lesion in the epiphysis metaphysis called as Gage's sign. Or there can be a sagging rope-like structure over the upper end of femur called as sagging rope sign. Crescent sign, just like avascular necrosis of the femoral head, crescentic lucency. Aim of treatment, maintain abduction. When you go beyond between 11 to 20, there can be a movement between the epiphysis and metaphysis called as slipped capital femoral epiphysis. It occurs in the growth spurt. It's a misnomer. The epiphysis does not move. It is the metaphysis that moves. It is associated with hormonal disorders like hypothyroidism. Treatment, identify and diagnose early. If you draw a line over the neck of femur, it will cut a part of the head called as normal cleans line. When you draw the same cleans line where the movement has occurred, the metaphysis moved and the epiphysis is at a different place, there is nothing above it. It's called a Strithoven sign. Cleans line, Strithoven sign. Treatment is fixation. In old neglected cases, you need to do osteotomies. Spotter. Duchenne's muscular dystrophy. There is pseudohypertrophy of the calf and tongue. It's a fibrofatty deposit inside these areas. It is not hypertrophy, pseudohypertrophy. Duchenne's muscular dystrophy occurs because of a mutation in a dystrophin gene, which is the largest gene in human body. The presentation is usually less than 5 years of age. There is weakness in the proximal muscles. That's why when a patient has to get up, he will take the support of his own body to get up, called as Gowers' sign. You climb on himself. This is congenital muscular torticollis. So your ear will touch the shoulder, chin opposite, called as cock robin appearance. It is associated with DDH, CTEV. And congenital muscular torticollis can present up to 3 months of life. And it is self-resolving by the age 1 in 90% cases. And if it does not resolve, between 1 to 5, you need to operate it. Because beyond 5, it will cause the facial dysmorphism. There is no benefit of doing it. When there is fusion of cervical vertebra, in fact, they do not segment. Then you have short web neck, low posterior hairline, restricted neck movements. And sometimes this condition is with short high scapula called as sprangial shoulder. But you know what is the most common association with Klippel-Feil syndrome? Scoliosis, 60% cases. And this is rocker bottom foot. The foot of the child is like a rocker bottom. It's a toy, and it can occur because of incorrect correction of CTV if you don't follow the correct order, or if the talus is vertical. Normally talus is horizontal, but if it's vertical, it can cause rocker bottom foot. And then CTV, one of the very common congenital anomalies in India, congenital talipes equinovarus. It is combined 4 things together, remembered by the mnemonics cave, cavus, increased plantar arch, adduction, medial deviation of the foot, varus, there is inversion of the subtalar joint, and equinus, plantar flexion. So there is, when you look at the components, equinus, varus, adduction, and cavus, and when you correct it, first correct the cavus, then adduction, then varus, then equinus. If you do not follow this order, you will have rocker bottom foot, you just saw. And treatment principle, less than 1 year of age, by Ponseti's method, apply routine cast, correct in this order, adduction and varus are corrected simultaneously, up to 1 year, cast, which is above knee. If you don't achieve the correction, which is very rare, between 1 to 3 years, soft tissue release. Posteromedial soft tissue release is one of them, called as Turcos. Or you can do a total release all around, called as subtalar release, complete subtalar release, or CSTR. Beyond 3 years, since your foot is like a bean, you take out a wedge of a bone, more like on the lateral side, called as lateral closing wedge of Osteotomies, along with the soft tissue release, which is on the medial side, tight. This is like a bean or a club. Club is a stick used to play golf. And beyond 3 years, you do a bony procedure and a soft tissue procedure. But when you go beyond 10 years, you do fusion of 3 joints, the talonavicular, talocalcaneal, calcaneocuboid. And it is the talonavicular joint which is the most difficult to fuse. When you achieve the correction, you put the child in a CTV shoe when he's walking, and at the night you put it in Dennis Brown splint. And when the child is not walking, you put it throughout the day in a Dennis Brown splint up to the age of 6 to 7 years, because after that the recurrence chances go down. Pediatric injuries, when there is a buckling of the cortex, it's called as a torus fracture. Torus is a bend at the base of a Roman pillar, just like this. And when there is bend without a break, plastic deformation, and when there is a break only in one cortex, green stick fracture. All these are common features seen in kids. When you see a child who has got anterolateral bowing, think about a pathology called as pseudoarthrosis. What is arthrosis? Joint. Pseudo, in the bone. They have been classified by Crawford into 4 types. 1, there is a bowing. 2, bowing plus narrowing. 3, there is a cyst. 4, frank movement. So when you open that cavity, you will have fluid, you will have cartilage-like material, but not hyaline cartilage which covers the joint. That is why false joint. Treatment, stabilize and put a graft just like non-union. The deficiency decides the deformity. If you don't have radius, your hand will move towards the radial side. This is called as radial club hand or radial hemimelia. You also don't have thumb, and it's bilateral. So you don't have the whole axis. The thumb, the radius, the muscles, the vessels. If you don't have ulnar club hand. If you don't have fibula, fibular hemimelia, the commonest hemimelia. Hemi means half, melia means axis absent. There is a valgus. Look at the lateral side of the foot. In fact, the entire foot is short, but the lateral toes are almost not there. You can have a tibial hemimelia. It looks like CTV, but it's not. Because in CTV, only the foot is affected. Here, the entire limb is. Or you can have a posteromedial bowing, which is non-pathological. Self-resolving. As you go, you improve. That's why this has maximum chances to come, because the conditions which are self-resolving have more chances to appear in the exam. And then you have made lung deformity. What is made lung deformity? It is the problem in the distal part of the radius in growth, and that is why it's a palmar and ulnar deformity. So palmar angulation ulnar deformity, that's the part of the radius which is deficient, the palmar, the volar aspect and the ulnar aspect. And that is why the lower end of ulna becomes more prominent. It's more common in females, 50% is bilateral, associated with Turner syndrome, but the good thing is the functions are excellent. And my friends, remember one thing also, coming to last thing here, polio affects the lower limbs and the common muscle affected is quadriceps, but if you have complete palsy, it's tibialis anterior. Which of the following is true about Poland syndrome? So absence of deltoid, absence of teres major, radial bone abnormal, web finger, hypoplastic nipples. So C, D, E is okay because the problem is in the pectoralis muscles. Evaluate the following segments with respect to CTV. 50% cases are bilateral and in males, true. Forefoot is adducted and supinated. True. With poinsettia correction is up to 90%. True. Equina should be corrected first. No, it's last because the order is C, A, V, E. So the answer is A, B and C. Management of DDH, sequence of surgery. So what will you do first? Will you open the capsule first? Will you correct the acetabulum first, or femur first, acetabulum first, or place the head in acetabulum? So what I'll do is I'll open the capsule. The first thing I will do is I will open the joint. Once my joint is opened up, I will identify where is the acetabulum. Once I know where the acetabulum is, I will correct the femur and I will place it inside. So this is what should be the first thing I will do. So I have two answers here which can be selected. So first is capsulotomy A, then C, then B, then D. So answer is D. And then this is what you should always remember, my friends. Ortho is a specialized subject. If you do it well, you can score very well. I have tried to cover everything that has been asked in the last 5 years, along with some important questions which I have picked up. But in case, if you further feel that you should do something, go to the main videos and do those topics from there. All the very best. Thank you very much.
Hi friends, this is Dr. Apurv and I'll take you through a journey of orthopedic images. I'll be going along the systems given in the ODD booklet, also along the systems given in the app, so that it's easier for the people who have already gone through the systems. The first thing I want to tell you is this brand started because of this man, Nicholas Andre, who's called as the father of orthopedics. Ortho means straight, pedics means child. Orthopedics means straight child. He was the man who gave the emblem of orthopedics, a crooked tree supported by a wooden stalk. And this is Nicholas Andre. His image is unlikely to come in the exam. Then came another man called as Thomas, who gave a lot of things, and hence this guy gave the first thing as a Thomas test, which is for hip flexion deformity. So they can show you a flexed hip and ask you which test will be done for it. Thomas test. This came as a question in AIMS November 2015, where the image of a flexed hip was given and you were asked what is Thomas test for hip flexion deformities, or what is this deformity being tested by the Thomas test. The second thing is he gave a splint. What is a splint? Anything that immobilizes a body part, and the rule of splintage is you immobilize a joint above and a joint below. So if I have to immobilize my forearm, you immobilize the elbow and the wrist. This is the rule of splintage. And when you go ahead with it, he gave a splint, Thomas splint, which can come as an image to you for his wife for tuberculosis of knee. He gave a wrench to correct the deformities which is not used. He gave a collar for cervical spine injuries or neck injuries. He also gave CTV shoes. So Thomas gave CTV shoes, which we will see subsequently in the pediatric orthopedic section. One of the very commonly done surgeries in the world today is arthro, means joint scopy. Arthroscopy, and the dad for arthroscopy is called as Watanabe. Father for orthopedics is Watanabe. For arthroscopy is Watanabe. And this can come to you because this is very commonly done in today's world, and the most commonly done is for the largest joint in human body, the knee joint. Then you have the joint replacement, also called as arthroplasty. And in arthroplasty, the father is Chanlis. So if they ask you father of orthopedics, the best answer is Nicholas Andre. If Nicholas Andre is not in the option, Thomas. If they ask you arthroscopy, Watanabe. If they ask you arthroplasty, Chanley. Images, images are extra piece of information. Why are we talking about images? Why we have come out with the scores? Because once you are comfortable with the images, that can make a big difference to your scores. Images, if you understand the rules, you will do fantastic. The first rule of any image based question is understand what the examiner is asking you. A photographer clicked it. How many individuals are there in the office? Now this is a question that a photographer is asking here. The point is how many individuals are there in the office, not in the image. So the point that the photographer has been colored should be understood by us. So you will have to add 1 to the number of individuals you will count in this office, then only your answer will be correct. Then images will always have hints, and if you look at those hints, you'll be able to answer things. For example, if the computer is on, there will be somebody beneath the table. If the almirah is open, somebody is here. Images, you should always look at every corner. So draw diagonals, draw a plus, draw a circle, so that you go all around. Then only you can have a look at the images. So I have made some rules for the images to be cracked. Number 1 rule for anything is think common. Think the most obvious thing. If they're showing you shoulder dislocation, think it's going to be anterior, because 95% of shoulder dislocations are anterior. If they're showing you hip dislocation, think it's posterior, because more than 90% of hip dislocations are posterior. If they show you a pediatric wrist, think of rickets. If they show you tumor lower in radius, think about giant cell tumor. If they are showing you inflamed great toe, think about gout. These are common things, because the rule of entrance is think common, read common, answer common, you will be commonly through. Think, read, mark, you are through. So this is a rule first, think common. Second point, keep distance means draw diagonals, draw a plus, make a circle all around with your eyes in the image so that you can pick up every corner. You don't miss out anything. Next, keep looking, don't hurry. Images are like relationships. Images are like relationships. The more time you give to them, the better they become. So spend time with it, they will be enhanced. In my country, there is 40 seconds for every question, so 20 seconds belongs to images. Localize the body part. Put a big skeleton in the room in which you are studying, an image of a big skeleton, and keep writing around shoulder what all can be asked, around chest what all can be asked, in the cut section of the heads what all can be asked, around abdomen what all signs are there, around knee, which is a common area for orthopedics, what all can be asked. Keep writing and keep seeing them every day when you're brushing your teeth or you are getting ready. Keep looking at those images, or you're having your food, or you are just talking on phone. You can keep looking at the skeleton, and this is how you'll score better. In an image, go from normal to abnormal, then look at the options. Sometimes in an image you don't need an image. That's a question. So sometimes an image based question will come and it will be so obvious and simple as an answer, you don't need an image in it. So apply your common sense. One of the most important things that people don't take with them in the exams is common sense. Keep it simple. Now, which freedom fighter is not seen in this image? The first thought that might come to you in this question is, where is the image? But then let's imagine the examiner is testing your common sense. And if you look at the options, Gandhiji, Lokmanya Tilak, Bhagat Singh and Mickey Mouse, you are very sure that Mickey Mouse will never be an answer. That's what you need to know. The first obvious thing is, where's the image? I agree, there's no image. But even then, even if there's an image like this, will it make a difference to you? Yes, it can. Because if you keep looking at this image, it will keep on showing you more and more number of individuals. If you keep looking at it, you finally can count up to 8 to 10 individuals in this. Right? I'll give you an example. Gandhiji, Nehruji, Shastriji, Subhash Chandra Bose, Bhagat Singh, and that's how it goes. So it gets better if you spend time with it. So images are like relationships. They get better with time. I went to Kashmir, right? And I was asked to click a photograph by my wife in the morning. And this is what I clicked. I clicked the big tree and I told her, you don't see such beautiful big trees in Delhi. But then she told me, this is not Kashmir. Kashmir should have beautiful sky, wonderful mountains, wonderful grass, and then some patch of good trees and some monuments maybe. So I said, but still the biggest is a tree. She said no, and this is what she clicked. a wonderful sky, wonderful mountain, good grass, some monuments, and then a tree. And then I asked her, isn't the tree the biggest here? She said, no, the biggest is the sky. And that's how the distance makes a difference. But the count is 1. So if you go too close to a tree, you will lose the sight. So never go too close to a tree. If you look at a tree, you are not getting Kashmir. To get Kashmir, you need to have multiple things. And this is what is the basic of an image-based question. If you look at one of the commonest asked images in orthopedics, this is upper limb, this is humerus, this is ulna, this is radius. Now you look at this, there is a fracture of ulna here. But then with that, there is a dislocated radial head. So fracture of ulna with a dislocated radial head has a name in orthopedics called as Montagia. M for Montagia, M for the medial bone of upper limb. That's the ulna fractures. But the point is the radial head dislocates. And along the radial head, one of the very important nerves that goes. We need to remember 5 nerves. Around the shoulder, the axillary nerve. Around the humerus, the radial nerve. Around the medial epicondyle, the ulnar nerve. Axillary, radial, medial epicondyle, the ulnar nerve. And around the head of radius, the posterior interosseous nerve, which is a branch of radial nerve. And then around the neck of fibula, the common peroneal nerve, whose palsy causes the foot drop, and the radial nerve palsy causes the wrist drop. That is what we should always remember. These are important points that we should not confuse. So this is what, if you look at only fracture ulna in this case and you miss out the radial head, your answer will still not be correct. So this is what, if you mark only fracture ulna, you mark a tree. But if you mark fracture ulna with the radial head dislocation, you mark Kashmir. You don't score if you mark a tree. You score if you mark Kashmir. Remember that you can have correct answers in one same question, but you have to mark the best correct answer, which is important to score +4. Coming to the next thing which I want to tell you here is the same image. Now look at the number of individuals there are. So if you count down the red arrows here, they will count down to be total of 10. And then you add 1 to it, that becomes 11. So the number of individuals in the office is 11. In the image is 10, and that 1 makes all the difference for the correct answer and the best correct answer, right? One of the basic things that you should remember, if you have a bone and you click an x-ray of the bone, remember one golden rule, that the cartilage is not seen on the x-rays. So cartilage is radiolucent, and the cartilage that covers at the end of the bones is the hyaline cartilage, and the hyaline cartilage is type 2 collagen, cartilage. It's type 2 collagen. And remember, the bone per se is having 1 in it, so type 1 collagen. And the defect in type 1 collagen causes osteogenesis imperfecta, because this gives the tensile strength to the bone and then it will be weakened out. One more thing you should remember, in our bone you have an area in the middle of the bone called as diaphysis. Diaphysis, general term, is middle of a bone, and then you have metaphysis, and the metaphysis is the most common area where the infections and the tumors start. So they can point an arrow at the metaphysis in an image and ask you what are the 4 conditions start there, and you will think about the infections or the tumors among the choices. This is about the hip joint movements. So if you ask a patient to lie down, and when you take his flex knee with the leg going inwards, right, the leg going inwards, then his thigh is going out. So this is external rotation at the hip. And when you take the leg out, you're taking the thigh in. This is internal rotation of the hip. Remember, in our hip and shoulders, the internal rotation is more specific movement to see whether they are normal or not. So if my shoulder has internal rotation and my hip has internal rotation, it means they are normal. So which important movement is, which of the two is the more important? Internal rotation. And that is why in AIIMS, May 2017, they had shown internal rotation. They will never be asking you external rotation. Remember that internal rotation is more important. The next thing, the first movement in our body is a yes movement. We are made positive. The atlanto-occipital joint at the top gives you this flexion extension movement, and this is the first movement that talks about yes. The second joint in the body is atlanto-axial, which is a no movement. That is left to right movement. So left to right movement is atlanto-axial, and nodding movement is atlanto-occipital. This is important for you to remember. This came in NEET 2019 this year. Remember, the first radiological investigation that we do in orthopedics is x-rays. X-rays can show you the marrow in the center in the bone, which is the main area where infections start, tumors start, diseases start. Then you have the cortex, the stronger bone, whose break is called as a fracture. And then you have joint space, which is actually what? Cartilage. And then you have a muscle layer and a fat layer, and in between the deep fascia, which needs to be opened up when you're doing decompression in a compartment syndrome called as fasciotomy. So a X-ray will not only show you the bone, it will show you a joint space, which is actually indicative of the amount of cartilage which is there, and it will show you the layers of the soft tissues. And any infection which will cause swelling, there will be loss of these soft tissue planes, which happens to be the earliest radiological feature seen in infections of the bone, also called as osteomyelitis. Anything which is radio-opaque can be picked up on X-ray, like glass pieces which are coated by lead at the back can be picked up on X-rays. Now if I look at this, this is a normal knee joint here. In the knee joint, this is the fibula, and this is where the common peroneal nerve goes, which palsy causes the foot drop. This is your tibia, and they can sometimes throw an arrow here and you might just get confused to mark it as a femur, which it is not. It's actually the patella over the femur. This is patella, and if they have to mark femur, they'll mark here. This is the lateral joint space, the medial joint space, and look here, the medial joint space is gone. This is called as destruction of the cartilage when the joint space is gone, also called as arthritis. And if we look carefully, this goes into medial, the distal part goes medially. When the distal part goes medially, this is also called as varus. Varus, the distal part, that is to the joint, the distal part goes medially, and valgus, the distal part goes laterally. Valgus is an L, so the distal part goes laterally, which is important. So this is varus. So there is varus, and then this makes an O in between the two legs. So varus of the knee is seen in O, that is osteoarthritis. This is valgus, and this makes an R in between the legs. And when it makes an R between the legs, it is seen in rheumatoid arthritis. So rheumatoid arthritis will be an R imaginary between the legs, and osteoarthritis will have an O between the legs. Remember that, right? When you look at an X-ray of a shoulder, remember the highest bony part is clavicle, and just beneath the clavicle you have the coracoid process. In the infraclavicular area, sometimes they throw an arrow in this area, or sometimes they will label different parts of the scapula and ask you what's beneath the clavicle. So the answer is coracoid process in the infraclavicular area. And then at the elbow, remember, they can show you the radial head and they can show you the capitulum, which is very, very important. The mnemonic crito, C-R-I-T-O-E, it's the order in which the ossification occurs around the elbow. Capitulum is the first one that occurs at 2 years, radial head at 4 years, the internal epicondyle at 6 years, the trochlea, the lower end of humerus medially, is at 8 years, the olecranon, the upper end of ulna, is at 10 years, and the external epicondyle is at 12 years, a table of 2. And when we look at the wrist joint, the lower end of radius makes the wrist, ulna is not a part of the wrist. On it, a boat-like bone sleeps called a scaphoid, and next to it is the lunate. Many a times they throw an arrow on the lunate and they ask you that which is this bone. Also remember, just above this is the capitate, which happens to be the largest carpal bone and the first one to ossify. So capitate is the largest carpal bone and the first to ossify. Lunate looks like a moon on the lateral view. Sometimes it's asked, when do you see a moon? I see a moon on the lateral view. On the AP view, I cannot see a moon. And then remember, the first metacarpal, also called as your thumb, is anterior. So that will help you decide whether the fractures or the dislocation are going anterior or posterior. When it goes towards the thumb, it means anterior. When it goes behind, it's posterior. And thumb alone is so precious. It takes care of the 40% of the functions of the hand alone. So thumb alone will do 40% of the functions of the hand, which is very, very important. And then remember, at the pelvis, they can show you a sacroiliac area where sacroiliitis is there in a disease called as ankylosing spondylitis. Ankylosing spondylitis is the fusion of the entire vertebral column, but it starts at the sacroiliac joint, and radiographic sacroiliitis is a very specific entity diagnostic tool which came in AIIMS May 2019, right? And then comes the knee joint. Remember, in knee joint, that patella is anterior, you have a medial joint space, you have a lateral joint space, and then you have a patellofemoral joint space, which is anterior. This is what is the knee joint, remember that. And then in the ankle, you have a medial malleus that forms the lower end of tibia. You have a lateral malleus, which is by the lower end of fibula. And then you have a posterior malleus, which forms by the lower end of tibia. So we have 3 malleus. So the fractures of 2 malleus or 3 malleus have a name, which again came in AIMS-May 2019. We'll do that in the fracture zones. Some views in x-rays. Von Rosen view is done for developmental dysplasia of hip, which means if you have a good head and this is the cup or the acetabulum, if there is a flat acetabulum, the shallow acetabulum, the head becomes unstable. This disease is called as developmental dysplasia of hip, also called as congenital dislocation of hip. Right? Then we have an open mouth view. Our tooth will not let the odontoid process to be visualized. So the moment you open your tooth and the x-rays goes in, it will be able to pick up the odontoid process, and that's how it will look in the center on the open mouth view. So O, open mouth, A, that is odontoid. So open mouth, odontoid. And then you have a Shenton's arch at the upper end of femur and the pubic rami. If there is a fracture of the femur or of the pubic rami or the head dislocates, this is called as broken Shenton's arch, and it can tell you about the status of the hip and the bones around that area. Very, very important. Shenton's arch, most important amongst the x-ray views around the hip joint. Remember, x-rays are usually the first thing that you do, but orthopedics runs on MRI. An MRI in the center can show you the marrow, it can show you the cartilage, which is not seen on x-rays or CT scan, and it can show you the soft tissues. The cortex is picked up on CT, C for cortex, C for CT, M for marrow, M for MRI. So MRI will pick up the marrow. This is very, very important. And then CT scan looks more white because it's calcified, and MRI will look more black because it is showing you the marrow. This is what is important. Remember, they can sometimes show you an image like this, an inflamed leg. And remember, whenever you see a position where is pain, fever and swelling in orthopedics, you will keep 2 differential diagnoses into it. Number 1 differential diagnosis that you should keep if you are writing entrance exams is tumors, and number 2 that you should keep is infections. So these are 2 differential diagnoses when you look at an inflamed leg. This is what you should remember. And then coming on to the periosteal reactions, and you will be asked in the exam different periosteal reactions. They can sometimes show you a single layer of periosteal reaction called as a solid periosteal reaction, or you can have multiple rays coming out called as sun ray appearance, or a triangular piece of bone called as Codman's triangle, or multiple layers over it called as onion peel appearance. These 3, the onion peel, the sun ray and the Codman's triangle, are called as white zones, indicative of chronic or the malignant process, but the single layer solid is called as benign zone or the narrow zone, which indicates a benign process. Right? So this is what is the solid periosteal reaction, single layer, seen in acute osteomyelitis or maybe some benign tumors, but 7 to 10 days. The white zones, the sun ray appearance, onion peel, Codman's triangle, they can have an overlap. Codman's triangle is very commonly asked in an image. Any malignant tumor, remember they are not diagnostic. Diagnostic is always tissue. The biopsy is diagnostic in orthopedics for infections and tumors. But if you have to choose one for Codman's triangle, pick up osteosarcoma. For sun ray appearance, any malignant tumor or any chronic infections, but if you have to pick one, osteosarcoma. And if you have multiple layers coming up, that's called as onion peel appearance. Any malignant or chronic process, but if you choose one, Ewing sarcoma, onion peel appearance, remember that. And then remember, one tumor which can go till the joint is the giant. Tumors, they respect the joints. They respect the cartilage. Infections, they eat both. The only tumor which can involve the cartilage and involve the joint is a giant cell tumor. So giant will go till the joint. So this is lower end radius GCT going and eating away the entire bone, because giant cell tumor is a tumor which eats up everything. And then you have cartilaginous tumors which calcify. If you have spotted calcification, you have mottled calcification picking up at areas. right? This is patchy calcification seen in cartilaginous tumors like chondrosarcoma and chondroblastoma. So if they have asked any calcification, even if they don't mention patchy, think of chondrosarcoma and chondroblastoma in this order. And if they want to talk about a homogeneous calcification, you must think about a tumor which is homogeneously calcified called as osteosarcoma. But if they just write calcification, then chondrosarcoma, then chondroblastoma, then osteosarcoma in this order. So this is about the initial phase, and now we'll talk about the specific units about all the images. So we're coming to the areas of infections, and my suggestion is continuing with the solid periosteal reaction which I told you for osteomyelitis. You must think about three directions: acute osteomyelitis, subacute and chronic. You will get images on either of them. So acute, you can be shown a solid periosteal reaction which we just discussed. But if they have to show you subacute, then Brody's abscess is one category which they can show you. And remember that it's a well-defined lytic lesion with sclerotic margin. You know what is sclerotic margin? Means that the body's immunity is trying to stop it. So it will always occur in a patient which has got good immunity. So it will not be seen in HIV positive individual. Coming to the chronic osteomyelitis, you will always have a dead bone in the center. So they can throw an arrow at the dead bone. Dead bone, remember, is white because it doesn't have a blood supply which causes osteopenia. So dead bone will look more white on X-rays, right? So there will be a center cavity and a dead bone. That's called a sequestrum. Surrounding live bone is involucrum. So in AIIMS November 2018, they had thrown an arrow on the involucrum and asked you what is this. And then if you look subsequently from the sequestrum draining sinuses traveling to the walls of involucrum are called as cloacae. So this is in the center a sequestrum, the dead bone. These are the cloacae which is coming to the surface, and then surrounding is the involucrum. So in the involucrum is the surrounding bone, right? And when I look at this, this is more better. This is showing you the sequestrum in the center, and then you have involucrum surrounding bone, which gives you an image of a rim around a dead bone called as a rim sign on osteomyelitis. So the aim is to take out the dead bone, and the moment you take out the dead bone, underneath the live bone will come which will bleed. This is called as paprika sign. And to take out these tissues, you need a nibbler or a bone cutter, which are two commonly asked instruments in orthopedics, a nibbler and a bone cutter, which are very, very important. So you can look at the solid periosteal reaction for acute osteomyelitis, well-defined sclerotic lesion. One of the differentials is Brody's abscess, and then you can have a dead bone in the center with surrounding involucrum and draining sinuses called as cloacae, the chronic osteomyelitis. Now these are two infections of the hand which can again come as an image to you. The phelon is the infection of the pulse space of fingers, and if there is an infection of the nail bed, it's called as paronychia, and paronychia happens to be the most common infection of hand. So overall the commonest is paronychia. Phelon is also common, but for MCQ world, phelon is more commonly asked. These are two images that should be imprinted here in your brain. You should know them. Remember, Faber and Farder are two basic positions of the lower limb which every aspirant must know. Flexion, abduction, externalization of the lower limb means more things can accommodate. It will be seen in TB synovitis, tubercular synovitis, because more synovial proliferation or any cause of synovitis. Infections means pus in the joint like septic arthritis, or it can be seen very important in anterior dislocations. Anterior dislocations of hip will have Faber. And Faber is a position, flexion, abduction, externalization is a position where there is lengthening of the limb. The limb will lengthen. So there will be flexion, abduction, externalization, there will be lengthening. And opposite to it is Farder, where you have flexion, adduction, internal rotation, and this will occur most commonly in the most common dislocation of the hip. Flexion, adduction, internal will occur in the most common dislocation of the hip, the posterior dislocation. And this is what is the 90% of the cases. That is why Farder is so commonly seen in posterior dislocation. And the second cause of Farder, when the cartilage gets destroyed, called as arthritis. So septic arthritis will have Faber because it's pus in the joint. When the septic arthritis is not controlled and it can damage the cartilage, the Faber will change into Farder, called as arthritis. Similarly, tubercular synovitis will have Faber, and if you will not control TB at that stage and it will destroy the cartilage, TB arthritis will have Farder. This is how you should remember Faber and Farder. One thing that you should remember, in a child the immunity is less. So the infections will rapidly destroy, and that is why if the epiphysis of the femur, which is here, is totally gone, this is called as Tom Smith arthritis, which is destruction of the capital epiphysis of femur, and because one part of the joint is gone, there will be hypermobility. In any infection there is absent movement, but in this, because one part of the joint is gone, there is hypermobility. mobility. One more image they can show you from the areas of infection is the fungal infections of the feet called as mycetoma, which is involvement of the subcutaneous tissue. But remember one thing, they have multiple discharging sinuses. They have swelling, but the characteristic point, they are painless. Two things in orthopedics which you should remember as painless are Charcot's and mycetoma. On MRI, these conditions have dot in the circle. These are the colonies of the infection. Dot in the circles and on MRI. It's a theory question. But yes, this image can come to you as an image. This also came in NEETPG in 2014. This is mycetoma. Remember, they are painless. Painless. When the similar infections, they involve the jaw or the mandible, they are called as actinomycetoma, the bacterial cause. The same thing. Multiple discharging sinuses at the jaw or the mandible is actinomycetoma, and in the foot is mycetoma, meaning the fungal infections. That is how we remember. Looking at an infection which is a national disease called as tuberculosis in India, tuberculosis will go through the blood because every infection goes through hematogenous area. Now, when I look at the vertebrae and the intervening disc, the lower half of above vertebra, the upper half of lower vertebra and the disc, they arise from the same mesodermal somite. That is why they are supplied by the same segmental artery, and that is why when the TB bacilli will come to the artery, it will involve the two contiguous vertebrae. It will involve two vertebrae together. That is why TB is always called as a two vertebral disease. It's also called as paradiscal, and since it's anterior to the spinal cord, it's also called as an anterior disease. Whereas malignancies are posterior element diseases and they usually involve one vertebra. But what is characteristic, they will not involve the cartilage because infections, right, can eat away the cartilage, can destroy it, but malignancies, they respect the cartilage, right, so they will not be involving it. Now, some of the replacements that can be done for a joint damage, one of them is replacing the hip but only the femoral aspect called as hemiarthroplasty. Hemiarthroplasty can be two types. One is when there is no fenestration, there are no holes in it, called as Thompson's, and the second which has holes called as Austin-Moore. In Austin-Moore spelling, there are two O's together, so it will have two holes. Remember, Thompson also has two O's in the spelling, but they are not together. In Austin-Moore, they are together, so there are two holes in Austin-Moore. These are hemiarthroplasty. When you also replace the acetabulum, it's called as a total hip replacement. Nowadays, you can do it with cement or uncemented. Remember, it is the uncemented which directly coats with the metal on the bone, and then there is an integration which is done for a good bone quality in a young individual, whereas cemented, which is cheaper, is done usually for the elderly and it is required for poor bone stock. But if you have good bone stock, you will do a uncemented arthroplasty, right? So next we talk about bone tumors. Tumors. The diagnostic point about a tumor is biopsy. If biopsy is not given, think whether it's a benign tumor or a malignant tumor. Benign tumor will have well-defined margins, and on touching, it will have a uniform feel throughout, either the hard of a bone or a firm of a cartilage or soft. Hard, firm, soft, three feels. Bone, cartilage, soft tissues. But if it's a malignant tumor, it will have variable consistency, somewhere hard, somewhere firm, somewhere soft, because liquefaction, calcification, cartilage deposition will occur, and also it will have ill-defined margins. Even if benign and malignant differentiation is difficult, then you will look at the age of the patient and the part of the bone it affects. Means, does it affect the epiphysis, the metaphysis or diaphysis? So coming to age of the patient, we need to remember the age first decade means 1 to 10 years. Number 1 tumor, Ewing sarcoma. Second decade, 11 to 20, adolescent, very favorite age, osteosarcoma. But remember, Ewing sarcoma has more number of cases in second than the first decade. Means, first decade, most common tumor is Ewing's, but Ewing's more number of cases are seen in second decade than the first decade. And then, after skeletal maturity, means the epiphysis fuses with the metaphysis and the physis or the growth plate disappears. So, we need to remember skeletal maturity of 6 major joints in human body: shoulder, elbow, wrist, hip, knee and ankle. So, if you remember this position, the milking position, the 3 joints that look up, they fuse at 18, that is shoulder, wrist and knee. And 3 joints that look down, elbow, hip and ankle, they fuse at 16. So, the age of skeletal maturity usually starts after 20 to 40. So, age group is 20 to 40. The tumor that belongs to this age group is giant cell tumor. And then more than 40 years, That's an age where metastases are seen, which is number 1 bone tumor, followed by multiple myeloma, which is the number 1 primary bone tumor. But metastasis is more common than multiple myeloma and more than 40. Going to next, the diaphyseal tumor, Ewing sarcoma. That's the key that one should remember. Osteoid osteoma, a tumor in the cortex. Adamantinoma. And in the metaphysis, which is the most common location, osteosarcoma. And if you have to choose in the epiphysis, chondroblastoma will be number 1 choice and number 2 will be giant cell tumor, in this order in epiphysis. Remember, chondroblastoma always calcifies. So, epiphyseal plus calcification is chondroblastoma. GCT, mind you, is a tumor that can go till the joint is the giant. Area-wise location of tumors, one should always remember, but the most common location happens to be the metaphysis. If you are treating a tumor, one way of treating a tumor, open the cavity and scoop out the content, called as curettage. Another way is when you scoop out the content with a curette, add some chemical called as extended curettage. And then there are excisions in which you remove the tumor to the center, called as intralesional excision or intracapsular excision. Taking it through the pseudocapsule, called as the marginal excision. Taking a normal cuff of tissue all around, which is 3 centimeters in orthopedics and majority of the tumors, called as wide resection, which is the most common resection, wide local excision, and removing the entire segment, called as the radical excision. The most common is wide local excision with 3 centimeter margin. So when we talk about tumors and their images, the number 1 tumor that you should come to your mind when you talk about upper end humerus is unicameral bone cyst. This is a metaphyseal tumor seen in the first decade of life, that is 1 to 10 years of age. It is single cavity. Center in the bone means equidistant from both the cortex. It is filled with the fluid, and then there is a cortical lesion that can occur here. With the movement of the fluid, this cortex can move up and down. This is called as trapdoor sign. This is how the cortical movement occurs. And when this cortex breaks and falls to the bottom, it is called as a fallen leaf sign. Both are seen in unicameral bone cyst. Similarly, if you have second decade of life and metaphyseal but before maturity, multiloculated means multiple septae, then you are talking about aneurysmal bone cyst. Second decade, before maturity, metaphyseal. But remember, tibia is the most common bone here. So it involves the tibia, that you should remember. If you look at a developmental malformation, then this is diaphyseal achalasia. It is actually called as osteo, means bone, and then there is a growth over it of the cartilage covering cap called as osteochondroma. So osteo means bone with a cartilage cap. You can touch the bone and the cartilage, but when you take an X-ray, you will only see the bone. So large to feel, small on X-rays is osteochondroma. It arises from the metaphysis and goes till the diaphysis. So it's called as metaphyseal or diaphyseal growth abnormality or achalasia. This is one image that can come to you. It's a bony growth. Then you have a tumor which is the most common benign bone tumor, true benign bone tumor, osteoid osteoma. Osteoid osteoma is a lesion in the cortex. So CT scan will be useful for it. They have a growing center called as a nidus. Nidus means seed, which has got lysis in the center surrounded by sclerosis. They are a tumor known for night pain relieved on taking salicylates or aspirin. Thickened cortex. This is nidus. That's how osteoid osteoma is. And then we come to upper end humerus. I told you, upper end humerus, think about UBC, but in the metaphysis. Upper end humerus, if in the epiphysis they talk about and they include calcification, it's called as chondroblastoma, which has a name called as Codman's tumor. So chondroblastoma or Codman's tumor is a tumor of the epiphysis with calcification seen at the upper end of humerus. Then whenever they talk about tumors of the bones of hand and feet, remember about N-chondroma, which has got hyaline cartilage into it. N-chondroma can have two syndromes. One is Olliers, which is only N-chondroma throughout the body. Multiple bones, multiple N-chondromas. And second is Maffucci, which has got N-chondroma, means bony destruction. Phlebolith means calcified superficial veins, and hemangiomas. So they have got many things. M for Maffucci, M for many things, O for Olliers, O for only N-chondromas, nothing else. Maffucci, many things. N-chondromas with hemangiomas with calcified superficial veins called as the phleboliths. And then we come to the king of images. 19 subjects, number 1 asked image, lower end radius tumor going till the joint is GCT till proved otherwise. So any tumor that goes till the joint is the giant. So this is how upper end tibia. So tibia I told you is very good for ABC, but that's metaphyseal before maturity. GCT is epiphyseal going till the joint after skeletal maturity, 20 to 40 years, mean age 30. Again upper end femur going till the joint. So GCT is 3 common images that come, lower end radius, upper end tibia, upper end femur, but the commonest area for GCT is lower end of femur. Remember that lower end of femur is the commonest area for giant cell tumor, osteomyelitis, osteosarcoma. Giant cell tumor, osteomyelitis, osteosarcoma. These three sites, these three things are in lower end of femur. So think about the images according to body distribution, then only you can answer it. Right? Remember, GCT going till the end of a bone, ABC is metaphyseal before maturity. Now, if the upper end of femur looks like a stick that a shepherd holds, a crooked stick, it's called a shepherd crook deformity, seen in fibrous dysplasia. So fibrous dysplasia makes the upper end of femur looks like a stick of a shepherd, called a shepherd crook deformity. It gives a hazy look to the bone called as ground glass appearance, and it has a sclerotic lesion just at the beneath the trochanter at the upper end of femur called as a Rind sign, which can come as a theory to you. If they show you vertical striations in a vertebra, it can come as an image to you called as a jail bar or cordhouse pattern. Right? This is a corduroy pattern or jail bar pattern or jailhouse pattern or vertical striations in a vertebra, hemangiomas. And when in the same condition you do a CT scan, you will see unequal sized dots, which is like a print of a cloth called as polka dot pattern. If they show you in orthopedic sacrum, it should come to your mind a tumor that arises from the notochordal remnants called as chordomas. Chordomas, sacrum, remember that. Very, very valuable. And then the tumor that causes night pain relieved on taking salicylates, osteoid osteoma. Tumor that causes pain or night pain, osteosarcoma. Osteosarcoma is metaphyseal, lower end of femur, and there is Codman's triangle or sundry appearance very commonly associated with it. One tumor that we should remember will have high calcification. You will have bone formation on the histopathology. And when you look at this presentation of infection, think about Ewing's sarcoma. Ewing's is a diaphyseal lesion which has a bony component, a soft tissue component, meaning that there is a variable consistency. When you talk about Ewing's, remember onion peel appearance. The cortex will appear hazy. There are multiple layers over it. That's what is onion peel appearance. And then coming to skulls, you know, nowadays they're showing you skulls. So if they show you small punches in the entire skull, punched out lesions, they are in multiple myeloma. Multiple myeloma can involve any bone. It can involve the vertebra, it can involve the skull, it can involve the femur, humerus or ribs, but it will have lytic lesion. One condition in the body which cannot have blastic lesions is multiple myeloma. It has got plasma cell, which is a lytic cell, a destruction cell. So they can show you a skull which has got lytic lesions, and then you will have to identify either it's a punched out lesion of multiple myeloma, or is it a beveled lesion which is also called as a sloping lesion seen in eosinophilic granuloma, or they are large permeative lesions on the skull seen in Langerhans cell histiocytosis, or they are salt pepper, like pepper and salt have been sprinkled together, seen in hyperparathyroidism. So beveled are the sloping lesions of eosinophilic granuloma. Permeative lesions are seen in histiocytosis. Eosinophilic granuloma is a variety of histiocytosis. So actually in histiocytosis you can have beveled or you can have permeative lesions, and then you can have salt and pepper sprinkled together, mixed together, called as salt pepper skull, seen again in hyperparathyroidism. When you have Paget's, it's a disease in which you have skull which has got deposits on the top called as cotton wool skull, which is characteristic finding of Paget's disease. This is a disease associated with increasing head size or head size, because as the year goes by the head size grows. Also in the disease you can have large osteoporosis called as osteoporosis circumscripta. So both osteoporosis circumscripta and cotton wool skull are part of Paget's disease. And then you come to hair on end appearance seen in hemolytic anemias, classically thalassemias. So this is about bone tumors. The next is about nerve injuries. Coming to nerve injuries. So when we look at nerve injuries, Basically, we are looking at the sensory supply of hand. Now, we all know this diagram which is being shown, and we all know we forget the moment we see it. So, I had this beautiful way of remembering it. This is called as horn sign. If anybody can do this, it means is all three nerves are intact. So, tip of index finger is supplied by median nerve. So, they can show you a shaded area in which the index finger will be shaded and this area will be in blue. That's median nerve supply. Little finger, ulnar nerve, and dorsum of first web space at the back is the radial nerve. And the image showing this shaded area came in this exam of NEET 2019, where you had to mark that this area is supplied by the radial nerve. Coming to this area, this is the upper area around the humerus, which is supplied by the axillary nerve, and the sensory area on this upper end where the army people, they apply their badges, is called as a regimental badge area, and when there is an axillary nerve injury, there is sensory loss here called as regimental badge sign. When I look at the ulnar nerve supplies the palmar interossea, which adduct pad, and dorsal interossea, which called abduction dab, pad, dab. So the middle finger does not have a palmar interossea, so its movement on either side is by dorsal interossea. This is called as Egawa test, Egawa by eye. And then if you have give a card to a patient and ask him to hold it between the fingers, when he's holding it, he's basically doing adduction called as palmar interossea, doing adduction card test. The thenar muscles are supplied by the median nerve, but one muscle is exclusively supplied by ulnar nerve called adductor pollicis. When you give book to a patient and he holds it between the thumb and the palm, it's called as a book test, which means an intact ulnar nerve. And if your ulnar nerve is paralyzed, you will flex your thumb and hold the book. This is called as Froment sign. The thumb flexion occurs because of flexor pollicis longus supplied by anterior interosseous nerve. So this is called as the Froment sign. This is the Froment sign. And then if you have abducted little finger, that's a sign of ulnar nerve called as Wartenberg injury. The median nerve is the exclusive supplier of the flexors of the index and the middle finger. So if you have a median nerve palsy, so when you make a fist, these two fingers will stand out, and this is called as a pointing index. A pope, when he talks to a big community, this is how he talks. This is also called as a benediction attitude, again the median nerve palsy. When you clasp your hands, you're making a fist in both the hands. So when you make a fist in both the hands, you're making testing the median nerve for both the hands, and if your median nerve is paralyzed, these two fingers will stand out, called as Ochsner clasp test, again for the median nerve. The abductor pollicis brevis of the thumb is supplied by median nerve, and when you abduct the thumb, you can touch the pen like this. This is pen test by abductor pollicis brevis. And when your thumb is anterior to the plane of palm so that it can do opposition, when thumb is in the plane of the palm, it's called as an ape thumb deformity. Ape thumb deformity, thumb in the plane of palm, right? Then the median nerve gives the supply called anterior interosseous nerve, and this is what it makes the sign of appreciation, the O sign. So there is flexion of the thumb by flexor pollicis longus supplied by anterior interosseous nerve, and index finger flexion by FDP lateral half anterior interosseous nerve. This is what it does, sign of appreciation, right? And then the action of lumbricals. This is what is action of lumbricals. Kapil Sharma made this. This is how he remembers the action of lumbricals, and when it's paralyzed, umbilicus is paralyzed, it's called as a claw hand, median and ulnar claw hand. So the lateral two lumbricals are supplied by median nerve, the medial two by ulnar nerve. So when there is a claw hand, total claw hand, both the nerves, or the ulnar claw hand or the median claw hand, depending on which lumbricals are involved. Alright, and then when you have claw hand, that is hyperextension MCP and flexion of interphalangeal joint, when you correct it, you have knuckle bender splint, which is used to correct the claw hand. So knuckle bender splint, if you to choose ulnar more than median nerve. Remember, the radial nerve, its palsy causes wrist drop, and the most common cause for radial nerve palsy is fracture shaft of humerus. It is the most common peripheral nerve damage, and it has the best prognosis. And remember, it has no test. So all the tests are for ulnar and median nerve. And right, and the radial nerve, that's how it travels, upper 1/3, the spiral groove in the lower 1/3, it pierces the intermuscular septum. The superficial radial nerve supplies this area, and the posterior interosseous nerve, which is a pure motor nerve, goes around the head of radius. So this area where the radial nerve, right, pierces the intermuscular septum at the lower 1/3 is the most common area where the radial nerve is paralyzed. This is called as the Holston-Lewis sign. So Holston-Lewis sign, there is involvement at the lower 1/3 level, right? And this is what is the sensory supply of the radial nerve. And remember, the Saturnite, the crutch palsy or the honeymoon palsy is the compression of the radial nerve in the middle 1/3 level because of unprotected actions causing a crushing of the nerve along the shaft of humerus. The treatment of a wrist drop is cock-up splint, remember that. So radial nerve causes wrist drop and the correction is cock-up splint. Its branch posterior interosseous nerve causes a finger drop, and finger drop is metacarpophalangeal joint loss of extension, so finger drop, which is a part of posterior interosseous nerve. The brachial plexus that we have is got the upper trunk and the lower trunk, and the involvement of upper trunk of brachial plexus C5, C6 nerve roots causes the Erb's palsy, or it causes the Vater tip or the policeman tip deformity. There is loss of flexion of elbow, abduction of shoulder, two very vital movements, external rotation of shoulder and supination of forearm. So this is what is Erb's palsy. And then one of the compression neuropathies in orthopedics that you should remember, the compression of a nerve in a closed space, is carpal tunnel syndrome. And in carpal tunnel syndrome, you have a Phalen's test where the median nerve is compressed, and if you feel the paresthesia around the distribution, or a reverse Phalen's test which is Seedha Namaste, or Phalen's test Ulta Namaste for both for carpal tunnel syndrome, which involves the median nerve. And then one basic question that came in AIMS November 18 was, if they can give you an X-ray of a chest and you will have a look at the upper part of the thorax, the last cervical spine can give a bony with fibrous tissue composition creating a cervical rib. All the ribs will come from the thoracic vertebrae, but if there's one coming from the last cervical vertebra, that is C7, now this is called as a cervical rib, and it can compress the C8 and T1 nerve roots called as a thoracic outlet syndrome, which is a clinical diagnosis. That is what these cervical ribs can cause. This is a very, very important thing. Let's look at the trauma. Let's talk about trauma now. When we look at trauma, this is a cotton wool like appearance on an X-ray called as callus. When do you see callus? 3 weeks. This is one question that comes to you. So callus is seen at 3 weeks. Remember that. Whenever you have a fracture, supposedly this is lower end of humerus. If you have a fracture which is extra-articular, that is away from the joint, you will reduce it with closed reduction. Means you will take the patient to operation theatre, apply traction, give anesthesia, apply traction and reduce it without opening the fracture site, which contains the valuable hematoma which helps the bone to unite. So closed and open terms in orthopedics are related to hematoma. If the hematoma is inside the skin, closed. If it's outside, it's open. If the injury is intra-articular, then you have to do an open reduction. You reduce it perfectly like a jigsaw puzzle and achieve a proper reduction at the joint surface. Then you have the rotator cuff muscles. One of them is subscapularis, which is internal rotator of shoulder. And this causes, the internal rotation will place your hand at the back of the shoulder and you can lift it up. And you can lift it up, it means it's normal. When you can't lift it up, that's called as lift-off test for subscapularis. Subscapularis has also been called as a forgotten tendon. When you want to test the anterior stability of shoulder, just do abduction external force, and with this force, if the head moves out like a fulcrum or a crank, or the patient holds it like apprehension, this is called as anterior instability test. So they can show you this photograph and can ask you what is the examiner testing. Abduction external, testing the anterior instability. Similarly, adduction internal rotation, opposite of it, jerk test, posterior instability, and a shoulder which is inferiorly unstable is unstable throughout. So inferior instability indicates multi-directional instability. Remember that point. Coming to next, the most common complication of a shoulder dislocation is a shoulder dislocation. So when a shoulder dislocates, the recurrent shoulder dislocation occurs because there can be a damage to the anterior part of glenoid labrum, which is called as the Bankard's lesion, or there can be a damage to the posterolateral part of the head called as the Hill-Sachs lesion. H for Hill-Sachs, H for head of humerus. So Hill-Sachs lesion posterolateral aspect of the head, right, and Bankhart's lesion, anterior tear in the glenoid labrum. These are two things which are very, very valuable. When we look at a shoulder dislocation, if you look at a joint, right, if this is the glenoid, if the head is below the glenoid in AP view and the arm is abducted, it's anterior. So anterior dislocation, whether it is shoulder or hip, the head will be below the joint and the arm will be abducted. It's a rule. And in posterior, the head will be by the side of the glenoid and the arm will be adducted. So anterior dislocations have lengthening, the heads, the humeral or femoral are below the joint and the arm or the thigh is abducted, and posterior is the opposite. Some methods to reduce a shoulder dislocation. One method is gravity assisted, called as Stimson's maneuver. One is Hippocrates, which is putting your feet in the axilla, which should never be done. But the commonest is Kocher's maneuver, where you give traction, external rotation, adduction, medial rotation. Traction, external rotation, adduction, medial rotation. This video can come to you in the exams. This is Kocher's maneuver for anterior shoulder dislocation. Posterior shoulder dislocation is the most common missed shoulder dislocation. And in this, you can have, in recurrent posterior dislocations, you can have anteromedial defect, which is called as reverse Hill-Sachs lesion. So Hill-Sachs is posterolateral defect seen in anterior dislocation, and reverse Hill-Sachs in posterior dislocation. One of the important fractures of upper limb is a fracture of ulna with a dislocated radial head. This is called as Montegia. In the beginning, I told you this is what his Kashmir was, right? And along the head of radius, the posterior interosseous nerve travels. That is why that's the commonest nerve involved in this injury. Also remember, the angle between the arm and forearm is called as a carrying angle. The reduced carrying angle is cubitus varus and increased carrying angle is cubitus valgus. So carrying angle, reduced is cubitus varus and increased is cubitus valgus, right? So carrying angle is more in females because the trochlea is at lower level as compared to males. The trochlea is the medial lower end of humerus, right? Then the supracondylar fracture humerus, I told you, is an extra-articular fracture lower end humerus, and it is treated with K-wire fixation, closed action K-wire fixation. In previous times, they used to give Smith or Dunlop traction for it. This is a fracture whose most common complication is cubitus varus because of malunion, called as gun stock deformity. As contrast to it, the lateral condyle humerus causes cubitus valgus, non-union of lateral condyle, cubitus valgus, and malunion of supracondylar humerus, cubitus varus. These two images everybody should learn by heart, right? Going to next, Montegia, the one I just told you, fracture of ulna with dislocated radial head. When the head goes anterior, it's type 1, the most common type. When the head goes posterior, it's type 2. When the head of the radius goes lateral, it's type 3. And when both the bones fracture along with dislocation of head, that's type 4. Commonest is type 1, and that's why that comes as an image. Now, alongside is Galeazzi. Galeazzi is a fracture of radius with disruption of distal radial joint, with damage to the interosseous membrane. And one important thing which goes here, triangular fibrocartilage complex at the lower end of radius and ulna. This also is damaged in Galeazzi. So there are 4 things that happen in Galeazzi: TFCC damage, interosseous membrane, fractures of lower end radius, and disruption of distal radial joint. Then one thing that's complication of trauma is myositis ossificans. Here you will always have a history of manipulation. So patient had an injury and the parents took the child for an osteopath who did a manipulation or a massage. The Pahalwan did a massage and then it caused a formation of a bone here. This is called as myositis ossificans. Remember this image. This should be imprinted here in your brain. Traction of elbow causes pulled elbow. Pulled elbow, the radial head subluxate out of the annular ligament. The forearm is in pronation. It occurs in the age group 1 to 4 years. Treatment is supination. So you just hold it and you supinate, the pulled elbow gets corrected. Very, very important that you should remember. Fractures of lower end radius are very commonly asked. If the fracture involves a joint, it's called as Barton fracture, intra-articular. Along with that, the wrist will move and the treatment is going to be operative. As compared to it, if the fracture is away from the joint, extra-articular, if the fracture fragment goes posteriorly, that is away from the first metacarpal, because first metacarpal of thumb is anterior, this is called as posterior, is called as coles. So posterior is coles. And if this fragment goes anterior towards the first metacarpal, it's called as Smith. Anterior is Smith, posterior is coles. These are two things that one should always remember. So posterior is coles, anterior is Smith. Right, so coles fracture, its malunion causes dinner fork deformity, and Smith fracture, which is reverse coles, its malunion causes garden spade deformity. Right, if there is a coles fracture, after the union occurs, there can be a sympathetic overactivity which can cause red hot shiny skin and osteopenia, which indicates there is Sudeck's dystrophy. So Sudeck's dystrophy occurs in coles fracture and there is sympathetic overactivity. If a patient has fall on an outstretched hand, the most common fracture that will occur here is coles, which also is the most common fracture in elderly. In young patients, you will have scaphoid fracture, and in a child, the supracondylar humerus due to fall on outstretched hand. But if you have to choose one, coles is the number one pick here. The blood supply of scaphoid, it goes from distal to proximal. Since the scaphoid breaks in the center area, it is the proximal pole which loses the blood supply and there develops avascular necrosis. Proximal pole avascular necrosis can occur. Right? Tenderness in the anatomical snub box is a characteristic finding of scaphoid. This is how the scaphoid fracture can be shown. It came in AIMS November 2017 as an image, and this is the glass holding cast which you give for scaphoid. This is what I was telling you, dead bone is white, and this is what is avascular necrosis of the proximal pole of scaphoid. When the scaphoid and lunate, their link breaks in between, right? This looks like a gap between the tooth of this gentleman. This is called as Terry Thomas, after the name of this man, Terry Thomas or David Letterman sign, which is also called as scapholunate dissociation. If your wrist, which is a link between the radius, the lunate and the capitate, if the lunate goes out, this is called as lunate dislocation, and when the lunate is in, the other bone goes out, it's perilunate dislocation. Remember, the perilunate is more common than the lunate dislocation, and two important radiological signs of lunate dislocation are when the lunate comes out anteriorly, it will create a triangular pie-like appearance in the front called the pie sign, or sometimes laterally there can be a sign such as the spilled teacup or spilled teapot sign, which is a feature of lunate dislocation. This is very, very important. Two fractures at the base of first metacarpal. One is Bennett's, which is a fracture of the base of first metacarpal with a pull of a muscle causing a dislocation. So it's a fracture dislocation. And second is a Rolando fracture. And remember, Bennett's and Rolando both are intra-articular. Rolando is only a fracture. Bennett's is a fracture dislocation. Right? Upper end humerus classification was by Neers, and he classified into four parts. He said head, the shaft, the greater tuberosity and lesser tuberosity. These four parts classify the Neers classification, that is at the upper end of humerus. Lower limb trauma. The important point is Tennenberg test for the hip stability. So if you stand on a normal hip, the abductors at the hip will work and take care that the unsupported side does not drop. But if you stand on a diseased hip, if this is a diseased hip, then the opposite side will drop. So drop of the opposite side is positive Tennenberg test. Normally it's negative. Thomas test, this photo comes very frequently. It's for hip flexion deformities. Spine fractures. Jefferson is a fracture of atlas. Jart is the mnemonic. So it's a burst fracture due to vertical injuries. Hangman is a slip of C2 over C3. Spondylolisthesis. Clay Chauvelar's fracture is a fracture of lower cervical spine, spinous process. Then you have normal curvatures of spine. You have cervical lordosis, thoracic kyphosis, and lumbar goes in lordosis. This came as a question in AIMS November 18. If you look at the acetabular fractures, if there is complete disruption of the pelvis, anterior and posterior column both breaks, it creates a sign called as spur sign. This is indicative of bicolumnar fractures of acetabulum. This is the weight-bearing axis of upper limb. Wolff law says that the bone will remodel and become stronger on the sides of stress. So acetabulum, the head and the neck, the trabeculae are aligned. and their disruption in fractured neck femur has been classified by Gardens. When the neck trabeculae go lateral, though there is a valgus, it's Garden grade 1. Grade 2 is all the trabeculae aligned in one line because it's a complete fracture, no displacement. Grade 3 is a complete fracture with partial displacement, all three malaligned trabeculae between the acetabulum, head and neck. And in grade 4, the neck goes away, total displacement, to acetabulum and head, they realign. Similarly, the angle that the fracture makes at the horizontal in the neck femur is called as Powell's classification. The angle being less than 30 is Powell's grade 1. The angle 30 to 50 is Powell's grade 2. And an angle more than 50 is Powell's grade 3. More vertical the fracture, poorer the prognosis. The blood supply of the head comes from distal to proximal. And if there is a fracture close to the head, there will be more chances of avascular necrosis. So subcapital fractures have more AVN than transcervical, which has more than intertrochanteric fractures. The intertrochanteric fractures are treated by nails into the upper end femur called as proximal femoral nail. One more treatment for them is put a screw in the head and put a plate over it. And as the bone will unite, the screw will side called as dynamic hip screw. And then when you are treating neck femur fractures, less than 65 years, you put a screw, more than 65 you replace with hemiarthroplasty. Gallows traction comes as an image in trauma, is for fracture shaft femur less than 2 years of age. But remember, the treatment of choice in this age group is spica. This is a Thomas splint used to immobilize lower limbs. It was described by Thomas for TB knee for his wife, but this ring is the most troubling part, and this is used nowadays for immobilization of femur fractures. Spica, treatment for lower limb injuries. Nailing for fractures of femur for adults. When there is a fracture of a major bone above the joint and major bone below the joint, it's called as a floating joint, and the treatment of a floating joint is fixation. So floating knee comes as an image. This is one image from Netters which one should remember. Flexion deformity of hip, right? Flexion contracture, Thomas test. Flexion, abduction, externodation at the lower limb. Faber at lower limb, always anterior dislocation. The head will be below the joint, thigh abducted and lengthening. Flexion, adduction, internodation of lower limb. Fadir, head will be at the level of joint, adducted and shortening, posterior dislocation. And in neck femur fractures, there is shortening and mild externodation. So shortening and externodation is neck femur, marked shortening, complete externodation in intertrochanteric fractures. Right? Anterior dislocation, there is flexion, abduction and external rotation, Faber. So there is flexion, there is abduction and there is externodation of the lower limb. The head is below the level of joint, thigh is abducted and there is lengthening. Posterior dislocation usually occurs when there is a collapse occurring in line of the dashboard called as dashboard injury. So the force will take the head out. Posterior dislocation occurs in a dashboard injury, and the second injury which can occur in a dashboard is when the force goes towards tibia, so the posterior cruciate ligament of the upper end of tibia gets avulsed, right? So dashboard injury, so this is how the order is. Once they talk about the posterior dislocation, there will be flexion, adduction, internodation, there will be shortening, the head will be at the level of the joint, there will be adduction. The femoral artery pulsations are felt against the head of femur. When there is a dislocation, the pulsations, the femoral artery goes here and you will not feel the pulsations. This is called as vascular sign of Narat, and positive means when you don't feel the pulsations. Some important fractures that one should remember. Knightstick fracture is an alterated fracture of ulna. Schoffer's is a radial styloid injury. It's an intra-articular injury. Jones fracture involves the base of fifth metatarsal. Pseudo-Jones involves the tip of fifth metatarsal. Boxer's fracture involves the neck of the fifth metacarpal, and the bumper fracture is the lateral tibial plateau of upper end tibia. The malleolar fractures around the ankle, the medial malleus, the lower end of tibia and the lateral malleus. When the both breaks, it's called as a bimalleolar fracture. And when the posterior malleus, that is the lower end of tibia posteriorly, along with the medial and lateral malleus breaks, is called as a Cotton's or a trimalleolar fracture. So Potts is a bimalleolar fracture, two malleus. Cotton's is a trimalleolar fracture. And when there is a fracture of lower end tibia intra-articular, damaging the whole articular surface and the joint above it, this is called as a pylon injury, right? Log-Hansen classification is given for ankle injuries. Supination externodation is the most common ankle injury. Remember the name. And in adduction injuries of ankle, the fracture of medial malleus is vertical. So adduction injuries, the fracture is vertical. Supination externodation is the most common ankle injury. Log-Hansen classification is for ankle injury, and this question came in AIMS May 2019 that runner's fracture involves the lower end of fibula. Some important casts that can be used. Cylinder cast can be used for fractures of patella. Patellar tendon bearing cast is used for the fractures of tibia. Then some splint. Cock-up splint is for radial nerve palsy. Knuckle bender splint is for claw hand. Dunlop traction for supracondylar humerus. Figure of 8 bandage, you can expect this question coming to you very soon. Clavicle injury. Velpio sling and swath bandage is for acromioclavicular injury to support that area. Mallet splint is for mallet finger. Mallet finger is one of the most commonly asked question. It is applied for avulsion of extensor tendon from the distal phalanx, and this is what is a very important splint. Bowler bronze splint is for immobilization of lower limb, femur, tibia, knee. Gallows traction for fracture shaft femur less than 2 years of age. Russell traction is an intertrochanteric fracture splint or traction, which is a skin traction originally described. Agnes Hunt traction is for flexion deformity of the hip joint. And then you have the Minerva cast for cervical spine. And most importantly, Milwaukee brace for scoliosis. This is very commonly asked, and you can expect this question come as an image. Remember some angles in orthopedics. Bowler's angle and angle of Gizane are measured around the calcaneum. Q angle is measured around the knee joint, and increased Q angle means there is a more chance of patellar subluxation or dislocation. Cobb's angle is for scoliosis. When you treat a fracture, the principle of tension band wiring is to compress the fracture site. It is given for fractures of patella and olecranon. Yes. So they will show you an image of fracture patella and ask you the treatment tension band wiring. Open injuries, when the hematoma is exposed to the environment, are treated by external fixator. Plates, they immobilize very well, so they are used for upper limb. You have dynamic compression plate, which is put on the entire bone and tightened with the screws. You have limited contact, means groove underneath. Dynamic compression plate, which is given so that some vessels can creep in. This is better than dynamic compression plate. But in today's world, sometimes when you do a plating, the screws, either the cancellous screw for the cancellous bone or cortical screws, they can extrude out, they can come out, the plate can become loose. So we came with a new idea where there was threads on the head and threads on the hole so that they lock to each other. This was called the locking plate. The locking plate is a very, very important plate that everybody should remember. Locking plate will not get the screws removed. If something has to come out, the plate and the screws will come out together, which is a very rare entity. For some of the implants and the instrument that you should know, osteotome is to cut the bone, curette is to clean a cavity, curettage. You have a bone cutter to cut the bone edges to freshen the margins. You have nibbler to do the same work, which is a very, very important image. Came in AIMS May 19 this year. You have bone holding forceps, anything that has a tooth will hold the bones. And then one side you have the tooth and one side smooth. This is called as bone plate holding forceps. Another variety of tooth on both the sides, bone holding forceps. Another variety where tooth on both the sides, bone holding forceps. So all these where you have tooth are bone holding forceps, and on one side when it's smooth holding the plate is called as bone plate holding forceps. Very, very important. Remember, in lower limb you put nails, and if you have to increase the length of a limb, the best fixator for it is Elizarov. So we talk about arthritis now. If they show you the front view of the fingers including DIP, think about OA. If they show you the side view of the fingers, think about RA. OA, the swelling at DIP is called as Haberden nodes. PIP is Bouchard's nodes, and first carpometacarpal joint is a characteristically involved joint in osteoarthritis. Osteoarthritis will spare the metacarpophalangeal joint and the wrist. Remember, this is what the front view, Haberden nodes. Osteoarthritis of knee, there will be decreased joint space, and remember, age-related degenerations will always have sclerosis. Increased blood supply will cause osteopenia, inflammatory disease like RA, hemophilia, and age-related degeneration like osteoarthritis will have subchondral, that is below the joint, sclerosis. Then there is genu varum, which is involvement of medial compartment in osteoarthritis, sclerosis, and so it makes a O between the legs. O is osteoarthritis. Most commonly involved muscle is quadriceps. The treatment for a young patient, that is less than 60 for OA knee, and if the activities of daily living are affected, is correction of the deformity of the genu varum called as high tibial osteotomy, and the treatment in 60 year or more is total knee replacement. Knee replacement will correct the deformities. In rheumatoid arthritis, there are finger deformities which are seen. One is swan neck, DIP is flexed, and there is hyperextension of PIP. and one is Boutonniere. There is flexion of PIP and hyperextension of DIP, opposite. Boutonniere and Swanneck are opposite of each other. In RA, you will have characteristic ulnar deviation. This image came in NEET 2019 this year. Pencil and cup. You can be shown this figure. It appears as if there is a cup and the pencil tip is pointing in that cup, is seen in psoriasis. Resorption of terminal tuft of phalanges called as acroosteolysis is seen in scleroderma, and destroyed hand seen in many conditions. One of them is RA. RA, the hand is gone. If you want to talk about ankylosing spondylitis, low backache, young man with sacroiliitis is ankylosing spondylitis. There is fusion of the entire vertebra. That's called as bamboo spine. The entire vertebral column is fused, right? This is a bony fusion. And when there is calcification along the interspinous ligaments, it appears as if there is an inverted knife called as a dagger sign seen in ankylosing spondylitis, or there can be calcification of the interspinal ligament with the facet joints labeled as trolley track sign, again seen in ankylosing spondylitis. If they show you intervertebral disc calcification and they talk that patient has urine turning black on standing, what will you sing? Alkaptonuria or ochronosis, classical. And remember, inflamed great toe is gout. There will be erosions around the great toe in gout, totally gone away, and the erosions of the bony and soft tissues is a characteristic feature of gout, whereas calcification of the ligaments, calcification of the meniscus or the cartilage is called as chondrocalcinosis, seen in pseudogout. Pseudogout involves the knee joint, gout involves the great toe, characteristic point. The erosion of the great toe in gout is called as Martel sign, which is overhanging bone, that came in NEET 2018. Charcot's is a neuropathic joint. The joint is totally gone, destroyed, damaged, over. The anatomy gone, the joint gone. That is Charcot's joint. And remember, if they talk about white intercondylar notch, they are talking about hemophilia. And then TB and JRA. TB is the cause of everything in my country, and JRA other causes of white notch. Hemophilia, more blood supply in the joint, will cause osteopenia around the joint, right? And the most common cause of a loose body in a joint, osteoarthritis. Most common cause of a multiple loose bodies in a joint, synovial chondromatosis. And the joint involved again is the knee joint, right? When you look at the neck shaft angle of femur, normally it's around 130 degrees. If the neck shaft angle is less than 120 degrees, it's called as coxa vara. And when it's more than 140 degrees, it's called as coxa valga. Coxa vara occurs in bone softening disorders like rickets and osteomalacia. In rickets, you can have costochondral junction prominent called as rachitic rosary. You can have a groove beneath the rib cage called as Harrison's groove, or you can have a varus or a valgus. In a child will always be rickets. In adult, the varus is osteoarthritis, valgus is rickets, but is rheumatoid arthritis. But in a child, varus or valgus will always be rickets. In rickets, you have bone softening disorder, so there will be widening around the bony ends. So the bone ends will wide, they will be cup shaped, and the bony ends will flare out at the margins. So there is cup, splay, which is widening and flaring. This splaying or widening is characteristic of rickets. When you give calcium and vitamin D to the patient, then you see a line of healing in rickets. This is called as white line of Frankel. So white line of Frankel is only seen in healing rickets. So if you look at this image, as contrast to the white line of Frankel, which is also seen here, this is scurvy because here the epiphysis has a margin which is sclerotic. So the sclerotic margin of epiphysis is called as Wimberger ring sign, and white line of Frankel is seen in scurvy. Number one, only healing rickets, not in active rickets. Lead poisoning and methotrexate therapy. These are 4 causes of white line of Frankel, but classical is scurvy. But remember, in scurvy, the diagnostic point is epiphyseal ring called as Wimberger ring sign. So remember, rickets is widening and scurvy is whitening. The bony ends will look more white, right? When you look at hyperparathyroidism, there is resorption everywhere. There will be pinpoint dots on the skull called as salt, pepper or pepper pot skull. In this condition, you will have lytic lesions in the bone called as osteitis because it's in the bone, fibrosa filled with fibrous tissue and cystica, right? And when there's blood inside it, it's called as a brown tumor. When I look at a condition in which enchondral ossification is affected called as achondroplasia, I will have short-heighted human beings in achondroplasia and a bullet-shaped vertebra, which can come as an image to you. They also have trident hand. This is one hand that they have in achondroplasia, and remember, this is sensory distribution of hand. C6 supplies the thumb, C7 the index and the middle finger, and C8 the ring and little finger. This is the sensory distribution of hand, and that's how the trident hand and the starfish hand are seen in achondroplasia, short-heighted human beings, where the trunk size is normal but the limbs are short because enchondral ossification is affected. As compared to it, when there is intramembranous ossification defect, you have cleidocranial disorder. The shoulders, they meet in the midline because there is no clavicle. Remember, there is no clavicle, right? When you have no bone marrow, it's an osteoclast defect, it's called as osteopetrosis. The bones will appear absolutely white like a marble. It's also called as a marble bone disease. This disease is such a characteristic that in this disease, you will have an osteoclast defect in osteopetrosis, and the bones, they appear white. They appear shining white, but the shape of the bone is maintained, right? As compared to it, right, there's one more osteoclast defect called as Paget's, in which you have the boundaries of the vertebra being white and highlighted, called as picture frame vertebra, or the entire vertebra being white, called as the ivory vertebra, seen in Paget's, which is a disease of increased turnover, more formation, more resorption, so all the markers are high. This is a disease in which you have a cotton wool skull, where the skull size increases as we grow, as we spoke about when we did all the skulls. In this disease, there is also osteoporosis of the great amount of skull, called as osteoporosis circumscripta. In this disease, a theoretical question, the pelvic brim is thickened, called as a brim sign, or there is a lysis of the long bone cortex, called as a blade of grass or flame appearance. Remember, Paget's, osteopetrosis, examiner just love. Next disease that comes is reduction in the bone density, called as osteoporosis. In osteoporosis, you will have the compression of the margins of the vertebra, so the intervertebral disc looks like a fish shaped, called as codfish vertebra, which is characteristic of osteoporosis, can also be seen in osteomalacia. When I look at destruction of type 1 collagen defect, there the entire tensile strength of the skeleton is gone, and you will have a crumpled skeleton, which is a feature of osteogenesis imperfecta. The difference between it and osteopetrosis is, osteopetrosis, the bone shape is maintained, whereas in osteogenesis imperfecta, it's gone. So when you have rugged jersey spine, the alternate bands on the vertebra, seen classically in CRF, can also be seen in osteopetrosis. The bamboo spine, seen in ankylosing spondylitis. When you have ivory vertebra and picture frame vertebra, you are talking about Paget's. When you have bullet-shaped vertebra, you are talking about achondroplasia. And when you think of codfish vertebra, you think about osteoporosis and osteomalacia. This is about the entire vertebral column. And remember the causes of ivory vertebra: lymphomas, tubercular infections, medulloblastomar metastasis, Paget's, hemangiomas, osteosarcoma, and osteoblastoma. So mainly bone formation, and it appears to be very white. The entire vertebra appears to be very white. When we look at the other areas where we talk about the amputations, the three amputations that one should remember is Chopard's amputation, which involves the intertarsal area, the Lisfranc's amputation, which involves the tarsometatarsal area, and then the Sainz amputation, which is 0.6 centimeter above the talus. 0.6 centimeter above the talus. Remember, if you have an amputation of a foot and you want to give an Indian foot to a patient, you will give a foot which looks natural. You will give a foot which has got subtalar movements. You will give a foot which has got ankle movement. So there will be subtalar movement of inversion, and there will be ankle movements of plantar flexion, dorsiflexion, allowing the patient to sit on the ground, walk on irregular surface, and this is a cheaper foot designed by Dr. P.K. Sethi, the Jaipur foot, right? When you look at the knee joint, when you want to look at the entire knee joint, the posterolateral corner of the knee, which is on the behind and laterally, that is most important for stability, and there is a structure called as posterior cruciate ligament there, and PCL is the most posterior structure on upper end of tibia, and it restricts the external rotation of the knee. So if it is damaged, the external rotation will go beyond normal, called as dial test. Similarly, opposite to it, ACL is responsible for anterolateral area, so it restricts the internal rotation. So if you jerk the internal rotation, this area comes out, called as a pivot shift test, right? If you look at the knee joint, this is what you should remember. ACL goes anteriorly on the tibia, PCL is the most posterior structure on the upper end of tibia, and PCL restricts external rotation and ACL restricts hyperextension and internal rotation. A very, very important thing. And this image which shows the PCL is the number one asked image. They ask you, what is this? This is an MRI because it's showing the ligaments, the sagittal section of the knee joint. That's what comes. For ACL, which is an important ligament, remember ACL and PCL, PCL is more important. ACL is also important. An important ligament is anterior draw test that you have for it, and the Latchman test where you have 20-degree flexion of the knee joint in which you test it, whereas the anterior draw test you are testing in 90 degrees. So that is what you should remember. Going further, if you look at 3 damages that occur in the knee, will have poor prognosis is Odonox triad, and the mnemonic is MAM is dangerous. This is MCL, ACL and the medial meniscus. When all 3 are damaged, it's called as Odonox triad. When you look at the McMurray's test, this is for the meniscus. The medial meniscus is fixed to the capsule, so it is damaged more common than the lateral meniscus. So McMurray's test, Apley grinding, Thessaly and Ege. Mate, McMurray's, Apley grinding, Thessaly and Ege, these are 4 tests for meniscus. The blood supply of the meniscus is such that the outer 1/3 is vascular. That is why when the peripheral tear is there, you repair it, and when there is a tear in the inner 2/3, you excise it. Remember that. And then when we look at the hand, if you look at the flexor tendon, they arise from the medial epicondyle, they travel the forearm. This is zone 5 of a flexor tendon. Zone 4 is an area of carpal tunnel. Zone 3 is for lumbrical. Zone 2 has lots of pulleys and crossover tendons. So this is the area of FDS. It should never be operated. So it's called as no man's land. And zone 1 is FDP, which should be again operated. So which is the no man's land? Zone 2 of FDS, right? And when we look at the spine, when we look at the lumbosacral spine, we must always remember in the lumbosacral spine, right, if this is a vertebra, this is a disc, this is a vertebra, this is a disc prolapse, it has come out. And a disc prolapse will always come posterolateral. The most common level of disc prolapse is between L4 and L5 vertebra, and the L5 nerve root, the lower nerve root is compressed. That's the most common nerve root compressed in human body. Right? If you look at an oblique or a lateral view of spine, you will see a dog. So what is it called as? It's called as a Scotty dog. So when do you see a dog? You normally see a dog, right? This Scotty dog or a normal dog, right? The ear of the dog is the superior articular process. The front leg is the inferior articular process. The neck of the dog is called as interarticularis. And whenever a vertebra breaks, it breaks from this area. It's called as break in the neck of the dog or dog with elongated neck. This occurs at the L5 vertebra. And you know, whenever a neck breaks, the head falls. And when the neck breaks and the head falls, it's called as spondylolisthesis, slipping of one vertebra over the other. And the most common level at which it occurs is L5-S1 level. Right? So the weak link is the interarticularis of the neck of the dog. Right? If you have a forceful ball coming to the thumb and it stretches the thumb laterally, it will break the ulnar collateral ligament on the medial side. This is the most common injury of the metacarpophalangeal joint called as gamekeeper's thumb. Then you have some inflammatory diseases of the tendons being overused, like the tennis elbow. There's lateral epicondylitis. It's inflammation of the lateral epicondyle. It involves the ECRB more than the ECRL. Then you have the golfer's elbow, the medial epicondylitis. The student's elbow, the olecranon bursitis. So these are important areas. And then when you hold your thumb in and you make a fist, and when you take it towards the ulna, nothing happens, right? When the thumb is out, nothing happens. But when the thumb goes in, this is a very painful condition, right? This is called as a Finkelstein test. When you do that, if the patient just jumps out, severe pain, this is called as decurrent stenosynovitis, which is inflammation of abductor pollicis longus and extensor pollicis brevis. These two tendons, this is NEET 2018 MCQ, and this test is called as a Finkelstein test that one should remember. Prominent calcaneal tuberosis, Haglund deformity came as a theory in Ames November 18, and when the palmar aponeurosis contracture occurs, then these ring and little finger, because they are the most commonly involved in Dupuytren's contracture, they do into flexion deformity. Remember, ulnar claw hand will be hyperextension of MCP, but whereas in Dupuytren's contracture there is flexion everywhere. Remember that. This is the key point that one should remember to differentiate between the two. Mallet finger, also called as baseball finger, there is flexion of DIP, came as an image in NEET 2019. Jersey finger is opposite to it. There is avulsion of flexor digitorum profundus from the distal phalanx, and this is a condition which is operative. And then hallux valgus is lateral deviation of the great toe. You know, great toe, you are asked at two places. One is inflamed great toe called as gout, and second is when there is lateral deviation of the great toe called as the hallux valgus. This came as an image. Hallux valgus came as an image in the exams. Hallux valgus is a very, very important thing, right? And then we come to the blood supply of the upper end of femur. The blood supply of the upper end of femur goes from distal to proximal, and that is why when there is a fracture occurring at this area, there is avascular necrosis or dead bone at the upper end of femur. Remember, the dead bone is white. Dead bone is white. It looks sclerosed, and that's how the avascular necrosis occurs. Similarly, the blood supply of scaphoid goes from distal to proximal. If there is a fracture, then the avascular necrosis will involve the proximal pole, and that's how it looks like. Similarly, if there is an AVN involving the upper end of humerus, it will look like a white cap called a snow cap sign, which again indicates there is damage to the blood supply, right? The blood supply of the upper end of femur, which is very common for avascular necrosis, creates a crescent sign at the upper end of femur. X-ray view, double line sign on MRI, which is the investigation of choice, MRI for IOC. You look at pediatric orthopedics. Remember one golden rule, right? Whenever your hip and shoulder are absent, you can do proper abduction, you can do internal rotation, both head, shoulder and hip. But if your shoulder and hip are damaged, you lose internal rotation and abduction. So internal rotation is a crucial movement. Second point, when you ask a patient, a lying patient, to flex the knee will go to the mid-clavicle line. The moment it's damaged, it will go to the axilla. So remember, it will go to the axilla. This is what you should remember. And when you look at a good X-ray, you will see that there is a Shenton's arch at upper end femur. There is a good epiphysis. There is a good acetabulum, right? The femoral artery pulsations, they go from here. But when there is DDH, you know, the Shenton's arch is broken. The epiphysis is so small. The acetabulum is very shallow. And the femoral artery pulsations are not felt as a vascular sign of Narad being positive. So the femoral artery pulsations are not felt, called as the vascular sign of Narad being positive. So in DDH, developmental dysplasia of hip, there is shallow acetabulum, small epiphysis, broken Shenton's arch, vascular sign of Narad positive. In DDH, you remember the test, when you abduct your thighs, the head goes in the acetabulum. So it's called as Ortolani test of reduction on abduction. And when you adduct the thighs, the head goes out, it dislocates, called as Barlow's or Baharlo. Baharlo in Hindi means take it out, dislocate. Ortolani, hip ko andar lana. So when you abduct the thighs, the head goes in. So it's a test of reduction. So we remember that. And then you remember the Perkins line, which is a vertical line drawn for DDH diagnosis. Remember this. This is asked. Ultrasound on DDH. MRI is investigation of choice for DDH. Ultrasound on DDH. The alpha angle decreases on ultrasound in DDH. So alpha angle decreases. Remember the mnemonic AD. You don't need to know further AD. And then some common anomalies associated with DDH. There are metatarsals, they go in, called as metatarsal adductors or talipus calcaneovalgus. Remember, DDH is less seen in India because we hold our kids in abduction, and abduction reduces it. So that is why the flexion prevents it, and that's why we have good hips and bad knees. So we have less of the diseases, and that's why when treated, abduct it, called as Pavlik harness. Or you can use a Von Rosen splint, a man who described DDH in different ways, Von Rosen, or you can apply a cast in which there is abduction. So DDH is number one image-based question. Second, when you have the normal epiphysis and there is avascular necrosis of femoral epiphysis at the age of 4 to 8, it's called as Perthes disease. In Perthes disease, you have lysis of the upper end of femur called as Gage's sign. You will have a sclerotic band going over it called as a sagging rope sign, or the epiphysis goes out. This is called as a lateral subluxation of the head. MRI is investigation of choice, and X-ray is crescent sign, just like avascular necrosis of upper end femur in adult. In Perthes in a child, you will see the crescent sign. When you draw a line over the neck of femur, it always cuts a part of the head which is above the line. But if there is nothing above the line, it means there is slipped capital femoral epiphysis. In slipped capital femoral epiphysis, the metaphysis that moves, the epiphysis does not move, so it's a misnomer. Slipped capital femoral epiphysis. When there is nothing above the head, above the line, it's called as Stithoven sign, and this line is called as Klein's line, right? Coming to some other genetic deformities like pseudo-hypertrophy of calf. When you have pseudo-hypertrophy of calf, you think about Duchenne's muscular dystrophy, which is an X-linked recessive disorder seen in males. The mutation is the largest gene in human body called as dystrophin. There is proximal muscle weakness, so the patient uses his own body to climb ourselves, called as a Goward sign. This image should be asked, but actually this came into November 16. You were asked about pseudo-hypertrophy of calf, but this is a more common image to be asked. Second thing that you should remember, congenital muscular torticollis. the sternocleidomastoid muscle, the action is, it gives the ear on the same side, chin to the opposite side. This is called as cock-robin appearance. When during the birth delivery there is ischemia of this muscle, sometimes the patient, this is the position that he attains, right? Cock-robin appearance. It can present up to 3 months of life, right? Congenital muscular torticollis sternocleidomastoid is involved. And sometimes when there is a fusion of the vertebrae, right, there is a short neck with low posterior hairline, which you can see here, and the neck movements are restricted, called as a Klippel-Feil syndrome. What's the pathology? Fusion of the vertebra. What's the pathology in congenital muscular torticollis? There is sternocleidomastoid ischemia. What's the pathology in Duchenne muscular dystrophy? Dystrophin gene mutation. When the foot of the child appears like a rocker bottom, it's called as a rocker bottom foot. Rocker bottom foot occurs as a very common deformity, right? It can occur because of correction of CTV, when you do not follow the order of correction, or when the talus is vertical, right? CTEV or congenital talipes equinovarus is also called as a club foot because the foot resembles a club. This is what? Shoulder joint. Golf ball on a tee is a shoulder joint, and club looks like a CTV. In CTEV, you remember that there is a large lateral border and there is a small medial border, tight medial structure. So aim is to equalize both the borders, right? The different procedures which can be done, but the most important that you should remember as an image, the triple arthrodesis which is done in an age group more than or equal to 10 years, fusion of 3 joints TN, TC, CC, talonavicular, talocalcaneal and calcaneocuboid, and remember talonavicular fusion is the most difficult to achieve. And then CTV shoes which were given by Thomas, which has got straight inner border, outer shoe raise and no heel to counteract the deformity of CTV which has cave. What is cave? You have there increased the plantar arch called as cavus. You have medial deviation of the foot called as adduction. There is inversion of the heel called as varus, and there is plantar flexion of the ankle called as the equinus. So CAVE, this is the order of correction. If you do not correct in this order, there will be rocker bottom foot, and this is a splint which is applied to both the foots to apply dorsiflexion so that you can correct the dynamic deformity called as Dennis-Brown splint. Remember, in pediatric age group, there are some injuries which can occur. There can be buckling of the cortex at metaphyseal-diaphyseal junction called as a torus fracture. Torus is a bend at the base on a Roman pillar. That's why how it looks like. When there is a deformity without a fracture called as plastic deformation, and when there is only break in one cortex, it is called as a green stick fracture, which can come as an image to you very commonly, right? If you have an anterolateral deformity of the leg, it means there is a stage called as pseudoarthrosis. Arthrosis means between two different bones, like femur and tibia, they make a joint. Pseudoarthrosis means a joint within a bone. This can be traumatic, it can be congenital, and in congenital pseudoarthrosis tibia, you have got anterolateral deformity. Remember, if I do not have a bone, it's called as absent axis. Aemilia means absent bone, hemimelia means off axis. So if radial bone is not there, it means the thumb is also not there, radial artery is not there, the musculatures are not there. This is called as radial hemimelia, right, which will be also called a radial club hand. The thumb is not there, and the entire axis deviates towards the lateral side, because wherever is the deficiency, the deformity goes towards. That's how it goes into that side. And then if you don't have fibula, you will have valgus and small lateral toes, smaller foot, small lateral toes, fibula hemimelia. You can also have a tibial hemimelia. It looks like CTV, but in CTV, the leg is not involved. This is tibial hemimelia. Or you can have a posteromedial bowing, which is characteristic of self-resolving conditions. So just leave it. It will be okay on its own. And remember, one golden word that I want to tell you after these videos. Remember that there will be people around you who seem to have studied more. But you know, in this crucial period, what will matter the most? What will matter the most is that how you hold yourself, how you utilize every minute, how you plan what to do next day, how you assess every hour with a stopwatch. Are you wasting time? And at the end of the day, look in the mirror and decide, are you going through that phase? Decide every day that this is what you have been preparing for. Speak to yourself that I will be doing something next year. I'll be joining a college, and at this point of time, I will be treating patients. I will be into a dream branch which I have. And if you do that, remember, you can defeat any intelligence. One thing that you should remember, if you want to do something good in life, work like a dog, live like a slave. That's only the way that you become a king. And remember, that's why attitude and passion is always more valuable than the talent anybody has. Before you sleep, write on a piece of paper what you want to do next day, because if you don't know what to do in the first 20 minutes of a day, your day is gone. So draw a plan for the next day. This is what I want to say. And the final words of the class, I always say that defy the given. If you defy the given, if you deny the given, God will rewrite your destiny. You should speak, fight for it, then only it will happen, because you have to demand and you have to give your 100% towards the direction that you dream of, right? तेरी किस्मत दा लिखा तेरे तो कोई खो नहीं सकता, तू श्रम करा चल बंदे, तू कर्म करा चल बंदे, जो उसकी मेहर हुई तुझे वो मिल जाएगा, तो तेरा हो नहीं सकता. So it just means whatever is your destiny, right? If you work hard, you'll get it. But if you work harder, then God will rewrite your destiny, something which even He did not think that He'll give it to you. So all the very best. This is Dr. Apoor Mehra signing off. I'm always there. Ask your queries. Thank you very much.
Hello students, I am Dr. Manish Soni. I am your dermatology faculty, and in these difficult times, I hope all of you are doing well and you are healthy. Today we'll be discussing dermatology in a very short time, that is, we'll be doing rapid revision course, and in this rapid revision we'll be discussing various topics of dermatology in short, mainly the important portions which are repeatedly asked in various exams. So let us begin with the introduction part. So if we talk about skin, we all know that skin have various layers like epidermis, dermis and subcutaneous layer. Now in between epidermis and dermis there is one very important layer which we sometimes forget, and that is dermoepidermal junction, also known as basement membrane zone. So these are the four important layers of skin. Let us first discuss about epidermis. So this epidermis is made up of various cells and it has various layers. The cells which form epidermis are keratinocytes, melanocytes, Merkel cells and Langerhans cells. While there are various layers of epidermis as well, like the most superficial layer is known as stratum corneum, then second is stratum lucidum, then next is stratum granulosum, then stratum spinosum, and finally the lowermost layer, that is stratum basale. Now there are a few important points which you need to remember about each of them, that is the various layers as well as various cells. So we will be discussing those points. Before that, remember that sometimes they ask you a question on these layers and it is very important to remember the sequence of these layers. So you know that the first or the topmost layer is stratum corneum and the deepest is stratum basale, as it is quite suggestive from the name itself, base. So this is the deepest layer or basal layer. Now in between are these three layers, that is lucidum, granulosum and spinosum. If you forget them, you can very easily remember by this simple mnemonic, that is legs. Okay, so lucidum, then granulosum, then spinosum. If we talk about keratinocytes, then remember that these are majority of the cells. Almost 90% of the epidermis is made up of keratinocytes. So these are the majority of the cells which are present in epidermis, and the hallmark of these cells is presence of keratin filaments. Keratin filaments. Like there is one example of keratin filament like keratin 5 and keratin 14, which are present in the lowermost layer, that is stratum basale. Now one more important point which you can remember here is that if this keratin becomes defective, that is keratin 5 and 14 which is present in stratum basale, it can lead to a disorder. So defect in this keratin can lead to a disorder, that is epidermolysis bullosa simplex. So sometimes they ask you such questions, so just remember this defect. Now the next cell is melanocytes. Now melanocytes are mainly present in stratum basale. So they are present where? In stratum basale. Already question have been asked. They synthesize melanosomes, and these melanosomes, they contain melanin. Okay. Now remember that these melanocytes, they are derived from neural crest. Okay, so they are derived from neural crest. So they are derived from neural crest, but they are present where? In stratum basale. So what happens from neural crest? They migrate to stratum basale. Okay, so these are what? These are immigrant cell. They migrate to stratum basale. So let us consider this is stratum basale, that is the lowermost layer of epidermis. These are the basal keratinocytes. And in between these basal keratinocytes, you might find a few cells having dendrites. These dendritic cells are melanocytes. So these are melanocytes. Okay. Now these melanocytes, as I told you, they synthesize melanosomes, and these melanosomes, they contain melanin. Now what happens that the surrounding cells here are all keratinocytes, because I told you 90% of the epidermis is made up of keratinocytes. So all these are keratinocytes. So what happens to these melanosomes? These melanin containing melanosomes gradually move along these dendrites, and finally they are transferred to adjacent keratinocytes. Okay. So what is happening? It is helping in distribution of this melanin to the adjacent keratinocytes, and normally 36 keratinocytes per melanocyte. That is, this single melanocyte is going to transfer its melanosome to adjacent how many keratinocytes? 36. So 36 keratinocytes per melanocyte. This is known as epidermal melanin unit. So sometimes this question is asked that what is epidermal melanin unit? 16, 26, 36, 46 keratinocytes per melanocytes. Answer is 36 keratinocytes per melanocytes. The next is Merkel cells. Merkel cells are also present in stratum basale, that is the lowermost layer, and they help in carrying touch sensation. These are touch receptors. So these are slow adapting type 1 touch receptors. So these are what? These are slow adapting type 1 touch receptors. Then fourth is Langerhans cells. Now this is important. They are mainly present in stratum spinosum. So they are present where? In stratum spinosum. Their hallmark is, presence of a characteristic granule, that is Birbeck granules. And why this is important? Because of its shape, because these are rod or tennis racket shaped. So these are Birbeck granules which are seen in Langerhans cells. These are tennis racket shaped granules. Now these cells have some characteristic markers. These cells are found to be positive for CD1A, CD207 and S100. Okay. So if in the question it is written that the cells were found to be positive for CD1A or CD207, then you can easily make out that they are talking about Langerhans cells. Now their number might increase. So the number of Langerhans cells might increase in conditions like Langerhans cell histiocytosis, which is also known as histiocytosis X, while their number decrease in conditions like psoriasis, sarcoidosis, also in basal cell carcinoma. So these are few important points which you can remember about all these cells, and already these questions have been asked. So we will make one table, and with the help of this table you can very easily remember these points which are repeatedly asked. Like they might ask you about the cells of epidermis, where they are derived from, and finally they are present where. So present in. So remember, the first one is keratinocytes. They are ectodermal in origin. They are present in all the layers of epidermis, because these are the majority of the cells. Almost all the layers of epidermis, they have keratinocytes. Next is melanocytes. They are derived from neural crest, and they are present in lowermost layer, that is stratum basale. Third one is Merkel cells. There is a controversy in the origin of these cells. Some books mention ectodermal in origin, some books mention neural crest, but if both are given in separate option, choose ectoderm followed by neural crest. They are also present in the lowermost layer. And finally the last one, that is Langerhans cells. They are derived from mesoderm, or sometimes mentioned as bone marrow, and they are present mainly in stratum spinosum. So all these are important questions, and already these questions have been asked in various exams. So remember these points. One more important point to remember here is that melanocytes which are present in skin are derived from neural crest, but the melanocytes are also present in eye, that is retina. So these melanocytes which are present in retina are derived from optic cup. Okay. Now next is layers of epidermis. As I already told you that these are various layers like stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Now these layers, they develop from below upwards. So this is the first one to be formed and this is the last one to be formed, and that is the reason why stratum corneum is deficient in preterm or low birth weight babies. Okay, so if they ask you that which of the following layer of epidermis is deficient in preterm babies, the answer will be stratum corneum, because that is the last one to be formed. Now I told you that keratinocytes are the majority of the cells and they are present in all these layers, but they change gradually as these cells move upwards. So what happens, that as the keratinocytes which are present in stratum basale, they move upwards, they increase in size, they gradually become flat, they lose their moisture, so they become dehydrated, and there is loss of nucleus. So gradually nucleus is lost. Okay, so nucleus is very prominently seen in the lowermost layer, that is stratum basale. So that's why this layer is highly mitotically active. Okay, so most mitotically active is stratum basale, but as we move upwards the nucleus is lost, so the nucleus is absent in stratum corneum. So this is inactive or mitotically inactive, there is no nucleus, and these are actually dead keratinocytes. Okay, so active keratinocytes are seen in stratum basale, dead keratinocytes are seen in stratum corneum. Now as these cells from stratum basale move towards stratum corneum, so let us consider this is stratum basale. These are the keratinocytes which are present here. Now as they move upwards, they reach stratum corneum, then they cross stratum corneum, and finally they get sloughed off in the environment. So this total time, that is the time required by the keratinocytes to move from stratum basale and finally shed off in the environment, this total time is known as epidermal turnover time or skin doubling time. So epidermal turnover time or skin doubling time is the time required by the keratinocytes to move from stratum basale and finally shed off in the environment. Now how much is this time? Actually these cells require around 14 days to reach stratum corneum, then another 14 days to cross stratum corneum, and once they reach the topmost layer they gradually slough off in around 28 days. So this total time becomes 56 days. So remember, epidermal turnover time is 56 days. If range is given, you can mark 52 to 75 days. Okay. Now once these highly mitotically cells which are present in stratum basale move towards the stratum spinosum, that is in stratum spinosum, you will find few features. Okay, so let us write down few points about stratum spinosum. Stratum spinosum is the thickest layer. Now all these keratinocytes, they are attached together, like this is one keratinocyte and this is another keratinocyte. So all these keratinocytes, they are attached together via desmosomes. Okay, so when they are attached on all the sides, these desmosomes appear like spines, and that's why this layer is also known as prickle cell layer, or its name is stratum spinosum. Spines are seen. Okay, so this was the question which was asked in one of the exams. The desmosomes are prominently seen in. So they are prominently seen in which layer? Stratum spinosum, like you can see in this image also. So here you can see these are the various layers of epidermis: stratum corneum, then stratum lucidum, then stratum granulosum, then stratum spinosum, then finally stratum basale, which is the lowermost layer. All these layers have these cells, that is keratinocytes. In between these keratinocytes you might find some other cells like melanocytes, Merkel cells, or Langerhans cells. Now these keratinocytes, as you can see, if this is a keratinocyte, this is a keratinocyte, they have these spine like processes. So these are what? These are desmosomes. They are helping in attachment of the keratinocytes. Then I told you that these granules, they are characteristically seen in which cells? They are seen in Langerhans cells, and their shape is like a rod or like a tennis racket. So it appears like a tennis racket. So these tennis racket shaped granules, these are known as Birbeck granules. Now remember one more point, that these desmosomes, they are made up of desmosomal proteins. They are made up of desmosomal proteins, which are also known as calcium dependent adhesion molecules. So they require calcium for their function, and their function is adhesion. So these are calcium dependent adhesion molecules, and these are few examples like desmoglin, desmocolin, desmoplakin, placoglobin. So all these are what? All these are desmosomal proteins. They are present in desmosomes. In short, sometimes they are written as DSG, DSC, DP, and PG. So all these are desmosomal proteins. Now you tell me that if these are desmosomal proteins and they are present in desmosomes, and desmosomes are in between the keratinocytes, if they become defective, what will happen? The keratinocytes will separate because their function is adhesion, and once adhesion is lost, they start separating. So whenever these proteins become defective, whenever desmosomes become defective, what happens? Intercellular separation, and they are present where? In between the keratinocytes, and keratinocytes are in epidermis. So you can write down intraepidermal separation or disorder. Okay, so intraepidermal disorder, intraepidermal. Okay, sometimes they ask you that which of the following disorder is within epidermis or below epidermis. So it is within epidermis when these proteins get defective. Like you can remember one example here, pemphigus. So in pemphigus, which protein is involved? Desmoglin is involved. And pemphigus is which type of disorder? Intraepidermal disorder. So which type of bulla will be seen? Intraepidermal bulla will be seen. Okay, so these are few important points to remember. Next is stratum granulosum. Stratum granulosum, as the name itself is suggestive, it is granular cell layer, that is granules are seen, and there are two important granules to remember here. One is keratohyaline granule, which synthesize prefiligrin. This protein helps in filament aggregation. So now you know that why this is known as filigrin. Okay, so you can very easily remember the function agrin. So filament aggregating protein. And this pre term depicts that this is a precursor molecule. So this is a precursor molecule of filigrin which helps in filament aggregation. Now sometimes this filigrin, becomes defective, and the defect in filigrin leads to disorder, that is ichthyosis vulgaris. While another granule is membrane coating granule. Membrane coating granule, which is also known as Odland bodies or lamellar granules. Now these membrane coating granules, Odland bodies or lamellar granules, they synthesize lipid. And this lipid forms a protective membrane or a protective barrier. And if this protective barrier becomes deficient, it leads to another disorder, and that is steatotic eczema, also simply known as winter eczema or eczema crackle. So these are two important disorders to remember here. Ichthyosis vulgaris is due to involvement of filigrin, while steatotic eczema is due to deficient lipid membrane, which is a protective membrane in the skin. Moving on to the next layer, that is stratum lucidum. Stratum lucidum is also known as clear cell layer. And you might be wondering that why we call them clear cell layer, because the cells present here are translucent. And why they are translucent? Due to presence of one protein, that is refractile granules of eledin. So this protein eledin, it is refractile in nature, and due to which these cells appear clear, and that's why this is known as clear cell layer, stratum lucidum. And this layer is mainly present in palm and sole. So it is mainly present in palm and sole. Now the topmost layer is stratum corneum. And I told you that the nucleus is absent here. So these are dead keratinocytes. Like you can see here that the nucleus is quite prominent in the lower portion of the epidermis, but it is deficient in the upper portion. Okay, so in stratum corneum the nucleus is absent. Now this is a normal finding. So if you don't find nucleus in the topmost layer of epidermis, need not worry, because this is a normal thing. But if you find nucleus, that is abnormal. Okay, so there are few conditions where you might find nucleus in the topmost layer when you do histology. So let us note down such histological findings which are seen, like parakeratosis. Just now I told you that nucleus is absent in stratum corneum, but if it is retained, then we call it parakeratosis. So if you find nucleus in the topmost layer, it is parakeratosis. So if you find nucleus or presence of nucleus in stratum corneum is parakeratosis. Examples: the conditions where parakeratosis is seen are psoriasis, eczema, actinic keratosis, seborrheic dermatitis, and squamous cell carcinoma. All these can very easily be remembered by this simple mnemonic, that is PEAS. So psoriasis, eczema, actinic keratosis, seborrheic dermatitis and squamous cell carcinoma are the conditions where you might find nucleus in the topmost layer, that is stratum corneum. Next histological finding is dyskeratosis. So what is dyskeratosis? Dyskeratosis is abnormal keratinization. This can be seen in various conditions like malignant conditions, squamous cell carcinoma, pre-malignant conditions like Bowen's disease, and benign condition like Darier's disease, also seen in Halle-Halle disease. Already question have been asked on Darier's disease, so remember D for D. Okay, so dyskeratosis is commonly seen in Darier's disease. Other examples are Halle-Halle disease, Bowen's disease and squamous cell carcinoma. Third one is microabscess. Now these are again very important. Already questions have been asked. Microabscess, micro means small, abscess is collection of cells. So small collections of cells can be seen. If these cells are neutrophils, you can call them neutrophilic microabscess. Examples: papillary tip microabscess, which is seen in dermatitis herpetiformis. Another example, Monroe's microabscess, seen in psoriasis, and Kogo's pustules, they are also known as spongiform pustules of Kogo's. They are also seen in psoriasis. Now they are very important, and already questions have been asked. Kogo's pustules seen in psoriasis, Monroe's microabscess seen in psoriasis, papillary tip microabscess seen in dermatitis herpetiformis. Now if they are not neutrophils, instead if they are lymphocytes, so lymphocytic microabscess, this is example is Poutrious microabscess, which is seen in mycosis fungoides, which is cutaneous T-cell lymphoma. So this is a malignant condition, mycosis fungoides, cutaneous T-cell lymphoma, and here collections of lymphocytes are seen. This is known as Poutrious microabscess. Already question have been asked. And eosinophilic microabscess, example seen in condition that is pemphigus vegetans. Generally we read about pemphigus vulgaris or pemphigus foliaceus, but this is the rarest type of pemphigus known as pemphigus vegetans, where eosinophilic microabscess is seen. So in bracket you can write down rarest type. So this is the rarest type of pemphigus. Now the next histological finding is acantholysis. As I already told you that these keratinocytes which are present in epidermis, they are attached together via desmosomes. Now if these desmosomes become defective, what will happen? These keratinocytes will separate, and this separation is known as acantholysis. So what is acantholysis? It is separation of keratinocytes due to defect in desmosomes. Now once they separate, the cells which are formed are known as acanthocytes. They are also known as acantholytic cells. So acanthocytes or acantholytic cells are nothing. These are the keratinocytes which have separated from all the sides. Now if you want to see these cells, we generally prepare one smear, and that smear is known as zinc smear. So sometimes questions are asked on zinc smear that if on zinc smear acanthocytes are seen, then it is suggestive of which condition? The answer is pemphigus. And if multinucleated giant cells are seen on zinc smear, then it is suggestive of viral infection like herpes or chickenpox. So both these are important: acanthocytes, pemphigus; multinucleated giant cells, herpes. Now there are so many conditions where you might find acantholysis, that is the separation of keratinocytes, like just now I told you in pemphigus. So pemphigus vulgaris. Similarly in pemphigus foliaceus, in paraneoplastic pemphigus, then in conditions like Darier's disease, Hele disease. You can also remember the reason why the separation is occurring. As I told you, in pemphigus, what is defective? Desmoglin. To be more specific, here desmoglin 3 is involved. In foliaceous, mainly desmoglin 1 is involved. In paraneoplastic, plaquin family is involved, like desmoplaquin, placoglobin. Then in Darier's disease and Hele disease, there is defect in calcium ATPase. So due to defect in calcium ATPase, this separation occurs. So these were various points related to the cells of epidermis and the layers of epidermis and the normal and the abnormal histological findings which can be seen in epidermis. Okay. Next we'll be discussing about basement membrane zone or dermoepidermal junction. Now this junction which is present in between epidermis and dermis, it has various proteins and various layers like keratin 5 and keratin 14 filaments, which is present in the lowermost layer, that is stratum basal. This is attached to hemidesmosomes. So this is hemidesmosomal proteins like plectin, integrin. On the other side, BPAG1 and BPAG2. So all these four, that is plectin, integrin, BPAG1 and BPAG2, all these are what? These are hemidesmosomal proteins. This via laminin protein is attached to underlying layer, that is lamina densa, which have collagen 4. Now this lamina densa is attached to underlying dermis via collagen 7. Now this layer where collagen 7 is present, this is present below lamina densa, so this is known as sublamina densa. And above lamina densa, the layer which is present where laminin is present is known as lamina lucida, also known as salt split layer. So you can see this is dermoepidermal junction, where you will find keratin 5 and 14 attached to hemidesmosomal proteins like pelectin, integrin, BPAG1, BPAG2, which is attached via laminin to underlying lamina densa. Lamina densa have collagen 4, and below lamina densa is collagen 7, which is attaching it to underlying dermis. Okay, so these are various layers and these are various proteins. Now all these proteins are present where? They are present below epidermis. Okay, so if there is defect in any of these proteins, it will lead to certain disorders. Okay, and these disorders will be where? Below epidermis, that is subepidermal disorders. So defect in these proteins can lead to subepidermal disorders. Before discussing those subepidermal disorders, let us note down few more points. So remember that sometimes they ask you that which is the weakest layer of dermoepidermal junction. The answer is lamina lucida, and because it splits from here, that's why it is known as salt split layer. So remember, the weakest layer is lamina lucida, that is salt split layer. Now there are few names of these proteins like BPAG1 and BPAG2. BPAG1 is also known as BP230. BPAG2 is also known as BP180, also known as collagen 17. Then laminin is also known as anchoring filaments, while collagen 7 is also known as anchoring fibrils. Like I told you that these proteins may lead to subepidermal disorders. These are few examples of those disorders like bullous pemphigoid. In bullous pemphigoid, the proteins which are involved are BPAG1 and BPAG2. If both are given in separate option, choose 2 because BPAG2 is commonly involved. Then linear IgA disease. Here the major protein which is involved is again BPAG2. Then epidermolysis bullosa dystrophicalis. Here collagen 7 is involved. So because these proteins like BPAG1, BPAG2, collagen 7 are present below epidermis, these are subepidermal disorders. Now below dermoepidermal junction is dermis. Now there are a few important points which you can remember about dermis, that most abundant fibers in dermis are collagen fibers. So most abundant fibers in dermis are collagen fibers, collagen type 1, type 3. Most abundant cells are fibroblast. So fibroblasts are the most abundant cells. Now this dermis can be divided into two. The upper portion of the dermis is known as papillary dermis, while the lower dermis is known as reticular dermis. If this is epidermis and this is dermis, you will find that there are few projections of epidermis which are coming down. These projections are known as rete ridges, and there are few projections of dermis which are going up. These projections are known as dermal papilla. So remember, the projections of epidermis which are coming down, these are known as rete ridges. The projections of dermis which are going up, these are known as dermal papilla. So I told you Merkel cells are present in lowermost layer of epidermis, that is stratum basal. So once this question came, and stratum basal that they are present in, and stratum basal was not there in the option, okay, but rete ridges was there. So remember, Merkel cells are present in lowermost layer of epidermis. If stratum basal or lowermost layer of epidermis is not mentioned, you can choose rete ridges as well. Similarly, in dermal papilla, that is the upper projections of the dermis, Meissner's corpuscles are present. So this question also once came, Meissner's corpuscles, they are present in where? Upper portion of the dermis, that is the dermal papilla. Now below dermis is subcutaneous layer. Subcutaneous layer is also known as hypodermis or panniculus. It have two components, mainly fat lobules. So there is a lot of fat. This is the cushion layer, shock absorber layer, and this is separated via septa. Lobules and septa. So sometimes there is inflammation in the subcutaneous layer, and that inflammation of subcutaneous layer is known as panniculitis, because this is panniculus. So what is panniculitis? It is inflammation of subcutaneous layer. You can remember a few points here. Panniculitis, that is inflammation of subcutaneous layer, can be septal panniculitis or lobular panniculitis. The example of septal panniculitis is erythema nodosum, while example of lobular panniculitis is erythema induratum. Erythema nodosum presents with erythematous nodules over anterior part of the leg, so shin area. Erythema induratum presents with erythematous nodules over posterior part of the leg, that is calves, so posterior leg. So sites are different. These generally do not ulcerate, while these may ulcerate. So these are few differentiating features between erythema nodosum and erythema induratum. Both are examples of panniculitis, that is inflammation of subcutaneous layer. Now sometimes the examples of or the causes of erythema nodosum are asked, so you can write down. So what causes erythema nodosum? There are so many causes, and you can very easily remember these causes or etiology of erythema nodosum by this simple mnemonic, that is nodosum. So first cause, which is the most common cause, is no cause, that is idiopathic. Then it can be due to drugs like oral contraceptive pills. It can be due to streptococcal infection, also associated with sarcoidosis, ulcerative colitis, maternity, that is they might develop during pregnancy, and also associated with mycobacterial infection like tuberculosis. So these are various causes which you can very easily remember. Like you can see here, that patient started developing these erythematous painful nodules over anterior part of the leg, that is the shin area, and none of them have ulcerated. So this is what? This is erythema nodosum, that is septal panniculitis. Now after discussing these various layers of skin, let us discuss about appendages of skin. Here we will be discussing mainly about three things, that is hair follicles, nails, and glands. Let us first begin with hair follicles. Now the important questions which are asked in hair follicles are that what is the reservoir of stem cells, or stem cells are present in which portion of the hair follicle? The answer is Adamson's fringe. This is also referred as bulge area. So this is the site where stem cells are seen. So stem cells are seen in bulge area or Adamson's fringe. Whenever these hair follicles grow, they passes through few phases, and these phases together is known as hair cycle. So hair cycle have three phases: anagen, catagen, and telogen. So anagen is followed by catagen, catagen is followed by telogen. This phase lasts for 3 years. So this is the longest phase. Then there is a small transition phase of 3 weeks, and telogen phase lasts for 3 months. So sometimes these durations might be asked, like once duration of telogen phase was asked. So you can very easily remember these points: anagen followed by catagen followed by telogen. So this is following alphabetical order A, C, T. Telogen is for 3 months, catagen is for 3 weeks, and anagen is for 3 years. So to your surprise, you will find that this also follows alphabetical order. 3 is common. So A, C, T, M, W, Y. Okay. Now patient may present with various hair disorders like anagen effluvium. This is generally seen after chemotherapy. So all of you might have seen patients who have undergone chemotherapy and they go bald. So that is known as anagen effluvium, that is diffuse hair loss after chemotherapy. Then another one is telogen effluvium. This condition is generally seen 3 months after. And why 3 months? Because just now I told you telogen phase lasts for 3 months. So this is seen 3 months after pregnancy, typhoid fever, or any other chronic illness. So after pregnancy, typhoid fever, or chronic illness, specifically after this period, that is 3 months, patient experiences excessive hair loss. Okay, so that is known as telogen effluvium. So whenever question comes on telogen effluvium, there will always be a clue, that is this has occurred after 3 months of so and so condition. And third is androgenic alopecia. Very obvious from the name itself, androgenic. So this is under the effect of androgen. Which androgen? Dihydrotestosterone, which is a potent form of testosterone. So dihydrotestosterone is the culprit, and due to this androgen, what happens? Patient experiences patterned hair loss. So hair loss occurs which follows a pattern. Now there are two specific patterns. One is known as male pattern, other one is known as female pattern. So let us consider this is a male patient suffering from androgenetic alopecia. In females, two patterns are seen. So let us consider these are the females suffering from female pattern androgenetic alopecia. Okay, these are given names also, like male pattern is also known as Hamilton pattern. Female patterns are known as Ludwig pattern and Olsen pattern. One important differentiating feature between male pattern and female pattern is frontal hairline, because frontal hairline recedes in males while it is maintained in females. So if this is the frontal hairline, it will be maintained in females while it recedes in males. So receding frontal hairline along with hair loss from vertex portion, this is Hamilton pattern or male pattern. While in females, the frontal hairline is maintained and hair loss occurs from this area, that is the frontal area and the vertex area. And another pattern, that is Olsen pattern, where the frontal hairline is maintained but hair loss occurs from the site where the females part their hair. So that is the site of hair loss. So these are three different patterns. Like you can see here in this image, what is happening? The frontal hairline is gradually receding backwards. It is gradually receding backwards, leading to this type of hair loss. While in females, what is happening? The line of separation of hair follicles, the central parting line, gets broad. Okay, so the hair loss occurs from this area. So this is Hamilton pattern, this is Ludwig pattern. Like you can see here, patient suffering from male pattern hair loss. Here the female pattern hair loss. Now according to US FDA, there are agents which are approved like topically minoxidil and systemic finasteride. Finasteride is 5-alpha reductase inhibitor, because this is the enzyme which is required for conversion of testosterone to dihydrotestosterone. So 5-alpha reductase inhibitor, and this finasteride specifically inhibits type 2 5-alpha reductase. Next is alopecia areata. Now alopecia areata is an autoimmune condition, and clinically these patients present with patchy hair loss. Patchy hair loss. Okay, so let us consider this is the patient. You will find a patch of complete hair loss. Now there are two very important points to remember here. One is exclamation mark sign, and other one is turning gray phenomena. Already questions have been asked. So as I told you, these patients present with a patch of complete hair loss. Okay, so in the patch all the hair follicles are gone. So if you examine the surrounding area, you will find few broken hair follicles here, and if you examine them under microscope, you will find that they appear something like this. That is, they are broken, their distal end is broad, their proximal part is thin, and this is the root or the bulb of the hair follicle. Okay, so because they appear something like this, they resemble what? They resemble exclamation mark. Distal portion broad, proximal part thin, and this is the bulb or the dot. Okay, so that's why these are known as exclamation mark hair. So remember, exclamation mark hair or sign is seen in alopecia areata. Now in this condition there is sparing of gray hair. This is known as turning gray phenomena. So these are 2 points to remember here. Like you can see here, this is a patient suffering from alopecia areata. So alopecia areata, there can be a single patch or multiple patches of complete hair loss. Now in the central portion you can see all the hair follicles are gone. So if you examine the periphery, you will find that there are few broken hair follicles. If you plug them, they appear something like this. That is, the distal end is broken and appearing broad, and the lowermost portion is appearing like a dot. So that's why it is known as exclamation mark sign. Now remember that these patients may present with nail changes also. Okay, so if you examine the nails of these patients, you will find pitting, and this pitting is very superficial and regular. So regular and superficial pitting is feature of alopecia areata. If you do histology in these cases, if you take biopsy from these lesions, you will find perifollicular, that is around the hair follicles, perifollicular, especially around the bulb. So this is also known as peribulbal lymphocytic infiltrate. Now this perifollicular or peribulbal lymphocytic infiltrate gives one characteristic appearance. These all lymphocytes are around the bulb of the hair follicle, giving swarm of bees appearance. So group of bees or swarm of bees appearance is seen. Since this is autoimmune condition, so treatment is steroids. You can use topical, systemic, or intralesional. Within the lesion also you can give steroid injections. So steroids are the mainstay. Other modalities, like you can also use topical contact irritants like dinitrochlorobenzene and sometimes when the condition is generalized, you might use phototherapy. So here you can see the histology where you can see peribulbal or perifollicular lymphocytic infiltrate. So this is the cross section showing the hair follicle, and around the hair follicle you can see this lymphocytic infiltrate. So this is known as swarm of bees appearance, which is seen in alopecia areata. Now next we will be discussing about nails. If you see the structure of nail, you will find that nails appear something like this. This portion, visible portion, this is nail plate. This hemicircular white area which is present in the proximal part of the nail, this is lunula. This is proximal nail fold, and on either side are lateral nail folds. If you cut the nail and see the transverse section, this visible portion is nail plate, and below this is nail bed, and behind it is nail matrix. Now these two junctions, that is the distal junction and the proximal junction where the nail is attaching to the skin, this distal junction is known as hyponychia, and this is known as aponychia. So these are few important points which you can remember about these nails. Like hyponychia is the most common site for onychomycosis. So whenever fungal infection of nails occurs, the most common site is the distal sites, and that's why the distal type of onychomycosis, that is also known as distal lateral subungual onychomycosis, is the most common type, because this is the most common site. Then this lunula is nothing, this is visible nail matrix. So as you can see, this is nail matrix, but you can see that there is a small portion of nail matrix which is going below the nail plate. So this portion give rise to this lunula. So this is nothing, this is that visible portion of the nail matrix. Now there are various nail changes which are important, like pitting. I already told you that pitting is seen in alopecia areata, and it is also seen in psoriasis. But the pitting of psoriasis is slightly different. The alopecia areata have superficial and regular pitting, but psoriasis have deep, irregular pitting. In fact, in psoriasis, pitting is the most common nail change. So most common nail change of psoriasis is pitting. But sometimes they ask you that which is the most characteristic nail change of psoriasis, that is oil drop sign, also known as salmon patch. This occurs due to defect in nail bed. Another important conditions where various nail changes are seen is lichen planus. Here the most characteristic nail change is pterygium. So pterygium is the most characteristic nail change seen in lichen planus, pterygium. So if this is the nail of the patient and this is the proximal nail fold, you will find a wing-shaped projection of proximal nail fold. This wing-shaped projection is known as pterygium. Leukonychia. Onycholysis. Onycholysis is separation of nail plate from the nail bed. Subungual hyperkeratosis and nail tunneling. Subungual hyperkeratosis is thickening of the nail bed. Okay, so due to thickening of the nail bed, the nail plate is pushed upwards, due to which the nail plate appears like a tunnel, so nail tunneling. So these features, so all these four features, that is leukonychia, whitening of the nail plate, onycholysis, separation of the nail plate from the nail bed, subungual hyperkeratosis, that is thickening of the nail bed, and due to thickening of the nail bed, the nail appears like a tunnel. All these can be seen in psoriasis as well as onychomycosis. Sometimes questions are asked on apparent leukonychia. So these are the examples of apparent leukonychia, like tarry nails, half and half nails, banded nails. Tarry nails is feature of hepatic failure, also seen in congestive heart failure. Half and half nail, chronic renal failure. Banded nails, patients undergoing chemotherapy, and also in patients suffering from deficiency of albumin, that is hypoalbuminemia. Already these questions have been asked, so remember them. Tarry nails, half and half nails, and banded nails. Let us see a few images here. I told you pitting can be seen in alopecia areata as well as psoriasis. So alopecia areata, psoriasis, as well as it can be seen in eczema. And here you will find these small depressions over the nail plate. So these are pits. Now there is one condition, paronychia, and this is due to infection of the nail fold. So I told you, if this is the nail, this is proximal nail fold, and here on the either side these are lateral nail folds. So if there is infection in the nail fold, like you can see here, swollen and inflamed nail fold, so this is known as paronychia. This can be of two types, acute or chronic. So acute and chronic paronychia. Acute paronychia is due to bacterial infection, and chronic is due to mixed infection of both bacterial as well as fungal. Then onycholysis, I told you, this is separation of the nail plate from the underlying nail bed, which can be seen in psoriasis as well as onychomycosis. But remember that psoriasis is generalized condition, so most of the nails are involved, but if it is only localized to one nail, like you can see here, it could be due to onychomycosis. Then subungual hyperkeratosis. Sub means below, ungual means nail plate. So below nail plate is nail bed. Hyper means excessive, keratosis means keratinization. So due to excessive keratinization, that is thickening occurs, and this thickening is occurring where? In the nail bed. So due to which what happens, the nail plate is lifted upwards and it gives rise to tunneling of the nail. Like you can see in this nail, slight tunneling is present. Okay, so this is seen in psoriasis as well as it can be seen in onychomycosis. So next we will be discussing about glands. Two important glands we need to discuss here, sweat glands and sebaceous glands. Let us first discuss sweat glands. They can be eccrine and apocrine. There are few differentiating features, like if you look at the duct, you will find that the duct of eccrine sweat gland opens directly over the skin surface, while this opens along with hair follicles. If you look at the site, you will find that eccrine sweat glands are the most common sweat glands, so they are present almost everywhere over the skin, while apocrine sweat glands, they are present mainly over axilla, areola and groin. If you see the nerve innervations, you will find that this is under cholinergic control, this is under adrenergic control. These points can very easily be remembered because you can see here apocrine starts with A, so everything here starts with A, while eccrine, C is repeated twice, this is under cholinergic control. So very simple to remember. Sometimes they ask you about disorders. So disorders of ecrine and apocrine. Anhidrosis, hyperhidrosis, and malaria are disorder of ecrine sweat glands, while bromhidrosis, chromhidrosis, and Fox-Fordyce disease are disorder of apocrine sweat glands. These two are important. Repeatedly questions are asked on these two. So remember, both these, malaria as well as Fox-Fordyce disease, both these occurs due to blockage in duct. So if there is blockage in the duct of ecrine sweat gland, malaria will occur. If there is blockage in the duct of apocrine sweat gland, Fox-Fordyce disease will occur. The most common type of malaria is malaria rubra. Here this blockage occurs at the level of Malpighian layer. Malpighian layer. And you might be wondering what is Malpighian layer. So remember that the lower epidermis, that is stratum spinosum along with the stratum basale, these two layers together is known as Malpighian layer. Okay. So here the blockage occurs. This is the most common type of malaria. While Fox-Fordyce disease is generally seen in females in their second decade, and they present with itchy papules. And the most common site where the apocrine glands are present is axilla. So this condition is also present over axilla. So you can see here these red inflamed itchy lesions present over trunk. These are the lesions of malaria rubra, because what happens, there is blockage in the duct due to which there is spillage of the sweat, and due to which the inflammation starts and they appear red in color, and that's why the name is rubra. So this is malaria rubra. While Fox-Fordyce disease, I told you, this is a disorder of apocrine sweat gland. Common site is axilla, and over axilla you will find these itchy papules. So itchy papules over axilla. This is generally seen in females in their second decade. There is one more disorder which can occur due to defect in apocrine sweat gland, and that is hidradenitis suppurativa. Here again the common site is axilla. Patient may present with nodules or swellings in axilla. Sometimes inguinal areas are also involved. And then later on there are interconnecting sinuses which can be formed, and later scarring can also occur. So these are various features which can be seen in this condition. So over axilla, if you find nodules, sinus or scarring, then you can suspect hidradenitis suppurativa. This is again a disorder of apocrine. Next we will be discussing about sebaceous glands. So sebaceous glands are generally present along with hair follicles, but sometimes they might be present alone as well. When they are present along with hair follicles, we call them pilosebaceous units. When they are present alone, we call them ectopic sebaceous glands. The disorders of pilosebaceous unit is acne vulgaris, also rosacea. While ectopic sebaceous glands can be present over various sites, like for example over lips, we call them Fordyce spots. So many students get confused between Fox-Fordyce and Fordyce. So remember, Fox-Fordyce is disorder of apocrine sweat glands, while Fordyce spots are ectopic sebaceous glands present over lips. Then over glands, Tyson glands, over areola, Montgomery tubercles, in eyelid, Meibomian glands, gland of Zeiss, there is one more gland which is present in eyelid, that is gland of mole. And there is one gland which is present in external auditory canal, that is ceruminous gland, and breast. All these are modified apocrine sweat gland. So sometimes questions are asked that phosphodized disease are, so remember, ectopic sebaceous gland. Similarly, Meibomian and Z's are sebaceous, but gland of mole is apocrine. So let us discuss acne vulgaris in a bit detail. Acne vulgaris is a very common condition, and the most characteristic lesion of acne vulgaris are comedones. So comedones are the most characteristic lesions of acne vulgaris. Now there are different grades of acne. The most severe form of acne vulgaris is grade 4 acne, while the most severe type of acne overall is acne conglobata. So remember, overall most severe is acne conglobata, but among acne vulgaris the most severe is grade 4. Now this grade 4 is also known as nodulocystic acne. This is the severe type of acne vulgaris, nodulocystic acne, because here nodules and cysts are formed. And the drug of choice for this severe variant of acne vulgaris is isotretinoin. Isotretinoin. Now why this iso term is added to tretinoin? Because this is isomer, 13 cis isomer. So 13 cis retinoic acid is another name of isotretinoin. Okay, so isotretinoin, which is the drug of choice for grade 4 or severe or nodulocystic acne, is also known as 13 cis retinoic acid. This is given in oral form, so oral isotretinoin is the drug of choice. Now sometimes questions are asked on the side effects of isotretinoin, because these are very common and sometimes can be very severe. The most common side effect is dryness of lips. The most severe side effect of isotretinoin is DISH, that is diffuse interstitial skeletal hyperosteosis. There are a few other side effects as well, like pseudotumor cerebri, which is benign raised intracranial tension. So benign raised intracranial tension. Then it is teratogenic. So it should be avoided during pregnancy, as well as patient should not conceive for 1 month after stopping isotretinoin, because the teratogenic effect of isotretinoin can persist for 1 month. Okay, so patient should not conceive for 1 month after stopping isotretinoin. There is one more retinoid, that is acitretin, and this is drug of choice for pustular psoriasis. And this is also teratogenic, so should not be used during pregnancy, as well as for 3 years after stopping isotretinoin, patient should not conceive. Okay, so this period is very long in cases of acitretin. So remember, isotretinoin 1 month, acitretin 3 years, both are teratogenic. Then another condition is rosacea. There are a few important points which you can very easily remember in rosacea, and if you remember these points, you can very easily answer these questions correctly. First of all, the site involved. So remember, the site which is characteristically involved in rosacea is convex areas of the face. So convexities of face or convex areas of face are involved. Then there is one association, that is flushing. So whenever these patients of rosacea will come to you, they will give one characteristic history that whenever I consume hot tea, hot coffee, these lesions become red. That is known as flushing. And clinically, the most common type is known as erythrotelangiectatic, which is very obvious from the name itself, erythrotelangiectatic. That is, erythmo means red and telangiectasia. So lesions are red, that is erythematous. with telangiectasia. Telangiectasia is superficial dilated blood vessels. Okay, so if you find these things in a patient, then suspect rosacea. Okay, so rosacea presents with red lesions with superficial dilated blood vessels over convex areas like cheek, nose, chin of the face, and patient gives history that whenever she consumes hot tea, coffee, then these lesions aggravate or become more red. Okay, so this is a classical case of rosacea. Like you can see here, I told you ectopic sebaceous glands present over lips. These are Fordyce spots. So you can see these are Fordyce spots. Nodulocystic acne is the severe form of acne vulgaris, and here nodules and cysts are seen. So nodules, large lesions more than 0.5 centimeter in size, nodules, and they might form cysts. So such nodulocystic acne is the severe type of acne where the drug of choice is oral isotretinoin. Rosacea, I told you, present with erythematous lesions, and these erythematous lesions are generally present where? Over convex areas of the face like cheek, nose, chin, like you can see here in this patient. Now, whenever such image comes to you, some students get confused with SLE, because in SLE, red lesions are seen over cheek and nose, okay, and those are known as butterfly rashes. So, butterfly rashes are seen in SLE, and sometimes we get confused with rosacea. So, how to differentiate butterfly rashes of SLE with rosacea? So, remember that butterfly rashes have fixed erythema and nasolabial fold are spared. So here you can see in nasolabial fold also lesions are present, but in SLE nasolabial folds are spared. Already question have been asked, so they are spared in SLE. Then you will find other associated features of SLE, like there might be history of fever, arthralgia, photosensitivity. So here there is history of flushing, that is whenever patient consumes hot beverages, the lesions aggravate. Here whenever patient go outside in the sun, the lesions aggravate, and other than that you might find nasolabial fold sparing, then other features of SLE might be associated. So with the help of these points you can very easily differentiate butterfly rashes from rosacea. Next we will be discussing blistering disorders. Now all of you know that blisters are fluid filled lesions, and if this fluid filled lesions are very small, that is less than 0.5 centimeter in size, we call them vesicles, and if they are large, that is more than 0.5 centimeter in size, we call them bulla. So under this heading we are going to discuss all those skin conditions which can present with such fluid filled lesions, that is vesicles or bulla. One such condition is pemphigus. Now in pemphigus what happens, that IgG antibodies are formed against desmoglin, which is a desmosomal protein, and once this desmoglin is involved, what happens, the keratinocytes start separating and intraepidermal blister is formed, leading to intraepidermal blister. So this is an autoimmune condition. Here IgG antibodies are formed and they are targeting what? Desmoglin, that is a desmosomal protein, leading to intraepidermal lesions or intraepidermal fluid filled blisters. Now there are two important types of pemphigus which you need to remember. One is pemphigus foliaceus and other one is pemphigus vulgaris. Now these are few important points which you can remember about these two conditions. Pemphigus vulgaris is the most common type of pemphigus. Okay, now why this is most common? Because this term vulgaris itself means most common. Okay, so wherever you find this term vulgaris, you can very easily remember that this is the most common type of that disease. Like pemphigus vulgaris is most common type of pemphigus, psoriasis vulgaris is most common type of psoriasis, verruca vulgaris is most common type of viral wart, lupus vulgaris is most common type of cutaneous tuberculosis, ichthyosis vulgaris is most common type of ichthyosis. So vulgaris itself means most common. So we know that pemphigus vulgaris is the most common type of pemphigus. Still, we have written foliaceus first and later vulgaris. Can you tell me why? Because F comes first. So we have written it alphabetically. Why? So that you can very easily remember the defects, because here the defect is in desmoglein 1 and here the desmoglein 3 is involved. So simple to remember. F comes first desmoglein, V comes later, third desmoglein. But remember one more point, along with desmoglein 3, desmoglein 1 can also get involved. Okay, so main desmoglein is desmoglein 3, but here desmoglein 1 can also get involved. Now, once the desmoglein is involved, the separation starts, and this separation occurs at the level of stratum granulosum here, and here the separation is at the level of stratum spinosum. Again, very simple to remember, because G comes first, here S comes later. Then due to this separation, the lesions are formed, the blisters are formed, and these blisters are superficial in cases of foliaceous while they are deep in cases of vulgaris. Why? Because superficial layer is involved, so blister is also superficial. Now, which one will easily rupture? Obviously, superficial easily rupture, this do not easily rupture. Okay, so you can very easily remember these differentiating feature by just simple mnemonic, that is F come first. So F come first, so first desmoglein, superficial layer, superficial blister, and because they are superficial, they easily rupture. While V comes later, so third desmoglein, deeper layer, since the lesions are deep, they do not easily rupture. So whole pemphigus, foliaceous and vulgaris in one sentence. Now one more important point to remember, desmoglein 1 is mainly present in skin, while desmoglein 3 is mainly present in buccal mucosa. So desmoglein 1 is mainly present in skin, while desmoglein 3 is mainly present in buccal mucosa. So sometimes they ask you that buccal mucosal involvement is present in, so it is present in vulgaris, because 3 is not involved in foliaceous, while skin can be involved in both. So foliaceous buccal mucosal involvement absent, vulgaris presents with buccal mucosal involvement, and later on skin can also get involved. Now skin involvement is in the form of blisters, as I told you, superficial blisters here, deep blisters here. Now sometimes instead of writing superficial and deep, they write subcorneal and suprabasal. So this is again very simple to remember. Here the layer involved in vulgaris is stratum spinosum, and spinosum is above stratum basal, so this is suprabasal. While here it is granulosum, so granulosum is subcorneal. So it is so simple to remember all these features. You just remember one simple mnemonic, that is F comes first. Now other than these points, you can also remember few clinical features like the site involved. As I already told you, in pemphigus vulgaris, the most common site is buccal mucosa. Other than buccal mucosa, trunk, scalp, extremities, etc. can also be involved. While in pemphigus foliaceous, seborrheic areas are involved. Seborrheic areas. What are seborrheic areas? The seborrheic sites like scalp, retroauricular area, nasolabial fold, then forehead, nose, then pre-sternal, interscapular areas, so upper trunk area, these are the common sites, but buccal mucosa is spared. There is one important sign which you need to remember here, Nikolsky sign. And Buller spread sign, also known as Asbo-Henson sign. Let us consider these are the fluid-filled lesions of pemphigus vulgaris and foliaceous. So these can be seen positive in both vulgaris and foliaceous. So these are the features of pemphigus. Okay. Now what happens if you apply tangential pressure over this skin adjacent to the blister, you will find overlying epidermis separates. If you apply perpendicular pressure, you will find this bulla spread circumferentially. This is bulla spread sign. And when you apply tangential pressure, the overlying epidermis separates. This is Nikolsky sign. So these are two important signs which are seen positive in pemphigus. They can be seen positive in both, but if both are given in separate option, choose the most common type, that is vulgaris. If you do histology, you will find acanthocytes and a row of tombstones appearance. This is also important, already questions have been asked. Row of tombstones appearance is feature of pemphigus. If you do direct immunofluorescence, a characteristic pattern is seen known as fish net like. And this fish net like pattern is seen due to deposition of intercellular deposition of IgG antibodies. So we know that IgG antibodies are being formed in pemphigus and they deposit in between the keratinocytes where the desmosomes are present or desmoglein is present. So that's why this gives appearance like a fish net. Treatment. Since this is an autoimmune condition, so mainstay of therapy is steroids. Other than steroids, you can use cyclophosphamide. Then biological drugs like rituximab, which is anti-CD20. So these are various agents which can be used in this condition. Next blistering condition is bullous pemphigoid. Bullous pemphigoid. Now bullous pemphigoid is again autoimmune condition. Here also IgG antibodies are formed, but they target BPAG2 more than BPAG1. Clinically, these patients present with tense bulla. See, the bulla of pemphigus, they are flaccid, but here they are tense. So tense bulla. Sometimes what happens that because they are tense, they do not easily rupture. So the fluid get reabsorbed and this overlying epidermis settles down. So they might present with settled bulla. If you do histology, you will find subepidermal split because this is subepidermal disorder. So subepidermal split with eosinophilic collection. On DIF, linear pattern is seen, linear IgG and complement deposits along basement membrane zone. Why basement membrane zone? Because the protein involved is BPAG2 and 1 which are present where? In basement membrane zone. So this pattern is also seen where? In basement membrane zone. There is a very simple mnemonic to remember the differences between pemphigus and pemphigoid, and that is MINAR. So mucosal involvement, intraepidermal blister, Nikolsky sign, acanthocytes, and row of tombstones appearance. All these are seen in pemphigus, they are absent in pemphigoid. So this is a very simple mnemonic to remember, MINAR. So MINAR is seen in pemphigus, it is not seen in pemphigoid. Okay. Like you can see here in this image, I told you in pemphigus vulgaris, mucosal involvement is seen. So you can see these mucosal erosions. Then these patients present with flaccid lesions because these lesions are intraepidermal. So they are a very thin layer of epidermis is covering it. So this is very thin flaccid fluid-filled lesions might be present, and sometimes they might rupture, and when they rupture they form crust like you can see here. So they might present with erosion with crusting also. Pemphigus foliaceus, I told you, generally seborrheic areas are involved. So here you can see upper trunk involvement. Then if you do histology, you will find a row of tombstones appearance which appears something like this. You can see like a row of tombstones, and this is stratum basal. So this is the basal layer and the fluid is present above it. So this is a suprabasal bulla. So suprabasal lesions are seen in vulgaris. On DIF, you will find this net-like pattern. Why a net-like pattern? These are keratinocytes. The fluorescence is seen over its surface like a net. This is bullous pemphigoid where tense lesions are seen, and sometimes these tense lesions, what happens? They settle down. So you might find settled bulla or tense lesions. And on immunofluorescence, you can very easily differentiate pemphigus from pemphigoid because in pemphigus, net-like pattern is seen. So you can see fish net-like pattern, while in pemphigoid, linear pattern is seen. This is within epidermis. This is in basement membrane zone. Third blistering condition is linear IgA disease. Here again, antibodies are formed. These are IgA antibodies and they also target mainly BPAG2. This condition have bimodal presentation, that is, it can occur in children as well as adults. In children, generally less than 5 years, and the site involved are generally face and groin area, while here around 60 years, site involved are generally trunk and extremities. Now over these sites in these age groups, what you will get? You will get blisters which are grouped together. So grouped blisters around erythematous plaque. So let us consider this is that erythematous plaque, and around this you will get these fluid filled lesions. So because they are present around this erythematous plaque, it gives a characteristic appearance, a string of pearl, a string of bead, also known as cluster of jewel appearance. So this is the characteristic appearance. Already question have been asked. This is seen in linear IgA disease. As the name itself is suggestive, here also you will get linear pattern, but this is not due to IgG, it is due to linear IgA deposits in basement membrane zone, and the drug of choice for this condition is dapsone. Next is dermatitis herpetiformis. Dermatitis herpetiformis is seen associated with celiac disease, then there are HLA associations like HLA-B8, DQ2, DR3, then antibodies which are associated like anti-endomysial antibodies, anti-transglutaminase 3 antibodies. So these are common associations. How they clinically present? Clinically they present with extremely pruritic, that is very itchy lesions, extremely pruritic, vesicopapules. So some papules and some fluid filled lesions might be seen, and because this is very itchy condition, patient scratch them. So later on they might form erosions over extensors. So common sites are extensors like back, elbow, knee, buttock. So these are the common sites. So if you find vesicopapules or erosions which are extremely pruritic over extensors, then suspect dermatitis herpetiformis. There is one very important feature on histology which I already told you, and that is papillary tip microabscess is seen. Papillary tip microabscess. On DIF, here granular deposits are seen. Granular IgA deposits in dermal papilla. So this is very important. Already question have been asked. Granular deposits. So granular IgA deposits in dermal papilla are a feature of dermatitis herpetiformis. A drug of choice for this condition is dapsone. But as I told you, it is associated with celiac disease, that is gluten sensitive enteropathy. So that's why the treatment of choice is gluten free diet. Gluten free diet, and we all know that gluten is present in barley, rye, oat and wheat. So that's why ask the patient to avoid these things. So what is gluten free diet? Ask the patient to avoid barley, rye, oat and wheat, that is avoid gluten. Next is herpes gestationis. Now this term is misnomer here because this is not a viral condition, this is again an autoimmune condition. Clinically, it involves females in their third trimester of pregnancy. The lesions are peri-umbilical, that is around umbilicus. This is a self-limiting condition, but fetal mortality can be high. If you do DIF in these cases, you will find linear complement more than IgG deposits in basement membrane zone. The drug of choice for this condition is steroids because steroids are safe in pregnancy, so steroids is the drug of choice. So like I told you, a string of pearl appearance is feature of linear IgA disease where these grouped fluid-filled lesions might be seen around this erythematous plaque. Like you can see in this child also, the fluid-filled lesions are present at the periphery. Remember one point that I told you, there are two age groups where linear IgA disease can involve. So the childhood variant of linear IgA disease is also known as chronic bullous disease of childhood, that is CBDC. So this is nothing, this is childhood variant of linear IgA disease. Then dermatitis herpetiformis, I told you, they generally present with papules or vesicles. So these small fluid-filled lesions or papular lesions might be present. Generally, they are present over extensors like back of the patient, elbow of the patient, knee, buttock, and because they are very itchy, patient keep them excoriating them. So that's why these excoriations or these erosions might be present. Then herpes gestationalis, which is also known as pemphigoid gestationalis, this generally presents with lesions around umbilicus. So lesions are again fluid-filled lesions and they are present around umbilicus. Next is epidermolysis bullosa. Now this condition, epidermolysis bullosa, it can be of two types, congenita and acquisita. Now one important point to remember here is that epidermolysis bullosa is also known as mechanobullous disorder. Why it is known as mechanobullous disorder? Because this bullous, that is bulla, the fluid-filled lesions, they develop at the site of mechanical trauma. So these lesions, they generally occur over which sites? At the site of trauma or friction or pressure handling. So wherever pressure occurs, friction occurs or trauma occurs, there only these lesions will appear. Now there are two variants, congenita and acquisita. These are few important points about them. Congenita, as the name itself is suggestive, this is congenital. So this have early onset and this is common variant, while this is acquired variant. So it has late onset and this is rare. Now this is congenital, so this is a genetic condition, while this is acquired, this is immunobullous condition. Now in this genetic condition, that is congenital variant, there are few genetic defects, okay, and depending on the genetic defect, it is further divided into few subtypes like epidermolysis bullosa simplex, where this genetic defect is seen in keratin 5 and 14. Epidermolysis bullosa junctional, where laminin is defective. Epidermolysis bullosa dystrophicains, where collagen 7 is defective. So already questions have been asked, so remember these defects are very important. So these three subtypes of congenita variant of epidermolysis bullosa occur due to defect in these proteins like keratin 5 and 14 in simplex, laminin in junctional and collagen 7 in dystrophicains. Next is diarrhea disease. and Halle-Halle disease. Now you might be wondering that why we are discussing these two conditions together, because in both these conditions few things are common, like both are autosomal dominant. In both, calcium ATPase is defective. In both, calcium ATPase is defective, but the gene involved are different. Like here the gene involved is ATP2A2 gene, while here ATP2C1 gene is involved. Now clinically, the site involved here is seborrheic areas, while here intertriginous areas are involved. Intertriginous areas. What are intertriginous areas? These are folds like axilla, groin, inframammary folds. So folds are involved. Now what you will find over these sites? So over seborrheic areas, here you will find rough lesions, that is verrucous, that is warty, and because they are warty, they give sandpaper feel. And they are present over seborrheic areas, so they can be greasy. So you will find verrucous, greasy with sandpaper like feel lesions over seborrheic areas, while here you will find a recurrent flaccid vesicles. And because these fluid filled lesions are flaccid and they are present where? Over folds, and over folds friction occurs, so that's why they might rupture, so erosions. So if you find recurrent erosions and vesicles over intertriginous areas, then suspect Halle-Halle disease. If you do histology, you will find acantholysis and disc keratosis, which can be seen in both. But there are few histological findings which are very characteristic, like in Terrier's disease, corpse ronds and corpse grains are seen, while in Halle-Halle disease, dilapidated brick wall appearance is seen. So these are the histological findings which are specific to these two conditions. So remember, corpse grains and corpse ronds, they are seen in Terrier's disease, while dilapidated brick wall appearance, it is seen in Halle-Halle disease. Next is erythema multiforme and epidermal necrosis. These are few differentiating features between these two conditions. Erythema multiforme generally occurs due to viral infection, but if that is not there, choose drugs, while this mainly occurs due to drugs. Clinically, this presents with target lesions. These are very important. Already so many times question have been asked. Target lesions are seen in erythema multiforme. They are also known as iris lesions or bull's eye lesions. Now why they are known as target lesions? Because if you look at these lesions, you will find three concentric rings where there is central dusky erythema surrounded by edema, further surrounded by erythematous halo. So dusky erythema surrounded by edematous rings surrounded by erythematous halo. So there is erythema in the center, then there is edema, and then again there is erythema at the periphery. So it looks like a bull's eye. Okay. While here the lesions have two rings and not three rings, so that's why they appear like targets. So that's why we call them targetoid lesions. So targetoid lesions might be seen. Here there is epidermal necrosis, due to which epidermal separation starts, and this epidermal separation can involve different percentage of body surface area. So if the body surface area involved is less than 10%, we call it Steven-Johnson syndrome. If it is more than 30%, then we call it 10. and if it is in between, we call it overlap. So under this, you need to remember Stevens-Johnson syndrome and TEN, which are very severe conditions, and how to differentiate. So first point is you need to differentiate target and targetoid lesions. Then this is more severe, and then you can also look for mucosal involvement, because mucosal involvement is generally absent here while it is present here. Similarly, you can elicit Nikolsky sign, because Nikolsky sign is absent here and it is present here. So with the help of these 2 points, you can very easily differentiate. And Stevens-Johnson syndrome and TEN, that is toxic epidermal necrolysis, these are severe conditions where you might find lot of hemorrhagic crusting and lot of epidermal separation involving different body surface area. Like you can see here, this is the hemorrhagic crusting of Stevens-Johnson syndrome. Here you can see a lot of hemorrhagic crusting. The oozing out is oozing out of the mucosa is being seen here, while this is a patient of 10. As you can see, so severe epidermal necrosis has occurred. Lot of epidermal separation is taking place. Denuded skin is being seen, and it appears as if whole epidermis will separate. So this is known as sheet-like epidermal separation, which is seen in cases of 10. This is a medical emergency, and here the prognosis is very poor. Now next we'll be discussing infections. In infections, first one is bacterial infections. There is one bacteria, that is Corynebacterium. Now this bacteria releases keratolytic enzymes. Keratolytic enzymes. And these keratolytic enzymes, they digest keratin. They digest keratin. Now because they digest keratin, this digestion of keratin can occur at different sites, like over palm and sole, over axillary hair follicles, or over the skin of axilla. Now when this occurs over palm and sole, patient presents with multiple pits over palm and sole. Here yellowish discoloration of axillary hair follicles can occur, and here asymptomatic rashes might be seen. When it develops multiple pits over palm and sole, this condition is known as pitted keratolysis. While yellowish discoloration of axillary hair follicles, this is known as trichomycosis axillaris. While this, where the rash over axilla is seen, this is known as erythrasma. All these three conditions are important. All these three conditions are caused by same bacteria, that is Corynebacterium, but the presentation and sites are different. Among them, erythrasma is important. So remember, this is caused by mainly Corynebacterium minutissimum. And this rash, when examined under Wood's lamp light, it gives coral red colored fluorescence. Next is another bacterial infection, impetigo. Impetigo can be of two types, non-bullous and bullous. Non-bullous is also known as impetigo contagiosa. The causative agent for non-bullous type is strepto, but if strepto is not there, you can choose Staph aureus, while this is caused by Staph aureus. Clinically, both these conditions are seen in children, and the site which is involved is face. Here, in impetigo contagiosa, that is a non-bullous type, you will find erosions with crusting. Now this crusting is very characteristic, and this is known as golden yellow. So the color is golden yellow, honey colored crusting. So many times this question have been asked, golden yellow honey colored crusting is seen in. The answer is impetigo. While here fluid filled lesions might be seen. Third is ecthyma. Here generally causative agents are asked like ecthyma pyogenicum is caused by strepto as well as staph aureus. Ecthyma gangrenosum, it is caused by pseudomonas. And ecthyma contagiosum, it is caused by parapox virus. So remember, this is viral while these two are bacterial. Fourth is erysipelas and cellulitis. Generally causative agents are asked, so remember this is caused by group A beta hemolytic streptococcus, while this can be caused by both strepto as well as staph aureus. You can very easily differentiate these two by examining the borders, because borders here are sharp while here diffuse borders are seen. Here you can see this erythematous rash which is asymptomatic present over axilla. This is the common presentation of erythrasma. Under Wood's lamp light it appears coral red in color, and this is the characteristic crusting which is seen in impetigo contagiosa, that is golden yellow honey colored crusting commonly seen in children over their face. Next is fungal infections. The first fungal infection is pityriasis versicolor, which is very obvious from the name itself. Pityriasis means scaling, versi means different, and color all of you know. So here the scaling is very fine, rice powder like, and here different colors can be seen. Generally the lesions are hypopigmented, but sometimes they can be hyperpigmented also. This hypopigmentation is due to azelaic acid, which is secreted by the causative agent of this condition, which is Malassezia yeast. And this azelaic acid which is secreted by Malassezia yeast is a tyrosinase inhibitor, and because it is tyrosinase inhibitor, it inhibits melanin synthesis and the lesions can appear hypopigmented. Clinically, upper trunk is generally involved, and over upper trunk you will find these hypopigmented small macules. If you prepare 10% KOH mount, you will find spaghetti and meatball appearance. If you do Wood's lamp examination, you will find apple green fluorescence. This fungal condition is treated with antifungal agents like topically. You can use ketoconazole and selenium sulfide, and systemic agents like fluconazole. Another condition is tinea nigra. Tinea nigra is caused by Pheoanellomyces wernicke. Then third is candidiasis. All of you know candidiasis is caused by candida and they can present in different forms. The most common type is generally oral thrush, which is also known as acute pseudomembranous candidiasis. Pseudomembranous candidiasis. Why it is known as pseudomembranous? Because if you try to rub these lesions, this membrane can be detached. So this is pseudomembranous. While the membrane cannot be detached in cases of oral hairy leukoplakia. So that is the differentiating feature between the white lesions of buccal mucosa. If they can be detached, it could be candidiasis. If cannot be detached, that can be leukoplakia. Similarly, the white reticulate pattern can also be seen in lichen planus, and that also cannot be detached. Patient can also present with different other types of candidiasis like candidal balanoposthitis, that is candidal infection of glands and prepuce, then candidal intertrigo, that is candidal infection of intertriginous areas, that is folds like web spaces. When patient presents with candidal intertrigo, they might present with satellite lesions. Satellite lesions. Already question have been asked, satellite lesions. So remember, satellite lesions can be seen in various conditions like BT type of Hansen's disease, leprosy, sporotrichosis, and candidiasis. You can easily remember by BSC. So BSC, that is satellite lesions, can be seen in BT type of Hansen's disease, sporotrichosis, and candidiasis. Next is pedra, which is also known as trichomycosis nodularis. This can be of two types, dark or black pedra, white or light pedra. Black pedra is caused by Pedrae horti, while light pedra is caused by Trichosporon bijli. These agents can very easily be remembered because bijli in Hindi means electricity, and wherever there is bijli, there is light. So light is caused by bijli species, while horti is caused by black pedra because hot, we feel hot in black dress. Next is dermatophytosis. Dermatophytosis. As you all know, dermatophytosis is caused by dermatophytes, and these are three important dermatophytes: trichophyton, epidermophyton, microsporum. Now all these can involve skin, but hair follicles are not involved by epidermophyton and nails is not involved by microsporum. So these are two important points to remember, which you can very easily remember alphabetically. M do not involve N, E do not involve H, but tri means all three. So trichophyton can involve all three. Now these dermatophytes, they cause tinea, like tinea capitis, where there is a scalp involvement. Tinea capitis can be of four different types: carrion, favus, black dot, and grey patch. Among them, carrion and favus are important because questions are asked here. So remember, carrion present with tender boggy swelling and favus presents with thick crusting known as scutula. So boggy swelling in carrion and crusting of scutula in favus. This is caused by generally trichophyton mentagrophyte, also trichophyton verrucosum, while the common causative agent here is trichophyton Sholini. Already question have been asked on these. The drug of choice for tinea capitis is griseofulvin. But other types of tinea like tinea cruris, tinea corporis, tinea manum, tinea pedis, tinea unguum. Here, the drug of choice is terbinafine. If terbinafine is not there, then you can choose itraconazole. So, except for tinea capitis, where griseofulvin is the drug of choice, in other tinea like tinea cruris, corporis, manum, pedis, and unguum, we give terbinafine. Tinea corporis is also known as tinea cercinata. Why? Because this term cercinata means annular. So here the lesions are annular. Such lesions are seen, annular lesions. They have active margin and central clearing. So sometimes they ask you central clearing is feature of, answer is tinea corporis. But if they ask you central crusting is feature of and central scarring is feature of, so remember central crusting is seen in leishmaniasis and central scarring is seen in lupus vulgaris, which is most common type of cutaneous tuberculosis. When patient develop tinea infection of nails, it is known as tinea unguum, which is also referred to as onychomycosis. And the most common type of onychomycosis I told you is the distal involvement, that is distal lateral subungual onychomycosis. So remember, this is the most common type of onychomycosis where distal involvement is seen of the nails. Next is deep fungal infections like sporotrichosis. Sporotrichosis is also known as rose gardener's disease. The most common variant of sporotrichosis is lymphatic variant, where linear lesions are seen. So linear lesions are seen over extremities, and here the drug of choice is itraconazole. But if itraconazole is not there, you can choose saturated solution of potassium iodide. So sometimes questions are asked here that saturated solution of potassium iodide is used as, answer is sporotrichosis. On histology, asteroid bodies are seen. Another deep fungal infection is chromoblastomycosis, where another important bodies, that is Madler bodies, are seen, also known as sclerotic bodies or copper penny bodies. These patients present with rough growths which can become very large cauliflower like growth, and the drug of choice is itraconazole. Like you can see here, pityriasis versicolor, here over upper trunk, these hypopigmented lesions are seen. Sometimes they can be hyperpigmented as well. Oral candidiasis present with such pseudo membrane over buccal mucosa. If you try to scrap it, it will be removed. Then if intertriginous areas are involved, then this is known as intertrigo, that is candidal intertrigo. Tinea capitis presents with tender boggy swelling over scalp in children. This is carrion type. Interdigital tinea pedis, here again you can see that the tinea involving the intertriginous areas. Then tinea cruris if groin involvement is there. Then tinea corporis, as I told you, the ring like lesion is seen or annular lesion is seen where the margins are active but there is central clearing. Onychomycosis, that is the distal portion is involved first. So you can see the proximal part is appearing normal, but the distal portion is involved. So distal lateral onychomycosis. Sporotrichosis presents with linear nodules. So here the nodules follow a linear pattern generally seen over extremities. In chromoblastomycosis, rough growths are seen which can become large like a cauliflower. And here copper penny bodies are seen. Penny means coin and copper in color. So they are copper in color and round like coin. So these are known as copper penny bodies. Next infection is mycobacterial infection. The most common type of cutaneous tuberculosis is lupus vulgaris. But if they ask you that which is the most common type in children, then answer will be scleroderma. Lupus vulgaris generally present with apple jelly nodules. So generally question is asked on apple jelly nodules. This is the finding of diascopy. So what is diascopy? If you take a glass slide and press the lesion of lupus vulgaris, you will find these apple jelly nodules. So many times this question have been asked. So remember, apple jelly nodules are seen in lupus vulgaris. While the most common type which is seen in children is scleroderma, it occurs due to contiguous spread. So what happens in scleroderma? There is some focus which is already present. Like this focus can be in the form of lymph node, bone, or joint. And then later the overlying skin gets involved. Like if there is a lymph node here and this is the overlying skin, this lymph node ruptures and involves this overlying skin. So this is the common presentation of scleroderma. This presents in the form of sinus. Sometimes they ask you about tuberculosis. So tuberculosis is due to mycobacterial hypersensitivity. And these are the examples of tuberculosis like lichen sclerosorum. So remember, scleroderma is tuberculosis, skin tuberculosis, while sclerosorum is tuberculid. Then papillonecrotic type and erythema induratum of Basin. These are three examples of tuberculosis. Now the treatment for all these tuberculosis and tuberculosis is same, and that is we give anti-tubercular therapy. So first 2 months HRZE, and for next 4 months HRE. So total duration of 6 months. Next is leprosy. This is caused by Mycobacterium leprae, and according to Ridley-Joplin classification, it can be of 5 types, that is tubercular, borderline tubercular, borderline lepromatous, and lepromatous type. As we move from tubercular pole to lepromatous pole, the bacterial load increases, but the cell-mediated immunity decreases. Now this TT type generally present with single lesion, and because it is single, it is asymmetrical, unilateral. BT type presents with satellite lesions. BB generally presents with 3 to 10 lesions. And the characteristic lesions which are seen in BB are known as punched out lesions, also known as inverted saucer shaped lesions, also known as geographical lesions. These are very important points, and already questions have been asked. Punched out lesions are seen in BB, satellite lesions are seen in BT. In BL, the number further increases. There might be 10 to 20 lesions. They appear symmetrical but less symmetrical to LL. In LL, there are numerous lesions, and here the lesions become bilaterally symmetrical. Lesions are smaller, Face involvement might be seen in the form of leonine facies. These patients may have lateral medrosis, saddle nose, and sometimes systemic involvement in the form of testicular atrophy, gynecomastia. Nerve involvement is very common. Generally, bilaterally symmetrical thickened nerves might be seen. According to WHO classification, the leprosy is divided into two types, that is PB and MB. To differentiate between PB and MB, that is paucibacillary and multibacillary, you need to look for hypopigmented hypoanesthetic lesions. If they are 1 to 5, paucibacillary. If they are more than 5, multibacillary. Look for peripheral nerve thickening. If none of the nerves are thickened, paucibacillary. If more than equal to one nerve is thickened, multibacillary. Skin slit smear examination can be done and look for acid-fast bacilli. If you don't find them, it is paucibacillary. If you find them, it is multibacillary. Now, once you have made the diagnosis, the treatment also becomes very simple. The treatment of paucibacillary and multibacillary is almost same, that is, we give multi-drug therapy, that is MDT. In PBMDT and MBMDT, the drugs and the doses are same, that is rifampicin, dapsone and clofazimine. Rifampicin 600 mg given once a month. Dapsone 100 mg daily. And clofazimine 300 mg once a month and 50 mg daily. If everything, that is drug, dose, everything is same, then what is the difference? The difference is duration. The duration of therapy is different. In PB we give this for 6 months, while in MB we give this for 12 months. There are a few more important points which may be asked, that which is the most common cranial nerve involved in leprosy? It is facial. If they ask you which is the most common peripheral nerve involved in leprosy, it is ulnar. If it is not there, you can choose posterior tibial. Then they might ask you that which is the first sensation which is lost. Temperature is the first sensation which is lost. Cold followed by hot. Sometimes these patients develop acute exacerbation of the pre-existing lesions. This is known as lepra reaction. And this lepra reaction can be of two types, type 1 lepra reaction and type 2 lepra reaction. Type 1 lepra reaction is type 4 hypersensitivity and type 2 lepra reaction is type 3 hypersensitivity. This type 2 lepra reaction is also known as ENL reaction. Why? Because here erythema nodosum leprosum, that is erythematous nodules are formed, while here lot of edema develops. The drug of choice for both these lepra reaction is same, that is steroids. So steroids is the drug of choice in both. But sometimes they ask question on thalidomide. So remember, thalidomide is not effective in type 1, it is very effective in type 2 and it is considered as a gold standard drug. So if they ask you which is the gold standard drug, thalidomide, but which is the drug of choice for type 2, it is steroids. Okay, so steroid is the drug of choice for both, but thalidomide is effective in type 2 lepra reaction, that is also known as ENL reaction, erythema nodosum leprosum. Here you can see, I told you apple jelly nodules are seen in lupus vulgaris, and this is feature of diascopy. That is, when you press the lesion, you will see these nodules. Scleroderma, there is underlying focus, like here it can be cervical lymph node, due to which this overlying skin have involved. These are punched out lesions which are seen in BB type of leprosy. Why they are known as punched out? Because these lesions appear as if the central portion have been punched out from the lesion. In LL type of leprosy, I told you that lesions are small, they are numerous in number and they are bilaterally symmetrical. Gradually face involvement occurs, and face involvement can be very severe in the form of leonine facies, where you can see saddle nose, ear helix, earlobe infiltration, then lateral medrosis and rugosities, giving rise to lion-like face. Then, because there is hypoanesthesia, patient might develop ulcers, plantar or palmar ulcers or sores, and here you can see the nerves are thickened, so greater auricular nerve thickening can be appreciated. The patients suffering from type 1 lepra reaction presents with edematous lesions, while type 2 leper reaction present with these erythematous nodules. Next is viral infections. The first one is viral warts. Now these are caused by human papillomavirus. Now there are different types of viral warts and there are different HPV subtypes which can cause them, and this is a very simple mnemonic to remember it. DSP SLEP, D for deep plantar wart, S for superficial plantar wart, P for plain wart, C for common wart also known as verruca vulgaris, E for epidermodysplasia verruciformis, L for laryngeal wart. Along with laryngeal, also remember anogenital warts, and B for butcher warts. So DSP SLEP, so it is so simple. D, that is deep plantar, is caused by subtype 1. These are HPV subtypes. Superficial by second, plain by third, common by fourth as well as second, epidermodysplasia fifth as well as eighth, laryngeal anogenital by 6th and 11th, and butcher wart by 7th. So if you don't remember the second subtype, it is okay. At least you can remember the first one. So DSP SLEP 1, 2, 3, 4, 5, 6, 7. Now among them, this anogenital wart is very important and generally question is asked here. So remember the subtypes are 6 and 11. If both are given in separate option, choose 6. So here you can see this is a patient suffering from anogenital warts. This large growth which is seen over anal or genital area, which is rough warty growth, this is also known as condyloma acuminata. So condyloma acuminata are the anogenital warts caused by HPV subtype 6 and 11. Then next is molluscum contagiosum. Molluscum contagiosum is caused by pox virus and they present with these pearly papules. And as you can see in the center, there is umbilication. So they present with central umbilication. Now, if you take biopsy from these lesions, you will find characteristic bodies. These are known as Henderson-Patterson bodies. Henderson-Patterson bodies are characteristically seen in molluscum contagiosum, and these are eosinophilic inclusions, and that's why they appear pink in color. So you can see these pink color inclusions. These are Henderson-Patterson bodies or HP bodies of molluscum contagiosum. Then another viral infection is herpes labialis. This is caused by HSV1. Here you will find these grouped vesicles. So you can see these grouped fluid-filled lesions around lips. Okay. While herpes genitalis is caused by HSV2, here again the same thing is seen, that is grouped vesicles are seen around genitals. Sometimes they might rupture, so you might get polycyclic erosion. So polycyclic erosions erosion with cyclic margins might be seen in genitalis. Then chickenpox, you might have read in pediatrics also. This is caused by varicella zoster virus, and here there are prodromal features in the form of fever, malaise, and then patients start developing these rashes, and these are very small fluid-filled lesions with red halo around them. So these are known as dewdrop on rose petal. So dewdrop on rose petal appearance is seen in chickenpox. Now what happens in a child develops chickenpox and this lesion subside and this varicella zoster virus lie dormant in the nerves, and later on sometimes it can reactivate, and this reactivation of varicella zoster virus is known as herpes zoster or shingles. So this is herpes zoster. Now because this is due to reactivation of the virus and the virus was lying dormant in the nerves, so what happens, it affects a particular dermatome. So these lesions are unilateral along a particular nerve segment, like you can see unilateral lesion along a particular nerve segment. This is a very painful condition, and here again you will find multiple fluid filled lesions along a particular nerve segment or a dermatome. Here the drug of choice is acyclovir. As I told you, herpes labialis, herpes genitalis, chickenpox and herpes zoster. In all these, the drug of choice is acyclovir. The doses are different. Here the dose is 200 mg 5 times a day for 7 days. If you are using 400 mg, then 3 times a day for 7 days. While here in chickenpox and herpes zoster, we give 800 mg 5 times a day for 7 days. So drug is same in all these labialis, genitalis, chickenpox and herpes zoster. Doses are different. Next is sexually transmitted infection. Now, when these viral warts or molluscum contagiosum or herpes occurs over genital areas, they are also included in STI. So, herpes genitalis, then genital molluscum contagiosum and genital warts are also a form of STI. So, remember that sometimes they ask you what is the treatment of anogenital warts. So, anogenital warts are treated with imiquimod. If imiquimod is not there, you can choose podophylotoxin. Both these agents are teratogenic. So that's why they ask you next question, that what is the treatment in pregnancy? And then the answer becomes cryotherapy. If cryotherapy is not there, you can choose TCA application. TCA, trichloroacetic acid application. Then other sexually transmitted infections are syphilis, LGV, chancroid, and donovenosis. Syphilis, all of you know, is caused by Treponema pallidum. LGV is caused by Chlamydia trachomatis. Chancroid is caused by Haemophilus ducrei. And donovenosis is caused by Klebsiella granulomatis. The old name was Clamatobacterium granulomatis. The incubation period here is 9 to 90 days. Here it is 3 to 30 days. Here it is 2 to 5 days. While here it is 8 to 80 days. Now, how you are going to clinically identify these conditions? So, they are sexually transmitted infections, so they can present with genital ulcers. So, genital ulcers of syphilis, they are generally single. Here also single. Here multiple. Here also single. They are painless here, painless here, painful here, while painless here. They are firmly indurated. This is very important point. Firmly indurated. That's why this is known as hard chancre. These are transient. So because they are transient, they might go unnoticed. They have undermined edges. Undermined edges. Very important. Undermined edges. So firmly indurated and undermined edges in chancroid. Firmly indurated in syphilis. And here they have beefy red granulomatous base. This is also very important. Already questions have been asked. So you can very easily identify with the help of these points. If they are hard chancre, firmly indurated, probably syphilis. Then transient may go unnoticed, LGV, undermined edges, chancroid, and if beefy red granulomatous base, then donovenosis. You can also look for lymphadenopathy. Here generally bilateral, non-tender, shorty or rubbery lymphadenopathy. Here you will find unilateral tender lymphadenopathy, here unilateral tender lymphadenopathy, and here no lymphadenopathy is seen. But sometimes swelling might be present, and this swelling is due to pseudobubos. So if they ask you pseudobubos, remember false lymph nodes or pseudobubos are seen in donovenosis. Treatment here is benzathine penicillin. Benzathine penicillin is used in all the forms of syphilis except neurosyphilis, where aqueous or crystalline penicillin is used. In LGV, the drug of choice is doxycycline, while here the drug of choice is azithromycin, as well as in donovenosis, drug of choice is azithromycin. I told you in LGV what happens, that the genital ulcers are transient, so they may go unnoticed. If they go unnoticed, patient may present with late complications. So this is late complications of LGV in the form of groove sign. So groove sign might be seen, or genital elephantiasis might be present. Genital elephantiasis in the form of, that is, the size of genital increases in males as well as females. In females, this leads to vulval elephantiasis known as asthiomin, and in males, saxophone penis. Penis takes the shape of a saxophone. So here you can see this is syphilitic ulcer, where you can see single, painless, firmly indurated, and sometimes this is so indurated that if you feel it, it appears as if button-like induration is there. Then if the patient do not take treatment of this genital ulcer and later on this genital ulcer heal, patient may develop secondary syphilis, and secondary syphilis generally presents with rashes. These rashes might be present over palm and sole, which are generally dark in color, and if you press them with Allpen, you will find, or any blunt object, you will find that they have deep dermal tenderness. This is known as Buschke-Ollendorff sign. So this is seen in secondary syphilis. Secondary syphilis patient may also present with condyloma lata. These are generally seen over wet areas, that is groin areas, and these are highly infectious lesions of secondary syphilis. Then if a child develops syphilis, then this is known as congenital syphilis, which is presents with Hutchinson's triad. Hutchinson's triad, where you will find interstitial keratitis, eighth nerve deafness, and Hutchinson teeth. Like you can see, these are central upper incisors with notch. LGV, I told you, generally present with unilateral tender lymphadenopathy, and if the lymph nodes are enlarged on either side of the inguinal ligament, it gives groove sign, a groove in between. Chancroid present with multiple painful genital ulcers with undermined edges. In chancroid, which is caused by Haemophilus ducrei, this bacteria appears in parallel rows. Okay, so this is known as railroad track appearance or school of fish appearance, while safety pin appearance is seen in due to bipolar staining. This is seen in Chlamytobacterium granulomatous or Klebsiella granulomatous, which is feature of donovenosis. Okay, so in donovenosis, safety pin appearance is seen. In chancroid, school of fish appearance is seen. So donovenosis presents with single painless ulcer, but this ulcer have beefy red granulomatous base. Sometimes swellings might be present, but these are not enlarged lymph nodes. These are subcutaneous nodules in inguinal area. These are known as pseudobubos. This is again a feature of donovenosis. Then gonorrhea. Gonorrhea generally presents with purulent urethral discharge. So if patient comes with purulent urethral discharge, then suspect gonorrhea, which is caused by Neisseria gonorrhea, and this is gonococcal urethritis. Here the diagnosis is made, so gold standard for diagnosis is culture, Thayer-Martin media, and the drug of choice is ceftriaxone. Sometimes female patient may also present with vaginal discharge, and there are three common causes of vaginal discharge. It can be due to candidiasis, where thick curdy discharge is seen. It can be due to trichomoniasis, where greenish frothy discharge is seen, and it could be due to bacterial vaginosis, where you will find clue cells, whiff test is positive, and scanty adherent discharge. So next we'll be discussing papillosquamous disorders. The first papillosquamous disorder is psoriasis. In cases of psoriasis, sometimes HLA association is seen, like CW6, which is associated with juvenile psoriasis. and HLA B27 with psoriatic arthritis. It is also a strong association of reactive arthritis. How these patients clinically present? They present with erythematous plaque with silvery white scaling. So this silvery white scaling is very characteristic, and generally these lesions are seen over extensors like knee, elbow, back. And if you scrap these lesions with a glass slide, you will find that when all the scales are removed, pinpoint bleeding is seen. This is known as Auspitz sign. So many times this question have been asked. Auspitz sign is associated with, answer is psoriasis. Now this is the clinical presentation of most common type of psoriasis, that is psoriasis vulgaris. But there are other types of psoriasis also, like when flexors are involved, we call it inverse psoriasis. So normally extensors are involved, but if flexors get involved, it is inverse psoriasis. Then in children, after upper respiratory tract infection, guttate psoriasis develops. Guttate psoriasis. Then there are few severe types of psoriasis like erythrodermic and pustular psoriasis. So if lot of erythema develops, so whole skin becomes red, that is known as erythrodermic psoriasis. This is a severe type of psoriasis. And if sterile pustules develop, so pus-filled lesions develop, then this is known as pustular psoriasis. Now remember one point, that when this pustular psoriasis develops in pregnancy, then this is given a name known as impetigo herpetiformis. So sometimes they ask you what is impetigo herpetiformis. This is nothing, this is pustular psoriasis in pregnancy. There is one more important point to remember. Sometimes they ask you Warnoff ring is seen in, or Berkeley membrane is seen in. These are also seen in psoriasis. If you do histology from the lesion of psoriasis, you will find various histological findings. Few important ones are Munro's microabscess, Kogo's pustules, then there is acanthosis, that is thickening of stratum spinosum, suprapapillary thinning, that is the space above the dermal papilla becomes thin because these dermal papilla enlarged. So enlarged dermal papilla. And why they get enlarged? Because there is a lot of infiltration in the dermis and the dermal vessels become dilated and tortuous. So dermal T cell infiltration and dilated and tortuous dermal vessels. So these are the histological findings. Now in the treatment of psoriasis, there are three common systemic agents which are used. So systemic drugs which are used are methotrexate, cyclosporin, acitretin. Topical agents which are used are corticosteroids and keratolytic agents. Keratolytic agents like salicylic acid, coal tar. Then phototherapy can also be used in these cases. And there are biologicals drug. These are monoclonal antibodies like secukinumab, which is anti-interleukin 17A, ustekinumab, which is anti-interleukin 12 and 23, then infliximab, adalimumab, etanercept. These are TNF alpha inhibitors. Now sometimes they ask you questions directly like what is the drug of choice for severe type of psoriasis like erythrodermic psoriasis? Answer is methotrexate. Psoriatic arthritis. Answer is methotrexate. Pustular psoriasis. Answer is acitretin. But remember, I told you that impetigo herpetiformis is pustular psoriasis in pregnancy. So if this pustular psoriasis develops in pregnancy, then you cannot use both these drugs because both are teratogenic, methotrexate as well as acitretin. So then we give corticosteroids. If corticosteroid is not there, you can choose cyclosporin, but never choose acitretin or methotrexate because both are teratogenic. Now these patients who are suffering from psoriatic arthritis, sometimes they ask you that which is the most common joint involved. So most common joint in psoriatic arthritis is distal interphalangeal joint. Sometimes they ask you which is the most common type of psoriatic arthritis, that is asymmetrical oligoarticular type. So asymmetrical oligoarticular is the most common type, but the most common joint is distal interphalangeal joint. And the radiological finding in cases of psoriatic arthritis is pencil in cup. So these are few questions which are sometimes directly asked. So remember these questions. Next disorder is lichen planus. This is again an autoimmune condition and almost all the parts of the body can be involved, not only skin, but there can be changes over nails, hair follicles can be involved, and mucosa of the patient can be involved. Over skin you will find 5 P's. So what are 5 P's of lichen planus? Plain purple polygonal pruritic papules. Now if you examine these plain purple polygonal pruritic papules, you will find some reticulate pattern over it known as Wickham's striae. So Wickham striae is again a feature of lichen planus. If you examine the nails, the most characteristic nail change I already told you is pterygium. Hair follicles are involved, and the alopecia which occurs in lichen planus is permanent type of alopecia, that is scarring alopecia, also known as cicastaceal alopecia. And mucosa, if you examine the buccal mucosa of the patient, you might find a pattern there that is white lacy pattern. Sometimes reticulate pattern is also seen. So these are few important points. Already questions have been asked: Wickham striae, pterygium, scarring alopecia, and white lacy pattern. All these are feature of lichen planus. These patients of lichen planus sometimes are seen associated with hepatitis C virus infection. Sometimes isomorphic, which is also known as Koebner's phenomena, is seen associated. Isomorphic or Koebner's phenomena. See, it is very simple from the name itself, isomorphic. Okay, so same type of morphological lesions start developing at the site of trauma. Okay, this can be of two types, that is true and false. True is due to immunological. So true is immunologically mediated, while false is due to autoinoculation. Examples are important, like this is seen in lichen planus, psoriasis, also in vitiligo. While examples of autoinoculation are infective conditions like molluscum contagiosum and viral warts. So remember these examples of Koebner's phenomena, true and false Koebner's. Here also histology is very important, and common histological findings are basal cell degeneration, Savati bodies, these are also known as colloid bodies, Max-Joseph spaces, saw-toothed appearance, irregular acanthosis and wedge-shaped hypergranulosis. Hypergranulosis means thickening of stratum granulosum, and this thickening of stratum granulosum is something like this, that is like a shape of a wedge, and this is the reason why Wickham striae is seen. Okay, so if they ask you that Wickham striae correspond to which of the histological finding, answer will be wedge-shaped hypergranulosis. Treatment, because it is autoimmune, is again steroids. So steroids is the treatment. You can give in various forms, like you can topically apply, systemic steroids can be given, or you can give them intralesion. So intralesion, and in generalized cases phototherapy can be given. Third is pityriasis rosea. Now remember that this is a self-limiting condition, self-limiting. Generally trunk is involved, and the first patch which is formed over the trunk is known as Herald patch or mother patch, and after this Herald patch or mother patch, multiple lesions start developing and they go in downward direction along the ribs, something like this, giving which appearance? Fir tree appearance. They have a characteristic scaling which is very fine, cigarette paper like. So cigarette paper or collarette of scales is seen. These scales are something like this. So when you stretch the skin, the inner edges of the scales, they roll inward. So outer edges are attached and inner edges are free. So because these inner edges roll, this gives a sign known as hanging curtain sign. So you can remember these features. Many of them have already been asked, like collarette of scale is seen in fir tree appearance, Herald patch, and though this is having unknown etiology, but in some books it is mentioned that it is associated with herpes virus infection, human herpes virus 6 and 7. So these are the points to remember in papillosquamous disorders. Here you can see the characteristic plaques of psoriasis, that is erythematous plaque with silvery white scaling. Cobnus phenomena, I told you, it can be seen in psoriasis, vitiligo and lichen planus. So here in psoriasis, when patient is scratched, the new lesions started developing along the line of trauma. This is the first patch, that is Herald patch. And after this first patch, multiple lesions started developing, and these lesions are over trunk going in downward direction, giving fir tree appearance. In lichen planus, 5 P's are seen. So if you see these lesions, they are not exactly circular lesions. These are violaceous in color and flat topped. So plain purple polygonal pruritic papules. They are very itchy lesions and they are small in size. So pruritic papules are seen in lichen planus. Buccal mucosal involvement is also seen, and over buccal mucosa you might find white reticulate or lacy pattern. Like you can see here, this is the lacy pattern which can be seen over the buccal mucosa. So lacy pattern. So white lacy pattern is seen over buccal mucosa in lichen planus. Whenever the white lesion is present over buccal mucosa, sometimes we get confused. But remember these 3 very important points about these 3 conditions, that is candidiasis, leukoplakia and lichen planus. So candidiasis, if you scrap the lesion, it can be scrapped off. Leukoplakia is white, cannot be scrapped off, but it is only localized to buccal mucosa. Lichen planus, white, cannot be scrapped off, but other changes might be present over the skin in the form of 5 P's, plain purple polygonal pruritic papules, or nail changes might be present, or hair changes might be present. So with the help of these points, you can very easily come to the diagnosis or the answer that whether the examiner is talking about candidiasis or leukoplakia or lichen planus. Next, we will be discussing few points about these important pigmentary disorders like melasma. Melasma is brownish discoloration, usually over malar eminences. This is usually seen in females after pregnancy, and this is due to increased melanogenesis. So in the treatment we give tyrosinase inhibitors. One of the example is hydroquinone. So hydroquinone is the treatment. Then Mongolian spot, this presents with bluish discoloration, usually in infants over lower back. So if you find such bluish discoloration over infants in lower back, then this is Mongolian spot. But if you find bluish discoloration along ophthalmic and maxillary division of the trigeminal nerve, that is if maxillary area or eye involvement is seen, like here you can see this bluish lesion in the eye, so this is nevus of Ota. There is one more nevus, that is nevus of Ito. So nevus of Ota along ophthalmic and maxillary division of the trigeminal nerve, nevus of Ota along acromioclavicular nerve. So if this is acromion process, this is acromion process, this is clavicle. So if this site is involved, then it is Ito. Remember, both these are unilateral lesions. So both are unilateral, both are blue in color, sites are different. And the treatment for both is laser therapy. Generally we give ruby laser. Then Becker's nevus, this is usually seen in adolescents. These patients develop hyperpigmented patch. Like you can see here, this hyperpigmented patch develops, which later on start developing hypertrichosis. That is, thick dark terminal hair start developing. The site is commonly upper trunk. So upper chest, upper back, shoulder, this is the common site. So if you find such hyperpigmented patch in adolescents, in teenager over upper trunk with hypertrichosis, then it is Becker's nevus. These are few more cases of Becker's nevus. Then acanthosis nigricans also present with dark lesion. This has characteristic velvety appearance. So velvety, thick, hyperpigmented skin over folds. So generally folds are involved, like neck fold, axilla, groin, and the most common cause is obesity. So generally seen in obese patients. Okay, so in obese patients, if you get such hyperpigmented velvety skin over folds, then it is acanthosis nigricans. Like you can see here, other sites involved like axilla, neck folds. In obese patient, neck fold have this velvety appearance. Then this is one condition which is very important because of its inheritance, incontinentia pigmentosa. This is X-linked dominant condition. There are very few X-linked dominant conditions. Okay, this is one of them. Now in this condition, lesions can change. Like initially the lesions are inflammatory, then they become verrucous, then they become hyperpigmented, and then they become hypopigmented. So there are different stages. Inflammatory, then they change to verrucous, then they become hyperpigmented, then they become hypopigmented. So both the colors can be seen, hyper as well as hypo. And these lesions, they follow linear lines. Okay, so as you can see, these lesions are arranged linearly. So these lesions follow imaginary lines. These lines are lines of Blaschko. So lines of Blaschko are imaginary lines of development of skin. They do not correspond to blood supply, nerve or lymphatic drainage. These are imaginary lines of embryonic development of skin. Freckles are normal findings and they can be usually seen in fair skin individuals, like in Western countries, the individuals who have type 1 and type 2 fair skin. And they normally develop due to sun damage, and this is due to excessive melanogenesis, that is increased synthesis of melanin. This is a normal finding in Western countries. Okay, but sometimes what happens due to defect in DNA, that is DNA repair defect or nucleotide excision repair defect, what happens that multiple freckles start developing, lot of sun damage occurs, and gradually patients start developing squamous cell carcinoma as well due to excessive ultraviolet radiation exposure. So this condition is known as xeroderma pigmentosa. So xeroderma pigmentosa is autosomal recessive condition. Here initially freckles develop, but later on it may lead to squamous cell carcinoma, and this condition is due to DNA repair defect, nucleotide excision repair defect. Then there is one more condition, that is Peutz-Jeghers syndrome, which is autosomal dominant condition. Here lentigens are seen, and these lentigens have a characteristic site, that is they are present around lips. So perioral lentigens, perioral lentigens. These patients also have associated GI polyps. So if you find patient with GI polyps, that is GI hematomas and perioral lentigens, suspect Peutz-Jeghers syndrome. This condition is very obvious from the name itself. Fixed drug eruptions. Fixed. Why? Because every time lesions occur over same site. Usually develop on intake of drugs like NSAIDs, tetracycline, cotrimoxazole like Septran. Now cotrimoxazole and Septran have a specific pattern. They generally cause lesions over genitals, while NSAID they cause lesions over lips. Initially these lesions are erosions like you can see here or bulla. So a fluid filled lesion or erosion might be seen and later on it become hyperpigmented. So if you find history of drug and on intake of that drug patient start developing erosion or blisters over these sites like lips or genitals depending on the drug associated, and every time patient takes the drug the similar lesions develop over same site and heal with hyperpigmentation, then you are dealing with a case of fixed drug eruption. So this is the clinical finding which is seen in fixed drug eruption. Now hypopigmented disorders like vitiligo. Vitiligo, all of you know, is autoimmune condition, and here anti-melanocytic antibodies are formed. They destroy the melanocytes and that's why the lesions are depigmented or white in color. The most common type of vitiligo is vitiligo vulgaris, where generally bilaterally symmetrical lesions are seen. So if you find bilaterally symmetrical depigmented lesion, that is a case of vitiligo vulgaris. Now if the lesion is localized to one area, we call it focal vitiligo. If it is localized to acrofacial type, acro means hand and feet, facial face. So if hand, feet and face are involved, then we call it acrofacial type. There is a type known as segmental vitiligo. Segmental means a particular nerve segment is involved. So here the lesions are unilateral along a particular nerve segment or dermatome. Like we have seen in herpes zoster where painful fluid-filled lesions were present along a particular nerve segment. Here the hypopigmented or depigmented lesions are present along a nerve segment. So you can see unilateral along a particular nerve segment or dermatome. So that's why segmental type. Sometimes in these lesions, not only skin but the hair follicles also become white. This is known as leukotrichia. This have poor prognosis. So if hair follicles also start losing color, leukotrichia occurs, then this have poor prognosis. Then treatment of this condition, because it is autoimmune, we treat with steroids. It can be given topical or systemic steroids. Then you can use calcineurin inhibitors like tacrolimus, and phototherapy is also very important. So phototherapy units are available and you can ask the patient to take phototherapy in these cases. Various forms of phototherapy are there like PUVA, PUVASOL, NB-UVB. So in a case of pityriasis alba, sometimes students get confused with indeterminate type of leprosy. Indeterminate type of leprosy. Because in both these conditions, hypopigmented lesion over face in a child is seen. So if you get hypopigmented lesion over face in a child, it could be alba, it could be indeterminate leprosy. How to differentiate? You know pityriasis means scaling. So scaling is present here but absent here. Then history of atopy is generally seen in alba, absent in indeterminate leprosy. Atrophy over the lesion is absent in alba, present in leprosy. And sensation are always intact here but can be impaired plus minus in cases of indeterminate leprosy. So with the help of these points, you can differentiate alba from indeterminate leprosy. Pyebaldism, this is again a genetic condition, and here patient presents with white forelocks. So you can see the frontal group of hair follicles become white, and along with this patient also have this hypopigmented lesion over the skin which might be present over forehead or over the trunk. Now remember that this white forelock is not only associated with pyebaldism, it can be seen associated with Waardenburg syndrome. And in Waardenburg syndrome, you might have read in ENT, it is associated with sensory neural hearing loss, dystopia canthorum, which means that the distance between inner canthus increases, and heterochromia of the iris. If you look at the color of the iris, they are different. So if you find such features along with white forelocks, then it is suggestive of Waardenburg syndrome. And albinism, as you know, it is due to tyrosinase defect, and tyrosinase is the enzyme required for melanin synthesis. So here melanin synthesis is inhibited, and because of lack of melanin synthesis, not only skin, hair follicles also get white. So you can see depigmented skin, depigmented hair follicle, and melanin is also present in retina, and that's why these patients also present with ocular manifestations in the form of photophobia, nystagmus. So that's why this is oculocutaneous disorder. So we have discussed most of the disorders. Now we are going to discuss few important topics under this miscellaneous heading, like port wine stain. Now this is a type of capillary malformation, and sometimes it is also associated with Struck-Weber syndrome. So this is one question which is asked. Port wine stain is associated with. So port wine stain along with neurological finding and eye finding like glaucoma is seen in Struck-Weber syndrome. Then seborrheic keratosis. Now remember that seborrheic keratosis is benign and it presents with stuck on appearance. So these lesions, they have stuck on appearance. But if there is numerous sudden appearance of seborrheic keratosis over whole body, that is sometimes associated with underlying malignancy like gastric adenocarcinoma. So that is known as Lesser-Trillet sign. So what is Lesser-Trillet sign? Sudden numerous appearance of seborrheic keratosis like lesion due to underlying gastric adenocarcinoma. Cutaneous horn. So normally this is benign lesion, but if it persists for a very long duration, sometimes it can lead to squamous cell carcinoma. So initially cutaneous horn is benign lesion and this is just a collection of keratin, but gradually it can lead to squamous cell carcinoma, and the best is to get it excised. Malignant melanoma, here you need to remember A, B, C, D, E, that if a pre-existing lesion become asymmetrical, like you can see here the lesion is asymmetrical, borders become irregular. So here again you can see borders are irregular, color is variable. So at places it is light in color, at places it is dark in color. Diameter becomes more than 6 mm. So if gradually the lesion keep on increasing in diameter, so overall diameter increases, and evolution of the lesion occur, that is at places become elevated. Like you can see here it is elevated, then at places it is flat. So if these changes start occurring, then suspect malignant melanoma. Mycosis fungoides is cutaneous T-cell lymphoma. And in this condition, this is skin malignancy, and in this condition you will find few malignant cells. These malignant lymphocytes, they have tendency to move towards epidermis. So on histology there is a very important finding that is known as epidermotropism. They have tendency to move towards epidermis and they start collecting here. These collections of malignant lymphocytes is known as Poutrious microabscess. So Poutrious microabscess are feature of mycosis fungoides, that is cutaneous T-cell lymphoma. Now these cells, if you examine them closely, you will find that these cells have nucleus which have convolutions which are very similar to gyri and sulci present over cerebrum. So this is known as cerebriform nucleus which is seen in these cells. Then there is a condition known as pyoderma gangrenosum. This is a type of neutrophilic dermatosis. This is usually associated with inflammatory bowel disease like ulcerative colitis, Crohn's disease. These patients generally present with ulcer with undermined edges. So undermined edges are seen. So here you can see edges are undermined. So undermined edges are seen. And the drug of choice for this condition is corticosteroids. The diagnosis of pyoderma gangrenosum is diagnosis of exclusion because this is a rare condition. Then cafe au lait macules, these are seen in neurofibromatosis. Cafe is for coffee and lait is for milk. So this is coffee in milk. Why coffee in milk? Because this is dark lesion, hyperpigmented lesion like coffee present over milk like skin. So light skin, dark lesion. So coffee in milk, cafe au lait macules, these are seen in neurofibromatosis patient. This neurofibromatosis patient presents with multiple neurofibromas, like you can see here. The gene which are involved here are NF1 and NF2 gene, which are present on chromosome number 17 and 22. Sometimes these neurofibromas become very large. These are known as plexiform neurofibromas, and if you press these neurofibromas, they go inside the skin, and once you release them, they come out. This is known as buttonhole sign. So buttonhole sign is seen. This you can see a large neurofibroma. Then in tuberous sclerosis, facial angiofibromas are seen. Facial angiofibroma. This is the common site that is over nose, nasolabial fold, cheek, and these are known as adenoma sebaceum. There is a triad which is seen in this condition known as Vogt's triad. Vogt's triad consists of three things: epilepsy, mental retardation, and adenoma sebaceum. So epilepsy, low IQ or mental retardation, and adenoma sebaceum. That is the reason why this condition is also known as epiloia. Epi for epilepsy, LO for low, I for IQ, and A for adenoma sebaceum. Okay, so tuberous sclerosis or epiloia presents with such lesions over face. Now Wood's lamp, all of you might be knowing that Wood's lamp is a handheld device which is used to diagnose various conditions. Like I told you, in erythrasma, coral red fluorescence is seen. Like in pityriasis versicolor, apple green fluorescence is seen. Now this is an UVA lamp. UVA lamp. Why? Because UVA radiation ranges from 320 to 400 nanometer. And to be more specific, this is 365. So this emits 365 wavelength. That's why it is known as UVA lamp or Wood's lamp. And this is having a filter which is made up of barium silicate and 9% nickel oxide. So filter of Wood's lamp is made up of barium silicate and 9% nickel oxide. Contact dermatitis, very obvious from the name itself. Derma means skin, itis means inflammation, and if this inflammation of skin is due to contact to something, it is known as contact dermatitis. Like you can see here, what could be the reason for this dermatitis? The site is where the patient wears sleepers. Okay, so sleepers, that is having rubber, so rubber sleepers leading to dermatitis. So this is contact dermatitis. Wherever the rubber sleeper comes in contact, the dermatitis is developing. Sometimes some irritant dermatitis can occur. That is a chemical which is so harsh, when it comes in contact with the skin, that portion becomes red, inflamed, and sometimes vesicle bulla can also be formed. Then this is a very common plant which causes dermatitis. This is also commonly known as Congress grass. This plant is Parthenium, and this causes airborne contact dermatitis. So airborne contact dermatitis is caused by a plant known as Parthenium, also known as Congress grass. This is a patient suffering from airborne contact dermatitis. How to differentiate? When this patient developed dermatitis and it is through air, so that's why the air which comes in contact with the skin causes dermatitis. So the hidden areas are spared and the exposed areas are involved. Like if the patient wears vest, you will find that this area is involved while the hidden area is spared. Similarly here you can see, because of the collar, this area is spared and the exposed area is involved. To diagnose these cases of dermatitis, we need to do patch testing. And patch testing, the questions are generally asked on the reading. So 2 readings are taken, second day and 4th day. If both are given an option, 4th day reading is more specific. We take a small allergen and keep it in the small aluminium cap. These are generally known as Finn chambers. And we take the reading on 2nd and 4th day, and if there is a positive finding, you can make the diagnosis that probably this is the culprit agent which is causing dermatitis in this patient. Cradle cap is a type of seborrheic dermatitis seen in infants. So here you will find this greasy, scaly lesions over scalp. in infants. This is seborrheic dermatitis of infants, commonly known as cradle cap. Then atopic dermatitis is also important, and this atopic dermatitis generally have history of atopy associated. So whenever the question is asked on atopic dermatitis, you will find in the question that patient having dermatitis and mother having history of asthma. So remember that there is history of atopy in the patient or the family members. These lesions are extremely pruritic, so very itchy lesions, and the sites which are commonly involved are in infants, face, and because they crawl, extensors can get involved, but in other age groups like children and adults, flexors are commonly involved. So mainly flexors are involved. Only in crawling children or infants, they might get dermatitis over extensors as well. Okay, so here you can see over face, dry skin, there is exudative lesions which are present here. Similarly here again you can see this is the atopic dermatitis of infants, and in teenagers or adult children, adults, you will find lesions over flexors like popliteal fossa or cubital fossa. Denny-Morgan fold is one association which is seen in atopic dermatitis. Other than Denny-Morgan fold, you might also find a white dermographism. What is Denny-Morgan fold? It is extra skin fold in lower eyelid. This is known as Denny-Morgan fold. These patients may also have other eye problems in the form of anterior subcapsular cataract or keratoconus. The patients who are suffering from scabies generally present with itchy lesions over web spaces. So this is the common site which is involved, web spaces. To diagnose these cases, you need to look for few things, that is increased itching or pruritus at night, presence of burrows. So you should look for presence of burrows. Then characteristic distribution of lesion. So lesions are distributed usually over flexural areas of web spaces, and family history positive. So other family members might also be suffering from the same condition. Here you can see these are the burrows. These are made by the mite in the superficial layer of the epidermis, that is in stratum corneum. So in stratum corneum you might get such burrows in cases of scabies. These are S-shaped or serpentinous. In genital scabies, when the lesions are present over genitals like a scrotum, the lesions are nodular. So they are slightly large lesion. Nodular lesions are seen in genital scabies. Ichthyosis is another condition, and there are different types of ichthyosis like ichthyosis vulgaris, which is the most common type. Then X-linked ichthyosis, lamellar ichthyosis, and Harlequin ichthyosis. X-linked ichthyosis is X-linked recessive. Vulgaris is autosomal dominant, while lamellar and harlequin are autosomal recessive. So these are genetic conditions. And ichthyosis, ichthyo means fish. So in this condition you will get fish-like scales and severe dryness of the skin. Like you can see in this image, severe dryness of the skin, and these scales, fish-like scales, are seen. Okay. Now in lamellar ichthyosis, this condition is very severe, and when this child is born, whole body is covered with a membrane. So in lamellar ichthyosis, whole body is covered with a membrane when the child is born. This is known as collodion membrane or collodion baby. So this is associated with lamellar ichthyosis. While harlequin ichthyosis is the most severe type of ichthyosis, this is most severe type, and in this most severe type, what happens that many of these patients die in utero. The prognosis is not very good, and when this child is born, whole body is covered with this tight membrane, and you can see this gives resemblance to armor, as if the child is wearing an armor, the armor which is the protective shield which the warriors wear. So this is known as armor-like scaling. This is seen in harlequin type. Then there is a condition known as cutaneous mastocytosis. Another name is urticaria pigmentosa. cutaneous mastocytosis, that is the number of mast cells increase. So in these lesions, the mast cells are more in number. So if you rub these lesions, so these generally present with hyperpigmented lesion, but if you rub these lesions, what will happen? Mast cells will release histamine, and here erythema and edema will develop. This is known as Darrier sign. So this is a very common question which is asked, that Darrier sign is seen in, answer is Urticaria pigmentosa. While urticaria is the condition where wheals are seen. Here the mast cells are not increased in number, but they are hyperactive. So due to hyperactivity, a small trauma can lead to release of histamine and these wheals start developing. Now these wheals are due to triple response, where there are three things, that is erythema, followed by flare, followed by wheal. So this triple response lead to these lesions. Now wherever you produce trauma, there these lesions develop. So if you write something over the skin, that portion becomes red and there the wheals develop. So whatever you write over the skin, that becomes visible. This is known as dermographism. Graphism means write, dermo means skin. So whatever you write over the skin, that becomes visible. So remember, Darrier sign is seen in Urticaria pigmentosa, but dermographism is seen in urticaria. Now there are two more things which are sometimes asked in the exams, that is, so Darrier sign I told you is seen in Urticaria pigmentosa. Dermographism is seen in urticaria. White dermographism, just now I told you, is seen in atopic dermatitis. And pseudo Darrier sign is seen in smooth muscle hematoma. So these are few points which you can remember. Sometimes these questions are asked. Leukoplakia, I already told you, this is due to Epstein-Barr virus infection, and here also white membrane like lesions are seen on the either side of the tongue. But remember, if you try to scrap it, you cannot remove it. Then morbilliform rashes are seen in those patients who have suffered from fever. So after fever, sometimes these morbilliform rashes develop. These are macular or maculopapular rashes, and they are generally associated with fever, which is due to measles, rubella, or scarlet fever, which is due to group A streptococci, or parvovirus B19 infection, non-poliovirus enterovirus, adenovirus, or HHV6 virus infection. So in these cases, sometimes morbilliform rashes develop, like you can see in this image. Then acrodermatitis enteropathica is due to zinc deficiency. As it is very obvious from the name itself, acrodermatitis. So this dermatitis generally occur over acral part, that is hand, feet, then face also get involved along with diaper areas. Like you can see in this image, diaper areas are involved. Enteropathica, so there is some GI problem also in the form of diarrhea. These patients may also present with alopecia, hair loss, that is non-scarring type of alopecia. And you might need to give lifelong zinc supplements in these cases. Pellagra, all of you might be knowing. You need to remember 4 Ds of pellagra, that is diarrhea, dementia, dermatitis. Now this dermatitis usually occur over sun exposed areas, so photo exposed areas, and that is the reason why overexposed areas like neck, patient develop this castle necklace appearance. So this necklace like appearance can be seen, and if you don't treat these patients, finally death. So these are the 4 Ds of pellagra, which is due to niacin deficiency. So that's all for today. Thank you very much. I have one YouTube channel, so if you want to see a few videos, you can go there and watch. I am also available on Facebook, so you can like, share and subscribe to my YouTube channel. You can also recommend or review my Facebook page. So thank you very much.